kind of, is there a learning curve to this, or
Nothing. This is just as anyone,
like a
anyone.
family camera?
I am saying anyone in your OPD, even patient's attendant can also take a photograph. Within zero point 0.4 seconds, you get a panoramic view through a undilated pupil.
All right. And is there any kind of special
Manoj,
positioning
just
that
I
you
have
have
one
to do?
question.
I am not kidding. It is confused with your both of the voice. One at a time, please, madam.
Manoj, I
Yes,
wanted to ask you is that in this children, as in the older machine, that you had to use the flying baby position
yes,
for
yes.
publications. Do you
Same
have
here
to do the
also.
same thing here also?
Same thing also. We have to take out the cover and open the camera fully and adjust the flying baby according to the picture. And
Okay,
you get it is a little bit tricky. Takes some time because baby do not fixate it properly.
okay.
So sometimes you won't get picture, but once in a while you get a good picture also. Sir,
Manoj, one question before we
yes,
close
sir.
off your talk. Can we somewhere crop this lid's shadow?
Yes,
Because
it can be.
probably
It
that's the only thing which I had this issue, that
yes,
whenever that lid shadow, it distorts the whole thing. So if you
yes.
can crop it, probably that's the best thing what you can have.
Yes, whenever you want such types of thing, there are two things. You have to use the lid speculum, which are having plates. Okay, and otherwise, you can use the sticking, which stickings use come with every drape of the surgery. That
Yes.
those don't throw away the sticking. Use it in the OPD.
Wonderful. What a
Attach
Manoj,
it
good
to the
idea.
lids.
I think
Yes.
Manoj,
we should shift to the next talk. Karobi, can you
Manoj,
Yes,
invite?
Thank you.
Manoj, I have
Thank
one
you.
question. Manoj,
Yes,
please,
sir.
please.
Yes. Yes,
Manoj,
sir.
I have one question. Can we see aura with this, or can
Aura,
we
it is
do
not just
dynamic,
it is a
dynamic
uh,
fundus photography?
it is possible if you shift the focus little bit. You can change it to the right side, left side, upside or downside. Then aura is also seen. You have seen that the dialysis was seen. Means aura
Yes.
is almost seen in that trauma cases.
And can
Uh,
we do angiography also?
Yes.
Angiography, if you
Cases?
photograph this Optos model, Daytona
Yes.
won't give you the
Okay, okay,
angiography.
okay,
but you
okay,
said you could
okay.
do ICG also with it, no?
With the not with the Daytona, with the Optos it is
With the
possible,
Optos. Okay.
or you can have a ultrawide field Heidelberg spectralis
Oh, so this is only for imaging and photography.
imaging, but this is a tremendous useful, sir, madam.
Yes, yes, yes. I
Here
know.
you can see that this is a dialysis which is captured
Yes.
and without any effort. Here also you can see the up to periphery.
Yeah,
You
yeah.
can see the
I
choriotrendis
think
clepedora is clear.
Swapnesh, we are extending the time,
Yes,
and
thank you very much. Thank
can
you
we?
everyone for giving me
Thank you,
the
Manoj.
time.
That was a brilliant talk and lovely photographs.
Excellent, excellent talk,
Thank you,
Manoj.
thank you, thank you, thank you.
Lovely,
I'm exiting my
lovely
scheme.
photography.
Thank
Yeah.
you. Thank you, Manoj.
Thank you very much,
Bye,
sir.
Excellent talk,
Santosh.
Manoj. Thank you.
Yes.
Uh,
Yes, yes. Good
shall we
morning,
go?
everybody.
Good morning.
Morning. Good morning.
Shall we go over to
Saili,
Prashant, if you're ready?
to me,
Yeah.
I'm ready, but then there are other speakers. I can.
See, Saili is not there,
Okay,
and
okay,
Chaitra has gone for a parallel meeting.
okay. Shall
So,
I in continuation take this video angiography?
yeah, please do that.
Okay. So that's something because it is related to retinal
Related.
imaging. So let me just take you through the journey of angiography. We all know that angiography is a very important tool in the hands of us retina people to understand the uh, flow patterns inside the retina. So just I'll take you quickly through the machine which can give you this video angiography. We are using this IDON. It has got ultra high resolution. It has got wide field, and it is automatically it takes the pictures and it can do multimodality. Now, just I'll give you some pictures and I'll give you some comparison. Don't think that I am selling any machine. It's got a high resolution. This image itself tells you what it is. It is wide field, and in ultra high resolution, you can actually go into the details about the structure or the details about the corneal textures. I mean, the retinal textures. It also, in comparison between top one, I don't know personal interest in this. It has wide field. It can take one picture of 60 degrees as compared to 45 degrees, which are used to. And this is just the comparison, the same patient. And it has also an automatic fluorescein angiography, which can be done. Now that is where I want to emphasize my today's talk, that once you have this kind of images, it tells you how quality image can change the perceptions. This is a color image, then this is a red-free image, the IR image, the AF image, and the FFA image, all of a very, very high quality and high resolution. So that is where the camera comes into picture.
Can I interrupt, Prashant? We are not seeing your screen.
Are you not? Say, oh, sorry. I'll do that.
You have to share your screen.
Okay. Sorry for this. I don't know. This is the problem with this.
Share screen, na, the green button, just press on that.
1 second. Let me escape, because then only I can come. So that is the problem with this, let me go back and, oh yes, this is the share screen.
Yes, and select your presentation from the desktop.
Where do I have my presentation? ये वाला है, इसको share करना है, मुझे करना है.
Just first open your presentation, sir.
Yes, now we can
One
see
second.
it.
Now you can see that?
Yes,
the
we can
screen.
see. Now just make it full screen.
Okay, I'll do that. Sorry for
Yeah,
this.
we can see now.
Can you go back to
Can
the
you go back? I'll go
itself?
back. Yes, I'll start from the beginning. Yes.
Right. Thank you.
And is it okay?
Very fine.
Yes,
Okay.
it is.
So this is just to take you through some quality images, which I have been able to do it with this. 1 second, I'll shift this thing away. So you have this machine which gives you an ultra high resolution. It also gives you the, It gives you the wide field images. It also gives you automatically, it captures the image. It has got multimodality advantages. Now, let me take you through few images to make you understand what is this ultra high resolution. When you see the image like this, it really gives you a great idea about what is the retinal texture, the retinal, whatever lesions which you see on the retina. And this is to show you a few microaneurysms, a little cluster microaneurysms very close to the fovea. Now, this is just a comparison, no financial interest between the two. And the wide field is, it gives you in one shot 60 degrees, which is very good. Most of the time we require this area. And there's just a comparison between the same patient with two machines. Now, most important, which I want to talk today, is the automatically it can take a video angiography, which is where it edges over the other machines. Now, this is, it also has various color options. Like you can take color images, you can take RF image, you can take IR image, and you can also have an AF and a fluorescein angiography. This all multimodality is inbuilt into this machine. So that is probably one of the only machine which I found has so many features together. Now, this is where the highest resolution camera is in the market, as I understand, because I have seen these. These are the pictures I used to see, and now I'm seeing with this. And you can see as clear as this, where the pictures become so clear, it makes you understand the disease process much better. Now, it works with a 2.5 millimeter pupil. Now, that's where it helps, because your junior or your assistant can create these images and send it to you on your laptops or on your desktops. Now, automatically, you can mosaic a wide field. I cannot compare with Manoj's pictures, but then I think this is reasonably good for the cost, which is less than half the cost of what Manoj paid for Daytona. And this is 150 degrees, and which is more than enough. All modalities, including FFA image, can be done on this. This is just to show you one video angiogram. Now, here we see a classic case of a central serous, and you see, now you have seen, this is what we are used to seeing, a dot leakage. Now, let me take you through this is dot leakage increasing. Now, suppose you go to the video angiography now. See, video angiography has started, you have injected, and the pictures start coming. Now, you've seen the arterial phase, still now you can start seeing a hyper spot there, and gradually the spot is increasing, and everything is, see, I always feel that this is what every surgeon should see before deciding the treatment. But most of the time we see still images, and we see images post when it has been taken by your junior or somebody. Now here the 7 seconds and everything is over. Now you're seeing the choroidal phase going. So you know as to how much is the leakage. Now, this is another case. Now, when I saw this case, I was a little perplexed that this is a diabetic retinopathy. But I found that if you compare the upper retina and the lower retina, you find there is a difference in the extent of damage into the retina. But when I saw that, I said, well, angiography was done. It was a diabetic retinopathy with exudates near between the disc and the macula. There are flame hemorrhages also. There were dot hemorrhages also. Now, if I take you, this was the picture which I saw first, which gave me enough idea as to, yes, there are dropouts. There are areas which require heavy lasers, and there are areas which require treatment. But again, I found that there is a difference between the two. The upper retina was seemingly better, though there were lesions, but they are better than the lower retina. And then the video angiography gave me a clue as to why it is happening. Now, if you see the video angiogram, you will find that there is a definite difference in the circulatory pattern. I'll show you. Now, this is where you just keep watching this video angiogram. Now, you see the artery starts filling, the upper one starts filling earlier than the lower one. Upper one fills better than the lower one. Now, all these features suggest that there is a arterial blockade also. Now, this is where the difference starts, that you have to start searching whether this is behind, how much behind, and is it at the disc level or is it behind that? So this is where this thing is important, that sometimes watching a video angiogram is as if you are doing yourself. Though it has been done by a junior or by somebody, you can do that. So that's the advantage of this multimodality retinal imaging. It's easier and better quality, and it optimizes your patient flow. That's why it's a small presentation to make you emphasize what is the advantages of video angiography. Thank you so much. I think you can go ahead with the next talk now. I'll stop sharing my screen now.
Yeah,
You have
sir.
another talk,
Are,
no?
Any questions on this?
No, you have another talk, no, Prashant?
I have one more talk.
On microperimetry. Okay. Prashant, what I
You
wanted to say.
want me to do that also?
No, we'll just ask you one or two questions on this.
Okay, then that's fine.
I said that, see, the thing is that Daytona and your IDON, they are relatively very expensive machines. Do you feel
IDON is not.
IDON is not?
No, it is less than 50% of the cost.
Okay. If I may just ask, what is the cost of IDON?
Around 25
25
lakhs.
lakhs. Okay.
This is the cost.
Pardon?
Sanjay?
Lakhs only.
Manoj, for 25 lakhs.
25 lakhs. Okay.
1,000, I can have, each room has one IDON.
yes.
It's a beautiful
Not
machine.
1,000.
Prashant, as
Yeah.
Manoj also said, that in his Daytona, he doesn't have much of a learning curve. It's very simple.
It's very easy in this.
Even this is
Yes.
as simple.
Very, very easy. It is much easier than Daytona. Daytona has
Yeah.
sometimes, you have to focus. Here, it is like a fundus camera. It's a tiny device, as I said. It is half the size of Daytona, half the cost of Daytona. I mean, less than half the cost of Daytona. And, all these images can be transported on your desk. So you don't have to worry about. See, what happens, Karobi, is that when you say, oh, I missed this particular phase, in a video angiography, you don't miss anything. Because right from the injection to the end, what you want, everything is there. And then what you delete and whatever. So that's why I feel that it is a
Sir,
good alternative for a poor person like me.
Actually, the thing is that here you have been able to demonstrate the fluorescein angiogram.
Differential fluorescence.
Right, so which is not possible with the Daytona, as
Correct.
Manoj told us. But the advantage of that is that it gives a 200 degrees view, which is like a superb kind of view.
This is
right?
180 degrees. I
180
went to one.
degrees, yes.
I think, Karobi, it is a hype. All these machines which are giving 200 degrees, how many times those 200 degrees have helped you? It is more for teaching. It's more
Right,
for
right.
juniors. But, every institution is not a teaching institution.
Yes.
And they don't afford this.
Have you tried
Has
in
the
pediatric
ultra wide field
pediatric-
made any changes in the
pediatric
way you treat your
patients?
patients?
It gives you more
Only for
insight.
documentation.
It gives you insight into the information. Sometimes this wide angle angiography gives me an information as to how much I should tell the patient what all treatment he is going to require. Is it only the anti-VEGFs or is it the laser? Is it how much laser? Because see, ultimately, if you show them this image and post-operative, post-anti-VEGF or post anything, you show them the follow-ups. And the patient understand. If they show him small images and a larger image, patient understand. Because see, I have one large image in my clinic, which is where I tell the patient, this is what you have. But that I cannot have individual, that is a general image showing all the diabetic retinopathy changes and all those things. But here I can immediately, patient sits on that 2.5 millimeter pupil. Now that is probably the best what you can expect. This image is coming from a 2.5 millimeter. Manoj will agree because Manoj is a rich person. You know, he's a rich guy.
Nothing rich.
He always.
I agree with you.
nothing rich or poor.
The best thing about
And Prashant, you are not far behind.
The thing is that, madam,
at half the cost. That is the advantage of Manoj.
That is very important. But madam, what happens over a period of time in a practice, you don't have a teacher to teach. These are the machines which gives us the self-evaluation and self-criticism also. You learn so many things, how many things you miss day-to-day practice, and this machine will tell you that you had missed this thing and how you were managing years together without knowing this fact.
It's a learning.
That's why these are also teachers also, not only to teach the patients and students, but they machines teaches you several times.
Yes.
I had a question to both of you. Yeah. See, the thing is that in everybody's practice, we've all had our share of tricky patients and testy patients who sort of act little irritative or some kind of medico-legal issues. Do you feel that this instrument has helped you in any way?
Yes,
in
lots. See, these are the cases which is very common.
We can record this and we can say that yes, I have recorded. It's not that you can tell tomorrow that I was not knowing this and all that. Yes, it helps you to learn and it helps you to get out of tricky situations.
See, when we come into the medical practice or retina practice, our job was to telling the same thing repeatedly and about the prognosis and outcome. Now he sees one picture and he is kept quiet.
Correct. I think we should now go to the next talk because we have been messaged that there are 2 more talks there. If you want me to finish the microperimetry,
finish your microperimetry.
Okay, I'll do that so that will be a quick thing.
If there is time, we'll take questions at the end.
Okay, 1 second.
Sir, one question only. Have you tried in pediatric patient?
No, pediatric
patient.
See, it's difficult because 2.5 millimeter pupil, you need patient's cooperation to focus. So it's not possible.
So there, Manoj scores an advantage over you.
Yes, Manoj has an advantage over me.
Thank you. Daytona has an advantage, not me.
Okay, so I will go to my next talk, which is
microperimetry.
Microperimetry. Where am I? The problem here is here. Can you see my screen now? I'll share my screen.
See you.
You can see me, so I'll go there. I have to
go to the green button, share screen.
I have share.
Yes, now we can see it.
So you can see my OCT SLO. Yes, that's it. Yes. Fine.
Just
so you can see my screen. I can go to the full screen. Yes. So this is something which again is a very something very close to my heart. When I got this machine, I didn't know what to do with it, and gradually I realized that this is something which is very, very important for understanding the diseases and its function. If you have a lesion like this and you don't know what is happening into this lesion, and you want to know what is the functional thing, and for which this machine gives you the idea as to what is the exact function of that small area. Now, I am using a spectral OCT, which has got a inbuilt microperimeter, and it is given to me free of charge, so I don't have to pay for it. And it gives me localized perimetry function of the retina at that particular spot, which I want. It gives me fundus image, which is generated simultaneously, and you can correlate between the fundus image and the sensitivity of the retina. Now, that is probably one of the best things which can happen. This is my OCT machine setup is very simple. You choose an automated pattern. You can decide whichever pattern you want. I'm going quickly because I want to go to the diseases, and you decide the duration of the stimulus, interval between the stimulus, what side of Goldman's this thing you want to use, and then you can machine setup is over and patient setup, and you can start it. Auto align the patient, auto focus, and start it. Now, how do we know that exactly the same place is there? That is done by analyzing the fundus, and microperimetry starts automatically. When you prime the patient, software will select a vascular structure close to the region of the testing what you want to do, and the selected structure will be used. Now here it is the user can select the location or the machine selects. There is a tracker which tracks the vessel, and once it has tracked the vessel, it makes a marker. So when you are testing, you can always see that the marker will always point at that particular vessel at a particular spot. That gives you the specificity and exactness of the diseases. Start the test, and if you're repeating the test, there is a repeat retest which will give you the comparison also. And when it is completed, it can be compared with any of the previous MP macroperimetry exams you have performed on the same eye, the same patient. Now here I'll just give you exam number 1, exam second time you examined, and you can compare from the database as to what it is. Now here you can see that the first exam and the second exam, you have differences in the decibel values of the retina. It gives you an idea as whether the disease is progressing or it is worsening or it is improving. All this can be done because this is an exact thing. Again, to tell the patient, this was what you were, this is what you are today, is the advantage of this. So here one example, we had a case where we had multimodal, because of OCT along attached it. You have a fundus image, you have pictures, and you have an OCT image. Now here we see that there was a large thing, and all those the MP values are 0, 0, 1, 2, or 4. So a patient has lost a lot of central vision, and you treat the patient's hemorrhages have cleared. But hemorrhages being there also, you are seeing the improvement in vision, patient is happy. So this is the biggest advantage of microperimetry, which you should practice. It's a very easy procedure if you have inbuilt microperimetry with it. You have this comparison between a pre-treatment and a post-treatment. You find that the values are changing. These values tell you, and there is a differential map also, pre and post-treatment. I think this is a great tool to explain to the patient. I had a patient, this child came to me, 12 years old, and his was blind. Parents were really absolutely devastated that their 12 years old child is blind. I did a perimetry in spite of knowing that nothing is going to come out of it. But here I found one decibel value of 10. Now, this I showed it to the parents. I said that your child is not blind totally. He still has some vision, spark of vision there. And the patient, I really made their parents very happy. And probably this is one thing which I have used and I have found it to be good. You have lesions like a choroidal nevus. You want to know whether this nevus is going to increase, whether you need to do something. And you can know this exactly by calculating the changes in the microperimetric value. MP values will change if the lesion is increasing. Now here again, you're seeing that threshold sensitivity or cystic spaces are worse. So this is where you can find it out. In age-related macular degeneration, it gives you lesser values over the degenerated retina. The thin retina gives you lesser value. And here again, few cases I'll go through that this is an age-related macular degeneration where we have done microperimetry. We have found it out that the values have gone down. The patient can be explained that, see, you're losing vision. You still have vision, but you are losing further. And gradually, this is where, sometimes a patient with post-traumatic scotomas, we can show the patient that you have lost RP cells in this particular zone. And that's why you are, though you have 6/6 vision, you have to keep a watch on it. You may develop something in after some time. So this is where post-traumatic scotomas can be mapped. Now here, we are showing improvements after treatment. This is where it has helped me a lot, that exact values are given to the patient once we have done this, and we can compare November to December, the values have increased. That means there is an improvement over time of 8 decibels. Now, this is what is very important. You are quantifying your improvement. There is a difference map which has been given between November and December. Again, find the thickness has gone down over time, again from January to May. So there is no improvement. The patient, there is no improvement. And that is where probably you can tell the patient that I have to change the treatment, I have to change the molecule, or whatever you can explain to the patient. So no improvement also is a big tool to tell the patient what is the difference, what is the important. So we have a lot of patients who had no improvement and we had shifted to the molecules. So microperimetry basically tests visual functions at precise retinal locations. SLO is used to track the retina and patient fixation. Retinal sensitivity is tested at discrete locations. It fuses the images of OCT, perimetry, and retinal thickness map. So this is what is important in this particular microperimetry, which we have been using from last couple of years. And sometimes you have found out that when you do an OCT, the inner layer and the outer layer changes. We find that if the layers are inner layer changes, the damage is much more. Thank you so much. Any questions on this?
Excellent talk, sir. I have one question.
Sure.
Have you tried in macular hole prognostication?
Yes, that is one thing which I, unfortunately, time was very short and I had to finish within time. Macular hole, especially the surrounding of macular hole, how much vision has been lost depends on the thickness or the cystic changes in the edge of the macular hole. So that, and after surgery, it's a wonderful question that Santosh, after surgery, I found that though the hole is not closed totally, it is a flattening of the thickening, a thickness has gone down, the vision is improved. I tell the patient, see, I have done this. You have, though you may say you have not improved, but you have tested, this is your test, it's your figures, and you are saying that now, because when you press it, it checks, it's like a perimeter. It values it. So the value is created by the patient. So probably in macular hole also, I have series, I have not yet, included into my talk. But I think Chaitra would have done a lot of these things because their centers keep doing a lot of new things. But I have found this to be a very good, useful tool. It can be done by your juniors or by your attendants also. It's like a perimeter. You have to prime the patient, and comparison, most important. Next time when you take this patient, you say retest, it will start the test from the same place because it already has a tracker in place. So you don't have to prime the patient again. Yes. Chaitra,
wonderful.
Yeah, I'll give you an anecdote that I went to Arvind when Dr. Kim was there and my son was taking training there. And Dr. Kim told me that, can you talk to my colleagues, my juniors, that what is the useful, because they had perimeter lying there, not used. I'm sorry, I'm revealing this, but then they have started using it. My son was there and he said, now they are also realized the value of a test, because you buy a machine and you don't use it, that doesn't make sense.
Prashant, I had a question for you.
Sure.
I wanted to know that, okay, you record that there is 8 decibels over here, or there's an improvement in the decibel value. But I would like to know, what is the correlation of the decibel value with the actual visual acuity improvement in a child when you show improvements?
It is improvement means quality vision improves. Let me tell you. Rarely, of course, when the vision had gone down to 6/60 and then the vision is improved, that's different. That automatically you understand. But if you improve on the decibel value, patient can perceive light better and he starts recognizing the figures. I don't say that unless your value is about 18 or 16 and all that, when it becomes normal, but there is a definite perception change. And it is also, as you said, medico-legally, yes, we have done something and we have shown the results. So you are safe as far as that is concerned. You didn't do some surgeries just for the heck of it. Sometimes it happens that 660 visions remain 660 post macular hole surgery. Then the patient says, what did I gain? So I said that, hey, fine, I know that you have lost the central vision, but you have regained some part of it and it's going to remain with you. So probably, yes, that is something which is more of our satisfaction that we have done a good job.
But is there any table where you say that, okay, if the person has so many decibels over here, he's going to have this much amount of vision, maybe 660 or 636?
No, it's not. It's a generalized vision. It's not like like a 8 decibel value is some spots which were -8, they became 0, or those were 2, they became 10. So that is the decibel change of that particular spot. See, in macroperimetry, you are checked. Tracking that whole area of retina which you selected. So it's like a perimetry which you keep doing all the spots. Patient keeps responding by pressing a button. That's it. If he sees it, he presses. If he sees it, then the value goes down or up. So probably that doesn't correlate with exact figures of 20/20 or 20, whatever. But it is helpful and it is easily. I don't know whether now they don't give with OCT machine, but now you have to buy a separate microperimetry.
Again, this machine can be used in pediatric patients. Suppose there's a patient.
No, a pediatric patient, very different. See, pediatric patients need an absolutely different assessment, and you do need because there are more of perceptions. When we tell the patient, I feel you're losing vision. And, nowadays we are talking about this, new molecules and all that. And when do you change and when do you give another shot? I think microperimetry tells you the lesion may be visually not changing, but if microperimetry is worsening, I can tell the patient you do need a second shot or do you need a boosting shot. Now that is where microperimetry is absolutely wonderful. That we are seeing lesion as far as our eyes are concerned, we don't see there is any change. But once we see that the microperimetry is worsening, I can tell the patient, okay, fine, you can wait for some time, but this is worsening. And when he sees 2 visits, that worsening is more, he comes back to you for the treatment.
Okay. Let's go over to the next speaker.
Chaitra, yes.
None other than Chaitra. She's back from her other meeting. Chaitra will talk to us about pediatric retinal imaging, which is her main forte.
I know, that's why I spoke before. Otherwise, nobody will listen. Nobody will listen to me.
Sorry.
Welcome
Sorry
to this seminar, and you're always great in your presentation. Go ahead.
Thank you so much, sir. Thanks, Karobi. I'm so glad you're here. So, in case I'm not around, I'm sure you can even take it forward because you're so good at this. I'll be speaking on pediatric retinal imaging. I have no financial disclosures. Right. So, to highlight, we'll be talking about ultra wide field imaging. We'll be talking about fundus angiography, STOCT in infants, and what's new in that, Okta, the new tool, and also software analysis and AI. So wide field retinal imaging, I think, has now become part of our practice. It's so easy to explain to the patient for us to visualize the peripheral retina in uncooperative patients or not dilating, and even in children, young children, they're so much more cooperative for a one-time imaging using wide field. So this is the literature that was published, quite some time ago. It was a fast track paper which spoke about the use of optos actually in these children. They use the, flying baby position here, as you can see, that is put up there, and they were able to get fairly good images of the retina. So especially of the peripheral retina with fewer number of images of the quadrant, more panoramic view that you get here. So this is another patient here, FEVR, where you can see temporal traction very well. The stalk can be seen extending up to the ora, and nasally as well, persistent avascular retina can be seen very well, which gives us an indication for treatment. So this is, again, the optos image here. This is the fellow eye showing avascularity 360 degrees, and it shows NVs also, again, indicating the requirement for treatment. So this is the angiography as well. This is the role of the fundus fluorescence angiography in the management. So let us look at these some images of this. This is a baby post Avastin and then laser done in another center. Came to us for opinion now. Is about 9 months old. You think that it looks a little quiescent, the disease, despite not adequate laser. But on closer look on the image itself, you can see some amount of fibrosis in the upper temporal quadrant. You can see a closer up look here. You can see the fibrosis there. The fellow eye too looks quite okay, seems to be doing well with regards to the stage and the disease there. And however, when we do the angio, this was done on the RedCam 3, tells us another story. You can see active neovascularization even 9 months after the initial injection, and a large anterior area that is not only ischemic but also requires treatment soon enough. And that was also seen in the other fellow eye. So it is only after careful supplemental laser and fill in the other sparsely treated areas that we were able to bring the disease to stability, and it turns quiet, and the NV also regresses. So going on to ST-OCT in infants. So this is the international nomenclature for OCT now that we use for adult retina. We are very familiar with this now. We use these terminologies. We did have switch over time, but now we're all used to using ID and EZ now. But the OCT in infants is different, and a premature infant is not born with all the layers. So here is a 37 corrected PMA baby showing OPL straightened. There is persistence of the IRL. There is ELM that is seen, but no foveal tenting because the cones are not tall enough. The EZ and the RP are there, but there's no interdigitating zone. You can't see that. Infants do not have all the layers. When do they develop, and what influence do they have on vision is therefore very, very important. So this was a paper that was published where we looked at the foveal layer morphology detected on ST-OCT, and we correlated with visual acuity in infants in the first year of life. What we saw here was that inner retinal fusion or maturation was the most important event that correlates with better visual acuity throughout the first year. And between 9 and 12 months PMA, the completion of the EZ at the foveal center positively influenced visual acuity. So again, in this, we checked all these children at 3 months of age, which did show some amount of improvement. So we can also detect subclinical pathology. So this is another paper where we looked at macular changes in early ROP on STOCT. It showed that 29% of babies with spontaneously regressed ROP have some amount of foveal edema. So we categorize these macular changes that resembled edema into pattern A and B. So this is pattern A, where you see a dome-shaped elevation similar to an adult CME, intraretinal cystic spaces, vertically high the reflective septae are there, disruption of the foveal center. Then you also see the pattern B here, where again the foveal depression is relatively preserved, but you see intraretinal cystic spaces. You see fewer and lesser reflective septae and confluent or near-confluent vacuolated spaces. So this is the pattern A before and after resolution, and pattern B again. So pattern A had complete disruption of the foveal dip and a much larger CRT. Here, despite this edema showing spontaneous regression by 52 corrected age, we found that infants had poorer visual acuity at the end of 1 year when compared to age-matched cohort without edema and without ROP. So this definitely has a bearing on the visual acuity outcome. So this was another paper with Down syndrome infants. They have abnormal foveal morphology and persistence of the inner retinal layers as well. Here again, we did a correlation with the vision. This is another paper where we presented the expanding spectrum of STOCT in pediatric patients. And we could show that the value of a handheld device in these patients is extremely important in picking up a lot of vision-threatening conditions which can probably treat on time. So this is the number of patients that we saw. Now going on to OCTA in infants, it is a difficult imaging technique in infants because it takes a little bit of time to image. They need to be a little more cooperative. So we have been doing these studies where we've been looking at infants with unexplained vision loss. Sometimes we want to image the macula. So this is monitoring the neovasculation of an APROP using OCTA. This is one of the first papers that was published using OCTA in one of the youngest subjects. So this is an APROP post laser showing a flat NV, and the FFA shows avascular retina and neovascularization. On the OCT itself, you can see superficially neovascularization. But if you go on to the OCTA, you will see deep, the NV is in the superficial layer, and the deep layer shows shadows indicating flow. And the outer layer shows the flow, and the choroidal layer or the chorocapillary shows the shadow aspect. So selective laser was done here, and post laser, you can see that the neovascularization is now regressing, and also it has gone into the deeper layers, and that was also now returning back to normal. So it is not only superficial. What we try to show here is that the neovascularization is actually a complex which can go into the deeper layers. So there's few other patients that we've been able to study, 44 Indian children aged between 5 to 10, premature low birth weight, about 25 with ROP and 19 controls. We used the Avanti 3x3 and superficial DCP, and we used ImageJ as an to analyze these images. So what is the difference between normal and abnormal? You can see the round reticular layer here, whereas it's irregular, broken, and crossing in the abnormal. So what we found here is, despite normal appearing fovea clinically, you can not necessarily assume that the vascular plexus is normal. Even spontaneously resolved ROP had foveal changes. The capillary density was reduced in ROP, and DCP may be relatively preserved compared to the SC. So this I will quickly brush through. It is now actually not really much used. We have newer software, so I'm just brushing through these slides. It helps in subclinical detection, non-invasive, it's quick imaging in an uncooperative child, and handheld devices, especially useful for supine examination, and it has helped us understanding the disease spectrum much better and manage our patients. So these are some of the images that we're using, imaging tools that we're using. Thank you so much.
Thank you so much, Chaitra. It was wonderful. I just want to know how much time it takes, and do you sedate the child or something?
No, sir. None of them. Only time we probably require sedation is when we are doing angio in the OT. Even then, it again depends on the age of the child. Not necessary. None of the OPD based we use sedation.
Okay, so even when you're getting such wonderful images of OCTA and all that, Without any movement, the patient is not moving at all.
It's difficult, sir. It's difficult.
Great.
So it's especially Octa is tough. Optos is relatively
Especially I was
easy.
interested in Octa
Yes.
because that
Octa
gives you
is tough.
lots of information and it decides the treatment modalities also. Wonderful, great job, and then keep doing.
Thank you.
Chaitra,
Yes.
if you could just detail out, close that door, please. If you could just detail how you all manage to do it in these children, like what are the special precautions that you take, or the special kind of uh, arrangements that you make, for seeing these patients, the Octa in these patients.
Nothing specially, Karobi. It all depends on the age of the child. If the age of the child and the cooperativeness is pretty good, the child just sits like anything else because we don't have a handheld Octa. We're using our Avanti machine. The child is positioned there. The reason why we don't have a very, very large cohort, unlike for other imaging devices, is because it's a difficult examination in the children. Even the slightest movement, we don't get very good images. So it's a routine like how we image adults. Only when children cannot sit, they either seated on a parent or we use the flying baby position.
And you use a speculum as well?
Yes. Sometimes, not for all patients, again, only in uncooperative patients.
You feel the handheld device gives you lesser resolution as compared to the normal when the patient is sitting in front of the machine?
A handheld, which device? The Octa we don't have.
No, even the fundus imaging and all that, what you do with for ROP.
No, sir. So handheld is only now.
Blurred and always,
I think our technicians have been doing so many images. They're pretty good, sir. They get very good SCOCT images also.
You have dedicated technicians doing it. We hardly do.
Prashant, it is like this, no? The handheld devices require a little bit of learning, I mean, there is a learning curve definitely to it. Whereas these machines, it's easier to do it. I mean, the thing is that, of course, if you have a machine which is photographing it in one shot, it's much easier than using a handheld device, because there you have to have that exact adjustment of the distance. Then there should be no movement. There is a lot of adjustment which is required for that. And the same thing, I mean, we didn't have recourse to a red cam, but we used to do it on the fundus camera. And there also it is like, as easy as doing a fundus photograph. Of course, it's not wide field, but the thing is that there only the positioning of the patient was very important, where somebody trained had to hold the patient, had to hold the rump of the baby and the head and position it in front of this. And I used to always use my sugar pellet to.
I have started using it. Karan.
Oh, very good.
It's a beautiful thing. You have a string and you put it into the patient. The patient is very quiet. Yes, are we having the last talk or we are not having that?
No, I don't think Siley is there.
Okay, so is there any other input?
Question.
Let's decide, Chaitra. You have every machine, but I think we have to give a message that what is the best wide angle system a person can have at the lowest cost?
So that's a tough question, sir. Because, I'll tell you why. Because each center or each person's requirement is very different. But given the fact a lot of smartphones are giving very, very good, wide angle. So I think any of the newer devices, smartphone based for a single practitioner with those wide angle lenses are more than adequate. Because see, it depends whether it is for documentation, whether it is for publication, whether it's for a presentation. So it's a very wide, question in the sense that, of course, because we're a large institute and our turnovers are much better, our ROI will therefore be good enough. We have gone in for the optos. But I think the Claris is good, the IDON is good for centers, which have a large. I think
Claris and IDON, they make up for whatever they lose in cost. Thank you so much. I think we are finishing in time.
One last question.
One last question, Santosh, then we close.
Yes, Santosh.
Do we have to dilate each and every child?
We have to.
Necessary?
Yes.
We have to.
Yeah, so optos is not a requirement, sir. But if we dilate the patient, the image quality, the artifact is much, much lesser. But even in non-dilating pupils, even in K-Pro patients, through optos, we've got extremely good images, at least up till the mid-peris. Recently, I got a K-Pro patient done. It's like, 2 or 3 millimeters, beautiful image.
Chaitra, you have any senior citizen programs for in your institute?
We
Thank you so much. It was just to stimulate you for your next talk. Thank you so much. I hope your daughters are doing great. Thank you so much.
all good, sir. Thank you.
Chaitra, I just wanted to ask you that you mentioned
Yes.
these two kind of patterns, how much of time does it take for resolution? 6 months or 1 year of the
We've
patterning
seen 6
and
months to a year, Karobi. At least
That's the
6
time.
months to a year. We've had a serial follow up, and a lot of it we've even gone back and seen retrospectively. It takes 6 months to a year,
Okay.
but it does not translate into actually visual acuity.
True.
The
That's
rapidity of
something-
resolution does not correlate.
That message should go down, because basically everybody expects that you're treated and patient's vision should improve. There is,
Thank you all the speakers for the
Thank you so
wonderful
much.
session
Thank you very much, everyone, for
discussion
Thank you.
and the
Thanks,
lovely
Chaitra.
document.
Thank you, Santosh, Karobi, especially
Wonderful
to you.
session.
And it was a
Thank you,
wonderful
everybody.
session. I learned a lot. Thank you.
So did
Thank
I.
you very much. Thank you.
Over to
Thank you,
Swapnesh for
everybody.
continuing. Okay.
Yes. Bye-bye.
Bye.
Bye. See you.
See you in real meeting soon.
Yes.
Yes, soon in it.
Chaitra, you can run back.
Okay. Bye.
Bye. See you. Bye.
Dr. Chaitra, I'll keep messaging you.
No, so next session is starting right now, no, Sapnesh?
Yeah,
you're
in the
not
same-
then? You want to take up the first talk?
Yeah.
You think if it's okay, in 2 minutes I'll be ready with my next talk.
Kasavade sir,
You think I can?
Yes, I can. Bye.
Kasavade sir, please.
My talk is ready. No problem.
हमारा
No.
on-site meeting चल रहा है बाहर.
Yes.
Kasavade sir, let
Yes.
Dr. Chaitra finish her talk.
Yes,
Because she
sure.
has to attend the-
Okay.
Dr.
Yes,
Manish,
continue, madam.
yeah, we'll just wait for Dr. Manish to chip in. Dr. Malpani can introduce.
Yes, Swapnish.
Yeah, Dr. Manish will
Yeah.
start. It's 10 o'clock.
Okay.
Dr. Chaitra is presenting the first talk. Instead of
Yeah.
Dr. Ashwin Bafna, there's another speaker. I'll just text you her name.
Okay. I'm actually loading from my mobile
No problem.
because, can you send it on another, my second contact?
Yes.
Yeah.
Sure. Dr. Anupam sir, can you introduce the session, and then Dr. Bapai can take over and invite Dr. Chaitra.
Yeah, good morning, everyone.
Good
Am I
morning, sir.
audible now?
Yes, sir.
Good morning, Malpani sir.
Good morning. So we are at an interesting topic now in diabetic retinopathy, which is a very practical topic and of great importance to everyone, retina surgeon as well as general ophthalmologist. So I think we'll be starting since we are in time. I invite Dr. Chaitra to speak on OCTA in diabetic macular edema.
Thank you, Moss, for this opportunity. Pleasure to be here. I will start off with my presentation, and also thank you for letting me speak first. I have another meeting. Right. Is my presentation visible?
Yes, Chaitra, please go ahead.
Yes, sir. So my topic is basically on Octa biomarkers in DME. I will be covering that, and just a slide or two on OCT as well, because I think we use it a little bit more often. So why is it important? Why are we treating diabetic macular edema? It's the most common cause of blindness in people in the productive age group now. That's very alarming and worrying. It can develop in both type 1 and type 2 diabetics, and about 8 to 13% of the diabetic patients develop DME with vision impairment at some time in their disease course. So the DME prevalence after 15 years of diabetes was 20% in patients with type 1, 25% in type 2 diabetes taking insulin, and 15% of patients in type 2 diabetes not taking insulin. So this is, significant numbers. This is an old study, but I'm sure the percentage is even more now because our population with diabetes itself has increased. So initially, we relied basically on fundus photography, clinical examination, where we classified into mild, moderate, and severe DME. And then we had the ETDRS, classification, where we looked at clinically significant macular edema. Then we have the angiography itself and the OCT, where we looked at the microaneurysms, the patterns of hyperfluorescence. We look at the macular ischemia using these two. So why do we need a biomarker? Because there are no methods to prospectively determine which patient will gain or lose vision. We don't have anything like that. We can't look at an OCT and we can't tell a patient that you're going to need 10 injections, you're going to need 5, you're going to need laser, you're going to need injection. How do we tell them? Because that's the first question. A patient walks into the OPD, sees their OCT, knows that they have a problem. The first question, how many injections will I need? So we need to individualize the risk assessment based on whatever we are able to examine and image. We need something that's non-invasive, that's readily obtainable, because a lot of them are expensive, they are time consuming, the patient needs to come again and again. And therefore, these imaging biomarkers can help at least personalize treatment based on what patterns they have. So this is the SDOCT we're all used to looking at. On a day-to-day basis for our patients with DME as well. We look at the retinal structural alterations. The ultrastructural is now visible with high resolution. We're even able to see the choroidal changes and correlate it with the macular abnormalities. We're able to look at vitreomacular interface changes so that we can plan treatment, surgical or medical. So just to cover OCT biomarkers that predict visual outcome, you have to look at the parallelism, the presence of SRF, the ISOS continuity, the EZ, the ID, the HRF, or the hyperreflective foci again helps us in plan which treatment we want to give. Looking at an attached vitreoretinal interface, hyperreflective material and where it is located, whether, within the cyst itself also can denote not a great prognosis. And what is the configuration of the intraretinal cystic spaces? Now, going on to OCTA, which is the topic for the day, we know this is how the patients So looking at diabetic retinopathy without edema, this is imaged even before any edema develops. The FAZ is already altered before we are able to see any clinical changes. Okay, so this is another patient where you can see superficial plexus and the deep plexus, where we are able to very well correlate the FAZ. You're able to see the microaneurysms. Forget the NVD, just looking at the configuration itself, we are able to correlate the FAZ changes along with the angiography. I'm just showing you some clinical examples so that we can see how well we can correlate. Now, this is a paper that we published in IOVS special issue of 2016, where we looked at how the progression occurs across mild, moderate, severe, and PDR. So you can see the dropout areas. We used our own software to analyze. You can see the vascular density decreasing. You can see the increase in the areas where there is non-perfusion as the severity of the disease progresses. Macular ischemia on FA and OCTA also has shown a very, very good correlation. It is easier to perform the OCTA. It takes lesser time, time-wise, I would say. Of course, the image quality depends on the media, depends on the patient cooperation. The most challenging thing about OCTA is when you have to do the segmentation manually to get a little more information than that is given automated. So between the images of the angiography and the OCTA here again, you can see very, very good correlation between the FAZ borders. Now, again, here another patient where you can see increased FAZ capillary rarefaction, as I mentioned before, and you can see more microaneurysms in the DCP than in the SCP. So diabetic retinopathy with macular edema, sometimes the images are not really very great. You can see an altered FAZ in both the superficial and the deep capillary plexus. The corresponding en-face, we tend to ignore the en-face, also shows well demarcated zones of edema, which are correlating along with our SDOCT. This is again a patient with diabetic retinopathy and macular edema. I just showed you the well demarcated zone of edema. Now, with response to treatment, where between good response and poor response DME, you can see more microaneurysms. You can see a larger foveal avascular zone and lower vascular flow density. So these are some things that we need to see. And they are particularly seen when there is a poor response to DME. This is again well delineated on OCTA. There's also good correlation between the OPL and the DCP that you can see, when you're using both imaging devices. A disrupted OPL and DCP non-flow areas actually correlate. Intraretinal cyst communication between the inner and outer nuclear layers also correspond to non-flow areas on DCP. So now going on to the superficial and deep summated plexus, the greatest absolute difference in the FAZ area between the visits was seen in the deep plexus using both automated and manual methods. So this is something which shows that the automated may also be quite reliable. So what are the difficulties on Octa and DME? Differentiation and segmentation, like I mentioned, is difficult. Projection artifacts are there, especially when you have hard X-rays, when you have dense hemorrhages, it is difficult. There could be misleading features on Octa when there is edema and hard X-rays due to these artifacts. So to conclude, prospectively, they help us determine which individuals will respond to the available treatment. They assist therapeutic selection and reduce the impact of invasive and burdensome treatment for our patients. Thank you so much.
Thank you, Chaitra. That was excellent talk. That gives us overview of Octa in DME. This is a new modality which has come in and not yet well known to a lot of people. So as more and more acceptance develops, like with OCT, we'll get to learn more about it. And there's an excellent overview of the Octa in DME. Thank you so much.
Thank you, Manish. Thanks for the opportunity. I request to be please excused. I have another meeting on site going on.
Yes, so we understand. Institute. We understand. Yeah. Thank you so much for joining.
Thank you. Pleasure. Thank you, Dr. Saket.
Thank you, madam.
Yeah. Over
now
to,
the next.
Over to Dr. Sasode. Nice, sir. You please take over. Sir.
You will be moderating. I will be presenting.
Yeah, no, go ahead, sir. I think tumcha's pehla talk hai, so please go ahead with your talk on multimodal imaging in DME.
Yes. I'm sharing my screen. Is it visible now? Yes.
Yes, sir.
Yes. Thank you very much. Thank you, everyone, for giving me the opportunity to speak on this topic. As Chaitra has elaborately given the importance of diabetic macular edema in cases, we know that this is the most mysterious conditions because of few facts about the diabetic macular edema, which one should know, because this is a chronic and progressive disorder, more prevalent than fractional detachment as well as vitreous hemorrhage. There is a loss of quality of vision and difficulty to manage the diabetic macular edema is the most challenging, and it is always, most of the time, it is refractory and causes a frustration to the patient and surgeon also, because these cases occurs in a very executive type of people who wants to read and write and enjoy the life after retirement. The fact about the diabetic DME is the pathogenesis is not exactly known, but it is a response to the hyperglycemia. Hyperglycemia, prolonged hyperglycemia, and years together hyperglycemia can cause a free radicals release, PKC, AGA, and which leads to hypoxia and ischemia. There is a state of inflammation and liberation of VEGF, and there is alteration in the vitreomacular interface also. So we know that diabetic macular edema is now said to be as a chronic inflammation, which induces the state of low-grade inflammation. There is a breakdown of blood-retinal barrier, capillary occlusion, and tissue ischemia. In response, there occurs the edema. And after invention of the OCT in our practice, altogether the management has been changed. The objective, and we know that the OCT measurement of more than 300 micron or visual acuity less than 6/9 is the main criteria nowadays to treat, and OCT guided treatment is the mainstay of treatment, which helps really in diagnosis as well as the treatment and follow-up cases. The goals of the treatment in the diabetic macular edema is to reduce the amount of macular edema, to reduce leakage on angiography, to reduce the thickening on OCT, and to improve or stabilize the existing vision. Apart from this local treatment, we should know that there should be a good glycemic control, good BP control, lipidemia, and kidney disorders also should be managed well. In diabetic macular edema treatment, why it is required multimodal? Because I say standard of care is a laser treatment. Still, we need a multimodal because substantial group of patients do not respond to the laser because of new insight in the pathogenesis. We know that the VEGFs and chronic state and various markers which have been liberated by biological inflammatory markers, the newer treatments has been coming. And we know that the one treatment is suitable for one patient, while the same treatment is contraindicated in other cases, like in VEGF is not relatively contraindicated after stroke or after myocardial infarction. And DRCR study has shown us the various results of the anti-VEGF treatment in first year, second year, and third year, and up to the 5 years. How many injections are required and what is the outcome. So we'll also see that. So various types of modalities available are either in the form of anti-VEGFs, ranibizumab, Avastin, and nowadays Peginex as well as Eylea. Then laser photocoagulation can be red, green, or yellow, or micropulse. Then another modality is steroids in the form of Ozurdex or intravitreal or subcutaneous. And then if it is last treatment is a surgery, if it is associated with ERM with the diabetic macular edema. We know that the ischemic maculopathy is one of the things. There can be a division of maculopathy can be divided as a ischemic maculopathy, then focal maculopathy, then mixed type of maculopathy, or diffuse type of diabetic macular edema. If it is a focal maculopathy, we know that the focal is around an microaneurysm, and if you treat that microaneurysm with the laser, you get a good result. And here you can see that the good results after the laser. And but there are some limitations to this one. If the microaneurysms are very close to the fovea, or if they are in the papillomacular bundle, you can't do the heavy lasers in those cases. Then another modality and type of diabetic macular edema comes in a diffuse type of macular edema, which is invariably associated with the systemic uncontrol of the diabetes, as well as hypertension, cholesteremia, as well as the renal diseases. In those situations, first you have to manage with the anti-VEGF and then do the laser, and again you have to keep on giving the injections. Till you get the resolution, you give the anti-VEGF, and once it is there, then you can go for the combined treatment like anti-VEGF plus laser, or sometimes you have to add steroids also. And you can see the good results with the anti-VEGF pre and post treatment. You can see here also, you can see that the sponge edema has been reduced drastically within weeks after giving the anti-VEGF injections. This is a pre and post eccentric injection. But in one thing one should understand, over a period of time, if you are practicing as a retina person, the patient is loyal to you years together, and he is suffering from maculopathy or diabetic retinopathy, then it is your decision making power or your assessment which gives you what is to be used and when it is to be used, when to use laser, when to use anti-VEGF, and when to use steroids, or when to use combined therapy. These are also one of the pictures which is pre and post treatment or eccentrics. But if there is a ERM, you cannot give the get the good results after injections. If it is diabetic macular edema is associated with PDR, then the anti-VEGF is the first line of treatment. That is how it is a multimodal. If it is associated with renal retinopathy or hypertensive, then anti-VEGFs are the first line of treatment. Then newer insight, because of the inflammatory nature of the diabetic macular edema, the steroids have come into the pictures. And you know that there are various types of steroids and their relative potency. Here it is shown. The dexamethasone is 25 times relatively potent. And while the steroids, why steroids, and what is the difference between anti-VEGF is that anti-VEGF will act only against the VEGF, while the steroids acts against many inflammatory markers, including the VEGF. That's why steroid has an upper hand. But there are side effects of steroids. This cannot be given in cases of relative indications, contraindications in glaucoma, as well as it can progress to the cataract. And in an doubtful infection, it cannot be given. If it is a SMD, or in case there is intraretinal hyperreflective spot, that shows that it is a inflammatory type of disease or diabetic macular edema, then Ozurdex gives you the good results. And this is also pre-Ozurdex and post-Ozurdex. This is another picture of pre and post. If a patient is not affordable, you can give the anti-IVT also. And in cases particularly post-op, you have to think of pseudophakic macular edema also. And this is a post-eccentrics, and this is a case of post-Ozurdex. If there is a ERMs and there is a cystoid macular edema with traction on this one, then you have to think of the surgeries. And then in cases, whatever you give, anti-VEGF, steroids, or whatever, the rebound edema is a rule. And that is depending upon what type of edema you are dealing with. Particularly if it is a diffuse type of edema, systemic control matters more. So rebound edema is to be kept and periodic follow-up is required. In certain cases where there are hard exudate crystal beneath the macula, no treatment works. In such cases also, most of the times all treatments have been done, but because of uncontrolled systemic conditions, the treatment is failed. There are certain cases with like a mixed type of maculopathy. In those cases, you can try each and everything and keep on trying, and one fine day you may get a good result. So in conclusion, it is a diabetic macular edema is non-preventable, or there is no complete cure so far. Focus should be on early detection and treatment so that the patient's vision can be at least stabilized. Good communication, all concerned healthcare persons is very important, that include the ophthalmologist as well as diabetologist, to understand the physical and psychological stress of visual loss of because of diabetic macular edema should be understood, because there is a fear and anger on the part of patient because he is taking several times treatments in all forms, but the vision is not improving. So it is your wise and judicious selection of available modality and suitable combination can save the patient's vision and get the good results. Thank you very much. Thank you, Manish.
Thank you, Dr.
Manish.
Sasode sir, for your excellent talk as usual. It gives overview of not just medical side, but the practical side of diabetic macular edema, which we all know is can be such a frustrating disease to treat. Now, I would like to invite Dr. Anupam Malpani sir to talk about, give his talk on anti-VEGF in diabetic macular edema. Dr. Malpani sir, over to you.
Is my screen visible?
Yes, sir. Yes, sir.
Yes, sir, it's visible.
Yeah, at the outset, I'd like to thank the scientific committee of MOS for giving me this opportunity today. So after an excellent overview by Dr. Manoj, I'll be speaking on the specific of role of anti-VEGFs in diabetic macular edema management. I have no financial disclosure to make. So we know that laser is the gold standard in treatment of diabetic retinopathy, and ETDRS way back in 1985 had shown that when focal laser is done for DME, it doubled the chances that the patient would not experience significant loss of vision as compared to observation. However, it also showed that only less than 3% gained 15 letters at 3 years, indicating that the laser in DME probably only helped to maintain the vision, but did not give improvement in vision. Also, it cannot be used in leaks within 500 micron of fovea. So because of these drawbacks, in 1990s, there was a surge of interest in angiogenesis research in ophthalmology. And this was one of the earliest publications showing the role of vascular endothelial growth factor in diabetic retinopathy. At present, we are well aware that VEGF-A is responsible for angiogenesis and vascular permeability, and this forms the rationale for the anti-VEGF treatment. These are some of the common anti-VEGF agents in clinical practice that we use routinely for treatment of various vascular diseases. So there's a wealth of level 1 evidence supporting the efficacy of anti-VEGF treatment in diabetic macular edema. You can see a long list of trials, phase 3 trials, some of which have been extended to 5 years or more. And all of them have shown that anti-VEGF agents give a clear benefit as compared to observation, laser, or even steroid in the form of triamcinolone. And these trials have been done in various combinations and different ethnic populations, showing good results. Now, Protocol I was one of the earliest trials done by DRCR-NET, and it to see various treatment modalities in diabetic macular edema, and it has shown that those patients in ranibizumab group had the best visual outcome as compared to laser or triamcinolone. And it was also seen that in the ranibizumab group itself, those patients who were treated with laser at a later date, that is deferred laser group, had a better outcome as compared to the prompt laser group. Another interesting thing noted was that the need for injection reduced over a period of time from an average of 8 to 9 injection in year 1 to almost 0 in year 4 and 0 in year 5. Similar results were also seen with aflibercept. But in aflibercept, another interesting thing seen was that a significant more number of patients had more than 2-step improvement in diabetic retinopathy severity score as compared to laser, indicating that probably anti-VEGF could also alter or reverse the changes of diabetic retinopathy. And this has been studied in protocol W of DRCR-NET. Let us look at a clinical example. Now, this patient had come with bad diabetic macular edema, poor vision of 636 N18, received one injection of ranibizumab, had improvement in vision and decreased edema. And after 2 injections of ranibizumab, you can see the normal foveal contour and improvement in vision to 6/9 and 6 part, indicating that the anti-VEGF works not only in trials, but also in real world situations, as we have all experienced. So we'll try to answer some important and practical questions in the use of anti-VEGF in DME with the help of the various trial results. So first important thing is when to treat the patient. In non-center involving DME, we all know that laser is the best modality of treatment, and it's a no-brainer. But with center involving DME, laser cannot be done. So here we can divide the patient into 2 subgroups, those with good vision, that is 20/25 or better, and those with moderate to severe vision loss. And protocol V of DRCR-NET tried to answer this question of use of anti-VEGF in those with good vision. They divided the patients into 3 subgroups. One received anti-VEGF, the second received laser, and the third was treated with observation only and no treatment. So it was seen that at 2 years, the patients with more than 5 letter loss was same in all the 3 subgroups. At the same time, at 2 years, those patients who had more than 5 letters gain also were same in all 3 subgroups, indicating that among the eyes with center involving DME and good vision, there is no significant difference in loss of vision at 2 years, whether they will manage with an anti-VEGF in the form of aflibercept, laser, or with observation, and recommended giving anti-VEGF only if the vision worsened. But we all know that various trials have shown that those with moderate to severe vision loss or with moderate to severe macular edema, they do very well with anti-VEGF agents. And in these patients, anti-VEGF agents are recommended. The second thing is to remember is one should treat early, because the trials have shown that if patient in laser group are in the patient in laser group, whenever they are shifted to ranibizumab treatment at 12 months, they will show improvement in vision over a period of time. And at 24 months, you can see there's hardly any difference between the treatment arm and the crossover arm. Whereas in Rise and Ride trial, when the same thing was done, but at a gap of 24 months instead of 12 months, the sham treated group had improvement in vision, but there was a significant difference between the crossover group and the treatment arm, indicating that probably delay was responsible for poor visual outcome. Now, important question of which anti-VEGF is preferable was tried to be answered by protocol T of DRCR-NET. Here, the patients were randomized to 3 groups. One received bevacizumab, second aflibercept, and third ranibizumab. And it was seen that at 2 years, the number of patients having improvement vision was almost same in aflibercept and ranibizumab group, but was a little less in bevacizumab group. However, when a subgroup analysis was done, it was found that those patients with poor vision, that is 20/50 or less, in them aflibercept gave a much better result as compared to ranibizumab, and bevacizumab had the least improvement. But when the patient's vision was relatively good between 20/30 to 20/40, all these injections, they had almost equal effect, and any of them can be used. Now, how to initiate the treatment and for how long? This question was tried to be answered by Luminous study, which showed that when patients were given a loading dose of 3 injections at monthly interval, then the patient with those group of patients in the loading dose group had a better visual gain as compared to those without loading dose, although the number of injections in both the groups were same. So it is recommended that one should give at least 3 to 6 injections, but one can defer injection if vision is 20/20 or better and OCT is normal, or visual acuity and OCT is stable for 2 consecutive injections. Now, important thing is how frequently to give. Now, we know that probably monthly injection will give the best outcome. However, this is not practically possible because of the cost and the treatment burden. The other option is a PRN, which again has a lot of visits. So one can try to use a treat and extend method, which combines the benefit of both and individualize the treatment on patient's need. Here, the treatment is initiated at monthly maximum vision is achieved and no sign of disease activity, when the treatment is then extended and the patients are called at around 1 to 4 weeks and treatment is given till there is a recurrence. So the retained study have shown that the visual outcome with treat and extend is almost same at 12 months and also at 24 months if you compare with the PRN treatment group. However, the number of visits were reduced by almost 40% with the treat and extend regime, reducing the treatment burden on the patient. So to summarize, currently anti-VEGF is the first line of treatment in center involving DME. Observation only is recommended if vision is very good, that is 20/25 or better. All anti-VEGF agents work equally well, except when vision is 20/50 or less, where probably aflibercept has an upper hand. Injection should be given early and in sufficient numbers. This is very important. A need for injection decreases over time, and individualized treatment in the form of treat and extend may be preferable. Thank you for kind attention.
Thank you very much.
Thank you, sir.
Yes.
Thank you for excellent talk of anti-VEGF. It's a pretty daunting task to trying to figure out how many injections would patient need, and frankly, we still cannot do it. But these give studies which are extending over 5 years give us broad guidelines which we can tell the patient that this is how the treatment might pan out. Excellent. Thank you, Dr. Malpani, for excellent presentation. Next is Dr. Amruta Kumbhar. She will be talking about diabetic vitrectomies. She is vitreoretina consultant at JJ Group of Hospitals. Dr. Amruta is there?
Yes, sir. Good morning to all colleagues and seniors.
Malpani, sir, please close your...
Yeah, I'm trying to do that. It's not showing here.
So you have to stop screen share.
Yeah, but I'm not getting that stop share thing.
Because it is full of loaded with so many studies.
Try and minimize your presentation so you might get it.
Yeah, I've done that also. Maybe I'll log out and then log in again.
Okay, sir.
One second, just give me one.
Yes.
So is it
Amruta, you
visible,
can
sir?
share it. Yes,
Yes.
it is visible.
Good morning to all the colleagues and seniors, and thank you, MOS, for the opportunity. So today's topic is vitrectomy principles in PDR cases. So diabetic retinopathy is a leading cause of irreversible blindness. Pathophysiologically, there is an interaction between various angiogenic and pro-inflammatory mediators, such as vascular endothelial growth factors, which leads to fibrovascular growth. If this is not controlled, it leads to further complications such as vitreous hemorrhage, fractional retinal detachments, combined RDs, membrane formations, and vitreomacular tractions. So here are some of the PDR cases: preretinal hemorrhages, NVEs, traction with FVPs. Now, indications for vitrectomy in PDR: it is non-clearing vitreous hemorrhage, subhyaloid premacular hemorrhage, tractional defects such as TRDs, threatening macula, combined rhegmatogenous and tractional RD, progressive FVP despite of adequate laser, epiretinal membranes with vitreomacular traction, and complications of previous vitrectomy surgeries. Now, objectives of vitrectomy are removal of axial opacities, relieve the anteroposterior and tangential traction, segmentation or peeling of the epiretinal membranes, affecting the hemostasis, closure of all the breaks, 360 degrees endo laser, tamponade if necessary, and managing the complications. Now, vitrectomy procedures is a surgery to remove all the vitreous from the eye. Microincisional vitrectomy surgeries are nowadays preferred, which uses the small probes such as 25 or 27 gauge probes with transconjunctival sclerotomies. The advantages of small probes is good dissection of the membranes with less or minimal trauma to the retinal tissue, self-healing sclerotomies, and less post-operative inflammation. 25 gauge combines the benefits of both 25 and 27 gauge. There are the infusion cannulas which are shown, which are used to maintain the globe during the surgeries. Now, illumination systems which are used are two types. First is 3-port vitrectomy, which uses a standard endo illuminator. 4-port vitrectomy or the bimanual approach To dissect the membranes, it uses the 25 gauge microfiber filament, which is also known as chandelier, which is shown in the picture. There are a few instruments which are used for the membrane peeling and cutting of the adherent membranes, such as ILM or ERM removal forceps, vertical scissors, diamond dusted membrane scraper to removal of the PVD, then extended endo laser probes. Dyes which can be used are triamcinolone acetonide for vitreous staining, which also acts as an anti-inflammatory mediator, anti-inflammatory. Brilliant blue dye for staining of the ILM. Tamponade, it is used whenever necessary. It is used in cases of revitrectomy, vitreous lavage, recurrent vitreous hemorrhage, combined RDs, and iatrogenic retinal breaks. Tamponade used is air, 14% C3 effect, and silicone oil. The vitrectomy procedure, there are two types. If PVD is present, the opening is made in the posterior hyaloid, and subhyaloid blood is aspirated with the help of cutter or the silicone tape cannula, is shown in the picture. But in some cases of the TRDs or the excessive fibrovascular traction, PVD induction should be avoided. Specifically, when the tractional membranes are at the posterior pole, do not induce any PVD. Create an opening in the posterior hyaloid face in a circular fashion, and then address the membranes. Membrane removal strategies are three types: segmentation, which cuts the bridging tissue between the foci of fibrovascular adhesion; delamination, connection between the posterior hyaloid membrane and ILM is cut; en bloc dissection, removal of vitreous and membrane as a single unit. Here are some pictures which shows the segmentation, delamination, and en bloc dissection. Whatever the fibrovascular tissue which is firmly adherent to the disc, it is reduced with the help of vitreous cutter, and small amount can be left at the disc. Then in combined detachments, where there is a SRF with rhegmatogenous and tractional detachment, start the dissection distant from the detached retina. Preparation of the tissue from the center to periphery is advisable. Perfluorocarbons can be used to stabilize the posterior retina. Peripheral retinectomies are needed for resurgeries and where the anterior fibrovascular proliferation has developed. Some of the complications post-vitrectomy are post-op vitreous hemorrhage, which is the most common complication, NVI and NVG development, cataract, fibrinoid syndrome, anterior hyaloid fibrovascular proliferation. Post-operative vitreous hemorrhage is a common complication. Early is within 4 weeks and late is after 4 weeks. So how to prevent this? Careful dissection of the fibrovascular membrane with the full hemostasis with endocautery during the surgery. Intraocular tamponade with C3F8 or silicone oil in recurrent cases. Preoperative intravitreal anti-VEGF for fluid neovascularization and membranes. If it clears spontaneously, then most of the cases it clears spontaneously in less than 6 weeks. If it does not clear in more than 6 weeks, vitreous lavage with tamponade is recommended. Fibrinoid syndrome, breakdown of blood retina barrier with release of fibrin, which causes TRDs, pupillary block, ciliary body detachment, hypertony, and NVG. Treatment for this is topical steroids, PST, TPA injection in anterior chamber, revitrectomy with tamponade. Anterior hyaloid fibrovascular proliferation, which develops at the vitreous base, anterior retina, ciliary body, lens capsule, iris, with NVI, NVG, and TRDs. Treatment for this is lensectomy, cataract extraction, anterior dissection with retinectomy whenever necessary, extensive cryopexy or laser, and preoperative anti-VEGFs are helpful in some of the cases. Thank you.
Thank you, Dr. Amruta. That was a very nice talk about principles of diabetic vitrectomy. Now, we can, do we have Dr. Supriya here? Dr. Supriya will be talking about diabetic vitrectomies and sharing her experience about it. She is a consultant head of department of vitreoretina at Dr. Mohan Rajan's eye clinic and VHS at Chennai. She is from Mumbai and ex Aditya Jyot fellow and consultant. Dr. Supriya, over to you, please. Can you?
Thank you, Dr. Bapai. And I'd like to begin with thanking all the MOS scientific committee for kindly remembering me during MOSCON and letting me be a part of the panel. Dr. Amrita has made my talk very easy because she's dealt with all the theory of vitrectomy for diabetic retinopathy. So I'm going to begin it's a video presentation. It's a video presentation, so just surgical videos. So this is a 23 gauge vitrectomy, and as Amrita said, don't try and induce a quick PED. Do it in a graded manner and try and lift, make a cleavage around the disc and the retina with your cutter or a forceps, and do it in a graded manner. So this is the cutter being used to elevate the posterior hyaloid from its attachment to the disc. Luckily, it's not very vascular. As you can see, a lot of the retinal photocoagulation scars in the periphery. So that has made it relatively avascular. And then you can deal with the areas of focal points of traction where the hyaloid is adherent. Once the disc and macula is clear, then you can go on and trim the other FPPs. In the second case, it's a much vascular disease as you can see. And here we are raising the hyaloid with the cutter itself. This is the rollback technique where the hyaloid itself, the vitreous itself falls back, the membranes fall into the retina. With the cutter itself from the disc, we are using it for traction, and then with forceps, we are able to elevate it. So it's a combination of delamination and segmentation. This is en bloc resection. We are removing the whole membrane, and it's a dynamic state where we are using bits and parts of all the theories. Cautery is being done to attain avascular, to attain hemostasis. This is another place where we are using a cutter itself. The cutter itself is going between the posterior hyaloid and the retina. As a blunt dissection, it's going ahead, and because the cutter tip is, the port is much closer to the tip, and hence it makes it much easier for us to introduce the cutter below the membranes. Also, because of the beveled edges that we're getting in the cutters nowadays, the high cutting rates also make sure there's no traction on the retina. So we can also do something called a hybrid vitrectomy, where we are using 23 in some bits and 25 in some bits. Here you can see some segmentation being done, and you can see a large vessel there which is going to bleed, and now we're doing cautery to that blood vessel and trying and achieving hemostasis there. So again, the cutter is being used as the main instrument. This is another case where we are trying to delineate it from the disc and try and form cleavage points here. And sorry, that's my overzealous son there. And so the cutter and the forceps are able to, if it's closer to the disc, we can do a posterior to anterior delamination. As you go to the periphery, sometimes the membranes become more taut. So here the forceps is being used to elevate it, and then with the cutter we are able to go beneath the membranes and towards the retina and then segment it. So achieving hemostasis is very important. You can see the bleed on the side there. So you can either increase the bottle height or increase the intraocular pressure. Sometimes, as Amrita said, PFCL can also be used, but it's important to keep an eye on that intraocular pressure, because in these diabetics already the optic nerve is quite compromised. So you don't want to go ahead with a well-attached retina but a pale disc at the end of surgery. Sometimes it makes sense to leave some tips of not go ahead and relieve the entire traction, but leave some amount of the fibrous tissue, because that also acts as a tamponade on the vascular bleeds. This is a patient who had a very thick fibrovascular membrane with a CRD, and we're trying to use a cutter, but then realized bimanual dissection is a much better option. So chandelier has been introduced that leaves both your hands free, one to lift the membranes and then the cutter to go ahead and cut it. So it's important to realize early on in the surgery when bimanual dissection would be a good option and to go ahead with it. So that gives you ample time. Otherwise, by the time you realize it's a complicated surgery, it would help to have both the hands free. You may be a little later on in the surgery with corneal edema. So choosing it earlier on helps. And now the rest of the membranes are being dealt with in the usual manner. So here you can see the cutter comfortably going below the membranes and dissecting. So this is where we're trying to lift. So sometimes it looks very tough, but as you can see, the membrane comes off very easily. It may be just a very loose adherence in the posterior pole. So we're clearing that and then going on anteriorly. So here also the retina is not very sticky. I mean, it is sticky, but it's not tightly adherent. And so we're able to lift the entire hyaloid and go ahead with the cutting. Here the vitreous is rolling back again into the cutter tip. And sometimes it's okay to have some minimal bleeds during surgery and not cauterize every bleed that you see. This is a patient who had dense astroid hyalosis with PRD in the background. So in astroid hyalosis also the vitreous is very sticky and adherent. So that makes your surgery doubly complicated. And here you can see the cutter nibbling. So the high cutting speeds have decreased the sphere of influence, allows us to go very close to the retina. We're having 10,000 cutting rates, 25 gauge, 23 gauge. So 23 is a good balance between 25 and 20, which is more rigid, helps us to go to the peripheries more easily. But as I said, we can always do a hybrid vitrectomy. You prefer a 25 gauge cautery, 25 gauge laser, sometimes even 25 gauge instruments like a cutter or a forceps. You can do that in a 23 gauge vitrectomy session also. So that's mostly what I do nowadays. And here you can see the cutter very nicely nibbling away. It's important to realize when to stop and to see the points of attachment here. So this is when I used the OCT, intraoperative OCT, microscopic integrated OCT, which helps identify the cleavages very nicely. That's the shadow of the cutter that you see here. So better instruments are being formed here, and that helps in a good dissection. So as Dr. Amruta said, I'll just stop share. As Dr. Amruta said, doing a good, every vitreoretinal surgeon can be a champ in diabetic retinopathy. So the points are to do a good core vitrectomy, which is the C. H is hyaloid dissection. A is anti-VEGF pre-operatively. M is the membrane dissection, and P is a good pan-retinal photocoagulation. As you could see, most of the surgeries which I had done had a good PRP done pre-operatively. So that helps to prevent intraoperative bleeds, or decrease it, not prevent, maybe decrease it, or iatrogenic breaks intraoperatively. Thank you so much.
Thank you, Dr. Supriya. That was a wonderful talk. I think we are quite in time. If there are any points of discussion, we can take, have a couple of points. Dr. Sasavade sir, Dr. Malpani sir, can you share your experience about diabetic vitrectomies and tips for this?
Yeah. I think Supriya has done a very good job. She's shown excellent videos. But I feel that diabetic vitrectomy is probably the only place where a 27 gauge cutter has a very great role to play. It gives a lot of, you don't need any other instrument if you're using 27 gauge with a beveled tip, because you can go under the membranes easily, you can cut everything. So that is the only place where I feel that 27 gauge has an important role to play and gives a very good result. So most of the bimanual things you can now do unimanually with 27 gauge. I don't know what is others' experience about.
Dr. Sasavade sir?
Yeah, 27 I have used previously, as a wonderful experience in the PDR cases, particularly these types of advanced PDRs, you don't require forceps or seizures. But the only problem in India comes that you cannot use it for multiple cases. One case is, or maximum 2 cases you can do, or even I have seen in a single case also it starts reducing functioning at the end of the surgery. So 27, even though it is a good, practically it makes problem. So in macular hole and all those things, it can work. But in PDR, where the lots of vitrectomy and membrane cutting is required, I think 25 is the best in between the 27 and 23 gauge. And 25 works very well with the 10,000 cut rates and bevel tip, which is very close to the opening is very close to the end of the cutter, and it gives good dissection. Over a period of time, we have stopped using scissors at all. Scissor is not used since so many years. Sometimes you require forceps, but the scissor is out of our armamentarium because of these good cutters.
Dr. Supriya, there is a question for you from Dr. Amruta as to when would you recommend doing ILM peeling?
So I don't do a routine ILM peeling in all vitrectomy cases, because we know that the macula is already ischemic, and going ahead and trying to peel the ILM sometimes can complicate things. So definitely if there is DME, then I would consider peeling of the ILM and leaving a bit of tricot at the end of surgery, but not as a routine. Sometimes during SOR also you can decide to do an ILM peeling if there is DME. Yeah, but I don't do it routinely for all patients.
Okay.
Thank you.
Dr. Yeah. Okay.
Yeah, Dr. Ajay wants to say something. Yeah.
Yeah. So I think Supriya, it was lovely videos which I liked of yours. I just have one caveat which I use in all my PDR cases, even blindly. So when you have these extensive fibrovascular proliferations around the disc and the arcades, I prefer always to start the dissection from the disc, or around the disc region. As you rightly said, the retina is thicker there, and you can get a very good cleavage plane. So as Anupam was saying, using these fine cutters, if you can get that correct plane, which you get always around the disc, so I always initiate my dissection. I call it as disc onward dissection in PDR. Just wanted to share this one point, which I usually do in all my cases, and makes it very easy. To progress from center to the periphery makes the case very easy. Thanks.
That's true. But sometimes you have maybe subhyaloid hemorrhage. You have a hyaloid which is already elevated anteriorly. So it's good to start anterior to posterior, and then you concentrate on your FEP disc.
True. I think each case is
I've learned never to say never in diabetes. It's so dynamic, and you just decide intraoperatively. But as you said, it's always preferable to start posterior to anterior. Yes, sir.
Yeah.
Great.
Supriya, your cases were very advanced PDR cases. You might have given the anti-VEGF before surgery.
We do give anti-VEGF as a routine. I give it if it's quite vascular, then I prefer giving 3 to 4 days pre-operatively. And somehow I found that during COVID, a lot of them younger diabetics, somehow that aggressive diabetic retinopathies progressed, and they're all coming in really advanced stages also. So those cases which we used to get earlier with just one FVP somewhere or just one focal attachment, I'm not seeing them anywhere anymore. So
lot of combined RDs are also coming now.
Yes,
absolutely.
Have you seen that if patient has taken anti-VEGF and because of some reason, maybe because he has not got the fitness or some other reasons, he has not come with the, as Manish said, come with the combined RDs later on. After
so I give anti-VEGF only after patient has received his fitness. I don't inject before doing fitness.
And then don't check sugar again pre-operation.
Yeah, I know. It would be out of control, and then you are scared to go.
Yes.
Anyway, I think that was a great session we had. We had a wonderful talks about imaging of diabetic macular edema by Dr. Chaitra and Dr. Manoj Sasode sir. Then it was followed by in detail a description about role of anti-VEGF in management of DME, and it was very lucidly presented by Dr. Malpani sir. Dr. Amruta spoke about principles of vitrectomy in diabetes, and then it was followed by bouquet of excellent surgical videos by Dr. Supriya. I think it covers diabetic retinopathy in very comprehensively, and this was a wonderful session. Thank you all the speakers for joining and contributing for this session. Thank you all.
Thank you.
I think.
Thank you, everyone, particularly the MOS Scientific Committee and all participants for attending this useful session. Thank you very much. Thank you, Supriya, Malpani sir.
Over to Swapnesh.
Swapnesh seems to be very happy. We have finished before time.
Yeah.
Yeah. And before time, that too, despite of so many studies Malpani sir has shown and simplified it very nicely today.
Yeah. Wonderful session.
Wonderful. Thank you very much. Thank you, Swapnesh.
Thank you, Swapnesh, for opportunity.
Thank you. I think next panel will be there. Thank you, Baba. Thank you, Anupam sir. Dr. Dusar, Piyush there. Welcome, sir. Hi, Piyush.
Hi, Swapnesh. So I think
we are on time, and
time.
at the stroke of 11, you can just kickstart your session.
Okay,
thank you.
I think some people are yet to join in. We've got Dr. Dani sir who's there, and
Manoj is
sir
not
who's there. Oh, Manoj is not joined, and Dr. Pooja hasn't joined.
Okay, I'll give a call to them. Whoever are present, you can request them to start off the session so that we are not delayed.
Sure. Thank you.
Dudani sir, namaskar.
Namaskar, sir. Namaskar. nice
Good morning,
to see you.
sir.
Sunday morning. Hi, Piyush.
Good morning, Dudani sir.
Yeah, you're looking tense or what?
Nice
So the elections don't get tense. Yeah, you should be relaxed.
Ekdam relaxed, right? Ekdam relaxed.
Very good.
Piyush, exit poll kadi hai?
I'm tense because I tried to put a background, but the background isn't. It's making my face look purple.
Piyush, exit poll kabhi hai?
More than it already is.
Exit poll uska ho gaya already. Piyush, you're not telling the exit poll results, huh? NDTV पे आ जाएगा आज शाम को.
सब इलेक्शन कमीशन के हाथ में है. But there are strict instructions from the EC. No election talk during MOSCON. So
yeah.
Let's keep it at that.
Just light talk. Yeah. Hi, Saurav. Welcome, boss.
How are you?
Good. Nice to see you.
Good to see you guys. Have a long day.
Long time. Welcome.
Good morning, Sinha sir.
Hi, Piyush. How are you?
Good morning, Sinha sir. I'm very well, sir. How are you? Nice to see you, sir, after a long time. June के बाद आज देख रहा हूँ.
I know. Swapnesh,
things are becoming routine.
Sorry?
Things are becoming routine in Kolkata, sir. यहाँ तो movie halls खुल रहे हैं. People are now. I'm actually thinking of going and watching a James Bond movie.
I thought I would do that during the pujas, but we just last 1 week cases are going up horribly because of post puja madness that we had. And I don't know how much you are aware, but Calcutta during the puja time is like one jamboree only.
Good morning, everyone.
Ajitesh is Manoj, I'm assuming.
Yeah. Ajitesh
Manoj Khatri has joined in. That's his voice for sure.
Yes. Ajitesh is his younger son.
Morning. Welcome, Manoj sir.
Good morning, boss.
Hi, Manoj.
Good morning, iDocs.
When Swapnesh was saying, one of the first times I've seen these conferences finish before time. मैं तो एकदम
बॉम्बे में टाइम नहीं है भाई. बॉम्बे में टाइम बहुत इम्पोर्टेंट है. सौरभ.
I insisted.
कलकत्ता में टाइम ही टाइम है.
I insisted that timer has to be there. Otherwise, it is difficult to manage even for senior moderators.
Yeah. No, you did very good. Yeah, that that the first gong and the second gong is really loud and clear. You can't miss it.
It's more like
you won't believe that technology. You won't. Any of you won't believe it's outsourced from London.
क्या बात कर रहे हैं? Wow.
I had to pay, I think, 4,000 per hall per day for that.
Wow. Wow.
It goes like absolute proper.
Yeah, it's beautiful. Yeah.
You're still paying London, huh?
Yeah, we are still paying them.
But it's funny. Worth every paisa, I guess.
Yeah.
Yeah, you get scared, yeah, when that gong comes. Huh?
Third party app.
Correct.
दुधानी सर है तो क्या चिंता है अभी?
अरे कोई हम लोग को क्रेडिट नहीं दिया। हाँ,
अरे तुमको फुल क्रेडिट दिया अनुपम, फुल क्रेडिट दिया।
हम लोग फालतू क्वेश्चन नहीं पूछा। हम लोग
नहीं, अच्छा क्या?
सौरभ को इतना टाइम दिया, अभी पूरा अपना लंबा टॉक भी दे सकता है।
दुधानी सर पूरा लाइमलाइट ले जाते हैं अनुपम सर, प्रॉब्लम ये है। बॉलीवुड के साथ में सब ले जाते हो एकदम से।
नहीं, हम लोग तो देखो वीडियो में बना है, अजय दुधानी के ऊपर पूरा फोकस है हम लोग का।
वही तो ना, बॉलीवुड के साथ में सब पूरा वो ले जाते, लाइमलाइट ले जाते।
बॉलीवुड इज अ वेरी डेंजरस वर्ड नाउ, डोंट से।
मैं खाली ज्ञान देता है आजकल लोगों को।
Manoj, the entire Santa Cruz Retina faculty is here.
Yeah, correct. True. Huh? What is that? Santa Cruz. CME.
मोहल्ले का CME कह सकता है भी तो
True.
Like Dr. Ajay Arora does Noida Ophthalmic Society. You'll have Santa Cruz Ophthalmic Society.
True. It's almost like that. Because all three are from Santa Cruz, you know, Swapnish, me and Anupam. Yeah, true.
Shall we start?
Yes.
Sure.
Piyush.
So, iDocs, are you ready?
Ready, boss.
Okay, welcome everyone to this fantastic session of intravitreal injections. And our first talk will be by Dr. Manoj Khatri from Chennai, former Sankar Nitralaya alumni and the director of iDocs Hospitals and the chief of retina at Dr. Mohan Rajan's eye hospital. He'll be talking about the real-world experience of brolucizumab. I believe he has extensive experience and has been telling us all his experiences about brolucizumab. So over to you, Dr. Khatri.
Good morning, everyone. Are my slides visible and I'm audible?
We can see the slides and we can hear you, sir.
Okay, thank you so very much. Thank you once again, MOS, for giving this wonderful opportunity to be amongst all of you who don't need this kind of experience talk on brolucizumab, but I thought just share some of my case experiences which we have used this molecule for last 1 year or so. So just going straight to the talk, what is the clinical experience in Indian subcontinent with the use of this molecule for neovascular age-related macular degeneration? I'm going to stick to only one indication as of now, which is an approved indication. As we already understand that any retinal fluid, if it is secondary to neovascular age-related macular degeneration, has to be considered as pathological in nature and has to be treated appropriately. And major trials across the globe, mainly highlighting Hawk and Haria data, has told us that the efficacy of this molecule is superior to aflibercept. What we have learned more than the efficacy is the duration, so that plays a very critical role. Rather than giving them monthly injections or bi-monthly injections, we can extend the duration to up to 3 months, 4 months, and so the horizons are increasing. And this the treatment per se has been sustainable over a period of time with a well-tolerated safety profile. Just to quickly look into a couple of cases, this of my earlier cases when PCV indication was not actually given, but when we saw this kind of a young female patient in the treatment day Y with a notch PD, the diagnosis is no brainer, but straight away we thought treat with the best molecule available. And this is what we see within 2 weeks. Initially, when we started from last October, we were following these patients every 2 weeks. So what you see here is an immediate wow effect, what we are not getting with other anti-VEGF molecules. And over a period of time, this sustained. This patient had one more recurrence post second lockdown. But when she came with the recurrence as well, then with such an extensive subretinal fluid, again, we go back to the same molecule and within a couple of injections itself, we get a very good response. So over a period of time, these effects are quite sustainable and the patients do both functionally and anatomically quite well. Another patient had a treatment naive eye, again kind of occult CNVM. He had a retinal detachment and also a keratoplasty in this eye. But over a period of time, when we treated with brolucizumab, we get a very favorable response. He did also had one more recurrence, and over a period of time, the recurrence was also treated with the same molecule. But interestingly, what we have seen here is patients who have been treated in the past as well with different anti-VEGF molecules, like this patient who has been on aflibercept, had a recurrence post first COVID-19 lockdown, came with such kind of a vengeance looking CNVM with such a thick shrimp here. We are doubting whether any benefit of treatment will be there or not. But with just one injection, what you can see here is pre-injection and this is post-injection, a dramatic anatomical and a functional response. And over a period of time, these patients have done quite well. This was just after one injection, 4 weeks post-injection. And then after second injection, you can see most of this choroidal neovascular membrane has resolved and very well outer retinal architecture restored. So this is one of the major USP of this particular molecule, that the outer retinal structure restoration is quite dramatic pace and which also keeps sustained over a period of time. This was a mother of an ophthalmologist treated elsewhere with 4 other anti-VEGF injections. When I saw this kind of a chronic changes in the outer retina here, when they came to me, I said straight away, let's go with brolucizumab rather than wasting time with other anti-VEGFs. It's not that the other anti-VEGFs are inferior, but what you get is a good dramatic response in just one injection. This is immediately post second week of the first injection. And over a period of time, this patient had one more recurrence, but you can see here there are no changes in the outer retina, even in the recurrence phase. And when you keep these patients with treatment with the same molecule, over a period of time, they do quite well, and there is a good anatomical and functional response in these retinas. This patient had about 20/40 vision now at last follow-up visit, which is quite satisfactory for this kind of treatment, for this kind of pathology. Another patient who was on aflibercept in the past, lost to follow-up during the first lockdown of COVID-19, came with a recurrence. Again, there are dilemmas whether you are going to achieve much with any kind of treatment. But once you give brolucizumab to this kind of recalcitrant cases, over a period of time, they do pretty well. And what we have seen, apart from little bit of scarring in the subfoveal region, the rest of the drying effect is very effective. One of my other patients who have been treated for pigment epithelial detachment by myself with aflibercept was doing fairly okay. There was a good favorable outcome. It's not that the PED was not subsiding for the treatment, but when we had started this kind of a subretinal fluid at the edges, I thought, let me shift over from this aflibercept to brolucizumab. And as soon as we shift, we know the brolucizumab superior effect on the pigment epithelial detachment, especially at least decreasing the height. So this was pre-injection and immediately second week post-injection. You see a very good dramatic response. And over a period of time, these kind of responses are also sustained. So this is one of the other indications where we can use this molecule as a first-line therapy maybe. Another patient who had a treatment naive eye, lost other eye to the choroidal neovascular membrane. This quite, especially I believe, patients when they have a huge pachychoroid spectrum, brolucizumab works better because the penetration is better, bioavailability is better. So we can straight away start with brolucizumab and immediately 2 weeks later, response over a period of time did quite well. I'm not going to waste much of time. One of my last patient with a huge subretinal pocket of subretinal fluid, we were thinking even of rheumatogenic retinal detachment component here, but just after ruling out the clinical RRD, the SRF responded so dramatically to one single injection, which sustained over a period of time. This patient did have a recurrence once more after 4 months or so, but responded quite well to the treatment. So as we understand, the fluid has to be treated at appropriate intervals, considering after doing all the entire clinical workup for that patient. The wow effect is seen in real world experience, both in treatment naive and switchover cases in most of the neovascular AMD patients treated with this particularly exciting molecule. Thank you so very much for a patient hearing, and thank you MOS once again for the wonderful opportunity. I think I'm well in time.
Piyush, you're muted. Piyush.
Oh, sorry. Thank you, sir. Thank you, Dr. Khatri, for this lucid presentation and well before time. So I can see Dr. Dudani eager to make some comments. He has excellent experience with brolucizumab as well. Sir, would you like to make any comments over here?
Yeah, I think his presentation was really good. And, I just had one thing that even now we are seeing some, people like if they are like, not willing to give brolucizumab. Like I had my colleague who was in UK and her dad had got AMD, so I suggested that it was a bad AMD. The vision had gone down dramatically into the lockdown. So I suggested brolucizumab, but she was very apprehensive and she said, no, that causes vasculitis. I would not go. And that patient would have done really well, So I think we need to really educate our colleagues that the incidence of this side effect of inflammation and vasculitis is there. You should be aware of it, but not get scared and use this molecule, which gives excellent drying in these difficult cases.
Wonderful point, sir. Any other questions or any other comments from any other panelists? Dr. Saurabh Sinha, sir?
No, can I make a quick comment? One case here in Calcutta, one-eyed patient, other eye large scar, horrible, nearly a pan-off kind of a situation. Not just end of scleritis, the works, non-involvement. So, and it was going around it came 3 or 4 of the usual patient in the second, third, fourth opinion. I saw that and I got so scared. I don't know what the hell. And we were trying to say, no.
Sir, first injection or before that, any first Pagenex?
Known to somebody very well. All of you know him also. Part-time medical retina person, prolific surgeon. Now, the point I'm going to make here is that possibly if you have a very suspicious patient, like Ajay's friend's father, the friend, maybe if it's a one-eyed patient, it's sort of, I would think little bit go slow.
I totally agree with you. Agree with you, sir. Case
I love
selection is the key.
I think it's fantastic.
No, but case selection is the key, sir. Actually.
Yeah,
case
I would
selection.
just a little word of caution. Maybe after I saw that, my number of Pagenex, I suddenly started thinking, yaar, kuch ho jayega to, which I wasn't doing till I saw that case.
True.
Nothing against Pagenex, just the how it works. I think it's fantastic. Anybody,
So
Manoj, diabetics, have you used, Manoj?
No, I have never used any, apart from any other approved indication, I have not used, but a lot of patients treated by other colleagues I have seen, sir, they are showing very dramatic response.
Ajay, diabetics?
Yeah, Saurav, I have used in few of my patients and the results are good, but I would just say, compared to AMD, the results are not wow, In the AMD patients with PEDs and the fluid just disappears in a week. In the DME, I'm not seeing that wow effect, which I'm seeing with AMD patients,
I have done quite a few naive PCV patients.
Yeah.
Not the large subretinal lesions, the ones which are inside the arcade types, with gas, without gas, and wow means really wow.
Yeah, it's unbelievably wow. Yeah, true.
I have given it in diabetic patients myself. Same with what Dudani sir has said. The immediate resolution of fluid that happens with patients with AMD is it's not the same with other cases. I've given it in patients with off-label, of course, I've given it patients with vein occlusions as well. The requirement for multiple injections is certainly there. The effect is, however, longer lasting as compared to, say, a ranibizumab. So that was the only advantage that I felt in patients with diabetic macular edema or in patients with vein occlusions. So, Sinha, I would like to ask you, the patient that you described, was this a treatment naive patient or was this a patient who had previously received
treatment naive? And given at a good center by a senior person who does lots of injections. So that part we can't. And I talked to him personally myself on the phone saying, "Aapka patient aaya hai." So I know it's somebody I can vouch for the OT and the precautions that they take.
Can I make a comment?
Please.
I don't have a very huge experience. In fact, I have used only in 4 patients, and that too maybe single injections, except in one patient I have given twice. Now, this patient was one of my relative, was on aflibercept, Eylea, for a long time with PCV, was doing fairly well, but needed injection every 6 weeks or so. So once I gave her Pagenex, she responded well, and the duration could be increased to around, say, 2.5 months. But then I gave her Eylea again next time. I do a thorough discussion with all patients about all the possible side effects. So actually the patients don't opt for it most of the times. This patient, when I gave the second injection a month later, she came with very severe inflammation. It was both anterior and posterior vitritis. Luckily, there was no vasculitis. And this happened 1 month after the injection. And the vision dropped to from 612 to 660 or less. And I had to give oral steroids and topical steroids. And now she's doing fairly well. So it is not that we should not be careful about this. I don't know whether, yeah.
Totally agree, sir. Case selection is the key, sir, actually.
No, but how do you select a case?
So any old vasculitic problem definitely.
No, this patient had no history of inflammation, no vasculitis, was treated with all other anti-VEGF agents without any inflammation for many years now. She is on treatment for last 4 or 5 years. So how do you select? I want to know that.
So Anupam, what was a study, they have found out is that, patients who have received multiple injections of other anti-VEGFs before and who are not necessarily treatment naive have already some anti-brolucizumab antibodies due to the previous injection, So I think what you're saying, like one message I could share with you is that, treatment naive patients would be a better option, than multiple injected patients who have a tendency to develop antibodies to these anti-VEGF drugs, is what one caveat they say.
Okay, but because I thought that this is more common if you have used brolucizumab multiple times, and second or third injection, probably third or fourth injection gives
reaction,
the more risk of reaction.
True, correct.
That is there, sir, but still we are not having too much of clarity on this area. So the patients who have received 40-50 injections in the past, especially, is very typical of AMD. Better to be little careful with the use of brolucizumab in those patients.
Great.
So can we move on to the next presentation now? We have
please.
We have one of the strongest avengers of vitreoretina making the next presentation. So Dr. Rajesh Shukre, sir, would you like to introduce Dr. Dudani? And Dr. Rajesh Shukre, sir, are you there? Okay, so the next presentation is by the boss of Retina Care Center, Mumbai Retina Care Center in Bombay, one of the most leading and dynamic vitreoretinal surgeons in our country today, Dr. Ajay Dudani, sir, who I like to say is the Bruce, the Hulk of the Avengers of vitreoretina. So can you please do make a presentation?
Thanks. So I think when we started up a discussion, as I and Piyush said that the Pagenex doesn't work very well in DME. So because as I will tell you, why it doesn't work so well vis-a-vis other medicines. So the battle of DME, basically is a sort of a battle of like COVID. It's a battle of cytokines where you have a lot of immunomodulators which are working, which are leading to angiogenesis, vascular permeability, vascular occlusion, and neurodegeneration. So I think you've got to tackle all these cytokines rather than just tackling one anti-VEGF, because DME is a multifactorial disease. So would you call Batman or would you call Justice League? So anti-VEGF just acts as a Batman, which we know that will work only against one of the cytokines. So you require the Avengers, which will, work against all these various cytokines which are working. You require different superheroes. And we have a molecule which is combining all the Avengers together in one. And we call it steroids, which is available as, a depot preparation of Ozurdex. So we are all aware that, all diabetic macular edemas are not the same. There are a lot of rebellious patients. So there are one type of rebellious is where you cut an apple and you'll get an orange. So this is, you expect the unexpected, and you would have experienced these patients which don't respond to your anti-VEGF. Then you have these rebel patients, the patients where the problem is DME and the patient will not come for regular follow-ups. You tell him to come back. He said, because these are young patients who are working and who have other commitments. So they don't necessarily follow up like our elderly AMD patients, So these rebellious patients of DME, you should ensure compliance is the main key, key in controlling the progression of the disease and to prevent irreversible vision loss. So progression of PDR in 5 years among NPDR patients is very strong, especially in the severe NPDR patients. And Ozurdex, with its long duration of action, helps in ensuring compliance and controlling progression and visual disability in these patients. So the non-responders or the partial responders to anti-VEGFs are the problem cases of DME. And so VEGF is not the whole story in these cases. As we know that the Rise and Right study, 60% of the patients didn't meet the endpoint of having vision improvement by more than 5 lines. And Vivid Vista similarly also had 60% patients who didn't meet the endpoint at 100 weeks, that's 2 years. And the protocol T, 33 to 55% did not improve by 15 letters or more at 1 year. So there is there's a war going on in your retina in DME patients, and we are aware that this subgroup of patients who initially don't do well, as we are aware in protocol I, till the end they don't do well. So this is a patient who won't gain, about 40% of the patients won't gain even 5 letters of line with a constant anti-VEGF suppression. This meta-analysis by Mr. Khan et al. Showed the efficacy of Ozurdex for DME in refractory patients to anti-VEGF, and it had a robust data of almost 4,000 patients, and the Ozurdex led to a 4-line improvement at 6 months in these patients. And we have all seen in our practice also when we switch our patients, from anti-VEGFs to Ozurdex, which we add. So visual acuity gains, are they reproducible with anti-VEGF in real life? So 40% of the patients gain 3-line vision improvement at 24 months, even after monthly injections. And in real world, only about 75% of the patients receive less than 3 anti-VEGF injections. So it means even in a country like USA, the follow-up and the utilization of injections is very low. So compliance and comprehension is a bigger challenge for us in a developing country like India, especially where the cost is very high, So these are the various studies, starting from the Champlain to the Mozart study, and which have shown very clearly that most of these patients with Ozurdex, especially if they are the pseudophakic group, they do much better with Ozurdex with vision improvement also, which is maintained for almost, I would say, 4 months, as I will show you in my cases. This was another 2020 paper I got in ophthalmology, in which it's a registry showing that almost about 340 eyes in 8 countries, 25 sites, with almost 762 injections. So there was a 22% 15-letter gain, almost a 40% 10-letter gain, and peak improvement occurred at about 2 months, you could say, about 2.5 months. And there was definite improvement in the reduction in the thickness also, and the treatment-naive patients did well. So I am also going, more and more to treating this treatment-naive patient with a combination of Ozurdex, and I use laser in these patients, to act as an anti-VEGF agent, because we are aware that laser reduces the VEGF load, So I've also tried to try this out in patients. But the bugbear is the rise in IOP, which is seen in almost 7 to 10% of the patients, and which is not very high, and can be controlled with a single anti-glaucoma medication. So let's talk about this 60-year-old patient. It was a one-eyed patient. I'm seeing him over 9 years. It was the one eye was lost due to PDR. I had done a vitrectomy and he didn't do very well. He had received multiple Avastins and had undergone a total PRP scatter. And also I do a focal modified grid in these patients. He had a vision of 660, and we had to switch him to Ozurdex. I'll show you why briefly. So this is how the case starts. This is a sort of a diffuse diabetic macular edema where this fluid is turbid, which shows that this patient has a lot of inflammatory element with HRFs are seen here. So it is the fluid is to not move very well with, anti-VEGF Avastins. You can see that comes, it goes. And this wow effect I got with a single injection of Ozurdex. He required about 3 injections over a period of time. And last, when he came, he didn't require an injection after this 2 years of lockdown, which he came to me, and he was still flat with the last injection. So I would say again, compared to AMD, DME is a sort of a finite treatment, I would say. If the patient is controlling himself and is having a good diabetic control and having his HbA1c in control, unlike wet AMD, DME, I would risk to say it's a relatively a finite disease, if you can treat it well. So this is again a patient, a 75-year-old male, uncontrolled diabetic, received laser and some injection somewhere, one-eyed. Other eye had foveal atrophy. This is how the story starts in 2017. He's got drill, CME, VMT. Someone said removes membranes. This is the one shot at 2 months. Look at this. But he comes back. Again, we gave beautiful. Again, he comes back in lockdown. This is the situation we are facing all, these patients, Again, he received an injection and he's doing better now. So this is another patient, both eyes, post-op DME with CME, multiple Avastins, didn't do very well, got his Ozurdex and vision from 660 came to 612. So this is how it starts. See this hazy fluid, this suggests that there's an inflammatory component to this, which works very well, Instead of having clear cysts, you have this, hazy cyst. And this is 2013 it starts, So it doesn't work very well with Avastins. This is the dip you get back with, beautiful anatomical outcome with Ozurdex. See the PRP which is done here, I mean, so he's really doing well. It again comes back, but it really responds so well. The other eye, then don't forget to see that there might be an associated disease which develops. So he developed an occult CNVM in this eye, and he was not responding to this. He had a small pupil, so I couldn't see his fundus very well. And then we had to switch him back to eccentrics for his CNVM, which may be developed at the edge of a scar. This is another patient of mine, again, post-cataract surgery. You can see the edema here. This is a typical CME with CSME combination. You can see the cysts here. And look at the beautiful response to the single shot of Ozurdex. It stays that way. The other eye, again, it comes back. It requires multiple injections. But in the end, even if in spite of the ERM, he's doing really well. So these guys do very well in the end, and but you have to look out for the recurrence in these patients when they have a poor control. So this is a patient who didn't receive any treatment because he lost one eye to an anti-VEGF injection, like Saurav was saying. And this eye also does respond to topical therapy. See, over the period of time, over 5 years, I'm showing you how this CME responds to systemic control and just topical therapy. This is the last case I'll share with you. A teacher who was teaching, and this is how she responded, right eye, left eye. You can see, a complex CME which didn't work very well with laser or with Avastin. And this is the response we got post Ozurdex. You can see that, the foveal contour just comes back. That's the right eye. And this is recently, she's come back again after the lockdown of 1.5 years, and she's really flat. She said, "Doctor, give me another injection." I said, what for should I give you? This is the left eye. Look at the beauty, which these eyes resolve with. So this is one cyst which didn't respond to Avastin. It is to come back. That hazy fluid which I showed you, which shows an inflammatory component. And look at the response to a single Ozurdex. That was the previous responses were to Avastin. And he stayed flat. Post-lockdown, again flat. There's no need for any injection. This is a giant CME responding to a single injection and stays flat. Thank you so much for your patient hearing. Sorry, I took a little extra time. Thanks so much.
Absolutely no problem, sir. Thank you for this wonderful presentation. Such miraculous results. What I'd like to add is that apart from most of the diabetic patients that you had shown us, we do expect excellent responses in patients with the uveitic CME, with patients with Ozurdex as well.
True.
This is my go-to drug in patients with the uveitic CME, as well as non-responders or tapering responses achieved with anti-VEGFs in patients with vascular occlusions as well. So is it your preferred mode, or do you ever start off with the Ozurdex, or is it always your fallback method, like you said, like an Avenger?
Yeah. So as I would say, I would do, in treatment naive patients where there's a predominant sort of, as I showed you, an inflammatory element of CME, which HRFs and everything. And I would always add it with some laser in these patients. I do a little focal laser or a little modified grid laser as an anti-VEGF, So I am, because I've seen that cost is the big factor here. 3 injections you give, and then post-injection, it comes back with a vengeance, once the effect goes at 30 days, that CME is worse than what it started with, the DME. Whereas Ozurdex is like, that it's got a calming effect. It stays there and it keeps the eye down. So I have tried in a lot of treatment naive patients also. Saurav, sir?
Two quick, one question to you. You mentioned it thrice rather, that the hazy cysts are inflammatory. Is it your personal opinion, or are you talking about it like HRF is a well-known entity? I don't mean to be nasty to you. I'm just assuming asking a question.
I just showed you those images. Did you see those cysts,
I saw those images, but is this your personal feeling, or are you quoting an article?
No, this is my personal feel.
I agree with you. I don't have no opinion. Second, would you give Ozurdex in a 55-year-old sort of semi-recalcitrant, semi-patient with a clear lens, no cataract with Ozurdex,
Yeah, that's a very good point. I think, in these patients, a 55-year-old male who has a very clear lens, I would definitely err on the side of going anti-VEGF. I totally agree with you. Totally agree with you.
Because this hoo-ha about cataract developing, I think is something too much. बात पे लोग cataract कर रहे हैं. As a diabetic patient, they have this severe reservation about it. I think it's very
Yes, I have. Because I don't want to CME with DME. Yeah.
If you do the economics behind, if you have a bilateral disease, inject anti-VEGF, whichever one, in both eyes over the whole year, and Ozurdex will be cheaper for the patient.
True. Agreed.
Thank you.
Thanks.
Thank you. Can we move on to the next talk? It's a pleasure to welcome Dr. Pooja Sinha from Patna. So now from Chennai to Bombay and now to Patna. She is the chief of retina at AD Eye Institute at Patna. And welcome, ma'am. If your slides are ready. So for the audience to know, until the slides load, even as a student, when I was a resident, and Madam used to take classes of indirect retina. Yes, I believe the slides are on.
Yes.
Thank you.
Thank you, Piyush. A very good morning to everyone. Am I audible?
Yes, ma'am, we can hear you.
Okay. Big thanks and gratitude to Maharashtra Ophthalmic Society for giving me this opportunity. I miss being in Mumbai because we remember your excellent hospitality and the chance of meeting so many friends. So I'm sure that next year we'll be together again. But this year, let's all share this virtual platform. So I'll be speaking on challenges in the treatment of ischemic CRVO. Do we use steroids or we use anti-VEGFs? So all my medical retina colleagues will agree with me that CRVO is a very difficult and challenging disease entity to treat because of the time the patient reports to us, as well as the kind of macula that the patient has. So we know that macular edema is a frequent cause of decreased visual acuity in patients with CRVO. And the factors which lead to development of macular edema are increased venous pressure, elevated levels of VEGF, with subsequent breakdown of the blood-retinal barrier leakage, upregulation of other inflammatory mediators, and dysregulation of the endothelial tight junctions. So steroids, we all know, decrease the expression of VEGF and several inflammatory mediators, and therefore indirectly reduce VEGF levels in the vitreous cavity. Anti-inflammatory role is reducing the vascular permeability, inhibiting leukocyte movements, stabilizing endothelial tight junctions, and inhibiting prostaglandin and other cytokines. So 3 major steroids are currently being used in the treatment of CRVO. They're triamcinolone, dexamethasone, and fluocinolone. Let's all revise this core study, which was a randomized controlled trial, and it compared 1 milligram and 4 milligram doses of preservative-free triamcinolone versus observation in patients with macular edema and CRVO. And the results were that both 1 milligram and 4 milligram yielded better visual outcomes over 12 months than observation alone. And they also noted that the 4 milligram group had the highest rate of cataract formation and IOP elevation. So coming to the DEX implant, it's a potent water-soluble corticosteroid implant delivered to the vitreous cavity. And it's a 6-month study evaluated efficacy of 0.35 milligrams and 0.75 milligrams dexamethasone compared with sham. And they concluded that DEX implant reduces the risk of further visual loss in CRVO and increased chance of visual improvement. The DEX implant was also well tolerated, and increase in IOP was in less than 16% eyes. So this is the Ozurdex implant. Coming on to anti-VEGFs, the mechanism of macular edema is upregulation of VEGF response in relation to retinal ischemia in CRVO. And we have a whole basket of anti-VEGF agents, starting from bevacizumab. And there was a study by Epstein et al., which showed that injection of Avastin every 6 weeks for 12 months increases visual acuity and reduces macular edema compared to sham. This is the Avastin injection, which is most commonly used. The ranibizumab was also studied by the Cruise and Horizon studies and the Crystal study. And aflibercept, that is Eylea, had the support of Copernicus and Galileo studies, where patient gained 15 or more letters from baseline. So in our study, there were 4 patients we studied with recalcitrant CME, secondary to CRVO between February 2020 to July 2021. The inclusion criteria were that all the patients previously were treated with at least 2 injections of anti-VEGF agents. And then we switched to steroid. All the patients were pseudophakics. There was no previous history of glaucoma. The average CMT was greater than 250 microns. Average best corrected visual acuity was less than 636 in the affected eye. And the treatment was then switched to 0.7 milligrams of DEX implant because of non-responsive or persistent CME. And because this study was done in the COVID era, we also made sure there was no history of previous COVID-19 infection. Mean interval between anti-VEGF injections before initiation of intravitreal steroids was 1.5 months. And the mean interval between injections increased to more than 4 months after initiation of the steroids. So this was one advantage. We also investigated the best collected visual acuity and the CME on OCT. Scatter laser was done in 2 out of 4 cases for peripheral retinal non-perfusion and recurring CME, because we know that ischemic CRVO just lets out a whole basket of load of VEGF in the vitreous cavity. Re-injection of steroid implant was done at the end of 4 months in 1 patient. Mean anatomical outcome was significantly improved after initiation of steroids, along with slight improvement of mean functional visual outcome in chronic cases. Findings may be secondary to chronic CME, ischemia, and irreversible damage to the photoreceptors. No steroid-related intraocular complication like secondary glaucoma was luckily seen in our patients. So this was the case 1 at presentation. You can see the right eye, this classic blood and thunder appearance, a lot of hemorrhages on the right-hand side, bottom slide, large cystic edema, and elevation of the retina. This was a 70-year-old retired general from the armed forces, and he also had a history of hypertension. You can see at this time of presentation, the visual acuity was counting finger 3 meters. After orthotics implant, the vision improved to 6/36. You can see the corresponding OCT below. Case 2 was a 55-year-old teacher in the secondary school, history of hypertension, increased cholesterol, reporting vision was 6/36. But she did very well with Ozurdex, vision improved to 6/18. This is another case which I recently saw. The whole retina was completely distorted. The lot of intraretinal edema, hemorrhages. After 1 month of injection, the edema had come down, the hemorrhages had decreased. And then after 2 months, again, the picture was still very satisfactory. This is another case, didn't do very well, but I just wanted to show that sometimes ischemic CRV just goes out of hand, reporting vision counting figure 2 meters. You can hardly see any retinal morphology here. 449 was the CMT. Vision improved to 6/60 after 2 months. And at the end of 3 months, the retina was stable, but the vision didn't improve much, although the anatomic appearance of the retina was much better. Again, at the end of 4 months, vision dropped to counting finger close to face. After 1 month of second Ozurdex injection, vision improved to counting figure 2 meters, but I knew that we had lost this case. So to summarize, as monotherapy, steroids alone have not been proven to be superior to anti-VEGFs, but with a higher incidence of side effects, especially after repeated dosing, anti-VEGFs still remain first line of treatment for medical CRVO. Role of steroids as an alternative therapy in resistant cases, alone or in combination with anti-VEGFs, is a viable option. Thank you so much for your patient hearing.
Thank you, ma'am, for this wonderful presentation. So the takeaway over here is that we still inject with anti-VEGF in ischemic CRVO patients, which are extremely difficult patients to manage. And in cases of response that is inadequate, then we can definitely switch over to steroids. So with this, we quickly move on to the next presentation by Dr. Saurav Sinha, former Sankara Netralaya alumni and eminent vitreoretinal surgeon in Kolkata at Netralayam and BBI Foundation. He'll be talking about how he counsels his anti-VEGF, how he counsels his patients with the neovascular AMD patients for anti-VEGFs. Over to you, Dr. Saurav. Sir, we can't hear you.
Morning, everybody. Am I okay?
Yes, sir. We can hear you and we can see your slides.
Yeah. So it's a little difficult in front of Ajay, and I know he's the boss of all this, and he's the hulk of even counseling. And I don't know how many of you know he does, I think, more LASIKs than injections. I insist on that. Okay. On a lighter note, vigorous shake of head. Okay. So I do have financial disclosures. Everybody pays me. I'm on everybody's advisory board, and proudly so. I feel I can make some contribution to proper science. I'll quickly go through the 4 situations that we have when we counsel our patients. A naive patient has come to me. I said you need 3 and the guy needs more. Somebody else's patient unhappy with the disease, and I don't say with the doctor, unhappy with the disease and has come to me. And a recurrence mine or somebody else's. At initiation, I always say it's a lifelong disease. You may have a remission, but a recurrence is a possibility even after loading dose. And these are 3 things that you have to live by and write on the paper, that this is a lifelong disease. This is something that I drive home continuously into their heads. I tell my aim of treatment is to maintain vision. I never promise increase in vision. I only say you will have quality vision better, dark area and distortion less. And mine are talking about in AMD. And I tell them a color will be brighter. And I usually write this on a file also. We'll see colored better, we'll see darkness less. And when they grip to me after the 6th or 7th, they say, this is my likha hai yahan pe. So that gets me away sometimes. So at initiation, I quote another one of our gurus, Dr. Sangeet Mittal, who told me his Sardar patients are told, Pehla saal 2 lakh, agla saal 1 lakh. That's what they understand. That's the amount of money they have to spend. And I think that's works fantastically in a lot of patients also. They want to know paisa kitna lagega. Now you have a patient who needs more injections after loading dose. These are the patients, they've stuck around with you for 3 injections, 3-4 visits they've had with you. They have some faith in you. They're having a doubt on you and the disease right now. So I insist on showing the OST pictures, the vision recorded, something 1 line, half line better. I take a color photo sometimes, show the heme is a little less, or it looks a little less ferocious. But I now tell them that, I'm also little apprehensive the disease may be worse. So I say suggest titration will occur if further injections are not given. This is something that they need to understand, that continuation of therapy is very important. Because of financial issues, some patients do stop. Now, supposing somebody else's patients, before I see the patient clinically, all of us have multiple files lying on our table. I pull out files of my own and I show them, see, I have patients who have needing their 6th and 7th injections. They're on follow for 2.5 years. So this is the only treatment possible that you have. And I always verbalize that I have patients with 32 injections the last 6 years. Before I see the patient, I ask them what is the expectation of the difficulties. How the problems are solved there itself. Not you clinical judgment that you're giving the patient injection chahiye nahi chahiye. I think the patient just wants to have a definitive answer to what he expects from this treatment and what difficulties he's having. I think that's what we need to address more. I will quickly stop over here. This is a gentleman, 81-year-old. I've moved out his name. If you see here, he was giving injections in end of November and last year in January. Last year in January. He came to me a month later. So this is January, came to me in February. Not happy at all. And he said after 30 injections went down. And there's an old man who, if you see on the left side over here, he says right eye, no vision. He's typed it out for me. But he has these 5 distinct complaints and all are nonsense complaints. LED white light, blade going RPM, smoky screen. But I took around a minute to read all that. And then he was already happy before I'd seen him. He said, you're the first doctor who's actually read this whole page of mine. He has taken so much effort to write it down for us. We must give value to that. The patient became immediately happy. And he said, I have left eye, some haziness. I said, chala, ek posti karte left eye mein, and we'll see you back. But if he came back, he was already happy and he made peace that, okay, right eye, nothing more can be done. I think closure of therapy in these patients is necessary. Hand-holding is necessary. When they bring to these lovely notes, we must look at them very, very carefully. Now, recurrence. Again, color photos, tell them this is part of the disease. And this is a patient, you have to tell, I'm treating you now, and you may have a recurrence again. If you think telling him this will make him angry, do it. If you don't tell him right now, angry, upset, sad, do it right now. You don't want that happening later on. So break the news of the patient right now. So those are the 4 situations that I talked about. How do I choose an anti-VEGF? I tell them that Avastin is a Roche company's international brand. It's not made for the eye, and a single vial is expensive. I don't use it because there's a very rare chance of infection, but I've used it hundreds of patients. So I'm trying to reassure my patients, if I have treatment elsewhere with an Avastin, I'm fine by that. I've done it myself. It's not a poor drug. We sometimes rarely have got injections, therefore I have this reservation about it. But in case if you want to go elsewhere and have it, please go and have it. Ranibizumab, I talk about the original, the biosimilar. I do mention the price difference if it's an oversmart patient, my OPD itself. And I tell them that since 2006, this is the last 5 years, and there is a small difference. Things are becoming more difficult with Cipla one coming in, with Reliance one coming in. I don't know how I'll counsel in future with so many of them around. Lupin coming in another month's time. It's going to take a longer than see consultation with the anti-VEGF over here. This aflibercept passively I do mention as an option to my initial patients. I don't mention the price. It's very difficult for the patients to understand why you would pay for one and not pay for the second one, again pay for the third and not pay the fourth, fifth. Inside the clinic, talking about this payment and non-payment can make them very, very confused. So I don't talk about it. My counselor talks about it. I do mention brolucizumab, whatever the case, I do mention that it's available. I write on the file. I tell them I'm holding on to this, but I put a mention on the file on this because patients may jump doctors and may hear about somebody else and say, he never told me about this, or you didn't mention this to me earlier. I normally follow three loading dose protocol instead of monthly checkups. To my very intelligent and very fine schedule of patients who have had recurrence or had good vision recovery. Again, I insist over here, recurrences with vision recovery. I talk about it to an extent. I do have quite a few patients of mine who understood the implication. They walk in every 3 months and have an injection without any difficulty. For the oversmart patients who talk about heart attacks, I do tell them that if you had a last 3 months pregnant, I will not do the injection for you. Little oversmart patients, I say up to 6 months also. Otherwise, safe. Again, kuch hoga to nahi. Are you sure nothing will happen? That kind of hyper patient family, oversmart son, Google doctor, daughter. I tell them that even paracetamol can cause disaster contraction in non-intact lac patients. So I'm not God. I can't promise anything. I have these pamphlets which I give out in the vernacular language, and I tell them patients who don't know what's going to happen, they sort of read this and they feel happy. I've had some instructions, some clarity as to what this injection business is all about. Of course, this is for naive patients, for new patients. And I have a clear-cut chart which I give my patients at what costs how much. And I tell them that hospital has 1,700, I charge 500. It is for what medication you choose. I will not decrease my price. You do the expensive one, you do the Indian one. I don't care. My intellectual capacity remains the same. So I will charge the same amount of money. I will not decrease my amount. Except if you're a doctor, then I charge you 1,000 rupees less. And I give a written one. My latest one also has brolucizumab in this added in that. Why I mentioned even the coordinate numbers? They then tell them the third one is there and the fourth one is free. My counselor doesn't say that to them. We tell them, give them a call and find out the deal that you have. We don't do it ourselves. I do withhold treatment sometimes, large submacular heme. I play God over there. Multiple injections, counterfeit vision. I tell them, get lost. Let's leave it at that. Huge heme, vitiligo already done elsewhere. I tell them, no, I'm not going to treat you anymore. I think just leave it at that. My query to these esteemed people, colleagues of mine, my last slide. When you have a patient who's very aggressive on duration treatment, while on your treatment, how do you handle this patient? And it's difficult. Anything special that you see or do? You're treating one and the other develops a CNVM. It does happen once in a while. Once in a while. How do you handle these patients? And this is something I'm sure all of us have had. The free file injection did not work. The patient decides, not you. Patient insists that wo injection diya, wo kaam nahi kiya, wo free mein tha. I also have a few set of patients who have not been advised earlier to do elsewhere. And I've come to you and you are not talking about Paganex, saying that this is a possibility, but it's not been told to them. So what do you do in this kind of a patient? Thank you so much, my associates, 6 of us together. That's all. Thank you so much.
Thank you so much, Saurashtra, for this fantastic presentation. It certainly gave me a lot of points to incorporate in my practice, especially if I have troublemaking patients, maybe from Kolkata, then I know how to deal with them now. If there are no more questions, then we move on. If there are any questions? So we'll move on to the next presentation, which is also the last presentation.
Piyush Bansal is a young, dynamic vitreoretinal surgeon from Bansal Vision Institute of Pune, and is a good friend of mine. He'll be speaking to us on when anti-VEGF and steroids fail. You're saying both when they fail, is it?
I'm sorry, sir?
Piyush, it's when both are failing, you're telling us what to do.
Yes, sir.
Okay,
so,
good.
Unfortunately, I'm not able to move my slides properly, so please bear with me. Am I audible?
Yes, yes, very well. Please go ahead. Please go ahead.
Okay. So, like we all know that the entire landscape for retina surgeons has changed in the last decade and a half, and I consider myself very lucky, along with the patients as well, to have such a huge armamentarium of drugs that we have now, which wasn't available earlier, and we can see these patients improving drastically with anti-VEGF and steroids alike. So we know that there are so many indications that and these anti-VEGF and steroids have in patients who've had macular edema post-vein occlusions, or clinically significant macular edema with diabetic macular edema, CNVMs secondary to AMD with PCV. So the routine practice is to either follow monthly interval injections, or pro rata need, or a treat and observe, or a treat and extend protocol. There are so many of them, and we can tailor pick them because there's no one cap that fits all. However, there are these many patients that are considered as treatment failures. 95% patients do respond very, very well to anti-VEGF injections and steroid injections, but I would say that at least a 5% patient load in every retina surgeon's practice don't seem to respond very well, or there's a delayed response, or there is a tapering response. So there's no universally agreed definition over here. But what most retina surgeons would agree upon is that when there are multiple anti-VEGF treatments, and despite that there is fluid or leakage, that is when you would call them as treatment failures. Or the other counterpart would be when the vision loss continues despite treatment. That is when you would call them as treatment failures. Treatment disappointment is another term which is used for when you're continuously giving monthly injections and to maintain a macula to be dry, or despite all of this, if the treatment decreases macular edema, but the visual acuity doesn't continue to improve. So for practical purposes, I'd like to say that we can define treatment failures as persistent fluid on OCT, which is no longer responsive to anti-VEGF injections. So what do you do in such situations? So when you have recurrent CMEs or non-responsive CMEs, despite repeated injections, another option that you can definitely go in for is do a pars-plana vitrectomy with an ERM or ILM peeling, which is a more and more suggested option now as compared to the past decade. There are many investigations which show the same, that there is a significant amount of improvement of macular edema in such situations, whether it be diabetic or vein occlusions. So just a few videos that I'd like to show over here. This was a patient who had received multiple injections of anti-VEGF, Lucentis to be precise. I think around 8 or 9 injections, followed by a couple of Ozurdex shots as well. The edema just kept bouncing back. And what we did was do a vitrectomy in such a situation. You can see that the PVD is being peeled off. Now, removing the PVD helps in reducing the traction, the vertical traction, followed by peeling the internal limiting membrane over here. You see that's a boggy looking retina, and peeling the ILM can be a bit challenging. However, a good peel ensures that there is good oxygenation to the entire macula, and subsequent chances of recurrence of macular edema certainly become less. So this patient did quite well. After 3 months of follow-up, the requirement of injections did come down. Okay, so this is a patient with a branch settled, a more typical patient of with a branch settled vein occlusion. You can see over here, he received multiple injections, which caused a vitreomacular traction. It was a bit difficult to convince the patient to get a vitrectomy done. This is a more straightforward indication. So if you have complications, even though rare or sequelae of anti-VEGF injections, then these patients, you obviously go ahead and do a vitrectomy. What you see over here is the vitreous being trimmed around the hyaloid, around the posterior hyaloid, and then gradually making sure that the vitreous is cortical vitreous is peeled around the area of the branch retinal vein occlusion, followed by further trimming of vitreous around the VMT area, typical removal of posterior vitreous hyaloid, and then staining the ILM and then peeling it off. As usual, as in most cases, I like to go slightly slower over here and go peel across and make sure that there is no ILM remaining over here. Try to remove it in toto as against going in a capsular excess or a macular excess like fashion. You can see on the top right hand side that the patient did quite well. Patient did not require any subsequent injection either. Diabetic. So this patient I remember because patient had received, I don't know, over 20 injections, but then just kept on the edema failed to resolve, and so what we did was do a vitrectomy. I like to use Kenacort in some cases, especially diabetics, to make sure that you're removing all the posterior cortical vitreous. There is a vitreoscheisis that is seen in many of these patients, and it's important to remove all the vitreous in such situations. And I like to peel over here as well. It's not a mandate, but then it definitely increases the oxygenation and reduces the chances of recurrent edema. Your patient did quite well. And okay, so another patient with the, you can see the epiretinal membrane causing, so the chances of macular edema resolving in the presence of these epiretinal membranes is further reduced, and it's wise to go in and operate in such situations and try to reduce the chances of recurrent macular edema. You can see post-operatively on the right-hand corner, after removing the ERM and the ILM peeling, the patient did not require any further injections. Okay, let me skip this one. So, there are so many treatment modalities that are available to us, whether it's laser, anti-VEGF, steroids, PRP, surgery, but, there is such a big overlap in most of these situations. So we many a times have to use a combination of all of them, like Sir said, that he likes to use steroids and then perhaps also use you use laser, which acts, which reduces the VEGF load. Like I've already discussed, there are various mechanisms which help in such situations. That is, removing the posterior hyaloid reduces the risk of vitreous traction. It increases oxygen permeability and the tension in the inner retina, reduces the VEGF load and reduces the inflammatory cytokines. Okay, sorry about that. I don't have the time now. So what about clinical evidence? We have more and more studies. This is just one that I'm showing, that it showed that pathway vitrectomy with ILM peeling alone resulted in improvement in a greater amount of vision improvement as compared to other therapies. However, having said that, we still do prefer non-surgical treatments like intravitreal injection, which cause an increase in visual acuity rather than just stabilizing. So what I follow is, if we have a treatment-naive CME, we give patients anti-VEGF. If they are refractory, we do go in for steroid implants. I do prefer giving steroid depot implants as compared to IVT. I rarely use IVT in my practice. Anti-VEGF or steroids is a combination I don't use as much, but there are people who have excellent results with that. If there are still refractory patients, then those are the patients that I go in and go vitrectomy along with the standard ERM, ILM peeling. So in summary, in cases of recurrent macular edema which are not responsive to repeated anti-VEGF, past-spinal vitrectomy and ILM peeling is a viable option. However, even when macular edema resolves, visual acuity recovery might still not be the case because of photoreceptor layer damage. This has to be clearly explained to the patient, and we reserve this only for patients who have are not responders because of the surgical complications that can occur, and it is recommended to be the final treatment option only if there is no improvement with pharmacotherapy. So thank you very much.
Excellent, Piyush. I think the videos were really to die for. I mean, you pointed out very well, but I just want to say one thing only, Piyush, that we have to be very aware that you're going to lose the vitreous sink in these patients. So I have had some patients of PDR who have undergone a vitrectomy for the PDR, and then when they develop a refractory CME or DME after that, your anti-VEGFs don't work as well, is what I've seen. And so we have to be very wary, I think, before going in vitrectomy in these eyes, because you're going to lose the vitreous sink for the life of that patient. And the drugs don't work more than a week, I've seen in these patients. Anyone else on the panel? Any opinion on that? Or
absolutely, sir. This is what I tell my patients as well. because these patients are absolutely sick and tired of receiving these intravitreal injections, and they've window shopped, they've traveled to different continents, at least the ones that I've operated, and it's really difficult to convince them. I always tell them that if you if you do a vitrectomy in such situations, your half-life is going to reduce to less than maybe 15 days, best case scenario 15 days. And this is a risk that many of them are willing to take because they are, frankly speaking, sick and tired of receiving these multiple injections. So we reserve this as a, yes.
No, I think it's a good point. Yeah, Saurabh, please.
Calcutta is a very cheap city, and surgeries here are very, very, very cheap. So, unfortunately, I named them Disha Shushu does most vitrectomies around 30,000 rupees. Most vitrectomies. So patients will tell us, those who have finished this multiple injection, window shopping, hospital shopping, injection ka bhi, surgery ka 30 pe kar do na, nakki karo. So you usually have patients who come and telling you these things,
True. Wow.
So then it's like, "Arey yaar, ye kya bol raha hai?" And I think, like, I'm not very much in sync with what Piyush says. I have my own reservations. I have nothing against what he's saying or proposing and the studies he's shown, but somehow I'm not convinced about it. I have done my share of ILMPs. We've all done a share of these, I'm sure. But this is something I'm taking from a different point of view. Patient's point of view is $1,300, multiple injections cost more than that. So they are for that.
So I always tell them that the chances of improvement with surgery is definitely not going to be there, but the chances of improvement and with injections is certainly going to be there. So that acts as a definite deterrent because it is what we know for sure. It's only with patients who are continuously losing vision every 4 weeks, every 6 weeks, and they're sick and tired, and only those patients who just to stabilize their vision because money is, at least in the videos that I had shown, money was never an issue with these kind of patients. It was just the repeated trauma of getting injections again and again, 20 injections and 30 injections. So it's only those patients that I would, as a final resort to this.
Great work. Great view.
Dr. Piyush, can I ask a question?
Please.
Yes.
What about my topic for today, ischemic CRVO? Have you treated any cases with vitrectomy or
yes, ma'am.
Any experience that
yes,
you
ma'am.
have?
In fact, the first video that I had shown. Yes, ma'am. In fact, the first video that I had shown, patient had received I believe over 10 injections of Lucentis and I think 4 injections of Ozurdex, but this particular one did not respond to injections very well. Most patients do, and they do stabilize after a good half a dozen or dozen injections, but vision improvement isn't there in most situations like the one that you had shown. Patient vision generally stabilizes at around 360 or 660 or so. But this particular patient did not have that. So I did operate in that particular patient as well. And patient did not require any subsequent injection. Now the patient hasn't come back since 2 years. So I hope that the patient did not require any more injection. Well, if there are no more questions, I think we just finished exactly at 12. And thank you, Dr. Ragini Madam. She's also there over here. And thank you for this opportunity to have this wonderful session over here. Thank you, Dr. Swapnesh Sawant, for this wonderful opportunity. Thank you to all the esteemed speakers and faculty. Saurabh, sir, you would like to say something? Oh, okay. Over to you, Dr. Swapnesh.
Yeah. One last question, Dr. Dudani, sir.
Yeah.
Regarding the experience of Ozurdex in post-vitrectomized eyes with refractive diabetic macular edema. How do they, is it very predictable or?
Yeah, so I think that's a very good point. Actually, I have used it in a post-vitrectomized eye, and to give that injection in a post-vitrectomized eye, you always tend to have that loss of that fluid, because the full vitreous is liquid. So the eye does tend to get soft, and you have to get a real nice tunnel to prevent that. The one very sad side effect I had in one of my patients was, aphakic, because he had also had to undergo a lens removal because he had got P. acnes infection, and he was aphakic, and I gave an injection for his CME, DME. And that implant came into the AC, and you can't imagine how bad it becomes. It causes bullous keratopathy. So I think in an aphakic patient with vitrectomized, please never use an Ozurdex implant, because it always comes in the AC.
The Ozurdex, even the box says you're not supposed to use an aphakics. They have made that. And I have given in pseudophakic vitrectomized eyes. I 30 gauge needle, I inject, make the eye very high, tight pressure, and then I give the Ozurdex.
True.
One small trick that I've done before.
Thanks.
Thank you. Thank you so much, all of you. It was great hearing to your experiences.
Hello, Ragini madam. How are you?
Hi, Manoj bhai. Hi, Dr. Saurav. Hi, Pooja. Hi, Piyush. Hi, everyone.
Thank God आप दिख गए, आप दिखे नहीं रहते.
Pardon?
Thank God आप दिख गए.
Retina में दिख गए.
नहीं, welcome, always welcome, always.
So nice to see you, ma'am.
Family, I'm good to see you. हम लोग रेटिना में ये स्वप्नेश और साइली और प्रीतम बहुत बढ़िया है ना, तो हम लोग रेटिना से ही रहते हैं. So really, Swapnesh has put this program so well together.
Absolutely.
With Pritam, and I thank you all for being, and it's so good to meet at least virtually, and hope to meet you all. Swapnesh and Pritam will be organizing hopefully a live conference in January, and hope to meet you all in person.
Definitely.
Definitely, ma'am. Looking forward to seeing all of you.
I know, and your children are growing up, Pooja. By the time I see them, they will be so much more bigger.
Yes,
love you all. Thank you so much. Thank you, Swapnesh.
Thank you so much. Bye-bye.
Bye. Thank you so much. Bye.
I invite Dr. Paritosh sir for his instruction course.
Good afternoon, friends. I thank MOSCON, the scientific...
Hi, Paritosh bhai. Good morning.
Hi, Ragini Ben. How are you?
Welcome everybody for the next session.
Thank
Will
you.
disturb nahi karu. I'll see you all after you all.
No, you are never a disturbance. You are an encouragement. Thank you. I'm very grateful to MOSCON for allowing us to present this our instruction course. I am trying to get my screen shared.
Hi, Paritosh.
Hi, Karobi.
Sorry. I just lost track of time.
I'm sorry, I may need help to...
Hi, is anybody there from the numerotech side?
Okay, I think I have been able to accessibility, I've allowed it.
Doctor, what's the issue you're facing, doctor?
I'm not able to screen share from my MacBook Pro. I have said allow the apps below to control your computer. So Zoom US, I have said allow.
Okay, you're doing it for the first time. Now you may have to quit Zoom and restart again.
Okay.
I think you're using the Zoom new Mac or something. So it's for the first time you will face this issue.
Okay, so I get out of Zoom?
Yeah.
So I leave the meeting.
Yeah, you leave the meeting, close Zoom, restart Zoom. And once you're back, I will connect you on a breakout room. We can test there, and then until then, the next speaker can go ahead.
This sounds more like get out of the classroom and come back again.
But he's the chief instructor, he needs to be there.
Virtual classroom.
Mohammad sir also is traveling, so I'll be sharing his video. I have his video with me. And right after my talk is his talk, so I'll share his video also.
Whose video?
Dr. Bhomaj.
Acha, Bhomaj, okay. Can I share screen and see whether it's working?
Okay, Karobi, have you started your presentation by any
No, no,
chance?
no. I'm just checking whether this. Yeah, fine.
No,
Madam,
you'll
your
have to
screen
stop
seems to be
sharing.
condensed.
You'll have to stop sharing, then I can start sharing.
1 minute. Why is this not? Pause share. Yeah. Okay.
Not yet.
Oh shit. Where did this go?
So friends, while we are able to, get ourselves going, sorry for these technical glitches. We have a very illustrious panel today with us in this course of pole-to-pole surgery. I'm most grateful to MOSCON, the MOSCON Scientific Committee, MOSCON Scientific Committee Chairman, and all of our friends in MOSCON for permitting us to conduct this course. The participants are extremely famous and past masters in their respective fields, including Dr. Karobi Lahiri, Dr. Sharad Bhomaj, Dr. Swapnesh Sawant, Dr. Deepti Kulkarni. So while we are, Karobi, you need to quit sharing.
It's not quit as yet.
No.
I don't know what is happening.
Could somebody from Numerotech please come in and assist us?
1 minute. Okay.
Okay, great.
Yeah.
I am facing the same problem.
But since it's your introductory talk, probably you can do it without the presentation and start the conversation. I'll take you into the breakout room and we can sort it out there.
Okay, it's telling me to quit and reopen.
I think it's a new Mac or something, so we need to do a little bit of configuration in terms of security settings.
What's happening? Paritesh has gone to the break room. Can you all hear me?
Omkar, happy birthday.
Okay, I think now we are getting to it. Is the screen visible now?
Yes, it is.
Thank you. Sorry again for the glitch. Our illustrious speakers include Dr. Karobi Lahiri, Dr. Sharad Bhomaj, Dr. Swapnesh Sawant, Dr. Deepti Kulkarni. Dr. Karobi Lahiri is our first speaker, and she will be speaking to us about evaluation of pediatric trauma. Now, before she starts her presentation, this is the universally followed eye injury terminology. Either it's an open globe injury or a closed globe injury. An open globe injury implies a full thickness defect in the wall of the eye, which means cornea, limbus, sclera, anywhere, or even around the optic nerve. A closed globe injury implies that there's no full thickness defect. A closed globe injury could be a contusion or a partial thickness laceration, whereas an open one could be a rupture, which is more because of a blunt injury causing a pressurization and a depressurization of the globe. It could be a laceration. Laceration could be a penetrating injury where the object has entered on one side and there's a single wound of entry, which in case of a sharp object like a knife could also be the exit wound also, or it could be a perforating injury where there are two full thickness lacerations. So there's an entry wound and an exit wound also. All these things are important for uniformity of our conversation and conveying the findings and eventually for the results and research. There's also the zones of injury which are important for prognostication. Zone 1 is up the central cornea up to the limbus. Zone 2 is from the limbus up to the annulus of Zinn. I'm sorry, it's about 5 millimeters from the limbus, and then the zone 3 is from that ring of 5 millimeters around the limbus posteriorly to the annulus of Zinn and even beyond. Generally speaking, injuries of zone 3 and particularly the ones of zone 3 posterior are prognosis. I now invite Dr. Karobi Lahiri, who's an expert in pediatric vitreoretinal surgery, to tell us about evaluation and management of pediatric eye trauma. Dr. Karobi Lahiri, she is the head of department at Bombay Hospital Vitreoretinal Department and an expert in ROP apart from vitreoretinal trauma in pediatrics. How do I unshare my screen, sir? Do I stop the video? If I stop the video, does it get unshared? Somebody from Numerotech, please. It's not getting unshared.
Sir, at the top center, there might be a drop down.
Sorry. Got it. Pause share. Yeah. Karobi, please share your screen.
As soon as yours stops sharing. I can still see your screen.
On?
You have paused it, sir. You have to stop. Yes, sir.
It's up.
Okay, can you all see my screen? Can you see my screen?
Yes, go into the play mode so that it becomes a full screen.
Just a moment. Okay. Paritosh, thank you so much for this invitation to be on your IC. the topic for today is pole-to-pole surgery in children. Now, when we talk about pole-to-pole surgery, it obviously means right from the cornea right up to the optic nerve, and anything in its pathway which is affected by a certain problem. And sometimes there are multiple problems, and you have to deal with them either at one go or at multiple sessions. So the most important factor in these are cases of trauma where simultaneous injury has occurred to numerous structures, or there can be other conditions where you have to deal with things in the anterior segment as well as in the posterior segment. Now, ocular trauma is a topic of unresolved controversies, and there are continuous controversial and debatable management issues with this. Now, the type of injuries that we know is the open globe injuries and the closed globe injuries. And the injuries in children are very complex, and the problems are mostly related to where you have to place the incision, how you have to do the surgery, and also during the surgery the adherence of the PVD, which is a major thing to combat. And there are post-operative problems like post-operative inflammations, traction retinal detachments, PVR formations, subretinal membrane formations, and these things present later after the surgery, and sometimes the patient itself presents late because they're following the onset of macular separation or PVR. So these are few examples of the open globe injuries where you have a disruption of the anterior segment as well as a retinal detachment with vitreous hemorrhage at the back. There could be cracker or blast injuries. It could be at one time during the Mahabharata serial, we had the bow and arrow injuries where these were associated with endophthalmitis along with sometimes foreign bodies in the eye, and these foreign bodies generally used to be the wood of the broomstick, and they used to cause a lot of fungal endophthalmitis. And this is one of the old, because these are not really seen too many nowadays, and this was something which I had borrowed from Dr. Natarajan to show that there was a foreign body which he has removed, and this is how the endophthalmitis has created, which has to be combated. Now, the problems in children are that injuries in children are very complex, and as I mentioned that there are numerous problems which relate to what the post-operative sequelae are due to. Now, the occurrences at the back along with vitreous hemorrhage could be presence of detachments which may come on simultaneously, but rather they come on a little later, and the occurrence of these with the closed globe injuries are more common. Now, this is another patient where the thing is that the post-inflammatory after the detachment there is a recurrence of RD, and there is an inflammatory membrane on the macula. Now, the stages of repair generally would be either a primary repair followed by a secondary repair, where the primary repair closes whatever is the wound of entry, and that is if it's the cornea, it's the cornea, if it's the cornea sclera or the sclera. And then if there is a cataract where the rupture of the anterior capsule is there, you have to remove it at the first go. But if it is a self-sealing one, then you preserve it for a later date where you repair the cornea or the corneosclera, and then follow it up with USG, and following that after about 10 to 14 days you can go ahead for the secondary surgery where you tackle the other problems at that point of time. The ideal timing is generally for the primary surgery is between 100 days to 7 days for the secondary surgery, but early vitrectomy has more intraoperative problems, and a delayed vitrectomy is better because it has a formation of a PVD, but there are more post-operative problems with a delayed vitrectomy. So there are certain prerequisites that you have to do. That is, if you can image, you can do a USG, you can do X-rays or a CT scan, especially if you're feeling that there is a foreign body, because it helps to determine the nature and the location of the foreign body. So this is a case which is again a pole-to-pole repair where you find there was a foreign body. This happened to a child who had worn his glasses and he fell on a stone, and the glass pieces, the uh, pieces from the uh, eyeglass had entered into the eye, and the primary repair was done earlier, and this is the secondary repair where a keratoprosthesis is put. We have removed the first foreign body which was seen in the wound, and later when you do a vitrectomy you find another second glass foreign body which is there inside the eye, which is further again removed, and later the keratoprosthesis is removed and it is replaced by a corneal graft. So this is the second foreign body. This is the PFCL injection and the placement of the corneal graft. Now, coexistence with all these injuries is those like in the anterior segment, you could get hyphema, angle recessions, iris dissertions, lens injuries, scleral or corneal tears, orbital fractures. And in the posterior segment, you could get vitreous hemorrhage, retinal tears, commotio retinae, choroidal ruptures or detachment, macular holes, avulsed optic nerves, subretinal hemorrhages, and retinitis sclerotidia in the later part. And in the intraocular foreign bodies, you can get both the magnetic or the non-magnetic type of foreign bodies. Now, the thing is, these are other associations which I already mentioned, and the vitreous hemorrhage is often a accompaniment of a blunt trauma, and this is a manifestation of either a iridodialysis or a ciliary body trauma or an avulsion of retinal vessels, where there is a breakdown, subretinal bleed from a choroidal rupture or a Terson syndrome, or a shaken baby syndrome, or a whiplash injury. This is another condition where the child is shaken and you get manifestations, and the child may be even comatose and have hemorrhages in the eye. So hemorrhages in the eye in a child especially has to be seen in the light of the view that it could be a shaken baby or what we call as a non-accidental trauma these days. So what is this? We have to kind of restore the integrity of the globe. We have to allow the resolution of the hypotony, and you have to prevent infection from entering. And that is done by identify the full extent of the injury. You have a foreign body, so you have to remove it, whether it's metallic or superficial, and reposition of uveal tissue. If it is many days old, then it's better to cut it out, and the lens removal at the second go if the capsule is intact. So this is what I said was important, because the ultrasound gives us a good idea of what is happening in the posterior segment, so we know what to tackle and what to do before we go in. And foreign bodies, whether it's in which part, so that you could decide, because a foreign body like this which is placed near the pars plana area could just require a kind of a superficial kind of entry to remove it. Now, associations of a cataract, as I mentioned, that either at the first stage if it's broken, or later if it is the capsule is intact. And the secondary procedure could be a vitrectomy with either a belt buckling or a laser surgery interspersed with a cataract or a suprachoroidal hemorrhage drainage, a retinal detachment repair, a giant retinal tear repair, and intraocular foreign body which is removed accordingly.
Ruby, you will have to sum up, please.
Okay, fine. I'll just... These are a few examples of cases where the the pole-to-pole surgery has been done. This is where a cornea is removed, and after doing a vitrectomy, you place it with another graft. This is another patient, a highly kind of a dysmorphic looking eye, and how you rehabilitated by doing a pole-to-pole surgery. And removal of a foreign body, which is always a challenge. This is after the cataract is removed, you go ahead and remove the IOFB from its portion. This is a patient of endophthalmitis with a foreign body. This is Dr. Preetham's he has kindly given me his video for it's a beautiful video which shows the removal of the matter along with removal of the foreign body. And then comes the ROP, where this is again another pole-to-pole surgery, non-traumatic, where you have to go and literally work from the anterior segment involving a lensectomy, vitrectomy, and right up to the optic nerve, where you're doing a dissection of the membrane and going further down to the truncated part at the optic nerve. And these are other cases of endophthalmitis with foreign body removals and the outcomes. This is a case of vitreous hemorrhage following trauma, which is removed. Inflammatory membrane being removed in a child at the second go. And this is how we, this is with a K-Pro surgery. This is where you do it with a corneal graft, and this is just to show you that these cases can be tackled endoscopically also, but if the cornea is distorted or not there, then you have to replace it with a graft. Thank you very much for your kind attention.
Thank you, Karobi, for a wonderful exposition. You may please stop sharing the screen. And our next speaker is Dr. Swapnesh Sawant, who's the Medical Director of Anideep Eye Hospital. He'll speak to us about vitreous hemorrhage in a severely injured eye, evaluation and management.
Thank you, Paritosh sir, for considering me for this instruction course, and thank you, Moscon, for accepting our instruction course. So my topic is approach to vitreous hemorrhage in trauma cases. Sir has already illustrated the Ocular Trauma Society classification. The latest version is what he has spoken about. Just to add something is, in an open globe injury, the rupture mechanism is from inside to outside, whereas the laceration mechanism is from outside to inside. So this is what we should keep in mind. I would like to discuss a brief about the cellular constituents of any vitreous hemorrhage, or for that matter, any traumatic injury to the eye. There is first an activation of the cytokines, which are liberated by the inflammatory cells, and the first cells to arrive at the site are the macrophages. However, soon the RPE cells arrive at the site, and the study of these membranes have shown that younger the membrane, there are more amount of RPE cells on it, and as the membrane in the wound or on the traumatic site gets older, the RPE cells start reducing in size. Hepatocyte growth factor is one of the important growth factors which stimulates the RPE cells to change its character from an epithelial cell to a more fibroblastic cell or a mesenchymal cell. Glial cells also are important. They are identified by the immunohistochemistry because of the glial fibrillary acidic protein that they secrete, and they are seen around the areas of retinal holes and retinal breaks. They are independently present only in simple cases of epiretinal membranes. There is another group of inflammatory cells called as myofibroblasts, which are usually seen around the wound, which are the major cells which are responsible for the contraction of the PVR membranes that we see. On top of all this, when the fibrosis matures, there is a laydown of the extracellular matrix, mainly the collagen 1 and the collagen 3, which is responsible for the abnormal adhesions, abnormal contracture forces, which negate the natural adhesive forces. And the following is a list of the growth factors, which also have a small role to play. The major anatomical responses to any vitreous hemorrhage or any hemorrhage in the eye would be causation of the PVD, traction lardy, as I explained you, post-traumatic PVR. And we should always be on a lookout, even in a case of hemorrhage, for whether there is an underlying RD, traumatic endophthalmitis, which is there, which is confused picture with vitreous hemorrhage, or there is a IOFB, which we have missed. Obviously, we look out for mild vitreous hemorrhages, we look out for choroidal ruptures and peripheral retinal tears if it is permissible to have a good examination with the indirect ophthalmoscopy. Usually, in a close group injury, the hemorrhage is from ciliary body, retinal or choroidal vessels, and there could be associated underlying retinal tear, as I told you. Indirect ophthalmoscopy can be done with a scleral depression with a very gentle hand, only when we are sure that there is no missed open globe injury. And there is an important role of a gentle sterile B scan, which I would like to show you. This particular is a comparative B scan showing of a subhyaloid hemorrhage only, which was there because of underlying small HST and a very shallow peripheral retinal detachment, wherein other case is more like a taut PHF with underlying echos. Not very sure, this could be RD also when we go inside. So a good B scan done by the consultant himself is very important. This is more of an intragel vitreous hemorrhage and a very mild vitreous hemorrhage showing a point attachment. So we can plan our surgery, and in fact, in this patient, if the vitreous hemorrhage is clearing up, we can wait and watch if we have a fairly decent view of the retina. Some other examples, like in this case, you can see there is an underlying already two-quadrant RD, which is there with the attachment to the detached PVD over here. Here there is a close funnel RD with a pre as well as subretinal echos, suggestive of hemorrhage pre as well as in the subretinal space. And over here, there is vitreous hemorrhage, there is underlying RD plus a dislocated nucleus, which is seen in the post-trauma cases. So timing of surgery, as ma'am has told, is very important, because around 7 to 10 days after this traumatic vitreous hemorrhage is occurred, there will be PVD, which makes a surgery slightly easier, and the uveal congestion is less, and there is a lesser possibility of uncontrollable vitreous hemorrhage. In open globe injury, I think ma'am has put forward all the points, so this discussion is already done. Only thing which I would like to highlight is the MRI is best reserved for conditions of wooden, plastic, IOFBs, whereas CT scan is reserved for ferromagnetic IOFBs. However, the Hounsfield units, which are calculated depending upon what is the absorption power of these foreign bodies, metallic foreign bodies, really is almost equal for all the metals. So it really can't say whether it is it's a magnetic or a non-magnetic foreign body. It's almost the same for all the metallic foreign bodies. And the suspicion of endophthalmitis is always to be kept in mind. So sequence should be repair of the laceration, if possible, lens management, vitreous handling, and retinal repair at the same go, or differ depending upon the situation and the expertise of the surgeon. I would like to share this video of a traumatic retinal detachment, a typical case where we are clearing the vitreous around the ports, approaching with the core vitrectomy. You would be able to see other features of this trauma, in this case, capillary heme, as well as a bit of Berlin's edema. Induction of PVD, as usual, is very, very important, which can be noted in this video. So a gentle induction is important, because on the nasal side, there is a edematous retina, which your forces of induction of PVD can cause unnecessary iatrogenic breaks. Vitreous-based dissection is very important. This is a phakic patient, so you have to be really careful in your maneuvers inside the eye, and you don't want to have a post-operative cataract formation. Also, there could be some residual subretinal tissue which is left behind because of trauma, and you need to clear that. I've made a retinotomy because approach to that particular area on FG is going to be a challenge in a phakic patient. And fluid air exchange is done. and because the area, the horns of the dialysis or the edges of the dialysis, I have cryoed in this particular case, and the rest of the area, the retinopexy is done with the help of a green laser. So this is one more case where a patient was referred after the initial wound repair was done. Patient had a tone iris with a subluxated cataractous lens as well as a vitreous hemorrhage inside. What we can see is the initiation of the surgery with the lensectomy followed by the core vitrectomy. Dissection is going to be difficult because it was almost a month old after the reference was done. And you have to go layer by layer, where finding the correct plane to enter the posterior hyaloid space is crucial to have lesser iatrogenic breaks. As you can see, almost chicken fat-like or mutton fat-like thick vitreous hemorrhage is plastered over the retina. And sorry. Is plastered over the retina, and literally you have to go layer by layer to dissect out the thick vitreous hemorrhage. And I would like to show it's going to be tough to dissect it over the optic nerve head because there is underlying RD. Going to use LPFC as a third hand, and almost I am successful in doing that. And what I am going to show you is a carpet rolling of this entire thick layer. So as you can see, this carpet rolling of the thick layer of the vitreous hemorrhage and the underlying very edematous retinal detachment. So you have to be patient with these surgeries. You have to be ambidextrous, and you can see that adherent vitreous layer is rolled off. So you have to take your time, have a calm mind, and approach these cases. Apply all your skill as well as principles to get out of this sticky situation. PFCL is injected, and then it makes life more easier. And at the end, I think the case is closed with oil inside. This is the immediate post-op picture, where you can see, as I told you, a lot of RP deposition and 6 month as well as a 1 year follow-up of this case. So cornerstone is evaluation, a good evaluation from cornea to optic nerve. And in the end, I would also like to mention a good pharmacotherapy post-surgery is also crucial to reduce the inflammation and to have better outcomes. Thank you very much.
Thank you, Swapnesh, for a very nice exposition of the management of vitreous hemorrhage with and without retinal detachment. Did you put encircling band in the previous case?
Yes, sir.
Or the last two cases?
No, not the first one, but the second case, yes, I had put.
Okay. I would normally tend to put an encircling band in these cases, especially the phakic ones, because our dissection of the vitreous base is a little bit guarded in those cases. But excellent videos, and thank you very much. Our next speaker is Dr. Deepti Kulkarni, who will talk to us about intraocular foreign bodies and their management. Dr. Deepti Kulkarni is a senior vitreoretinal surgeon at Dr. Anil Kulkarni Eye Hospital in Meerut. Deepti, please go ahead with your presentation.
Yes, sir. First of all, thank you, Dr. Paritosh sir, for having me in your IC. It's been a privilege to work alongside you here, and thank you, MOS too. I'll be discussing about managing IOFBs today. First of all, the ball game with IOFB changes entirely because all this while we have been seeing that we wait for the PVD to occur and then do vitrectomy. But when we are suspecting an IOFB, then we have to operate as early as possible. There have been studies to show that a delay of more than 24 hours can increase the risk of endophthalmitis by 4-fold. And this is a huge number. So we must actively look for an IOFB in every case of trauma. Even if we assume that it is closed globe injury, we must first rule out an IOFB and only then decide our next course of management. So the nature of the injury helps us plan for the treatment and also helps in prognostication because this is a very big issue in cases of trauma, and the patients need to be counseled much more than in other cases. This picture I would like to share, although it looks like AMD or something of an adult case or rather old age case, it's not so. It's a young boy who had an open globe injury and he went close to his grandmother when she was sewing something, and the lesion or the large hemorrhage that we see at the macular area is actually a point of exit. He had a small wound at the limbus. Somehow there was not much vitreous hemorrhage. He came within a couple of hours of his trauma, but he didn't come back for the next 2 days. And by the time he came back, he was in a full-blown endophthalmitis, and unfortunately, we couldn't save his eye. But in cases like this, it is imperative that we must impress upon the patients also the need for early intervention. I won't go into the details now here because it will be a repetition. Basically, what can the IFB do to our eyes? First of all, there can be a suppurative reaction, not just with an expected infective foreign body, but also with other substances like copper, zinc, mercury, or nickel. Iron and copper do cause specific reactions, we know that. Inert materials may not cause any reaction at the outset, but they're likely to have a local reaction and fibrosis or encapsulation as time passes by. So it is important that these foreign bodies be removed too. Where a foreign body is also decides a further course of management. If we suspect that it is there in the anterior chamber and we're not able to view it, it makes sense to do a gonioscopy. If the media is not clear, then perhaps an anti-segment OCT or UBM will be our guide to help it. If it is in the iris, we must be careful to note where it is and remove it equally carefully as well. Posterior chamber, again, approach changes. The vitrectomy like we do for a plas plana vitrectomy for hemorrhages or the other cases. And I'll go into the details of the foreign body later. How are we supposed to image this IFBs? This has evolved from plain X-rays to CTs. CTs today are the preferred choice of imaging. An axial or coronal cut less than 1.5 mm is preferred so that we can localize and also determine the size of the foreign body. If we suspect a metallic foreign body, obviously we defer an MRI. B-scan ultrasonography is perhaps the most valuable tool in imaging or documenting an IOFB. An IOFB gives a steeply rising echo and a strong sound attenuation. And we can also evaluate the surrounding areas, the vitreous, the retina, and the choroid too. Now, in this case, we see that there is a small area which can be a foreign body. And once we place the A vector over that foreign body, we know that there is a 100% steep rise. So we know that we are going to find a foreign body here when we take up this patient for surgery. Also, the risk of infection has to be expected and assumed unless proved otherwise. And so broad spectrum antibiotics are of help. A most important point to note here is that antiemetics have to be given as a primary plan during our management because vomiting can precipitate expulsion. I won't go into the details, just to point out that iron particles cause degenerative changes. Epithelial structures are affected the most. So right from the lens to the cornea to even the retinal pigment, there can be retinal pigmentation similar to RP also. And since this iron can cause devastating side effects, early treatment for iron foreign bodies is imperative. Copper also causes a lot of damage. More than 85% copper results in a severe full-blown endophthalmitis. And then it's very difficult to discern whether this is an infective or copper-related. So when we are suspecting a foreign body, we have to do an early intervention as far as possible. Now, this case again was a tricky one where a part of the foreign body was stuck in the sclera and there was an intraretinal foreign body as well. So when we know that there's a foreign body in the cornea, then we must make sure we inject some viscoelastic, protect the structures in the AC, and then remove the foreign body. Iris, again, a very careful handling because it can cause bleeding and then it clouds our field of surgery. Lens warrants or surgery like cataract and IOL placement. Posterior segment surgery, depending on the size of the foreign body and where it is located, we can either go the transscleral or intravitreal. IOFB again depends on various factors, even if it is in the posterior segment, whether the patient is conscious and are there any life-threatening conditions he's dealing with. In that case, that is the only case where we can postpone. Otherwise, it has to be done immediately. Many instruments have been used by many surgeons. Of these instruments, I have only one which is similar like this. But this suture basket technique has been reported with great success, a rare earth magnet for ferrous bodies. This is what Dr. Bape and Mahesh Mugan sir had published about. And there are few studies which show the use of a nitinol stole basket. Although this is a urology instrument, this has been used for larger foreign bodies with great success. If it is an intraretinal foreign body, then there are two approaches that can be followed. One is the transscleral approach, where a flap is created, the choroid is diathermy is done to prevent the bleed, then it is incised and the foreign body removed. Although literature says that cryo is not needed, most surgeons prefer to do it, and most surgeons even prefer to place a buccal prophylactically. A transvitreal approach, again, a pars plana vitrectomy. If there is a capsule around the foreign body, that has to be removed carefully. A PXL may be used to protect the posterior pole, and the foreign body is excised. Often, the sclerotomy wound needs to be enlarged for the foreign body to come outside. All the other principles are the same: laser, oil, as and when required. This is one which I wanted to highlight here because this gets talked about very little, and in our area it is very common. Starting with winter season, from now up to early summer, we get a lot of caterpillar hair, and it's a very painful affair for the doctor and the patient as well. Right from the eyelid to the conjunctiva to the sclera and cornea, anterior segment, and rarely even the posterior segment, when children tend to rub their eyes, or they have something on their toy and they have injury along with the caterpillar hair. So these cause a very severe inflammatory response. Most of the times there is so much hypopyon, we cannot see any structures in the AC if there is a foreign body inside the eye, and it is very difficult to remove. We prefer to do this under sedation even for adults, and in children under short GA. So this also is one foreign body that we must make a point to note in our minds when we are looking at foreign bodies or open globe injuries with severe inflammation. Thank you.
Thank you, Deepti, for a most wonderful presentation on IOFBs. Our next speaker is Dr. Sharad Bhomaj. He is the director of Shanti Saroj Netralaya in Meerut, a very senior vitreoretinal surgeon and an excellent vitreoretinal surgeon. He will talk to us about vitreoretinal surgery in badly injured eyes. While Dr. Sharad loads his presentations, Karobi,
Deepti, can you share the screen? Yeah.
Yes,
yeah, go ahead. Karobi, are you still there? No. Okay.
Yes, I'm still there.
Yeah, Karobi, so can you give some tips about how one would examine a child who comes with injury and you don't know, whether it's open globe, closed globe? How do you tackle such a child, and how do you patav him to allow you to examine the child?
See, first of all, when the history is very important, because if the parents know how the child has got injured, it gives you an insight of what could have really happened. Whether he was hit by a stone, or he fell down on a stone, or something went into his eye, or something has injured his eye while playing some kind of toy, or sometimes it can be knife injuries, etc., which the child, it suddenly falls, like, and the child injures himself. So the history is very, very important, and also always watch the parents when they are giving you this history, the parents or the relatives who are there, because many a times if you find them a little shifty on the history, you know that there is some kind of sort of manipulation in the story that they are telling you. So you have to be alert to that. Then the thing is that if, like, generally the patient comes, they have generally patched the patient when they come. So the thing is, and the child is generally crying and howling away. So first is, like, you have to, like, sort of allay the child, and but you have to examine. So what do is that first you put the patient, if it's a small patient, you hold the hands above the head, and ask somebody to hold the knees, and then you have your to this specula, which are ready, not specula, I would say, just those retractors ready, where you have to put in a lot of lignocaine, and then you do a careful external examination, and then if it is possible, if you feel that it is safe, then just go in, put in a little bit of lignocaine along with this a tear emollient, a drop, and then you put in your speculum, and just sort of prise the eye open and just try to see what is the extent of injury. You have to take care that you kind of do it towards the outer side and not giving any kind of pressure on the globe. and suppose you feel that there is definitely a large injury, then it is safer to close it and do this examination directly on the table under GA, because there you would get an assessment, but you have to give the kind of prognosis to the patients, because sometimes the lens matter is out, sometimes the vitreous is out, sometimes it's a corneoscleral wound, sometimes it's a self this. So that is how you generally do the examination. You have to hold the child, because otherwise if you don't hold the child, he's not going to allow you. Even older children, it is very difficult, more in older children than in younger children, because they have strength on their side, and they generally would be sort of resisting any kind of this. So no pressure has to be given. That is the most important thing. And suppose say the injury is such, then you go and assess whatever is the nature of the injury, see what is the pupillary reaction, whether any other structures that you can see are done, and then if it is an open globes injury, you have to also take a history whether the patient has had a fasting period for a certain period of time, and then go ahead and schedule your surgery and do the rest of the things on the table itself.
Thank you, Karobi. Dr. Sharad is ready with his presentation. Please go ahead, Sharad.
Yeah, this is a video, so I'll just play the video. Deepthi, please start. Yeah. Can we hear the audio?
No, not really. We can just see the video.
I'll increase the volume on my PC so that you'll be able to hear.
Are you able to hear? No.
You can give a running commentary.
Yeah. So start from the beginning. Start from the beginning. Yeah. Yes, I'll just show a video showing some of the pearls which we need to keep in mind while managing these badly injured eyes. So the most important thing is to have a meticulous wound closure, primary wound closure. So many times the scleral injuries which are posterior can go not properly sutured. So that's very important to have a properly tight, watertight wound so that it can withstand the second intervention. The second important thing is in these eyes, we need to have an early surgery between 3 to 7 days to maximum 10 days, because most of these eyes have got a detachment, subretinal blood, and many of them are having a retinal incarceration. All these issues have to be tackled as early as possible. The third important thing is that we cannot rely on ultrasound in complex trauma to make our decisions. If there is a detachment, it can miss, and if there is not a detachment, we can feel that there is a detachment. So we have to base our decisions of intervention based on the clinical assessment. And the thing is that when you are not able to see the retina, you just intervene. The other thing is that these badly traumatized eyes, the visibility can be an issue. So surprisingly, by doing corneal epithelial debridement, by using a non-contact viewing system and using viscoat to coat the endothelium, there can be a dramatic increase in the visibility. If there is a phakic patient, then we should do a lensectomy, which can dramatically again increase the visibility. So you can see in this patient, the cornea, how it was looking, but you can see that we are able to perform all the necessary steps in this patient in spite of having a bad cornea. So you can see the use of non-contact visual, and if that is not possible, then we do a temporary keratoprosthesis, and then we go ahead with doing the intervention. So we can see one such case where the cornea was totally opaque, and then we put a temporary keratoprosthesis and we did the detachment surgery. All the steps could be done, and this retina was very stiff, so it needed a retinectomy and PFCL injection, removal of the subretinal blood. And you can see that the temporary keratoprosthesis is excellent. At the end of the surgery, we place a graft and then remove the oil at a later date. So most of these patients we can do anatomically. The other thing is that patient counseling is extremely important, because some of the patient, if you don't talk to them properly, they just go shopping from one clinic to another, and then the surgery is delayed. So this is a similar case which has been operated somewhere else, and 1 month later we are seeing this young
Sharad, we are not able to hear you clearly. Maybe if you stop the video, not the presentation, continue with the screen share.
Yeah.
You know, down below there are two buttons. One is mute and other is start video or stop video. So you stop the video, don't stop sharing the screen, just talk. So that may, help to transmit the sound better. You won't be seen, but your voice will be heard.
So are you able to hear me now?
Yes, sir, but it is a little sketchy. So you put off your video. I'll keep sharing your video from my screen here. And your video that you're using the device on, that video you put off, sir.
Sharad, please unmute yourself. We can't hear you.
Sir I can hear some bits of his video here, where he had put a PFCL and then he exchanged the PFCL with the oil directly.
So you're not able to hear me?
Now I'm able to hear you.
Okay. So this is one of the cases where, okay.
This was a suprachoroidal hemorrhage.
So, play the video. Yeah. So the other important thing is that we have to recognize the suprachoroidal hemorrhages very early.
Drainage of suprachoroidal hemorrhage, vitrectomy is done. Lipids were lasered and oil was placed.
Now you're able to hear me now?
Yes.
Yeah. So these are foreign body patients, can create multiple problems. This is a pediatric patient, and you can see the multiple the huge amount of PVR and multiple breaks which are post foreign body removal. And this can be avoided where you can have very large foreign body impact sites close to the macula. So whenever you see a very massive hemorrhage in a case of foreign body, then that's not a very good sign, because it can indicate a lot of choroidal damage, as well as there may be a retinal vascular injury which is causing this kind of hemorrhage. So you can see this is one of the patients where he had a massive vitreous hemorrhage with a foreign body, and after doing the PVD, we could see multiple foreign body impaction sites. So most of these impaction sites were there, multiple of them, and one was very close to the macula, which was along the superior-temporal arcade. So some of these patients will have very bad retinal ectopia, macular ectopia and scarring in the post-operative period, though initially they might do well. So in this patient, we did a wide ILM peel, which was around the foreign body impaction sites, multiple foreign body impaction sites. And later on, the large foreign body impaction site, a lot of choroid was exposed. So we did a deep diathermy to the choroid, and we ablated the choroid. So this is called as a choroidectomy or a chorioretinectomy. This is also useful in patients where a bad incarceration is seen in trauma patients. So with these patients, with this chorioretinectomy, they do well. And you can see the post-operative OCT scan of this patient where, it shows a flat choroidal scar and there is no reproliferation. So this patient is maintaining 6/18 vision. So another patient of a foreign body with a subretinal abscess. So we had to excise the entire necrotic retina and evacuate the subretinal exudates. And then, in this particular case, because the foreign body was impacted so firmly in the ocular coat, we explored the foreign body entry site from outside and removed it from the external route. So sometimes the foreign bodies are better and safely removed through the external route, as shown in this particular patient of a large foreign body which is impacted in the ocular coat. So we could remove it from the outside. So transcleral foreign body removal should be employed whenever it is feasible and whenever it is more safe to do than an intraocular maneuver. So at the end, after doing all these multiple interventions, we are left with an aphakic eye in many patients. So we have to reconstruct the iris, and sometimes we also need an aniridia IOL. So this is one of the examples which we are seeing. Aniridia SFIL has been placed. Thank you.
Thank you, Sharad. Excellent presentations, excellent videos as usual. Very good work, very nice. There was a question about use of MRI for detecting intraocular foreign bodies. So one needs to be careful that it's not, you're not suspecting a metallic one, yes. And second, most important nowadays, a lot of people have all sorts of implants put into them. So including certain, dental needles and dental caps and whatnot. So one has to make sure that none of those are magnetic as well. While I'm sharing my screen, just another question to the panelists. Basically, the role of one moment, please. Yeah. The role of systemic antibiotics. Under what circumstances would you give systemic antibiotics, and where would you just restrict yourself to local and intravitreal antibiotics? Hello?
Yes, sir.
So let's start with Sharad.
Yeah, actually, if we want to give any open globe injury, we have to give prophylactic antibiotics. Most of the time, oral antibiotics are quite fine. But if you have a frank traumatic endophthalmitis, then IV antibiotics along with the intraocular antibiotics and doing the surgery, all of them are supportive. They are useful.
Deepti?
So for all open globe injuries, I think it's worth giving an IV antibiotic at the outset itself because the blood ocular barrier is broken. So this antibiotics they'll give us more benefit than being in doubt and not giving them. So IV antibiotics for all open globe injuries, sir.
Would Swapnesh and Karobi agree to that? I agree with that.
I prefer to give at least 3 to 5 days of oral antibiotics to all my operated patients. So the thing is that irrespective, and the intravitreal of course would definitely be there when there is an endophthalmitis which is there. And open globe, as was mentioned, is definitely an indication for an antibiotic because it's preventive.
I generally tend to inject prophylactically also, at least vancomycin and ceftazidime, where even if it in any open globe injuries as well. So Apnesh, you have any other views?
Additionally, because the patient is there in the OT, I also encourage use of IV antibiotics. I request the anesthetist to just push in IV taxane for whatever work it is, because it's a direct parenteral route that we can access and then continue the same in the work.
Thank you. While we were all discussing different things, there is one aspect which we must not forget, and that is an occult globe rupture. So whenever one finds a deep AC, posterior iris retraction, relative hypotony, extensive hemorrhagic chemosis, vitreous hemorrhage with or without a conjunctival tear, subconjunctival hemorrhage, hyphema, may or may not be present, and RAPD may or may not be present, and a poor visual acuity, and especially a decreased ocular motility, please suspect an occult globe rupture. Like this lady, she was just being treated with topical steroids and antibiotics and homatropine elsewhere. And then actually what she had was a rupture through her cataract wound with prolapse of the ciliary body. There was a vitreous hemorrhage, of course, and she needed vitrectomy. I was not actually prepared with a scleral graft at that point of time. So I just, picked up some Tenon's capsule and applied it over that. And we had a good outcome from PL vision. She maintains 618 N12 vision. The only enigma is that with a good-looking macula, why is she not, 6/9 or 6/6 partial? It still remains an enigma. Perhaps it has to do with, the refractive errors which have been created. Chorioretinitis, I thought I'll just touch upon this as well. So this was a young person working in a factory making huge machinery, in fact, for the automobile industry. And one day there was, large machine tool broke off into two, and a large part flew like a missile and hit him on the eye. And he presented to us with that cataract, defective projection vision, and this is what happened during the surgery. Generally, these eyes have a very poor outcome. So here I said that let me see. Obviously at this stage we didn't know that what's there lurking behind. So lensectomy was performed. There was pre-retinal blood which was removed, apart from the vitreous intragel hemorrhage, and then the true extent of the damage got revealed. The entire macula was fired. Notwithstanding, I said, let me just clean up as much of it as possible. Here, what I decided is that for whatever it is worth, let's peel off the internal limiting membrane. The objective is that ILM, as all of us are aware, it's basically the footplates of the Mueller cells, which not only support, but they also can become supportive of supportive of the glial tissue which gets formed on and under the retina. So I said that let's remove the ILM so as to purportedly reduce the amount of scarring which might occur. And then after a good cleanup at the end, we did a pupilloplasty, a fluid gas exchange, and eventually injection of triamcinolone on the surface. This is just for some of the young people who might be attending our video. Baracus tonometer can be used intraoperatively. So chorioretinitis clopiteria, so clopitus is basically an old Italian style gun. It has, this terminology has many synonyms. but basically because there's no inflammatory component per se or severe inflammatory component, so retinitis or chorioretinitis clopiteria is used commonly, or just traumatic chorioretinal rupture. So basically what happens is it's a closed globe injury where the missile-like object with a very high velocity either passes close to tangent and tangential to the globe, or it also impacts the globe at a very high velocity. At that point of time, the elasticity of the choroid and retina on one hand is different from the elasticity of the sclera overlying and the posterior hyaloid, which is usually attached because these are injuries which occur in young people. So the posterior hyaloid phase and the sclera have different elasticity, and retina are different. And so the choroid and retina tend to rupture, and they retract. The posterior hyaloid remains intact and the bare sclera typically gets exposed. Now, usually it's believed to be a coup injury, but in our case, it's more like a contra coup injury, that the shock waves impact was so strong that it not only created that cataract, it caused traumatic maculopathy and also retinitis clopiteria inferior to the macula and the optic nerve head, as was seen. Typically, these things occur with BB gun or shotgun injuries, but can also occur with the fugas which are thrown during Govinda or Holi. And as in this particular case, it was at the place of work, occupational hazard. So these are these serial scans of that patient post-vitrectomy, where we see that the retina is thinned out and eventually just replaced by scar tissue formation. And because there are no photoreceptors, some amount of hyperplasia of the RPE occurs. There is transformation also which occurs and which leads to scar tissue formation. So one can see how the scar tissue has grown across the macula. This eye it recovered 6/120 vision initially, but after about 3 years, it's down to about 6/239. I have told the patient whether he would be keen to undergo any revitrectomy. He's not very keen, so we just rest at this. I shall be very happy to, if there are any questions from the audience, we shall be very happy to answer them. Is my screen share gone now?
It's still there, sir.
On? No? Anyways, I have a question for all the panelists, that in case we have an open globe injury, what kind of anesthesia do we prefer? Does everybody go in for only general anesthesia, whether IV or does anybody use local anesthesia also?
No, open globe, I prefer general anesthesia.
Sharad, Swapnesh?
Yeah, general anesthesia is ideal and it should be done in majority of the cases. But sometimes the repair has to be taken at odd times where the anesthetist may not be available, or we cannot wait for the unavailability of an anesthetist. So at in those patients, we do give a subconjunctival infiltration and midazolam. We ourselves give it, and then we take cardinal sutures to seal the wound. And after that, if the pain is there, we can infiltrate a bit of local anesthesia. You top it up as and when it is required. But most of the times, with the combination of topical anesthesia, perilimbal anesthesia, and intravenous midazolam, and taking cardinal sutures, and then give little by little top up or local anesthesia, we are able to manage most of the injuries. Unless they are very posterior scleral tears, we can manage in most of the patients, even under local anesthesia. But if the intraocular contents are already outside, especially if you are seeing the retinal tissue outside, then it is very dangerous to give a local anesthetic. In those patients, we put a tight bandage and then give general anesthesia, because even that procedure of giving general anesthesia can cause bucking, or sometimes so it can worsen the prolapse of the condition or contents of the globe. So you give a tight bandage, give general anesthesia, and then you open up. That's what we follow.
Paritosh, one question to you.
Yeah.
Like, suppose, or anybody can answer. Suppose, say, you go in.
Just before we go to that, Karobi, one thing I would like to add is that whenever we are with an open globe or a suspect open globe, if we are doing it, if you're going to use any local anesthesia, it should be preservative free. So xylocaine can be either the intraocular xylocaine, which is available, or it can be even the cardiac xylocard, which is supposed to be
You get phenocaine also now from, I think, Entod makes it.
no, that contains phenylephrine and tropicamide also.
Huh.
So that's okay. You use it intraocular, but it's a very small quantity that we need to use. Otherwise, it can cause endothelial damage or other. Yes, Swapnesh, please.
Decision to whether to give a GA or a LA really depends on the fasting of the patient, because if suppose we consider a scenario that he's coming at the odd time of the day and we have to operate, the patient is insisting on operating, and are we then operating without anesthetist? Because if the anesthetist is there around, then why not wait for 3 hours more or 4 hours more, whatever it permits, and then give a GA. So especially doing these trauma cases without anesthetist on paper, medical legally, it could be a challenge. So only from that point of view, obviously a scleral wound, a small laceration, we all know we can give blocks and do it. But then are we then doing it without anesthetist? Even that is not like a good thing to do without anesthetist.
So, Apnesh, I wanted to add, Paritosh,
Yeah.
that anyways you have to do the investigation. So sometime will go in that. You can easily arrange for an anesthetist in that point of time.
Yes. But sometimes I still
Fasting
remember
also
of
can be
my
maintained at that time.
yeah my good old days in when I used to visit Miraj. Getting an anesthesiologist sometimes used to be really very difficult. So I guess I don't know what's the situation now, but I guess sometimes those difficulties must be arising even now. Those are the sorry, Karobi, please, you had a question.
No, I had a question is that suppose say you go in and you are operating and then you find that there is underlying an endophthalmitis, you have a detachment. What would you do? You would proceed. I mean, if you find a hole and would you proceed in the view that maybe later you will go back and treat the detachment, or you would leave it alone and come out?
No, I would go ahead, treat the endophthalmitis. I mean, in the sense, do the vitrectomy for that also. But I would go ahead and induce as much of a PVD as I safely can without creating too many breaks. But I will treat that detachment, and I will go ahead and put silicone oil inside that eye. And I will cover it up with systemic antibiotics, IV antibiotics.
What about the rest of you?
I think if it is possible to do the surgery, it should be done in the same sitting. That's the ideal thing. We should do it.
Yes.
Because things are going to get only worse when we postpone it.
Swapnish, what about you?
Yes, sir. If the media is clear, just go ahead and try and settle the detachment.
all these eyes are going to mean such an eye is obviously going to require multiple resurgery.
Interventions.
So, but then at least because otherwise if we don't fix it then there's a very high likelihood that it might go into a closed funnel RD with a PVR, and then may become difficult to open it up later on by the time the inflammation has reasonably subsided. Do any of the panelists have any other questions? I'm sorry, because of the glitches at my end in the beginning, I think we've overshot the time. Do any of the audience have any other questions? I think there was only...
There was just one question in the chat box that we have not answered. If it's necessary to do an MRI from medico-legal perspective, even if the globe is intact, or if there's just a suspicion, but we have not been able to prove a foreign body.
what would you think? Yeah, what is your answer to that?
So I'd say no, MRI is not justified doing just an MRI just because we want to complete a medico-legal aspect. If we are suspecting, then we are anyway going to do a B scan or a CT scan, which is more easily available and much more affordable compared to an MRI.
Wouldn't if you are not very sure and just a mild suspicion is there, just to cover the medico-legal aspect, wouldn't a simple X-ray, PNS with Waters, Caldwell's, and lateral view be sufficient?
Yes,
that would be more than sufficient.
Because I still follow that, and
yes.
Then if required, then we pursue further imaging. Are there any other questions or points of discussion from the panelists? So thank you very much, all of you. It's been an excellent course, and all of you had excellent videos. Most grateful. Thank you very much for all your presentations. And I hope whoever from the audience attended also, I hope they benefited. And thank you once again, Moscon, for this opportunity.
Paritosh, thank you very much. It was a nice instruction course.
Thank you, Karobin.
Thank you,
sir, and thank you all the
Dr.
presenters.
Paritosh bhai, thank you, Karobin. Thank you, Bomad
The
sir.
next session,
Thank you, Dipti.
the
Thank you, Swapnesh.
The woman in red has come back.
Thank you, Ragini.
Flying around.
Yeah.
I'm actually just showing that I'm working. Actually, Swapnesh, Shirish, Sumit are doing all the work. I'm pretending to.
No, even pretending takes effort.
Wonder Woman.
You have already done your brass tacks and soiling your hands over so many years. So I think it's time that you should
time to pass the baton.
But you should
Overdue.
Thank you.
Thank you. Nice to see you, Bomad sir. Thank you, Paritosh bhai. Thank you, Ma. Thank you, Dipti, Swapnesh. Thank you, everybody.
Bomad sir, excellent videos. Bomad sir, तुमचे videos super होते.
Only thing is the audio was not playing.
आमचं चुकतंय ना, आम्ही कॅटरॅक्ट मध्ये तुमचंच फॉल्ट आहे. बोमाद सर हे सगळे जेव्हापासून आहेत ना, प्रीतम, स्वप्नेश, शैली, त्याच्यामुळे आम्हाला रेटिना येत नाही. आता ते स्पेशली परत जाऊन बघावे लागेल. If they were inefficient, then I would be doing retina.
Yeah, you tell them now that you'll हट जाओ हम लोग करते हैं.
No, or best is just send them on a holiday, na, for some time.
No, ऐसा कुछ नहीं.
आपकी 200 की लिस्ट इज मोर देन वीआर सजेस्ट
सर अभी तो 200 नहीं है, अभी तो 50-60 पे रुकी हुई है, गाड़ी अटकी हुई है.
It's just a matter of time. It's just a matter of time.
I know. Hopefully be back.
How you people are able to do so many surgeries, I think it's just amazing. That itself calls for an instruction course, according to
I know. On managing numbers.
5,000 patients in a camp.
Wow.
5,000.
Wow. Mind-boggling.
I'm feeling
so, some areas are like that, Parvani, Beed and Parli.
Okay.
Like if sir landed there the night before, And I was just saying कि sir आपने किसको बताया नहीं तो my resident is saying अच्छा हुआ ना sir छुप के सो गए थोड़ा रेस्ट मिला नहीं तो कैंप अगली रात से ही शुरू हो जाए. It's that bad.
I know.
People running after sir, but it's good. It's good. We love the patients and they love us.
I know. At that moment, it's a different mood, you know.
Dipti, I think you have an announcement to make for the upcoming Moss Melodies.
Cultural Fest.
Yes. The
Yes,
next
ma'am.
session here is the MOS Melodies. So it'll be a shift from the non-romantic retina to a romantic MOS Melodies.
No, who says retina is not romantic? I think it's very romantic, you know. हम लगे रहते
I
हैं.
disagree.
लगे रहते हैं बस.
Paritosh, I disagree.
अरे no करो भी.
I don't romance the retina. You may be doing it.
There are so many good retinal surgeons singing. Sandesh sir is an example.
I
He sings also, he plays instruments also. He's so passionate about singing.
So that's why he
Darshana
romances
is looking so
it.
nice and fresh. The cultural committee has joined.
Yes.
Yeah.
Thank you everyone. Thank you.
Yeah.
Bye.
Thanks for
Bye.
it.
Bye.
Thank you everyone. Thank
All
you.
the panelists today request to join evening session also of MOS Eye Talent. Please.
Yes. Yes.
Thank you.
Bye.
Bye. Hi, Gitanjali.
Hello, Gitanjali ma'am.
Hi Gitanjali. Hi Vanashri.
Hi, Manishri.
Hi, ma'am. Hello, ma'am. How are you?
Suddenly the
All
session
set to say,
changes, you know. The vibe of the session changes so suddenly, you know.
I know. All the
This is a
females
very
and
good
the males
idea,
are
you
not
know.
to be seen.
Vanishri is there, Dr. Sachin, everyone, almost everyone has
Are there?
joined.
Okay.
Sandesh sir is there, Vaijanti Gadre is there, so everyone is there.
Darshana, all yours.
Yeah. So, should we start, Ragini ma'am?
Start.
Yeah.
Quickly, all yours.
Okay. Good afternoon. Namaste. Welcome everyone to this very interesting session of MOS Melodies. I promise that these super singing stars of MOS will really entertain you with their beautiful songs, melodies. Let us start right away with our first singer, Dr. Vanashri Nair. She is she's an anti-segment surgeon in Kochi, but has taken training in classical singing and is our winner for MOS Idols this year. I may say that she is Asha Bhosle of MOS because she is so versatile. Welcome, Vanashri. Can you switch on your camera?
Yeah, she has. She has. Just unmute yourself, Vanashri.
Can you hear me?
Yes, we can.
We can.
Thank you. Thank you so much.
It's a pleasure having you here. Let us play your song.
Sure, ma'am.
जिया जाए ना बिन तेरे तेरे बिन साजना सांस में सांस आए ना तेरे बिना जिया जाए ना तेरे बिना जिया जाए ना बिन तेरे तेरे बिन साजना सांस में सांस आए ना तेरे बिना जिया जाए ना जब भी ख्यालों में तू आए मेरे बदन से खुशबू आए जब भी ख्यालों में तू आए मेरे बदन से खुशबू आए महके बदन में रहा ना जाए रहा जाए ना तेरे बिना जिया जाए ना तेरे बिना जिया जाए ना बिन तेरे तेरे बिन साजना सांस में सांस आए ना तेरे बिना जिया जाए ना तेरे बिना जिया जाए ना रेशमी रातें रोज न होंगी ये सौगातें रोज न होंगी रेशमी रातें रोज न होंगी ये सौगातें रोज न होंगी जिंदगी तुझ बिन रास न आए रास आए ना तेरे बिना जिया जाए ना तेरे बिना जिया जाए ना बिन तेरे तेरे बिन साजना सांस में सांस आए ना तेरे बिना जिया जाए ना
Wonderful.
Thank you, ma'am.
Tell me, Manashri, is like it gets hectic sometimes, or you always enjoy whenever you are like called for singing a song?
It's a hobby, ma'am. So whenever possible, I do try to record songs or sing songs. So whenever possible, I do try to do it. Always not possible, but being a hobby, it's not
Enjoy
hectic.
every bit of it.
Yeah, thank you, ma'am.
Lovely, lovely. Thank you so much.
Thank you.
Karobi ma'am? Our next singer is Dr. Sandesh. Are you there?
Yes, he is there. Sandesh sir.
Okay. We have pleasure of having Dr. Sandesh sir, Doshi sir, who is a singer, who plays instrument, who is a marathoner and whatnot. He's a VR surgeon from Pune, and I have always found him so active and so versatile and always happy to contribute to any program. Sir, we really are lucky to have you, and we'll like to request to play this song which you have given to us.
तेरा मेरे हमदम मेरे दोस्त ना जा कहीं अब न जा दिल के सिवा है यही दिल पूछा तेरा मेरे हमदम मेरे दोस्त ना जा कहीं अब न जा दिल के सिवा बेसबब उड़ेगी हर सू तेरे पैर हन की खुशबू बेसबब उड़ेगी हर सू तेरे पैर हन की खुशबू इधर तो आ सवार दूं खुले खुले ये गेसू वफा देती है सदा ना जा कहीं अब न जा दिल के सिवा ना जा कहीं अब न जा दिल के सिवा के खून दिल मिला के भर दो इन लबों के खाके आके खून दिल मिला के भर दो इन लबों के खाके बुझा बुझा बदन तेरा कवल कवल बना के खिला दूं रंग जा कहीं अब न जा दिल के सिवा। आज शहर दिल में चलकर सूरते चराग जलकर, आज शहर दिल में चलकर सूरते चराग जलकर, इसी झुकी कोई नजर के काजल से दिल पर लिखे आना में वफा। ना जा कहीं अब न जा दिल के सिवा, है यही दिल कूचा तेरा ऐ मेरे हमदम मेरे दोस्त। ना जा कहीं अब न जा के सिवा, ना जा कहीं अब न जा दिल के सिवा, दिल के सिवा, दिल के सिवा। Thank you for listening.
Superb, Sandesh sir.
Mesmerizing, mesmerizing.
Your energy and everything. You know, watching him is also such a great pleasure.
कोई नहीं जाएगा छोड़ के इतना अच्छा गाना। सर ये एनर्जी कहाँ से लाते हैं आप? कुछ तो हमको राज बता दीजिए।
Just be happy about it.
I can see on your face. We can sense it, sir.
Very happy to be part of this program.
Yeah, it's our pleasure to
Yes.
have you. Yeah.
Gitanjali ma'am.
Yeah. Yes. Let's now move to our next singer. And it's really my pleasure to, introduce Dr. Devika. I have seen Devika when she was a small baby. तर मला असं वाटतं ती बोलायच्या आधी गायलाच लागली. देविका, you can start your video. She is a natural singer, but she has trained herself and very, very fortunate to share a stage with none other than Pandit Hridaynath Mangeshkar. So here is Devika for you, who is doing final year residency, MS Ophthalmology at Karad.
जहाँ चलेगा मेरा साया साथ हो, तू जहाँ चलेगा मेरा साया साथ होगा, मेरा साया तेरा साया, मेरा साया मेरा साया। करेगा मेरा साया साथ होगा तू जहाँ जहाँ चलेगा मेरा साया साथ होगा मेरा साया मेरा साया मेरा साया मेरा साया तू अगर उदास होगा तो उदास होंगी मैं भी तू अगर उदास होगा तो उदास होंगी मैं भी नजर आया ना तेरे पास होंगी मैं भी तू कहीं भी जा रहेगा मेरा साया साथ होगा मेरा साया मेरा साया मेरा साया मेरा साया
Superb, Devika. Devika, can you start your? Yeah, how are you?
Hi, hi all. I'm fine.
Beautiful, very melodious voice and beautifully sung.
Wonderful, wonderful. And Gitanjali, you are looking so beautiful as ever.
Oh my God.
Yeah, that's true.
Devika, my question to you is, how are you managing your riyas during this busy schedule of residency?
That's a difficult question to answer, actually. But yeah, I have somehow managed to do it. And luckily, since I have been practicing since so much of years, so it has just paid off right now. की फिर से वही आता परत नाही करत बसायला लागत आहे तितक्या डेप्थ मध्ये जेव्हा केव्हा टाइम वेळ मिळतो त्यावेळेला आय एम मॅनेजिंग टू डू इट
Devika, lovely song. I'm sorry I was busy during the other people was on the phone, but
Okay.
everyone was so melodious. Sundays, as usual, dancing and right
Yeah.
in the mood. Vanashri also does her bit so well, and it's really nice to hear you all. And I'm feeling nostalgic of the BOA this afternoon sessions that we had,
Yeah.
and it's really nice having you all
It was
over
fun.
here. And thank you for consenting to come on the show because now you people are celebrities. So
Yeah.
Yeah.
this is like we've got appointment with celebrities. So we feel good,
That's really true.
What do you
That's
say,
really true.
Darshana, Gitanjali?
Yes,
Yeah.
yes,
They are
definitely.
so
They are
super.
celebrities.
I
You
know.
know,
Names.
Nothing like that. Please don't say that.
they
Hey,
are famous
Vanashri,
all over
you also
India.
won, okay?
Yeah, everywhere they are famous.
But Sandesh, वो तेरा mandolin missing है रे?
नहीं नहीं आएगा ना शाम को आएगा
अच्छा शाम को आएगा अच्छा
हाँ
और whistling भी missing है. Whistle
नो
बहुत missing है.
करवा लेंगे
नहीं,
सर से
गीतांजलि तू ज्यादा बोली ना तो वो तेरे लिए विसल करेगा
करने दीजिए ना. मुझे चलेगा मैम.
अरे माय गॉड संदेश टेक इट एज अ एडवांस ओके
whistling can be extempore also you see
Yeah.
यस यू कैन डू दैट अच्छा थोड़ा बजा दे ना 2 सेकंड के लिए
कौन सा गाना
कोई भी जो भी तेरे को पसंद है
अभी लेट्स से तू जहां जहां चलेगा
हाँ
Okay.
आता हाँ
Yeah.
Thank you.
Superb.
Excellent. Gitanjali, this was
Wonderful.
not for you. This was Devika. This is for Devika. And I saw Devika scratching her head, ki wondering किसके लिए बजा रहा है. But Sandesh, fantastic. What lung function, yeah? What
हम और
lung
इंटरल्यूड के
function,
साथ
yeah?
गाया.
He'll never have any respiratory ailments.
Yeah, beautiful.
Beautiful.
हे पूर्व पुण्य आहे हे मागे कधीतरी गाणं बसवलं होतं मी.
अच्छा अच्छा ओके हाँ हाँ that we believe.
Let's now go to our next singer, Dr. Sachin Atle. He is a cornea specialist, cornea surgeon from Pune, an excellent singer, and like Devika, he has won many awards in singing competitions, ophthalmology, non-ophthalmology, all doctors competitions and otherwise. He is also a trained singer. So over to you, Dr. Sachin Atle now.
Hey, you should all call them celebrities. And Sachin, you will be allowed to sing only if you first smile.
Yes, sir.
Look at us, me and Karobi madam, we are always laughing.
I know. Yeah.
So much.
Sachin, I saw you smiling. Now you can go ahead.
धूप से निकल के छाँव से फिसल के हम मिले जहाँ पर लम्हा थम गया, आसमां पिघल के शीशे में ढल के जम गया तो तेरा चेहरा बन गया। दुनिया बुला के तुमसे मिला हूँ, निकली है दिल से ये दुआ, रंग दे तुम मोहे गेरुआ, रांझे की दिल से है दुआ, रंग दे तुम मोहे गेरुआ। हाँ निकली दे तुम मोहे गेरुआ। शुरू तुम पे फना है सूफियाना ये दास्तां, मैं कारवां मंजिल हो तुम, जाता जहां को हर रास्ता, तुमसे जुड़ा जो दिल जरा संभल के, दर्द का वो सारा कोहरा छन गया। दुनिया भुला के तुमसे मिला हूँ, निकली है दिल से ये दुआ, रंग दे तुम मोहे गेरुआ, रांझे की दिल से है दुआ, रंग दे तुम मोहे गेरुआ। दिल का जहां जिस दिन से तू दाखिल हुआ, एक जिस्म से एक जान का दर्जा मुझे हासिल हुआ। आप ही के हैं सारे नाते जहाँ के, तेरे साथ रिश्ता गहरा बन गया। दुनिया बुला के तुमसे मिला हूँ, निकली है दिल से ये दुआ। रंग दे तू मोहे गेरुआ, रांझे के दिल से है दुआ। रंग दे तू मोहे गेरुआ, निकली है दिल से ये दुआ। ओ रंग दे तू मोहे गेरुआ।
Sachin, how you manage to select nice songs every time? Every time you perform, your song selection is so good.
Thank you so much, ma'am. Thank you so much.
You know what, Darshana, Sachin Dada, wonderful. Darshana, I'm worried कि साइंटिफिक सेशन में कोई आएगा नहीं, वो बोलेंगे यही कंटिन्यू करो. It's so good on a Sunday afternoon.
Their time.
Sachin, three things, Sachin.
Yes.
One, wonderful
Yes, sir.
singing, no comparison.
Thank you.
Okay.
Thank you.
Second is that you are smiling. I'm happy. And third, don't sing Shah Rukh songs now. The NCB will be after you.
Yes, ma'am. True.
No, but wonderful. Very nice. Very nice.
Thank you so much.
We even have a nice lineup. Next is Dr. Vaijayanti Gatre. She is a anterior segment surgeon at Dinanath Mangeshkar Hospital, Pune. And she is doing community work also and has learned light classical music since 7 years. I welcome you, Dr. Vaijayanti. We'll first hear your song.
Thank you. Thank you, sir.
बाहों में चले बाहों में चले हो हमसे सनम क्या पर्दा हो हमसे सनम क्या पर्दा ये आज तक नहीं मिलन ये संग है उम्र भर का बाहों में चली हो हमसे सनम क्या पर्दा हो हमसे सनम क्या पर्दा
Superb.
Oh, wow. Just
Wonderful. Her voice is like Rasmalai here.
Yeah.
It's so smooth and velvet.
Yeah.
Vasanthi, very nice.
Today's all songs were romantic.
Yeah.
Ultra
Kadwa Chauth hai, Kadwa Chauth.
right. Or next
Hey,
time
don't remind me. Hey,
Meena
Bhagwan,
Kharat.
don't remind me. Hey, now it should be
Complain of
that
the
the males
Vasanthi,
are doing for
beautiful.
the women.
But wonderful. Really, everyone is enjoying. Next session allowed us for another 5 minutes. So we'll quickly introduce Dr. Meena. Dr. Meena Kharat is from Pune. She is anterior segment surgeon. She is with Dr. Parikshit Gokhale sir. And I invite her to present her song.
She is also winner of our MOS Idol.
MOS Idols. It's a wonderful song.
Hello, I am Dr. Meena Kharat from Pune.
Superb, Meena.
We wanted it to continue only. I was like waiting.
Yeah. Even I thought she's continuing. It is so beautifully sung.
Super, Meena. You know, Beena and I were residents together.
Oh,
okay.
Okay.
So beautiful. And such a lovely voice.
Yeah.
Great. We have extended time for the next session by 10 minutes. I really apologize for it. And we'd like to hand over this session to the next moderator. And thank you so much, everyone.
Yeah, thank you so much.
Yeah, thank you, madam. Thanks for handing over. It was a wonderful session and we too were enjoying it.
It was your kind permission, really.
Yes. We thank you a lot.
Thanks. So, from all the masti and singing, let's now come back to our ophthalmology core. And here we are with the instruction course that is vitreomacular interface disorders.
Thank you, Dr. Anirudh. I'm sorry, but it was so wonderful. We didn't have the heart to stop it.
Yeah,
Thank you so much. Thank you. Hi, Dr. Anirudh, Dharmesh. Hi, everybody.
Hello,
Thanks,
ma'am.
thanks.
Yeah, thanks,
In
ma'am.
fact,
It
it
was
was
very
lovely.
nice.
In fact, yeah, Dharmesh.
Yeah, it was very nice. So we really enjoyed it.
And in fact, Amol, are you there? So Amol is our great singer.
I'm here.
Yeah, Amol. So
Hi, good afternoon, everyone.
yeah. So now let's go on to core ophthalmology, and this is vitreoretinal interface disorders course. So it's an instruction course. So the speakers are going to be Dr. Dharmesh on macular hold, Dr. Vikram, and Dr. Jaideep Walinchkar, as well as our panelist, Dr. Amol and Dr. Chinmay. Amol, how are you?
I'm great. How are you all?
Excellent. So let's go.
Yeah,
So
good
no
to see you all.
financial
Hi,
interest.
Dr. Amol. Hi, Jaideep. Hi, everybody.
Yeah.
Hello.
Nice to have you.
Thanks a lot. So we have no financial interest, and in this there will be some off-label use of intravitreal triamcinolone and intravitreal brilliant blue. So what is vitreoretinal interface anatomy? First, most important is posterior cortical vitreous, which is mainly collagen type 2, along with hyaluronic acid, glycoproteins, and the most important part another is internal limiting membrane, mainly collagen type 4 and laminin, fibronectin, and proteoglycans. So this is one video which I have taken from actually YouTube. The source is mentioned below, and we can see the vitreous. The aqueous is in front, the vitreous body. So this is the main vitreous body. This is the vitreous cortex. This is the anterior surface. The vitreous base is one of the strongest attachment of vitreous. We all know that. The other important attachments are at the optic disc, the parafoveal area. So this is the cloacoid canal, is the actually embryological structure wherein the blood vessels supply the blood supply and then they regress.
Now, let's take advantage of our ability to take back and show what the vitreous would look like if it was dissected free from the back of the eye. I have left it attached in front of the eye.
So this anatomy is very, very important in understanding vitreomacular interface disorder. So this is the main vitreous cortex, and all our surgeons will be dealing with the vitreous cortex and the interface between the cortical vitreous and the internal limiting membrane. So we can see where the cloacoid canal is missing. This is the attachment. Now if we go into biochemistry, these are the collagen fibers that are seen. In a young patient, these are all transparent and the vitreous cortex is attached to the ILM. So if we zoom in and look at the collagen, we can see that these collagen fibers are structures and then there are cross-linking between two collagen fibers. So this is very well interspersed and that gives clarity, and we can see hyaluronan going around the collagen. So this anatomy of vitreous is very important because newer drugs are coming up which can help us in treating vitreomacular interface disorders. And as we age, this anatomy, this biochemistry of the collagen fibers and other structures starts to change. So temporal changes. So this is liquefaction of the vitreous and increasing liquefaction. As age increases and in some pathological diseases, we can see. So we can see that the distance between the collagen fibrils changes and they start to form clumps initially, which gives rise to vitreous floaters. And as we age, this number of floaters keep on increasing. So we can see the number of floaters has increased. And this is associated with vitreoretinal interface disorders. So the patients have symptoms like light flashes, new floater formation, and loss of vision sometimes. And one of the most important anatomical and physiological change which occurs with age at the vitreoretinal interface disorder is the separation of cortical vitreous, which is called as posterior vitreous detachment. So we can see that the liquefied vitreous starts to seep and separation of cortical vitreous occurs. But it is attached at the optic nerve head and at the fovea. So this separation begins around the fovea. The vitreoretinal interface disorders that we are going to study. Sometimes if it is natural, then it keeps on progressing and is attached only at the optic disc initially, and then also separates from the optic disc. And then the patient will have the typical symptom and we can see the V ring on clinical examination. So this is the usual course of posterior vitreous detachment. We can see young cortical vitreous attached, then perifoveal separation. In a normal state, the fovea separates, optic disc remains attached, and ultimately the optic disc also separates. So this is some other thing like. So vitreoretinal interface disorders can be listed as vitreomacular traction syndrome, idiopathic macular hole, lamellar macular hole, epiretinal membrane, even myopic fraction maculopathy, interface disorders in PDR, age-related macular degeneration, and other interface disorders like the retinal tears and other such things. So vitreous gel liquefaction and weakening of the vitreoretinal adhesion that we saw in this video, wonderfully demonstrated, cause complete PVD, and liquefaction results in the mismatch and causing of anomalous PVD. So in retinal periphery, this results in vitreomacular interface disorders of tears and detachment. At the macula, VMT, macular hole, ERM, and other changes related to diabetic macular edema. And at the optic disc, we can have vitreopapillary traction. So OCT is now one of the most important diagnostic tools to help us in determining the vitreoretinal interface disorders. The most important thing is that we should not restrict ourselves to single photograph that the patient sends us on WhatsApp. We should go through the whole OCT scan. OCT itself has now classified it as vitreomacular adhesion, vitreomacular traction, and full thickness macular hole. So by the vitreomacular traction study classification system. Most eyes have a complete adhesion at birth, and vitreomacular adhesion is a normal state, but slowly it starts to separate. So partial PVD, then persistent vitreous attachment to the fovea, then acute angle between the posterior hyaloid and the inner retinal surface, absence of changes, and then macular hole formation. So here we can see there is only foveal adhesion. Here we can see there is a broad-based macular adhesion. So the correlation is stage 0 of original GAS classification and international classification system. So epiretinal membrane, there are other things which is a macular pseudo hole and a lamellar macular hole. So lamellar macular hole is the spontaneous rupture of the inner wall of the large central cystoid space to form a lamellar hole in one major complication of the cystoid macular edema. Whereas spontaneous contraction of an epiretinal membrane that surrounds but does not cover the foveolar area may produce a biomicroscopic appearance simulating a full thickness macular hole, but it is not a full thickness macular hole. So this is a lamellar macular hole. Management, the general principles are the same. A vitrectomy, separation of the hyaloid is done. So we usually triamcinolone acetonide to stain, and then we induce a posterior vitreous detachment followed by internal limiting membrane peeling. And in some cases, we can do a vitrectomy with an epiretinal membrane peeling, depending on. So gentle posterior hyaloid separation and careful ILM peeling, as our surgeon team will describe, is the most important thing in the management. Thank you. Over to you, Dharmesh. We'll go through the talks and then we will cover the questions. What do you say?
Yeah, same. That's great. So
I will stop sharing.
Yeah, you just stop sharing. I'll start.
Yeah, I've stopped.
Yeah, good afternoon, everyone. And thanks, Anirudh and MOS for inviting and being part of this instruction course. As a macular hole, we know it's a very common thing. It's easily diagnosed on fundus photography. Every day we see in our practice. And with the help of OCT, it's become the very simple thing. First described by Knapp and just a minute. Yeah, it's first described by Knapp and Noyes in 1869 and 70, and term was coined by Ogilvy in 1900. But the factors for inciting macular hole is a vitreous synersis, posterior vitreous separation, cystoid macular edema, traumatic blunt injury, or high myopia. One more hydration theory was proposed by Tornambe, and he says the perifoveal traction with the hydration of the edges of the macular hole causes the breach to expand more and increase in the size of the hole. Now, incidence is 0.05% more in the female. Lack of estrogen is being suggested, and bilateral in 3 to 22% of the cases. Now, this is the gas classification. Donald gases work too much, and this is all given before the OCT has come. So this is stage 1A, 1B, 2, and stage 3, and stage 4. So how he has described stage 1 is the localized shrinkage of the prefoveal cortical vitreous and the tractional shallow detachment of the foveola. But there's a lack of the Watzke sign, and then the light reflex is just foveolar depression is gone. And stage 1 is a small yellow spot, that is 250-300 micron. And 1B is a foveal detachment and yellow halo forms. So this is stage 1. And stage 2 is a minute hole from the near the center, and it's a detached fovea. There is not inevitable process. 50% of the cases, there is a vitreofoveal attachment spontaneously. That's the stage 2. In stage 3, there is a full thickness macular hole greater than 450, but no posterior vitreous separation. And this is the common presentation in the clinic we have seen. And this has the positive Watzke sign and some fluid or the cystoid changes at the margin of the macular hole. And this is the stage 3 we see. But we can see here on the OCT there is an operculum. And in stage 4, there is a full thickness macular hole with posterior vitreous detachment. So there is a total PVD, and then the full thickness macular hole is stage 4. Now this International Vitreomacular Traction Study Group has again reclassified after the OCT has invented, and there's a lots of thing on vitreomacular adhesion, vitreomacular traction, and so many things came. And then we again OCT derived anatomical findings, and the classification was proposed. So now OCT based VMA is already being discussed by Dr. Anirudh. It's like cortical vitreous above the retinal surfaces and vitreous remaining attached within a 3 mm radius of fovea without retinal abnormality. That can be focal, that is 1500 micron, or a broad more than 1500 micron. And vitreomacular traction criteria about OCT is the perifoveal vitreous cortex detachment from the retinal surface, macular attachment of the vitreous cortex within 3 mm radius of the fovea, An association of attachment with distortion of the foveal surfaces, intraretinal structural changes, elevation of fovea above the RP, or a combined thereof the factors. Now, VMT can be subclassified into focal or a broad, depending on the width of the vitreous attachment, and can be generalized thinking for the macular vascular leakage on FFA, schisis, or the CME, where a focal area shows the distort foveal surfaces, elevate the foveal floor pseudocyst formation in the central macula. ERM formation is always seen as the residual vitreous remain on the surface of retina after the PVD, and that's called vitreous schisis, and then later on that form the epiretinal membrane. Now, full thickness macular hole classification based on the OCT is as per the size of the hole, presence or absence of the vitreomacular traction, and the cause. So, aperture size is being diagnosed as 250 micron, 250 to 400 micron, and more than 400 micron. So, they are usually macular hole, it's concurrent with the vitreomacular traction associated, then only they can be tried for the pharmacological vitreolysis. It can be again diagnosed between the primary or secondary full thickness macular hole. Primary is idiopathic, secondary can be blunt trauma, lightning strike, high myopia, macular schisis, wet AMD after the anti-VEGF. So here we measure the aperture size on the OCT, and we can small, medium or large classification done, and along with the vitreomacular traction or the posterior vitreous status can be diagnosed on the OCT. Now there is a comparison of the chart where, as per the first classification of the gas classification of 1 to 4 stage, and here is the vitreomacular adhesion traction, small, medium, large, full thickness macular hole with or without the vitreomacular tractions. Now, impending macular hole is the case with full thickness macular hole in one eye and vitreomacular traction on the OCT in fellow eye. And VMA in a fellow eye has been referred to as a stage 0 macular hole. Now, lamellar macular hole is the irregular foveal contour defect in the inner fovea, schisis, and typically between OPL and OLN and the intact photoreceptor layers. And that can be seen in a cataract surgery, myopia, uveitis, AMD, or RD, and the treatment is always a controversial. Pseudo hole can be diagnosed on the OCT with the hip foveal edges along with the ERM, steep macular contour, but no loss of the retinal tissue. Now, pseudo hole can be of the two types, either tractional or degenerative types, and both can be easily diagnosed on the OCT, where here we can see there is the cyst changes formation with the elevated surface. So this is the traction. Watsky-Allen signs can be used for the diagnosis. Management is surgery, vitrectomy with ILM peeling, SF6 gas, and a prone position, initially for 2 or 3 days, more importantly, first 24 hours. Larger holes require inverted flap technique. Field surgery may require amniotic membrane graft and retinal patch graft. A small surgery, we usually do different method of ILM peeling. I'll just show you the pinch and peel of the, bringing the edge of ILM. And once we get the edge of ILM peeling can be done completely. And in circumferential manner, we remove the ILM. All sutureless 23, 25, 27 gauge vitrectomies can be done for macular hole. And once the ILM peeling is done, FGE and the gas injection is performed. So once we complete the circumferential ILM peeling, fluid gas exchange done and SF6 is injected. Sure. Thank you. Thank you very much.
That was really wonderful, Dr. Dharmesh. I think then we'll go on to next speaker and then take on any questions or discussion later on. Is that fine? Yeah, over to you, Dr. Vikram. Can you share your screen? You are mute, Dr. Vikram.
Yeah, just a moment.
Yeah, Dr. Vikram is going to speak on epiretinal membrane.
Is my screen visible?
Yes, yes.
So, good afternoon all. Thanks to Dr. Aniruddha and Moss for allowing me to be a part of this IC. So, I'll be talking on epiretinal membrane. It will be more of a theoretical presentation. Epiretinal membrane is a term used to describe a semi-translucent membrane, a fibrocellular tissue, proliferating on the surface of the internal limiting membrane. Epimacular membrane, macular pucker, and premacular fibrosis are the various terms used to describe this condition. The variety of these names given to this disorder reflects the wide spectrum of presentation, and the clinical findings may range from benign asymptomatic disorder to debilitating metamorphosia and central visual loss. It was first described by Ivanov in 1865. Evidence regarding the epidemiology predominantly comes from two large studies, the Beaver Dam Eye Study and the Blue Mountain Eye Study. The prevalence overall was found to be 7 to 11.8% with a 5-year incidence of 5.3%. And the idiopathic ARMs were bilateral in 19.5 to 31% with a 5-year incidence of second eye involvement of 13.5%. Seeing the Indian scenario, the overall prevalence of ARM in Asian Indians was found to be 7.6%. The ARM is basically classified into three categories with no associated ocular abnormality, is termed as idiopathic or the primary ARMs. With any associated ocular abnormalities termed as secondary, in which the causes could be retinal vascular disease, any trauma, retinal detachments, or any intraocular inflammation. And iatrogenic if they occur following any medical or surgical intervention, as in post-operative after cataract or RD surgery or retinal lasers. A clinical grading was proposed by Glass to describe the different stages of the disease. In grade 0, also termed as cellophane maculopathy, a translucent membrane is seen with no underlying retinal distortion. These membranes are often asymptomatic and they are usually an incidental finding during a routine examination. Grade 1 epiretinal membrane is associated with irregular wrinkling of the inner retina. When this involves the fovea, the patient often complains of distorted vision or blurred vision. The other symptoms that the patient may complain are loss of binocularity, central photopsia, and macropsia. Eccentric grade 1 ARMs that do not involve the fovea are usually asymptomatic. A grade 2 ARM is characterized by an opaque membrane which causing obscuration of the underlying vessels with marked full thickness retinal distortion and vascular tortuosity. The patient may complain of distorted vision and metamorphosia. ARMs with full thickness retinal distortion may also be associated with cotton wool spots, exudates, dot hemorrhages, and microaneurysms. Systemic macular edema is seen in 20 to 40% of the patients. Moving on to the pathogenesis, the initiating event or the factors responsible for development of ARM formation have yet to be fully elucidated. However, there is evidence that the ARM formation represents a reactive gliosis in response to retinal injury or disease involving the inflammatory and the glial cells. In general, the ARM have two main components, an extracellular matrix consisting of collagen and the cells of retinal and extraretinal origin, such as the glial cells, the RP, and the fibrocytes. The relative abundance of these components within the ARM reflects the underlying etiology. Like in idiopathic ARM, they are mainly composed of glial elements, whereas in ARM secondary to proliferative vitreoretinopathy are more heavily pigmented due to the high RPE content. Similarly, ARMs that develop in response to neovascular proliferation may have a large vascular component. More advanced ARMs have a contractile element that exerts traction on the underlying retina and distort the retinal vasculature. In these membranes, a higher content of myofibroblasts is observed. The diagnostic features, OCT is considered as a diagnostic feature. In OCT macula, an ARM is seen as a hyperreflective layer on the surface of the retina. It may be associated with underlying corrugation of the retinal surface, blunting of the foveal counter, increase in the retinal thickness. The idiopathic ARMs are seen as adherent globally to the underlying retina, whereas secondary ARMs are seen as focal retinal adhesions. Seeing the OCT classification of ARM, it is divided into 4 stages depending on the severity of the retinal damage caused by the ARM. In stage 1, there is a mild ARM with preservation of the foveal depression. Stage 2 shows the foveal depression is lost, but all the retinal layers are easily identified. Stage 3 shows the presence of an ectopic inner foveal layers, which is depicted by white arrows across the foveal flow. The foveal depression is lost, but all the retinal layers remain identifiable. Whereas in stage 4, there is severe alteration in the anatomy with foveal disorganization. The ectopic inner foveal, again shown by white arrows, is present and retinal layers are not identifiable. Despite the advantages of OCT, fluorescein angiography still remains a useful tool, particularly in cases where an underlying retinal vascular event or a choroidal neovascular membrane is suspected. Fluorescein angiography can highlight the extent of retinal wrinkling, degree of retinal vascular toxicity, and the presence of macular edema. Displacement or distortion of the foveal capillary network may indicate a foveal ectopia. Fundus autofluorescence has demonstrated that retinal vessel displacement may be correlated with the severity of metamorphosis. Focal macular ERG has also been used to predict the post-operative outcomes. Oscillatory potentials, B wave and A wave, are all reduced in patients with ERM. A reduced B by A ratio appears to be a sign of an early disease, with the reduction of the A wave amplitude correlated with poor post-op visual acuity. When to offer surgery to the patient and the prognostic indicators. The principal indications for ERM surgery are patient-reported symptoms of reduced visual acuity and metamorphosia. Although surgery is usually reserved for patients with a reduction in visual acuity of less than 20/60, however, improvement in the surgical techniques have led the patients to undergo surgery with better visual acuity if disturbed by symptoms of metamorphosia or diplopia or for occupational reasons. There is also evidence that the integrity of the outer retinal structures, the external limiting membrane, the left side status, and the anti-digitation zone status may also have an impact on the post-operative outcome. Both idiopathic and secondary ERMs appear to benefit equal extent from the surgery. However, in some cases, a pre-existing macular pathology may limit the visual recovery. There is also debate whether to peel the ILM or not to peel the ILM. One group proposed that the removal of ILM at the time of surgery removes the scaffold from fibrous proliferation, thus reducing the risk of recurrence. Conversely, there are concerns that the loss of retinal tissue and damage to the Muller cell foot plates may adversely affect the visual outcome. Thus, in conclusion, understanding the pathogenesis, the factors responsible for ERM formation, and prognostic factors will allow clinicians to make an informed decision whether between continuing a follow-up and appropriate timing for surgical intervention. Thank you.
Thanks, Vikram. That was really wonderful and very elaborate. I think we will go over to Jaideep now. Jaideep, are you there? Dr. Jaideep?
Yeah, I'm here. Hi, Mahendra.
Yeah.
Hi.
So over to you, Jaideep.
Hi, Dharmesh.
Start sharing your screen. It's really nice to see everyone virtually.
Yeah, same here. Thanks for inviting.
Yeah.
I'll share my screen.
Yes.
Yeah. So thanks, Aniruddha, for inviting for this wonderful instruction course, and nice to see everyone. So I think most of the previous speakers have already discussed most of the things which I'm going to speak of, but other than the management part, is my screen visible?
Yeah.
Yes,
visible.
Okay. Just a minute. Let me see if my slides are moving. Okay. Is it moving now?
Yeah, it's moving.
Yes.
Okay. Yeah. So I think we have all discussed about the PVD and the mechanism how most of the vitreoretinal interface disorders occur. So the brief is basically PVD happening, and then these are the steps in which it happens. We all know it separates around the perifoveal region first, and then goes on to separate in the end around the ONH. So this is the basic mechanism where our most of the vitreoretinal interface disorders occur when there is an anomalous PVD. So the progressive liquefaction as well as weakening of the adhesions between the posterior vitreous and the ILM, they lead to the plane detected between the retinal surface and the posterior vitreous cortex, and that is the posterior vitreous detachment. And an anomalous PVD is where the liquefaction occurs faster than the detachment of the vitreous cortex, as well as there are abnormal adhesions between the vitreous cortex and the ILM. So this anomalous PVD can lead to the multiple disorders which we are discussing today. So as my Aniruddha had highlighted, the International Vitreomacular Traction Study Group first highlighted or classified the vitreomacular adhesions on the basis of OCT characteristics, and they defined them as focal or broad. Focal, which is less than 1500 microns, and broad is greater than 1500 microns. So here you can see a simple vitreomacular adhesion without any traction, which is a physiological process before the PVD sets in. And most of the patients are asymptomatic with no retinal changes and no treatment required. So subsequently, when there is an anomalous PVD development with anomalous adhesion, you can have a vitreomacular traction, and sometimes in 10 to 20% of the patients, you can have a spontaneous resolution as well in the 6 months to 2 year period if you observe them. But then there are patients who have this persistent vitreomacular traction and they are symptomatic and will need some treatment. So by definition, vitreomacular traction is nothing but excessive traction in the macula from the vitreous that changes the contour of the fovea. Symptoms, as Dr. Vikram has also said, that's reduced visual acuity, metamorphopsia, you can have micropsias and photopsias. So all these are the majority of the symptoms the patients present with, and what we see clinically is very difficult to pick up when it comes to vitreomacular traction, unlike the ERMs as well as macular holes. Here you are not really sure because things are not very clearly visible clinically, but you may find distortion of the fovea, a blunted foveal reflex, sometimes cystic changes, as well as a little bit of SRF, subfoveal in severe cases. So in the IVTS classification, what they graded it as grade 1, where there is an incomplete separation of the cortical vitreous with persistent vitreous attachment at the fovea. Grade 2 is grade 1 plus some kind of intraretinal cyst, cleft or schisis formation with VMT with cystic spaces. So that was grade 2. Then comes grade 3, which is grade 2 plus some subretinal fluid resulting from neurosensory elevation of the retina and from the RP at the fovea. So this was how they graded it in 3 grades. So there are 2 types of traction profile again, which they describe. So this is one that is V-shaped. So V-shaped traction is the vitreous cortex detached from the retina on both the temporal and the nasal side of the fovea and attached only at the fovea. And then there is a J-shaped traction, which is only temporal to the fovea, but the nasal side remains attached. So this is important as far as prognostication is concerned, because some studies have shown that the V-shaped traction is having better prognosis compared to the J-shaped after treatment. But recently there was a group which classified or grouped it slightly differently, where this was in Graphe's journal in 2019. So what they proposed is a group A where there is a foveal pseudocyst, which was defined as a formation of a cystoid cavity located in the inner part of the central fovea, along with some foveal thickening. That is group A. Then group B's parafoveal retinoschisis was defined as an intraretinal cyst or clefts, along with no apparent foveal thickening. So no foveal thickening in group B. Group C is outer retinal dehiscence at the fovea, which is sometimes accompanied by foveal thinning. So what they found was that with this classification of VMT, they found that the group A were having favorable outcomes and worse outcomes in group C. So this is about the classification. The other investigations which we can do other than the SD-OCT, which is the most common one which we use, are FFA or OCT angiography and a fundus photo for documentation, but it does not really, because it's 2-dimensional, very difficult to pick up any vitreomacular traction on it, but associated conditions like an ERM or a macular hole can be documented with the fundus photography, serial fundus photography. So I wouldn't go into the details of how the FFA or the OCT angio is going to look in VMT, because here you're not going to see any leakage on the FFA. Unlike the other CME, there might be cystoid spaces. There might be an associated ERM which might stain in the late phases. An OCT angiogram might just show us a few abnormalities in the blood supply. So the preferred practice pattern of the AAO, what they have suggested that the VMT, when it is less than 1500 microns, you can observe it, because some of them, they say 30 to 40% can have spontaneous resolution 1 to 2 years. But if it is more than 1500 microns, you need to intervene. And vitrectomy is the most commonly used modality here. And they have shown at least 2 lines of improvement in most of the patients. So coming to pharmacologic vitreolysis, now this was something which came back way back into 2012, And the one which we heard about and had a lot of excitement about was ochriplasmin, called Jetria by trade name. However, although it was promising in the beginning, it has lost steam now. So what the trials shown that there was significant improvement, statistically significant improvement in patients who were used, but then which we use this mainly for vitreomacular traction, ERMs, as well as macular hole up to stage 2, early macular holes. But the patient selection criteria was quite stiff, and there were side effects. So as a result of this modality has been, not so popular now among the retina specialists. So anyways, it was never marketed in India, so we never had a chance to use it. The second one is gas injection. Again, gas injection itself, just gas injection, has shown some promising results, although there is no randomized clinical trials on it. But in individuals' hands who has experience with it can consider this as an option when you want to actually treat a vitreomacular traction. Then comes vitrectomy, which is the most commonly used modality. So decision depends on the severity of the patient's symptoms, how much of the daily activities are affected. That is very important to ask. It is an elective procedure, never an emergency. So you need to, weigh the pros and cons and discuss with the patient carefully. When there is a documented worsening, you can consider it. Broad VMTs, you can consider it. When there is a NSD at the macula, poor vision at presentation, all these can lead to decision making for a vitrectomy. So I would just end with my technique where we do a core vitrectomy. You can use any gauge. IVT assisted delineation of posterior vitreous cortex and a gentle PVD induction, preferably start on the nasal side and do gentle PVD induction and then go circumferentially towards the macula rather than directly lifting the PVD over the macula and having disastrous complications like a large FTMH on table. Then you release the vitreomacular traction, do a gentle suction with a gentle suction and a high cut rate, cut the vitreomacular traction without undue traction on the macula. Once you have released it, then complete the peripheral vitrectomy. Then stain the ILM with the dye and negative staining of the ERM if it is present. Peel both the ERM and the ILM if it is present over the macula, and do FG and gas injection. In case of cataract, you can definitely combine significant cataract. You can combine the surgery with cataract surgery because the cataract definitely progresses faster after these surgeries. So to conclude, the OCT has really changed our understanding of the vitreomacular interface as well as the vitreomacular traction syndromes, and it remains a gold standard in these cases. Vitrectomy remains the most commonly performed surgical treatment, but you need to discuss carefully with the patient pros and cons. Although pharmacologic vitreolysis had shown promising results, I think it's not very popular anymore because of its side effects and need for careful case selection and limited success compared to vitrectomy. So I'll stop with that. Thank you.
I think that was really a great talk, Dr. Jaideep. And I really appreciate all of our speakers to be very well in time. So we have enough opportunity to have a great discussion. And I open the forum for discussion. Also, Dr. Amol, are you there? So you can join in the discussion. So first, I want to ask to everyone how important do you all think is vitreomacular interface disorder to general ophthalmologist? What do you say, Dr. Dharmesh?
Yeah, it's very important, and now with the OCT having available at every centers, they have started doing in many cases and started picking up few subtle things. And for even premium IOL or multifocal or toric IOL, before that, if we are doing the OCTs, we find many subtle ERMs or mild traction, which can be, reason of unhappiness patient after the surgery. So it's something very important thing which we have ignored before and just looking at the macular hole, and many other things we are pointing out as a VMA category.
Yeah, Dr. Vikram, what do you think about the relevance of these epiretinal membranes or such things that you just described? Please unmute yourself before you start talking about these disorders in a routine cataract operation. So if you see a patient with a very thin ERM or a thick ERM, what do you advise the cataract surgeon? Is there any specific guideline or what do you say?
No, as we have already said on our presentation, the gradings of ERM. There are many patients with grade 0 cellophane macular which do not have any symptoms, or an eccentric ERM which do not have any symptoms for the patient. But it is a must for the patient to, for the patient education, what does he have in his eye before going for a cataract surgery. Because later on, over a period of time, say after a post cataract surgery, say even after a year, if the ERM progresses, the patient can complain to the doctor that is because of the cataract surgery he has lost his vision. So it is basically about the patient understanding that he already had this problem pre-operatively, and which can increase over a period of time. So we need to observe and keep a watch on it. So, and as it, if it increases, then the what options we have for it. So I think before a pre-operative, it should be considered as a routine thing, as an OCT should be considered.
Yeah, Dr. Amol, from your
Yes.
international experience now, what do you think is the protocol followed by you over there?
In cataract,
Yeah.
if a patient is referred to us with specific complaints like metamorphopsia, uh, maybe not correlating with the cataract, we would go for a OCT. Otherwise, it's not done very routinely out here. And as even Dr. Dharmesh mentioned, maybe unhappy patient post-operatively complaining of maybe a small scotoma or metamorphopsia and not happy with the Snellens, maybe even the general ophthalmologist should be more suspicious, and a retinal surgeon could have a look and do an OCT and find out clinically or with OCT what's going on at the macula. Yeah.
Yeah, Dr. Jaydeep, if there is a mild vitreomacular traction, do you actually advise undergoing vitrectomy, or you advise waiting? Are you there, Jaydeep?
Yeah. Can you hear me? Yeah, so mild vitreomacular traction, actually, I carefully discuss with the patient how is the vision affecting his day-to-day activities, his or her day-to-day activities, because these patients are, whenever they are a little younger, they have significant symptoms, although there is a mild VMT. So even then, vision might be even 6-9, but they are having significant metamorphopsia or micropsia or, photopsia. So then, photophobia. So I discuss with them and tell them that, see, the risk to benefit ratio of doing a surgery is this, and if you are significantly affected, then go for it. This is when I talk to them at first visit. Normally I would, in good vision with a minor VMT, which is a single point VMT, I will not operate. I will probably observe them for 3 to 6 months and look for any documented progression of VMT on the OCT, as well as worsening of symptoms and visual acuity, and then plan it. In case it's a broad-based VMT with already cystoid changes and a neurosensory detachment, I would still go ahead early, even if the vision is reasonably good, because these patients, if you operate early, they do better. Otherwise, they definitely don't, improve if you operate little late.
Yeah. And also in those BMTs which are quite severe, wherein you feel that sometimes if you are going to operate and do a PVD induction, it might lead to conversion into a macular hole. Is there any tip or trick that you will like to share to fellow vitreoretinal surgeons? Now we will focus on a bit of vitreoretinal surgeons, not just anterior segment surgeons. Yeah. Yeah, Jaydeep. Yeah, anyone, Dharmesh.
Right. So
Jaydeep,
the basic thing which I follow is, as I was discussing, the PVD induction has to be very careful in these patients. And if you had an intra-op OCT, I think it would have been great, but most of us don't have those options. So pre-op OCT, you have to carefully look at it very carefully and see where the traction is and the configuration of the traction, and then go ahead for the surgery and try to stain the vitreous with IVTA and start inducing the PVD nasally and very gently. And then once you lift up the nasal side, you do a circumferential PVD induction like you do in diabetics when there is no no PVD. Then go towards the macula and don't peel off the macular PVD immediately. Go ahead and do a good vitrectomy over the fovea, over the macular region, with a very low suction and high cut rate to remove any cut off any traction with the other part of the vitreous. Once you are reasonably sure that you have done that, then you can do a peel, stain the vitreous, complete the peripheral vitrectomy. Don't do the peripheral vitrectomy before, because that causes undue traction at the posterior pole. And then you might end up with, you might even not know, you might be doing peripheral vitrectomy. When you come to the macula, there might be a macular hole there. So follow this and then stain, and always do a ILM peel. That's what I do. And if ERM is there, remove the ERM along with it. It is kind of a prophylaxis, as well as in case you end up with a hole, you can get away with it with a gas tamponade and a ILM peeling. So these are the few things which I follow.
Yeah, regarding
Yeah,
ILM
it's
peeling, Dr. Dharmesh, what do you suggest? So, do you suggest doing ILM peeling as a routine, like Dr. Jaideep suggested, or you think just releasing the VMT or any other tip or trick?
The one point very clearly suggested is the trimming of the vitreous with very low suction over the fovea. It's a very important step by staining, and just not to have a undue pulling or like PVD induction kind of thing in VMT. And once we do, I try to do a dual kind of staining. So sometimes there is in VMT we might have ERM and ILM and both, and we are not able to peel both in a one go. So sometimes I do a dual staining and then peeling, and it's really help. As I say, if we are created by mistake, also iatrogenic small holes can be closed. But the trimming and peeling around that foveal region is very important in VMT vitrectomies. I have a question for all the panelists. Is a patient with the full thickness macular hole with grade 3, grade 4 nuclear sclerosis, so cataract with a macular hole, what Amol or Vikram or Anirudh, what you do? First you advise cataract, then macular hole, or you do macular hole first and then cataract?
Yeah, I usually prefer doing combined procedure. Yeah, Amol.
Yeah, same here. Yeah, I think combined procedure would be the ideal thing to do because you can always do that in a single setup, and the results, you need not wait for any of the problem to progress.
That's great.
Yeah, regarding the last thing, what VMT things we were saying, there's a small thing for the newer vitreoretinal surgeons, that while staining with IVT or IM, please basically use a 1cc syringe, because that's more guarded. In my early days, I had used 2cc syringe, and while coming out, I had a big retinal break because it gushes the fluid very fast. So it's better to use a 1cc tuberculin syringe to stain. It's very guarded, very easy. And regarding the macular, yes, I do a combined thing.
Also, Vikram, do you use any specific stain for epiretinal membranes? Yeah, Dr. Dharmesh also after this about this.
It's basically a negative staining, but it's brilliant blue and then do a negative.
Yeah, I prefer triamcinolone. So it usually help for the PVD induction also and the ERM removal, and then using the brilliant blue dye for the ILM peeling. Amol, your view on the staining?
Yeah, no, I prefer, while doing vitrectomy and PVD, I prefer triamcinolone as well. And for the, of course, if you are going for the macular surgery, brilliant blue for the ILM.
Yeah, Jaideep, what do you use
I
it
think
for?
I think we all agree on that. So I also use the IVTA for PVD induction with for vitrectomy, and then brilliant blue and negative staining for ERM, and it stains the surrounding ILM, and it's pretty good to safe to use it.
Still using
I don't
ICG?
think we use ICG anymore.
ICG is being not used, but I feel like in myopia, especially when there is a liquefied vitreous or there is a many layer of vitreous, the triamcinolone staining is really helpful in high myopic patients.
If I can share one tip of we were discussing about the surgery of the vitreomacular traction in mostly of the V-shaped configurations. Here, one trick I do is in high magnification, I try to open up the PVD around the macular hole because it's already present there, right? So if you can segregate the fovea and do the dissection around and then lift the PVD at the disc, it would not harm the fovea and cause any de-roofing. So if you can, it's a tricky thing because the space is small, but maybe using a small pick or MVR blade And now that we are doing it with 25 gauge needles, the induction and further surgery becomes more easier. So this is just a trick to prevent the de-roofing of the
I think our
BM.
time is over now.
Sure.
It's
Yeah.
a really great thing. There is just one question, one suggestion which just came. Thanks for the suggestion, but we are now out of time. So thanks MOS, and thanks all the faculty to give your valuable time and share your knowledge. Let's hope it was worth our efforts. Thank you everyone, and let's say
Thank you,
goodbye.
Anirudh.
Thank
Yeah.
you.
Thank you. Thank you,
Thank you,
Anand. Bye.
everyone.
Bye, Jaldi. Bye, Anirudh. Thank you.
Yeah, Dr.
Bye.
Anand Subramaniam, over to you. Thanks. Thanks a lot.
Hello.
Thanks, Sarvesh. Yeah.
Yeah. So I think with that wonderful session, I think we can now move on to the next session about dealing challenges, situations in myopic eyes. So first of all, a very good afternoon to everybody. Today, we are going to have a very interesting discussion about dealing with patients with high myopia in our day-to-day practice. As we all know that high myopic patients pose numerous challenges from every step, right from the refraction to the retinal surgery. Our speakers today are going to share various nuances about tips and key points in dealing with such challenging group of patients in our daily practice. So without wasting any further time, I would like to first invite my first speaker for the day, Mrs. Prachi Agashe, who will be talking about dealing with progressive myopia in children. Over to you, Prachi.
Thank you, Sarvesh, and thank you for making me a part of this IC. I'll begin with my talk about Stop Me If You Can, and try to elucidate some take-home points for myopia control in children. Okay. So the title of my talk is Stop Me If You Can, trying to control progressive myopia in children. So as we know that the prevalence of myopia has been increasing a lot, especially in the pandemic, and it is expected to go to up to 50% by 2050 among children, and high myopia of more than 6 diopters to around 10%. So why do we need to control myopia in the first place? Because we know that there is a high incidence of ocular morbidity and visual disability due to the retinal changes, higher risk of glaucoma, early onset of cataracts, and also it involves higher cost of optical correction in the form of glasses, contact lenses, or surgical corrections in the form of LASIK. Can anybody identify this gentleman? So he is Sir Duke Elder. In 1935, he had predicted that excessive near work and lack of outdoor activities influence myopia progression. So the myopia control interventions can be divided into environmental, which involves outdoor time and near vision activities, spectacles and contact lenses, a whole lot, I'll be going through them, and pharmacological therapies in the form of atropine and pirenzepine. So let's look at the environmental considerations first. So talking about the outdoor time, it has been proven beyond doubt that increased level of outdoor time is protective for myopia. How it works is that the increased level of light that is there outdoors increases the retinal dopamine production and release. This alters the gene expression in the retina and hence reduces the axial elongation. So these were two significant studies that were done, which proved that the outdoor physical activity was a protective factor for myopia development. The Sydney myopia study, which involved 863 Australian children, showed that children who spent almost 21 hours outdoor had almost no myopia compared to children spending 16 hours outdoors. Coming to the near vision activities, again, a lot of studies have proven a link between increased near work and myopia. In the Singapore study, it was proved that if the near work was performed for more than 20 hours and with writing, it was positively associated with myopia. Similar findings were found in the Sydney myopia study. Why I have stated these two? Because though the population groups are different, this risk factor had a similar result of having a progression in the myopia. Coming to spectacles and contact lenses, so bifocal or multifocal spectacles were thought to reduce the accommodative effort to slow the progression of myopia. However, few investigations have found clinically meaningful slowing of myopia. A large randomized controlled trial was done for children wearing myopic multifocal spectacles, and this showed a marginal decrease in the myopia progression. This was another Cochrane meta-analysis that was done, which stated that the progressive lenses were slightly beneficial for myopia control as against single vision lenses, but that was not true for bifocal glasses. I would like to specifically state about these lenses called as the DIMS lenses, which is the newest thing in myopia control. These are single vision corrective lenses with a surface that has lots of small segments that provide myopic defocus and have reported results of good myopia control over the past 2 years. So they are so new that they're still not available in India, but these seem to be very, very promising. Coming to orthokeratology. So these are lenses that are worn overnight to shape the corneal surface and hence control the myopia. They are shown to have an effect on reducing the axial length by achieving the relative peripheral myopia and hence reduce the myopia progression. So this was one meta-analysis that was done that showed that the mean axial length in the orthokeratology group was almost 0.25 millimeters lesser than that of the control group, leading to almost 45 to 50% decrease in myopia progression. However, the demerits include in that study where there was no washout period. What happened to the myopia after stopping it was not known. There was no long-term data on the potential long-term effects of these lenses, and there's always a risk of infective keratitis with contact lens wear. Soft bifocal contact lenses, they work similar to those of the bifocal or the multifocal lenses and can be used, though not widely practiced in India, I can say. Gas permeable contact lenses have no role to play in myopia progression. Undercorrection of myopia. So this was taught to us when probably we were doing our postgraduate undergraduation or post-graduation, that it was the idea of reducing the accommodative effort could probably slow the progression of myopia. However, it is proven that this is not a good idea, and in fact, this can lead to progression of myopia by blurring. Hence, it is not recommended. Coming to the pharmacological therapies, which is the in thing today. So there are two drugs that are being talked of. One is atropine, which is a non-specific muscarinic receptor antagonist. The specific mechanism how it acts is not very well known, but what is known is that it is not a result of reduced accommodation. The proposed theories include a neurochemical cascade, which acts on the muscarinic M1/4 receptors at the retinal level. Second theory is direct action on the scleral fibroblasts by inhibiting the glycosaminoglycans. And a third theory was similar to that of the outdoor activities, where the amount of dopamine released from the RP cells was more, and hence it controlled the eye growth. Mirenzapine, on the other hand, is a specific antagonist and has similar effects like atropine. So these are two studies, ATOM-1 and ATOM-2, wherein it has been proved that 1% atropine is probably more effective than the lower dose atropine. However, the rebound of this treatment after stopping has been lowest with 0.01%, which was proved in the ATOM-2 study. So I'll just summarize. Environmental factors like reduced time spent outdoors and increased near work activities play an active role in myopia progression. Also, when the near work is being done for long hours, it is prudent to take intermittent breaks. Of the various interventions, ortho-K lenses and soft bifocal lenses are shown to be effective, but may not be suitable for use in the Indian scenario. Atropine drops seem to have the maximum benefit in control of myopia progression. 0.01% seems to be the most effective with least side effects and least risk of progression. And newer generation progressive lenses like DIMS may change the management protocol. Thank you for your attention.
Thank you so much, Dr. Prachi, for that enlightening talk. So before I move to the next speaker, I would just like to introduce Dr. Prachi. Sorry, I forgot to do that in the beginning. She's a well-established pediatric ophthalmologist working with Haji Bachchu Ali Eye Hospital. Along with that, she has her own independent practice, and she's also working as a senior pediatric ophthalmologist in advanced eye care in Vashi. Thank you for that wonderful talk, Dr. Prachi.
Thank you, sir.
So now moving to the next speaker. Our next speaker for the day is Dr. Sarika Ramugre. Dr. Sarika is working as a lecturer in Sion Hospital. Apart from that, she's also working as an independent glaucoma consultant with her own private practice. So she will be sharing about the how to deal with glaucoma in myopic patients. Okay, over to you, Sarika.
Hi, Dr. Sarvesh. Sorry to interrupt. Great
Yeah,
going.
ma'am. Thank you, ma'am.
Hi,
Thank you so
Prachi.
much.
Hi, Anand. Hi,
Good afternoon,
Smitesh.
ma'am.
Hi, Sarika. Sorry to interrupt. Great going.
Thank you so much,
Continue.
ma'am.
Thank you so much for this course.
Thank you. Okay, Sarika, I think you're mute. Can you unmute yourself?
A minute, yeah.
Yeah. Yeah, we can see your presentation.
Good afternoon, all. I'll be talking on managing glaucoma in high myopes, a practical approach. Glaucoma is a leading cause of irreversible blindness globally. The prevalence estimated to be 64.3 million, and it is increasing up to 111.8 million by 2040. Incidence of the myopia affects more than 1.6 billion people worldwide. It is an independent but a strong risk factor for the development of POAG. In meta-analysis, global prevalence of myopia and high myopia and a temporal range from 2000 through 2050 has predicted that by 2050 there will be around 4,758 million people with myopia. So association of myopia and a primary open angle glaucoma has been recognized for decades. So when we see the patient of a myopia or glaucoma, the question arises, is it only glaucoma or is it just a high myopia? So why it is difficult to detect the glaucoma in a high myopic eyes? Because first, the optic disc is anomalous and the surrounding peripapillary structures, which is highly deformed. Second, the deformation is generally more severe with a higher myopia and it shows highly variable patterns. And third is an abnormal visual field, but the normal pressure is always a problem. So 3 ways to assess glaucoma. First is changes in a nerve by using the fundus photography and OCT imaging. Second, by visual field testing. And third is a IOP monitoring, which is a major and only modifiable risk factor in glaucoma. So coming to the pathogenesis of a myopic glaucoma, the different anatomical or the morphological factors in the myopic eyes, such as the elongation of the axial lens, stretching of the sclera and choroid, deformation of the lamina cribrosa, contribute to the higher susceptibility to the mechanical stress on the axons of the retinal ganglion cells, which leads to the compromised ocular blood flow and ischemia. The increased risk of a development of the glaucomatous damage may be related to the already reduced retinal nerve fiber layer thickness in the myopic eyes. So I'll be coming to some pointers to diagnose a myopic glaucoma. So myopic glaucoma is considered as a disease which is composed of a myopic optic neuropathy and a glaucomatous optic neuropathy, which are often difficult to clearly differentiate. So first thing is a myopic neuropathy. The visual field defects can occur in the absence of the typical fundus findings because of the changes in the fragility of the lamina cribrosa, dynamic imbalance due to structural changes of the optic nerve head, scleral curvature, which is shifted temporal to the disc, is associated with the progression of the visual fields. And if the patient had a myopia of more than -5 diopter and axial length about 26 millimeter, the mean deviation and mean sensitivity decreases as the axial length elongates on perimetry. So typical appearance of the beta peripapillary atrophy in high myopia is as a whitish lesion with a well-defined border is seen that normally develops inferior temporal or temporal to the optic disc. So as a myopia progresses or the axial length elongates, the peripapillary atrophy enlarges over the time. This is a fundus photo which shows first photograph shows the optic disc which is enlarged with the appearance of the small peripapillary atrophy. 2 years later, you can see the enlargement in the peripapillary atrophy along with the tilting of the disc, but the the cilioretinal vessels remains at the disc margin. And 6 years later, you can see the enlargement of the peripapillary atrophy along with the more tilting of the disc. So as a result, the myopic optic disc tends to develop tilted with a crescent conus. Coming to the second pointer, the Nicolian and colleagues, they classified the glaucomatous disc into the 4 types. The first is a focal ischemic, second myopic type, and a third stenile sclerotic type, and a fourth general enlargement type. They found that this patient with the senile sclerotic type, the morphological changes of the optic nerve as well as the visual field defect progresses fast in a senile sclerotic type, and the visual field progression, the senile sclerotic type, the progression is slow compared to the general enlargement type of the disc. So these are the few photos of the focal ischemic senile sclerotic and myopic type and general enlargement type. The myopic type of the disc always presents a dilemma in a diagnosis as well as the management of the glaucoma. So in the cup disc, the key factor is in aiding the diagnosis is see for the sloping of the rims, loss of a rim, and a kinking of the vessels. So general morphology, these are the two photos showing the typical tilted myopic disc and a myopic macro disc. Here you can just see the flat or the shallow cupping with a flat disc. These are variable deformation of the optic disc with a peripapillary atrophy. So coming to the third pointer of the myopic glaucoma is the myopic glaucoma and a visual field defects which are more common near to the fixation point. So myopic glaucomatous eyes with the RNFLD in the papillomacular bundle could be more susceptible to the visual field defect near the fixation point at an early stage. Myopic glaucoma patients should be managed at an early stage the development of the impaired visual acuity and a central visual field defect. The progression of the central visual field defect lead to the decrease in the quality of vision of the patient. So during the follow-up, the central 10-2 and 30-2 threshold test should be used alternately. This is a photo which shows the different types of the visual field defects. Mainly, these are all secocentral defects. So higher myopia patients has been associated with the significantly the higher incidence of the centrocecal scotoma located just temporal or inferior to the fixation points in an advanced glaucoma. So myopic glaucoma has a more chances of a disc hemorrhage which leads to the progression. So OCT plays a main important role in diagnosing the glaucoma, which we can see the thinning of the ganglion cell complex in a papillomacular bundle using the OCT. So these are some pictures of the OCT, where we can see the beta peripapillary atrophy on the spectral domain OCT. This is a gamma zone where we can see the scleral tissue, underlying scleral tissue, and in a beta zone atrophy, we can see the choroidal tissue up to the disc margin. So OCT findings in myopic glaucoma, the spectral domain OCT has shown that the Brooks membrane is often absent within the beta PPA in a highly myopic eyes. So usefulness of the deviation map is very important in a highly myopic patient. So deviation map is accurate in detecting the retinal nerve fiber layer defect in early glaucoma. It is also an indicator of a glaucoma progression. In a normal patients, the double hump pattern is present where while in a high myopic patient, you can see the double hump pattern of the RNFL is lost. The macular, although each of the macular retinal layer decays with the aging, symmetrical shape remains with the age. So now coming to whether to treat or not to treat the myopic patients with glaucoma. By detecting the measurable change indicating the glaucomatous progression, in many cases simply accumulating the risk and the benefit, it may justify the treatment of choice. So keeping that in mind, the steps to follow are check the OCT nerve fiber layer and a ganglion cell layer analysis. The number of caveats in an OCT, mainly look for the signs of error in the OCT algorithm. Make sure that the significant defects are present and it correlates with the visual field. Beware of the color coding, that is a red-green disease. Remember, the normative data does not account for whether individuals have high myopia. Check the diurnal pressure. Try to find the pre-existing clinical data like old pictures of the old fundus photo. Focus on comparing the patient himself or herself rather than general population. Find out what the patient is willing to do, that is whether he wants the treatment like eye drop or surgery. So involve the patient in treatment plan. Monitor the patient and look for the change. Consider how much vision reserve the patient has. Consider how close the existing damage fixation near the damages to the fixation, and then treat or not treat. If it appears to be glaucoma, consider how fast it's likely to progress. So when you want to treat, if the patient has a paracentral defect and a disc hemorrhage to other causes, I see it as a high risk and tend to treat the patient. If a cornea is very thin, patient had a previous LASIK on the, I would like to treat the glaucoma. In either of these situations, it is more difficult to accurately measure the patient's true eye pressure. So considering using, so that increases the risk of misjudging the patient's condition. So consider using minimally invasive surgery to treat the myopic glaucoma and avoid going straight to the filtering surgery. So take home points are: myopic degeneration can cause the optic nerve damage and as well as produce the field defects that mimic the glaucoma. So before you treat a high myope who appear glaucoma but doesn't have revealed the eye pressure, take some of the following steps which I mentioned. If the patient seems like low risk glaucoma, then see whether the progression occurs or not. In a higher risk situation, whether treatment is called for, try to look for the treatment options such as a drop, laser, or the MIJ surgery, and lastly for the filtering surgery. Only treat aggressively with the filtering surgery if the patient has already lost substantial vision, or if you suspect that individual is potentially a fast progressor. Thank you for the patient listening.
Thank you so much, Dr. Sarika, for that exhaustive presentation. I got to learn a lot of points today. Thank you for that talk.
Thank you.
So now give me opportunity to invite our next speaker for the day. This is Dr. Smitesh Shah. Dr. Smitesh definitely needs no introduction. He is a well-known anterior segment surgeon in Kalyan Dombivli, having his own private practice with the name of Isha Netralaya. Today, he'll be sharing some wonderful points about how to deal with high myopic patients when they come to you for cataract. So over to you, Dr. Smitesh.
I can't share my screen.
So there's an option for share screen in the down on the screen. Can you see
that? Yeah, but it's saying that you cannot start the screen share while other participant is sharing.
Sarika, can you just
wait? I'll ask somebody to help out. I'll just ask somebody. Hi, Smitesh.
Hi.
Sarika, just stop sharing your screen, then Dr. Smitesh can share his screen.
Yeah, Sarika, you have to stop sharing the screen. Sir, try doing it now, sir.
Yeah.
Yeah.
One second.
Is it opening, sir? Try doing it now. Yeah.
I'll just ask somebody to help.
Yeah.
So,
yeah, we can see your desktop, sir.
See your desktop.
Yeah.
So I can't see my now.
Yes, Smitesh, we can see your screen.
Yeah, you can see my screen, but I'm not able to see my PPT. Where is it gone?
I'll ask somebody to help you out.
Try to off your PC and on it again. It's gone in the background. Try to minimize this screen.
Okay. One second.
Sir, have you opened your presentation on your desktop? Is it
yes,
visible?
I had opened. No, it is not visible to me.
It is not visible to you?
No. It was
previously
it was
just minimize this Google.
Yeah, you minimize this desktop screen, sir.
Smitesh, help is on the way. Saidada is helping you out.
Excuse me, doctor. See, I just suggest you stop your screen share right now.
Okay. Or share, no?
Yeah.
Okay, or stop share.
Yeah. You just open your presentation. You have your presentation open now?
No, I can't see it now. It was there before. One second. It is there in my mail.
Oh, the presentation is in your mail, is it?
Yeah, presentation was on my mail and I downloaded it.
Okay, just open the browser.
Yeah, sorry.
And you're using a Mac or you're using Windows?
I'm using the Windows.
Just press Ctrl J.
Yeah.
After opening the browser, you'll go to the downloads folder. You'll find the PPT there.
Yeah.
You're able to find the presentation?
Yes, now I'm able to find the presentation.
Yeah, you can open the
Okay.
presentation now. Double click
Yeah.
and open the presentation.
Yeah, I opened the presentation.
Now you do a share screen. And on this
Okay.
share screen tab, you will find the thumbnail image of your presentation. Choose that.
Yeah, yeah. Can you see now?
Just a minute. Can you just stop sharing and share it again, because the presentation is not visible.
Okay. Which one? This or this? Can you see?
No.
Sorry for this. I think I'm doing it.
But there's some issue actually, the PPT is not visible.
Okay, should we just go to the next presentation by the time you get it ready, sir?
Yeah, that would be better.
That would be better, I think. No, sir?
Dr. Smitesh, I will call you on your phone. We can take it offline and I'll set it right for you.
Yeah, that would be better.
Swapnesh and Sai Dada will help you. Swapnesh and Sai Dada will help you, Smitesh. They'll coordinate.
Yeah, thank you.
Okay,
Thank
sir.
you.
Okay.
And sorry for this.
No issues, sir. No
we
issues.
have Dr. Sarvesh's talk.
Yeah, sir. I think I'll go ahead with my presentation.
I'll just introduce Dr. Sarvesh. He is a senior vitreoretinal consultant. He is now practicing full-time at Haji Bacholi Hospital. He's done his fellowship from Arvind Eye Hospital and has been a consultant in Arvind for some time. Over to you, Sarvesh.
Okay. Thank you so much for the intro, sir. Smitesh, sir, I think you'll have to stop sharing your screen.
Okay.
Yeah, 1 sec.
Okay,
please mute yourself.
Okay.
Dr. Smitesh, you'll have to stop sharing your screen. Then only I can start sharing mine. Dr. Smitesh, can you hear me, sir? Yeah, now it's
So
fine.
I will leave the.
Yes. Okay.
Leave the meeting, no?
No, that's it, sir. That's it. Just now you have exited the screen. Thank you.
We can
Thank you,
see
sir.
your screen, Sarvesh.
Yes, sir. So my presentation dealing with VR abnormalities in high myopes. So just to go over the definition that myopia, as we all know, is classified broadly into as simple and pathological types. Pathological myopia is basically defined as any myopia of more than -6 or equal to -6 diopters with an axial length of more than 26.5 millimeter. Most of the time, the retinal associations and challenges associated with myopia are broadly divided as vitreoretinal interface disturbances or those lesions involving the retina and the choroid. So first discussing the vitreoretinal interface disturbances. So most common is vitreous syneresis and posterior vitreous detachment. This is the most common type of lesion which we encounter in day-to-day practice. Apart from this, peripheral retinal degenerations like lattices, retinal holes, areas of white without pressure, lacquer cracks, chorioretinal atrophy, myopic CNVMs, myopic tractional maculopathy, and paravascular inner retinal defect. So discussing in short about each one of it, starting with vitreous degeneration. It occurs usually in young individuals of 20 to 40 age group. It is more common in myopes than non-myopes. It has a tendency to present as incomplete PVD. and prime contributor to causing retinal tears and subsequent retinal detachment. So this is one of the commonest patient complaint which a VR surgeon encounters in day-to-day practice. Apart from this, we also come across various peripheral retinal degenerations like lattices, retinal holes, and white without pressure. Lattice degeneration is around 6 to 8% present in general population also. However, its prevalence is higher of about 33% in myopes. 30% of lattice degenerations are found associated with retinal detachment also. The incidence of lattices is inversely proportional to the increasing myopia. That means you find more number of lattices in lower myopia than compared to those in very high myopes. Bilateral lattice degeneration is associated with a great risk of developing retinal detachment. The risk of retinal detachment in the other eye doubles if one eye already had retinal detachment. White without pressure are usually seen in around 30% of the population, although it is more common in myopes. Retinal breaks, giant retinal tears are usually developed at the posterior border of the white without pressure lesions. These lesions are generally innocuous and need not warrant any treatment. However, a close follow-up is required. So, most common question which comes to us is, when should you intervene when you come across such lesions? So there have been a lot of theories and dictums that you should treat this lesion or you should treat that. However, in broad, there's a general consensus that any lesion associated with a symptomatic patient, that means if a patient is seeing any photopsia or flashes or floaters, and if that is associated with any lattice or holes, the general dictum is you should treat them by doing a barrage laser around it. Needless to say, lesions such as horseshoe tears, traumatic dialysis, large tears, these require urgent retinal lasers. Now coming to lacquer cracks, these are linear breaks in the Brooks membrane and the choriocapillary complex. They are present in 4% of myopes. They are formed due to stretching of the chorioretinal structures and associated expansion of the scleral tissue. They are seen as yellowish-white linear lesions involving the macula. This is a picture showing you the lacquer cracks. As you can see on FFA, these are hyperfluorescent. Lacquer cracks are predisposing factors to myopic CNVM. They need regular follow-up. Around 10% of these do evolve into myopic CNVM over a period of time. And once it develops, intervention in the form of anti-VEGF agents is required. Chorioretinal atrophy. This is atrophy of the choroid and the retinal pigment epithelium due to choroidal hypoperfusion secondary to stretching. It's very prevalent in very high myopes. They are broadly classified into 3 types. That's tessellated, patchy, and diffuse. This is the tessellated variety. This is patchy, and this is a diffuse variety. This is a fundus florigen FFA showing the evolution of a patchy chorioretinal atrophy into a CNVM. Patchy atrophy has a greater chance of developing CNVM, the chance being as high as 20%. Areas from the edge of the atrophy are prone to developing this membrane. Total or diffuse atrophy is usually associated with a lesser chance, around 3 to 4% risk of CNVM developing in the future. So now coming to myopic CNVMs. Myopic CNVMs are a bit different than compared to the normal CNVMs associated with wet AMD. The salient features being, these are usually small. They are usually associated with few hemorrhages. They are generally not associated with drusense unless seen in older age group. They are mostly associated with type 2 CNVM, and the prevalence is as high as 10% in myopes. 15 to 30% of those who have CNVM in one eye are at the risk of developing it in the other eye too. Most common association is patchy atrophy, Less intraretinal subretinal fluid is associated with this type of CNVM. Juxtafusion CNVM respond fantastically to even 1 dose of anti-VEGF injections as compared to the wet AMD counterpart. However, the presence of scarring around the CNVM causes an increase in the positive scotoma as the lesion heals over the period of time. The treatment definitely, as with wet AMD, is with anti-VEGF therapy, along with the biosimilars which are available nowadays. So basically, this is a flowchart showing that what to do when you come across a patient who high myopic patient who presents to you with a retinal bleed and in which you suspect that that could be a CNVM. First step is to go ahead with a standard spectral domain OCT along with an angiography. If you can see the presence of a myopic CNVM and OCT, good, go ahead with treatment with anti-VEGF therapy. However, if you feel there's an absence, you can exclude other macular pathologies. If the lesion presents, there is no activity, keep a close watch with a 3 monthly follow-up for such patients. Now coming to myopic fractional maculopathy, they are usually VMT associated foveoschisis, full thickness macular hole, and macular detachment. So VMT with foveoschisis is defined as a vitreomacular traction over the macula predisposed by bulbar elongation of the posterior staphyloma. This is most commonly prevalent in high myopes with posterior staphyloma. The general pathogenesis is an axial traction with the alteration of the vitreous body. This traction causes the cortical vitreous along with posterior vitreous to cause a cellular proliferation along the vascular arcades, causing the progression of cellular migration along with collagen formation. This collagen formation causes stiffening of the internal limiting membrane, which makes it rigid. So the internal limiting membrane no longer follows the scleral contour as the myopia progresses. This causes intraretinal cleavage and resulting into splitting of the fovea, causing foveoschisis. So this is a classical foveoschisis, as you can see in this picture. Coming to full thickness macular hole, some pathology somewhat similar to foveoschisis. Here the alteration of the posterior pole profile due to staphyloma causes an epiretinal membrane and an incomplete PVD or a VMT. The tangential forces acting on it cause foveoschisis, which may result into a lamellar macular hole, which over a period may result into a full thickness macular hole. This is, you can see a VMT and a lamellar hole there. So as the VMT progresses, it lands up into a full thickness macular hole. So the principle of managing these lesions is to first relieve the macular traction, to remove the elements of scaffold, like that's the vitreous, which can be done either pharmacologically by vitreolysis or by pars plana vitrectomy and a PVD induction. Along with that, doing a ILM peeling to release the tangential traction and a gas tamponade for glial cellular proliferation and subsequent hole closure. So apart from this, for myopic traction maculopathy, a macular buccal is also sometimes helpful, which can be either by use of synthetic material or by using a donor sclera. So the last to come is paravascular inner retinal defect. This is a spindle-shaped or caterpillar-shaped dark areas along major retinal vessels, commonly seen in high myopes. They result due to cleavage in the inner retinal layers, especially near the nerve fiber layer due to stretching of the sclera. So the most commonly seen in the inner retinal layers, they can be seen also along the outer layers as well, can cause positive scotoma in some patients. No active intervention is needed. However, close follow-up is required as they play an active role in the formation of foveoschisis. So identifying the retinal pathologies resulting secondary to pathological myopia is the key in their early and successful management. Thank you. So I think with that, I come to the end of my presentations. Any questions, if any, we can take it at the end of the presentation. So Dr. Smitesh, are you ready with your presentation, sir? Yeah, I think sir is ready. Over to you, sir.
Can you see the presentation?
Yeah, sir, we can see, sir, now.
Yes.
Okay. So I'm speaking on the cataract surgery in high myopes. Thank you, Sarvesh and Anand and Moss for bearing with me. There was a problem with the Zoom probably. Now, it's not moving. So the difference, before the cataract operation, we start with the pre-op investigations. And what is the difference in biometry? So we, at our place, we are using only the newer generation formula, example Barrett suit. We don't use SRKT. We have seen difference of almost 1 diopter between the Barrett suit and SRKT. And we use, for those people, those patients with the myopic astigmatism, we use integrated K. That is also from the Barrett suit. And this is available online only. This is not available in any of the instruments. So even if somebody is telling you we have posterior K and all this K, you still need the integrated K. I have spoken to Barrett myself, and he said even if you have posterior K, even if you have total K, you still need the integrated K at the end of the day. So this is the Barrett toric calculators for the myopic astigmatism people. And it gives you predicted PCA or measured PCA also. Both the posterior corneal things are there. If you don't have a machine with the measured PCA, you can go for the predicted PCA like it is clicked over here. So the predicted PCA is seen over here like this. So what you have to do, you have to take the readings of the 3 machines, either a biometer, auto K, or topographer, whatever you have, and fill it. You have to fill it in this integrated K formula. And once you get, that's how it works. And once you fill it up, all these readings from all the 3 machines, then you will come to this screen, and at the end of the day, you will get the integrated K. So as per the Barrett himself, the integrated K is the most most accurate whatever is available. Still, we can get the residual astigmatism even after doing all these things. So many of the patients, they have these people, they have undergone the RK, and it will be, and most of these RK cuts are around 3 or 9 o'clock, around 180-degree axis, and where we generally take the incision. So you have to modify the incision to the superior-temporal or superior-nasal area, and you have to move ahead. So in such cases where there is a post-RK or post-LASIK, we have to use the ACRS website to get the biometry readings. So they have special formulas on the ACRS website for the post-RK and post-LASIK formulas. The tomogram is better, but all of us may not have tomogram. So getting the posterior K either from the tomogram or anterior OCT is most accurate, but this post-RK formulas will also work. And the incision has to be between these 2 RK marks. Otherwise, these RK marks, they do open up because they are at the 90% depth. Then you have to take the stitch and it becomes messy. Should we always aim for 0? This is the main question, which and we have burned the fingers by aiming for 0. So if the patient has 6/9, 6/12 or 6/6 vision, then you can go for the target refraction as 0. Otherwise, if the patient has less than 6/36 vision and he has myopic degeneration and pathological myopia, then we keep the target myopia as -5 diopter. Why? Because I will show you what happens in such cases. See, this is the patient. I told him to read it with his spectacle. Now, with his spectacle, he should be 0. But with his spectacle, he was not able to read even N10, N12. What he was doing was, he was reading like this. Now, if you make him 0, he will be unhappy because he is not able to see anything. And you will have to give him +7 or +8 after spectacle as a low visual aid after the cataract extraction. So in such cases, we keep them -5, and then we can give them little addition and they are happy. What about the pre-op retinal examination? Of course, we have all retinals, good surgeons, so they will examine the patient, and if possible, they will do the barrage before the cataract extraction. If it is not possible, they will do it afterwards. The other things about the OCT, already the other speakers have dealt with this problem. We have got the post cataract extraction, we got the RD within 15 days. So on 5th day, whenever we check the dilated, we check the patient's dilated, and that time only we start doing the laser barrage if it is remaining. Now, what should be the choice of IOL? If it is a pathological myopia, if the vision is less than 6/24, we should straight away go for 3-piece foldable IOLs. Now, these 3-piece foldable IOLs in Alcon series, my preferred choice is no financial interest, is a Mama IOL. So they are very good, and we don't get PCO with these IOLs. Now, what about the patients who have 6/12 or better vision, 6/9 or 6/6 vision, or whose macula is good on the OCT? Then we can consider this newer variety of EDOF IOL. They are called EDOF X. These are the IOL which has the near vision also. So there are 3-4 IOLs. There is one VVT IOL, which is by the Alcon, which gives the patient near vision. And then there is a Lucidis, which is obviously a hydrophilic IOL. And there is one more Indian company which has come up with this. Many of my friends, they have tried many well, but problem is all this, it's very difficult to get this kind of IOLs in this range. In mild to moderate myopia, we are using trifocal lenses. What should be the surgical consideration? The low bottle height to avoid the bend. These people, they have very deep chamber, so we use low bottle height and less vacuums. So there is, as soon as you enter into the chamber, you get LIDRS syndrome. That's a lens iris diaphragm retropulsion syndrome. So how to avoid this? I will show you the video. Video is not playing. So probably the video is not playing. So what we do is we keep the bottle heights very less, almost 40 to 60 centimeter bottle height, not more than that. If I'm using the Centurion machine, then it is around 40 or to 50. If I'm using the Stellaris machine, it's around 70 to 60 to 70 bottle height. We use the vacuum around 300, not more than that. The flow rate should not be around, should not be more than 35 to 40. And when you enter into the chamber, we have to lift up the iris to prevent the deepening of the chamber, and patient gets severe pain if you do it under topical anesthesia. Sometimes the pain is so severe that we have to shift to the to the posterior subtenon with a blunt cannula, but never try the retro bulbar injection or peribulbar injections, because of this people can have posterior staphyloma and you can open up, you can enter into the posterior chamber. Most of the myopic people, they have it's a B-dip chamber, so it's possible to flip the nucleus very easily. Many of the people they need toric IOL in such cases, so we sometimes use the ring for the toric stabilization. Sorry, I couldn't show you the video because it's not running. Thanks a lot.
Thank you for that wonderful presentation, Smitesh sir. Okay, so moving to the next presentation, I would like to invite our next speaker, Dr. Anand Subramaniam sir. Dr. Anand Subramaniam is the head of department of Khan Bahadur Bacholi Eye Hospital, Parel. Along with that, he's also attached to Fortis Hospital and he's having his own independent practice. So over to you, Anand sir, with your presentation.
Thank you, Sarvesh, for those.
Can I finish this video?
Yes. Oh yes, sir. Yeah, please do that.
So when I'm entering into the chamber, I use the iris spatula. And can you see my video?
Yes, sir.
Yeah. So I enter with the iris spatula, and then we lift up the iris to avoid the deepening of the chamber. And then I start doing the chopping. So when I enter with the chop, I'm in the chop mode, and it's very easy to tilt the nucleus in the high myops. Then you chop it, and then surgery is routine. While doing the eye also, we have to do the same thing. We lift up the we lift up with the iris with the help of this IX cannula. So when I'm entering, before pressing on the bottle, on the foot switch, we lift up the iris and then put the irrigation on. Thanks a lot.
Okay, great video, sir. Great video. Thank you, sir.
Thanks a lot.
Over to you, Anand, sir.
Dr. Sarvesh forgot to mention that Dr. Smitesh is a pan-ophthalmologist. He's not just an eye treatment surgeon. He's
Absolutely,
done his fellowship
sir.
in vitreoretina. So, just sharing my screen.
Sure.
So, is it visible?
Yes, sir. Very much.
Yeah. So, the onset, I'd like to thank Dr. Sarvesh and MOS for having me for this presentation. It's been lovely so far to hear all these intellectual talks. So, my talk, which Dr. Sarvesh has given me, is vitreoretinal surgical challenges in very highly myopic eyes. So, all speakers, they have talked about what all wrong with eye myopia and what are the problems. It is very specific. We are going to discuss only the surgical considerations in vitreoretina surgery. So what all things we have to be looking out for, and these are the things that are going to cause us trouble, is the high axial length. The length is more than 26.5 millimeters. Along with that, sometimes you have these posterior staphylomas that change the shape of the eyeball. You have thinner atrophic retina. You have a degenerated vitreous. We have vitreoscheisis. You have thinner and elastic sclera. So these are the problems. So these are the things that are going to cause us problems. So let's see what will happen if you're going to do a scleral buckle. So when we are doing a buckle, we are outside the eye, but you still need to be careful because of the thin sclera and the muscle attachments over there. If you are very exuberant with your muscle hooks, we may just have the muscle in your hand. So you should avoid this muscle avulsion by being very gentle. The vortex veins are a little bit anterior, so you have to be careful when you are hooking the muscles that we do not engage the vortex veins. And when we are doing scleral tunnels, we should be careful that we do not perforate these thin sclera. If we have any of these problems, we have to undertake remedial actions immediately. So in scleral buckle, again, we do drainages. The external drainage is sometimes uncontrolled. So you have a very sudden decompression, and the choroids of myopes are very vascular and they may cause hemorrhagic choroidals on table. You have to be very careful when you're draining these scleral buckle cases. What happens when we are going inside the eye? As a general rule, I think we will all be happier if we used valved cannulas. And in myopes, like Dr. Smitesh had just mentioned, for cataracts, I think we should have the same precaution. Keep the infusion low, the flow rate should be less. And if it is phakic, we would like to have some curved instruments. So in 20 gauge instruments, what we used to do, we just used to bend those instruments ourselves. So that is not possible with the 23, 25 gauge, but a slight curve is still possible, or you can get these specially made, these instruments to have a slight curve. So we'll just take up vitrectomy in these subheadings and see what all can go wrong and what we should be ready for. The incision is very important in cases of very high myopes where we want to do a posterior segment dissections like say macular hole or ERM, or you want to do some surgery for macular schisis. So since the ora is situated posterior in myopes, it's a good idea to take advantage of this. And we can actually go a little bit more than 4 millimeters, say 4.5 or even 5 millimeters behind the limbus and make our sclerotomies. So that gives us that precious 1 to 2 millimeters, which might be making the difference between a good ILM peel and a shoddy ILM peel. The other thing that we can do is we can look through the indirect and can titrate the distance of the incisions. And we would want to have our sclerotomies more towards the 3 and 9 o'clock meridians as much as possible, so that our distance becomes less as we go inside the eye. Vitreous, we have a lot of vitreoschisis, so we know that. So there might be a case where you have thought that you have done a complete vitrectomy because PVD was already there. But then this is the time when you have to stain with tricot. I think one of the most important places where you need to use tricot is a myopic eye. So once you feel they have done all vitrectomy, stain it again with tricot. Then you will see that some amount of cortical vitreous is still adherent to the retina. You need to meticulously peel this off. So what I found that you can use this finesse loop, which you get from Alcon. So you just brush it over the retina and you get the residual vitreous cortex out. Retina, we all know that is thin, atrophic. And what we have to remember is if there is a retinal detachment, you might have a multiple lattices, multiple holes, but lurking around your posterior staphyloma or the peripapillary atrophy, there might be a slit break just around the vasculature. You have to be very careful and look for these things in the posterior pole. So since we don't have much of choroidal pigmentation, so you need to see your breaks very clearly. You need to stain, like I say, stain thoroughly, then repeat the stain. Use different stains. You should keep them ready before the operation. Use tricot, trypan blue, brilliant blue, whatever is there, you can use all of them. The next step, which we have trouble, is fluid gas exchange. So better to use a silicone tip, preferably colored ones, so that you can know where your tip is exactly in spite of not having the choroidal contrast. And you need to mark your breaks very, very, very thoroughly so that you know after that, after the air, the break should not become invisible. If it happens, then you might have to sometimes restart the infusion and then do a thorough marking, and then do your FGE again. Again, keep your gas low and then avoid choroidals in that way. What about laser? Again, lack of choroidal pigmentation. You might not get good choroidal, you might not get good laser burns. So a good idea is to have a high power and longer duration. If you cannot get any burns, you might have to resort to endocryo. The last step is the one which we always forget, is that when everything is done, you just want to get out because you already had so much of trouble with your myopic eye that, and you already promised the patient that it's not going to have any sutures. But this is the time when you have to take a little bit of a back step. Take your time. If the ports are leaking, take a stitch. Don't feel shy. Don't feel it doesn't hurt your ego. You should take a stitch. This is the time to take care of that. So these are the things that we discussed. If anybody wants to take a screenshot, they can. So these are the things which we discussed right now. I think the last take-home message will be that when you have a high myopic patient, the planning begins before the operation. You should be ready. You should strategize. Incisions, like I said, you can remove the trocars. You'll get 1 or 2 millimeters more. Make the incisions posteriorly. You should be ready with longer forceps. Maybe have the finis loop ready. Keep all the dies ready. And finally, endocryo. I don't think the newer generation retinal surgeons know that such a thing exists. And there are still these things known as 20 gauge instrumentation. They are still available. They might be there in your OTs lurking somewhere behind. So those things can still be used. Thank you.
Thank you. Thank you so much for that wonderful presentation, sir. So I think we have just last 4-5 minutes to go. There's one question for Dr. Smitesh, sir. Which IOL power calculation is more convenient in clinical practice? Haig's or Barrett's, sir?
Barrett's.
Okay.
It's available and it's freely available on the, even if you don't have the instruments, it's freely available. But you need 5 parameters like white to white, lens thickness, and other things. So you at least 5 or 6 variables you need. Not only in SRKT, there are only 2 variables like the axial length and the keratometer. Here you have 5 to 6 variables, so it's better to have the Barrett's. It's freely available.
Thank you, sir. Another question by Dr. Anand to Dr. Sarika. You are there with us, Dr. Sarika?
Yes.
Yeah. So I think you must have read this question. Can you elaborate how to distinguish between early glaucoma and myopic peripapillary atrophy in a large disc? Yeah.
So actually the peripapillary atrophy, as we know, there are 4 types: alpha, beta, gamma, and delta. So the beta peripapillary atrophy is the most common. The length of the beta papillary atrophy is associated in glaucoma, but it is not that significant in high myopes. Whereas the gamma peripapillary atrophy is more commonly seen in the patients with a higher axial length, high myopia. And the studies have said that these patients are not, in these patients, the glaucoma is not seen that commonly compared to the beta peripapillary atrophy. So that is the one thing which we can see on the like spectralis domain OCT, we can find out the early glaucoma. And also we can see the retinal nerve fiber layer thickness and the changes. And we can, because the ganglion cell dropout and the retinal nerve fiber changes are earlier to come before the visual field defects in glaucoma patients. They say that they usually come 2 to 3 years earlier than the visual field defects. They actually become evident. So these are the changes. These we can see, and also we can have the stereo photographs, like to compare the peripapillary atrophy, whether it is increases over the years, so that the serial disc photos we should have.
Thank you. Thank you for that response, Dr. Sarika. So I think now, in the interest of time, I think we should wind up. Before winding up, I would like to thanks BOA, Moscon, and Dr. Ragini ma'am and Swapnesh for giving us this opportunity. I would also like to thank all my colleagues as well as my co-instructors for giving their valuable time to make this instruction course highly successful. Thank you so much, sir. Have a nice day. All.
Thank you.
Thank you. Thank you.
Thank you, Sarvesh, for finishing on time. And thank you, everybody.
Thank you so much. Thank you.
Hello everyone. Hi Swapnesh.
Hi.
I think most of the speakers for the next session are here.
Yeah, it's 4 o'clock. We can start.
Yeah. So at the outset, I'd like to thank MOS, Swapnesh and Ragini madam for giving us this opportunity. This is a UVR based session and it's like a mixed bag that we are having here. I'm sure it will be an enjoyable session. So I'll be starting first. Let me share my screen. I hope my screen is visible.
Yes, Sharan.
Right. So I'll be talking on the enigma of retinitis, right? And at the outset, let me tell you this approach that I have kept. It's going to be, trying to keep things very simple and brief. We'll try to keep only clinical based findings and avoid complicating it with OCT and FFA things. And I would strongly recommend this course conducted by LV Prasad Eye Institute for anybody who wants to know anything about uveitis. It's a wonderful course, and I think everybody who's interested must give it a thought. To begin with, as we all know, retinitis is nothing but inflammation of the retina, and most probably it also involves the adjacent structures. Right now, there could be different types of retinitis. You could have focal infiltrates, you could have full thickness retinal involvement. It could be unifocal or multifocal. It could be retinitis standalone, or it could be chorioretinitis or retinochoroiditis. Importantly, it could also be infectious or non-infectious. Now, the golden rule to remember here is that unless proven otherwise, retinitis is always infectious. So whenever you think of retinitis, you see retinitis, you have to think of an infectious cause. Just to quickly go through the common differentials that many may get confused. To begin with, there could be myelinated nerve fibers, but you have to understand these have this typical feathery edges out here, usually lack of any other lesions, and the patients are usually asymptomatic. Cotton wool spots have been nothing but small infarcts of the nerve fiber layer. So there will be small points here and there, usually associated with other hemorrhages because they are associated with systemic diseases like hypertension and diabetes. Retinitis, on the other hand, will have fluffy borders. There will be accompanying inflammation of some sort, probably with hemorrhages, and the patients will present with some decreased vision. The other way of looking at it is the level of the lesion. What is the depth of the lesion? If it's extremely deep with a bump there seen on the choroid, then you could think of a posterior scleritis. You will see the vessels comfortably pass over the lesions. Similarly, for a choroiditis, the vessels will be passing over the lesions, and again, it will be at a deeper level, and an elevation would not be seen here. Retinitis are superficial, so the vessels would definitely be obscured, and there could be accompanying retinal hemorrhages. Having established that it is retinitis, there are a lot of infectious and non-infectious causes, but for lack of time, we would be sticking to the most important causes today, that is the toxoplasma and the viral retinitis. If we look at the toxoretinochoroiditis, it is usually found in immunocompetent patients. The lesions are small, unifocal, and at the posterior pole. Usually there is lack of hemorrhages, and you could also see confluent vasculitis. There could be anterior segment involvement here as well. If it's a recurrence, then there would be dense vitritis and what typically known as the headlight in fog appearance. And you would also see an adjacent scar of the previous infection. But if it's a first episode, the vitritis could be minimal and a no scar may also be seen. And the lesions heal with pigmentation, and many times patient just present with a scarred lesion and just representing an old toxo infection. Now, IgG for toxo positivity doesn't mean much, but a negative IgG may help to rule out toxoplasma as a cause. But it is important to remember it appears positive 1 or 2 weeks after the infection. IgM is an indicator for active infection. Anything unusual that you find in your the presentation of the patient, then you should consider HIV, because even in immunosuppressed patients, toxo may be present. Treatment is usually Bactrim or Septran along with oral steroids. The point to remember is that steroids have to start after and end before the course of antibiotics. Intravitreal clindamycin may also be used, especially if the macula is getting involved, or in pregnancy where oral cannot be given, along with oral spiramycin. Moving on to viral retinitis, we are discussing the three main types, that's CMV, ARN, and PON. If you look at CMV retinitis, it is seen in immunocompromised patients, usually with CD4 counts less than 50. And generally, there is no anterior segment inflammation which is seen. Now, the lesions start at the periphery and spread slowly. There is no significant vitritis. There are white borders with central clearing. And there are definitely associated hemorrhages. The three different forms which are described, one is the fulminant form, giving rise to a typical pizza pie appearance. Then it could be an indolent or a granular variant where there are multiple small retinal lesions seen, or it could be the frosted branch angiitis, which is a rare variant. And all this leaves behind atrophic and necrotic retina, which can further lead to retinal detachment. Treatment for all viral retinitis include an induction phase for initial 2 to 3 weeks, where the doses are a little higher. And then there is a maintenance phase to prevent reactivation. In immunocompromised patients, antiretroviral treatment would also be required. IV ganciclovir can be used, but generally oral valganciclovir is the preferred because of no need for hospitalization. Moving on to acute retinal necrosis, it is necrotizing retinitis in immunocompetent individuals caused mainly by VZV and HSV viruses. There is rapid onset ocular pain and anterior segment manifestations are prominently seen with pigmented KPs, raised IOP, and anterior scleritis. The systemic history or past history can give some clue as to what organism it could be. Posterior segment, there is severe vitritis. Lesions are in the far to mid peripheral retina. There is occlusive arteritis and hemorrhages are rarely seen. Optic neuropathy and RD is very commonly seen in these cases. Treatment is by oral valacyclovir. In severe cases, there is a role for intravitreal ganciclovir and oral steroids as well. Finally, coming to PON, it is mainly caused by VZV in immunocompromised patients. The course is fulminant and visual prognosis is poor. These are multifocal deep lesions with involvement of the posterior pole early on. And there is a perivascular lucency which gives rise to a cracked mud appearance. Treatment is difficult with a single agent, so multiple agents are required along with intravitreal treatment, and of course hard treatment would also be required. Briefly, in testing for these retinitis, these are the tests that you would be doing. You need to rule out syphilis and TB as a cause. AC parasynthetase or vitreous tap can be done for PCR, and at times you may require FFA OCT and neurological evaluation. In conclusion, I'm going to end with a stepwise algorithm for approaching retinitis. Try to keep it simple, but of course you have to understand there could be variation seen. Now, if the patient is a healthy patient with significant anterior segment involvement and vitritis, and there is vasculitis, confluent or occlusive, we need to think in terms of toxo or ARN. On the other hand, if the patient is immunocompromised with minimal anterior segment involvement, minimal vitritis, hardly any vasculitis, then we should think in terms of CMV or PORN. Now, in this category further, if the area involved is small at posterior pole, variable visual loss, progression is slow, and retinal hemorrhages are few, and you get a typical headlight in fog appearance, you would think more in terms of toxo. On the other hand, if the lesions are large, peripheral, severe visual loss, and rapid progression is seen with multiple retinal hemorrhages, what is known as a late Swiss cheese appearance, then ARN would be the thought line. In the immunocompromised patients, if the lesions are peripheral with a late visual loss, slowly progressive, multiple hemorrhages is a pizza pie appearance, you would think in terms of CMV. While if the posterior pole is involved early and there is rapid progression and a cracked mud-like appearance, then PORN would be the thought process. And then you treat as I've just described. Thank you so much.
Thank you, Sharan. That was a wonderful presentation. I would take this opportunity to thank and invite Sumashila Murthy, Madam. It's an honor to have you on our panel, Madam. There's no need to introduce her, but just for the newer retina aspiring people, we should know that Madam has a rich experience of more than 15 years as faculty at LVPI, and she is very much a Mumbai girl. where she has done her post-graduation as well as undergraduation from Nair and Sion Hospital. And then she went on to US, where she was a faculty at Doheny Eye Institute, California. Madam, it's a privilege for us that you have accepted the invitation. And Dr. Ragini Parikh, Madam, is also here. She would like to say a few words. Madam, you're muted. Madam, you're muted.
Very well said, Swapnesh. And I think we are really proud of her because she's a Mumbai girl. Welcome back to your home.
Thank you very much. Thank you so much, Swapnesh, for your very kind words. And thank you, Dr. Ragini and Sharan, for having me here. And of course, the minute I got the invitation, I was more than happy to be part of this very important session.
Hopefully we'll meet in person soon.
I hope so too. Sharan, that was an excellent talk. I think you covered mainly infectious causes of retinitis very well. And the last slide of yours just about summed it up. In fact, my question to you was going to be that how can a general ophthalmologist, figure out between all of these, and you just covered it beautifully in your last slide. So thank you for that.
Thank you, madam. Yeah, next I would like to call upon my friend Dr. Yogesh Patil, who is an excellent VR surgeon practicing at Advanced Eye Hospital, Navi Mumbai, to give the next talk. And he's going to talk on unsolved mystery of vitreous haze.
Thank you, Sharan. Thank you so much for this wonderful session. And thank you, Swapnesh, for putting it all together.
Thank you. Thank you, madam, for the opportunity. I'm not seeing Yogesh here. I thought you had logged in.
We can move on to the next.
Yeah, we can move on. Madam, I think it would be better if you could, if you could take over. I think Swapnesh has already introduced you, so I need not speak more. I think you can start with your presentation.
Sure. So as Sharan started off by saying that this is kind of a potpourri of uvea. So we're going all the way from anterior to posterior, and also we're going to talk about scleritis. So I thought I'll try to speak on my favorite topic first, and this is about scleritis. And I thought I'll try to keep it sort of more engaging to the audience if I simply discuss real life cases that we had. Sharon, am I sharing my screen? Is it?
Yes, ma'am. Yes, ma'am. It seems.
Thank you. So, everybody is familiar with this classification from Watson and Here, which talks about scleritis, then divides it as infectious and then non-infectious. And then when it's non-infectious, you have anterior, posterior, and then you have non-necrotizing and necrotizing. So the ones that I've highlighted here are just that with experience and with these cases that we have seen, I thought that it would be worthwhile to include a few more in this classification. So when you talk about scleritis, nowadays we might see the rare masquerade, which may have associated scleritis or which may be looking like scleritis, like a mimicker. And we often say anterior and posterior scleritis, but sometimes we see such fulminant scleritis that just like pan-uveitis, some of us have started calling them as sort of a pan-scleritis. And under the necrotizing variety, just wanted to point out that, how the textbook says without inflammation, especially say for the patients with rheumatoid arthritis, but actually it's without clinical inflammation, because if you go and take this biopsy, you will definitely see inflammatory cells. And the surgically induced necrotizing scleritis and surgically induced diffuse scleritis were not included in this original classification. So I thought it will be interesting to put it in here. And we have published this in a textbook that has just come out on inflammation in general. So let's go to case one of a 37-year-old lady who had symptoms which had become quite severe. She had it since a year. She had undergone cataract surgery 2 years ago. And her systemic entities that she had was that over a period of time, not at her first instance itself, but she gradually developed nasal septal involvement in the form of inflammation of the nasal septum and collapse of the bridge of the nose. And she continued to have this lower limb relapsing myalgias. So this was her entry-level pictures where she had diffuse scleritis, as well as what you can see prominently is the peripheral infiltrates on the cornea. So we diagnosed her as scleritis with corneal involvement, and we investigated her thoroughly, and we started her on oral medications. But despite all that, the patient continued to go on having these relapsing episodes. So this patient I have in follow-up for 17 years now. So 2 years from the initial presentation when she had this saddle nose deformity, then we could pick up the diagnosis of relapsing polychondritis for her. And after multiple medications, we finally started the patient on tocilizumab, and with that she stabilized, and just before lockdown she had come in and she seemed to be doing well. She's on teleconsultation too. So this was a case of a very chronic kind of a disease, relapsing polychondritis with scleritis. The second patient is somewhat similar, as in the systemic etiology of this patient. She has granulomatosis polyangiitis, which is what we used to call as vaginals. And she presented with severe necrotizing scleritis. In fact, the thought was whether to do a patch graft or not. But we did not do a patch graft for her. We started her on oral steroids. She also had recent tuberculosis, so we couldn't start her on cyclophosphamide. And after a while, the scleritis component went down significantly. Of course, there's a staphyloma formation, but the patient was doing very well till she succumbed in 2018 due to aspergillosis of the lungs. So she had a lot of systemic morbidity. Can you have infectious causes? Yes, you can. Sometimes it can be subtle like this. So this patient gave history of pigmented, history of typical rash over the forehead on one side, and the same eye was affected. And so this is obviously when you have such a symptomatology, you're dealing with herpes zoster ophthalmicus. He did not have any other neurological symptoms, but he did have these peripheral corneal infiltration in the cornea. And then the patient was on oral steroids, not getting better. So this particular patient, we started on oral acyclovir as well. This was the OCT showing that this is the anterior part, and you can see that this is not as thickened, but the posterior part is very thickened. And once we started the patient on therapy, there was gradual resolution and the patient quietened down. So this was a different case. What about fulminant infections? We probably see them a little bit more than the West. So this patient had history of mud falling into the eye, and then the patient came to us with these necrotic looking white patches from which we could isolate Pseudomonas species. Again, it took us a very long time to get the patient to quieten down. In fact, at one point, we even thought of starting the patient on immunomodulators and oral steroids, but subsequently the patient settled down with amikacin. And that was because we had a microbiological diagnosis for this patient. Another similar case where there was history of trauma turns out could well turn out to be fungal keratitis. In this particular instance, we had a patient with a stick injury and multiple scrapings were negative. Finally, we got separate fungal filaments. And on starting the patient with treatment, there was rapid resolution. So I think bacterial and fungal keratitis, scleritis have been fairly common in patients because many of our patients are in the agricultural background. All right, coming to an unusual case of a patient, he did give history of injury. He did say that he had some kind of systemic component like joint inflammation. So, but what he had was this very dense white looking lesion. Now, at that time, it was diagnosed as scleritis, but now that I show you the pictures, you know that this doesn't look like the previous pictures of scleritis. And indeed, it was not. So we did extensive workup and then even did the scleral deroofing, but the patient did not get better at all. And you can see that there is extension of the lesion here. Ultimately, it dawned on us that this is looking like a masquerade, and our oncology colleagues as well saw the case. This patient turned out to have diffuse OSSN. He systemically had HBsAg positive. And unfortunately, it was so diffuse with orbital involvement that the patient had to undergo an exentration. This was the exented specimen. So these are the various different cases that I had of scleritis to present to you. So it runs from infection to what you expect as inflammation, and it can sometimes end with these very rare cases of masquerade. So the masquerade is an exception. What you commonly see would be a sort of a garden variety immune-mediated diffuse scleritis most of the time. But watch out if the patient has history of trauma or if the patient has history of recent surgery, especially pterygium surgery or the older kind of vitreoretinal surgery or a retinal belt buckle in place. Then think about an infectious component. So that was what I had to share, sir, if you want to take over.
Thank you, madam, for that wonderful talk. Yes, Swapnesh.
Sharon, can I ask one question to?
Yeah.
Of course.
Yeah, madam, how to make best use of OCT in cases of scleritis? How to make optimum use of OCT? Does it help to monitor or prognosticate the treatment?
Right. So the first part, I would say that don't depend on OCT, and especially for those of us who don't have OCT in our practice, you don't need it for scleritis. It does help. The OCT helps us because I'm being a cornea anterior segment person, I anyway have the OCT with me. So I find it fairly useful, and we're just trying to finish up with our work on how to differentiate between episcleritis and scleritis using the OCT alone, without using, the person who's looking at the OCT images is unbiased, doesn't know the history. And then can you diagnose episcleritis versus scleritis? Yes, it's fairly, it's pretty good. We got more than 90% in terms of sensitivity and specificity. The second way to diagnose for my patients is in the management. So clinically, the patient might still have symptoms, but you might see that on OCT, the amount of edema has gone down. So there are it's still unexplored, and I think that we cannot really differentiate between the infectious versus the immune mediated, especially if you have a huge nodule. But it is probably more useful for those borderline cases, whether it's episcleritis or scleritis, and it's more useful to monitor the therapy for these patients. I hope that answered your question, Swapnesh.
Yeah. Thank you, ma'am. Yeah.
And would you like to continue with your next talk, viral anterior uveitis?
Sure. Are there any other questions in the meanwhile?
No, ma'am, you can go ahead with the next one.
All right. So moving on to the second part of what I wanted to speak on, what I like to speak on, is about a fairly under-recognized entity. And this is viral endothelitis or viral anterior uveitis. The next time each of you goes to clinic, I want you to pay attention to the cases that come in. And perhaps we've been missing these cases a lot. We've been labeling them as granulomatous anterior uveitis, labeling them as glaucoma, maybe steroid responders, and also considering that entity of Postner-Schlossman syndrome. So all of these are nothing but a viral endothelitis. And when you have a patient with this kind of clinical presentation that I'm going to show you, rest assured that it's going to be a viral infection. You just need to figure out which virus so that you can start the appropriate antiviral. So let's go in very quickly with these few cases, or rather with a little bit of background first. What are the common viruses causing endothelitis or keratouveitis? These are all terminologies you can use. When the endothelium alone is affected without any stromal or any epithelial component, then I'd like to call it as endothelitis. If there is a past stromal scarring or current stromal scarring, then you have a keratouveitis. And if the patient presents only with the keratic precipitates and some amount of anterior uveitis, secondary glaucoma, then we can label them as anterior uveitis. But we are pretty much talking about the same culprits. So we need to also know how to diagnose between viral and non-viral, as well as amongst the viruses, which are the ones that could be causing it. And so therefore, we'll go through some cases, which I think always teach us a lot. And if we have time, we'll go through the management. So the commonest viruses that can cause endothelitis or keratouveitis, I'm just going to use endothelitis, which represents all of the others that I mentioned, would be, of course, herpes simplex type 1, varicella zoster virus, and cytomegalovirus. Rubella virus is more in the context of Fuchs heterochromic cystitis. And then there are rare viruses, but nevertheless, they do exist. And perhaps it's harder to pick up these viruses, especially Epstein-Barr has been reported, and also chikungunya virus has been reported as causes of a viral, maybe anterior uveitis. That you will only know because the patient might present with other symptomatology related to that disease. And certainly I would put the SARS coronavirus also under this category, where you can have a viral anterior uveitis. So let's go to the common viruses. I'm not going to talk about the SARS coronavirus at all here, but the commonest ones that we're going to see in our clinic would be HSV, VZV, and CMV. These are the commonest causes. So how do you differentiate between them? So whenever you have a patient with maybe history of recurrent keratitis, so there could be some corneal lesions or scarring or footprint scars. Hypoesthesia is a very common feature, as you know, in HSV, and do test the corneal sensations of all these patients that come to us. Or you can have the patient with a disciform, a classic disciform kind of a keratitis. The keratic precipitates are always there. They can usually range between small to medium, and they're very often pigmented, like in this example here. And there would be a very moderate AC reaction, not fulminant. But if you don't treat it, then yes, the reaction gets much more fulminant. And the intraocular pressure is moderately raised. So it would be about 30s or something like that. So you have a patient with secondary glaucoma and the symptomatology, you might lean more towards HSV. So this is about HSV. What about the second entity, that is VZV? So VZV can be seen both in the immunocompromised, for example, in HZO, or it can also be seen in the immunocompetent. So it's not necessary to see only in the immunocompromised. So here it is a little bit more classical when you have that moth-eaten pattern of the iris trans illumination defect. So that is due to VZV because the depigmentation that happens is much more and it's sectoral. And you can also have this very florid and slightly ugly looking mass of keratic precipitates, which are very large. And you can have pseudodendrites, you can have nummulokeratitis associated with it, especially with the HZO, when they have HZO. And raised IOP, sometimes IOP can be very high also, very highly raised, like 40s, 50s, and so on. So these are the patients where you can think about VZV etiology or even HZO etiology. Coming to the most under-recognized entity, the third one, that is CMV endothelitis. So this is an entity that I got very interested in because of seeing publications from the Singapore group. And after that, when we looked at our patients very closely, you could see a number of patients coming in with these cases. And when I recall, I think that we have missed a lot of these patients because we labeled them as something else, or maybe viral, or maybe just anterior uveitis and investigated them. So what is the symptomatology here? They have years of history, maybe 1 year, 2 years. They have coin-shaped or linear or granulomatous KPs, very minimal AC reaction, and super high pressure. So pressures in the 50s or even 60s. And during the episode, when they come in with this kind of KPs and so on, the speculars, the endothelial cells are usually affected. So if you do a simple specular microscopy, you will see that the cells are affected. So this is very hallmark of CMV endothelitis. Surprisingly, in HSV, you don't really see this typical changes of the endothelial cells unless it is very, very chronic and the endothelial cells are damaged. So that is the entity of CMV endothelitis. I'll probably just go through one case and then end. So this was a child who presented with a hypopion uveitis. Initially, it was thought to be a masquerade, although the B scan was normal. And then next, it was thought to be JIA because a pediatric patient with uveitis, we naturally think of JIA. So what we did was the AC fluid was sampled and it showed chronic granulomatous inflammation. But at that point, we did not think of testing it for viruses. We didn't suspect it. But subsequently, we sent a repeat sample. We sent that for virology and we got HSV1 positive for that. This is the histopathology from the first specimen. What it's showing here is these large sort of folded in cells, which are sort of the macrophages, which are pretty hallmark for viral etiology. So this child turned out to have herpetic anterior uveitis. Even it's so significant because it was not treated, that he presented with a hypopion. And so think of it even in pediatric cases that viral etiology could be one of the causes of uveitis in these pediatric cases. Another case is a patient who presented with diagnosis of chronic anterior uveitis, was only 36 years and secondary glaucoma. So the patient presents to us with these, hardly anything you can see, just some small little keratic precipitates. But so what's very important here is the history. So the patient has recurrent episodes, everything else is negative, and the patient also has secondary glaucoma. And so we sent an AC tab, which was actually initially negative, but we anyway started the patient on oral acyclovir. So you don't have to have a positive virology on AC tab. Clinical suspicion, a strong clinical suspicion is good enough because acyclovir, we are very familiar with how to use it. And it's not a very toxic drug, it's very well tolerated. And it's fairly cheap also. So you can use acyclovir or valacyclovir, whichever you prefer. And so with this patient, despite negative serology from the AC, despite negative virology from the AC tab, we were very convinced was viral based on the symptomatology. And we stopped all the anti-glaucoma medications over time. The patient could be taken off steroids and continues though to be on oral acyclovir. So now when the patients ask how long should I be on this drug, it's kind of hard to say, because most of the viral inflammations most of the drugs are only virostatic, they're not virucidal in that way. But one last point is that if it's CMV endothelitis, then valacyclovir or acyclovir will not work. We'll have to use valganciclovir for these patients. So the same patient didn't respond to oral acyclovir, then I would have probably switched to valganciclovir, which is much more expensive. So you need to convince the patient to take it. So that's all I have for this patient. Once again, thank you very much for this opportunity. I would like to end on time.
Thank you, ma'am. That was wonderful. Madam, could you highlight what exactly do you mean by coin-shaped KPs? Means just for somebody who has not seen it clinically, would you describe it, how it looks on slit lamp exactly?
Yeah, so coin-shaped KPs does not mean the huge, like a big coin or something like that. I would say that if you have, so you don't always have coin-shaped KPs, but if you have coin-shaped KPs, that is very pathognomic for CMV endothelitis. So let me just blow up this picture here. And this is more typical what we see. If you can see this little small keratic precipitate over here.
Yeah.
So these are more typical features. You just see some isolated but fairly large precipitates. So this kind of precipitate could be in a small little ring or a much larger than this. So that would call it a coin-shaped keratic precipitate. They're very tiny though.
And the ring is probably because of the localized corneal edema always?
No, the ring is again a host of keratic precipitates that conglomerate because those particular cells are affected by the disease. And this is what the specular would look like, as you have in this picture here, that the specular microscopy, this was because of the edema, you can't see anything, but as the patient improved, you can see that how bad the endothelial cell count looks like and the changes in the endothelial cells itself. So that is also classical for CMV endothelitis.
Thank you, ma'am. Sharan?
Yeah, I see Dr. Yogesh has logged in again. So I think he had some network
Yes,
issues.
yes.
Yeah. So Yogesh, you can start your presentation.
Sure. Thank you. Yeah. Is my screen visible?
Not yet.
Not yet.
Oh. Wait a minute. Now?
No.
Oh.
I think we'll move on to the next speaker, Yogesh.
Yeah. Please. I think, yeah. This is basically, there is some.
Okay.
Please carry on. Please carry on. Yeah. Thank you. Yeah.
Next speaker, I'd like to call Dr. Nikhil Beke, who's a VR surgeon and uveitis expert from Pune. He's received his training in retina and UVI at PGI Chandigarh and is presently serving honorary consultant at HP Desai Hospital and Dinanath Mangeshkar Hospital at Pune. His areas of interest include diabetic retinopathy, ROP, and uveitis. He's going to enlighten us about the various therapeutic options in uveitis. Dr. Nicholson? Yeah, please carry on. We can't hear you. Dr. Beke, you're on mute.
Yeah, hope I'm audible now.
Yeah. Please carry on.
Yeah. So was going to talk on the infectious therapeutic options in uveitis. And largely, we grossly classify uveitis in two entities, infectious and non-infectious. And the treatment of infectious uveitis is relatively easy if the diagnosis is quickly and correctly achieved. So you have to treat the infection, you have to give steroids judiciously at the right time once the antimicrobials start acting. You have to monitor for the side effects, and you also have to think of the conditions that lead to immunosuppression, that lead to the infection, for example, the immune deficiency. So when it comes to non-infectious uveitis, this is where the trials and tribulations, both for the uveitis expert as well as for the patient, start, because both of them know, they need to know that they are in for a long haul. And to begin off, you need a good start. You need a good opening batsman to get a rapid control over the entity. But you also need an agent to sustain the effort, to win the long-term battle. So when it comes to the quick effect or the rapid onset of actions, nothing better than steroids. They quickly start their actions, but unfortunately they can't be continued in the long run because you would be caught up. The steroid side effects start catching up. So you require another agent which would relatively, start its action relatively in a delayed manner, maybe at 4 to 6 weeks, but it would be feasible to give it over a long term for months and years without side effects. So steroids in chronic infectious, non-infectious entities are thought of once they are the first line of treatment for inducing remission. They also are useful for controlling each recurrence, and they are effective because they can be given multiple dosage forms. So if you want a rapid control of the inflammation for the sake of patient discomfort or vital tissues at risk, then one can think of methylprednisolone, which is given IV. And this is usually after getting the patient hospitalized. Once the initial acute phase is over, you can maintain the control for the short run on an OPD basis or with oral steroids. Usually the drug chosen by ophthalmologists is prednisolone, and it started at 1 to 1.5 milligram per kg and then tapered over a period of time. So what is inevitable is, especially when we are using prednisolone for more than 12.5 milligram per day for more than almost 3 months, then hypocortisolism catches up, which is commonly manifested in the terms of raised BP, raised sugars, osteoporosis, and gastric ulcers. But what is something which defies monitoring and which goes unnoticed is disturbed mental health and even psychosis at times. So now that we are all fond of we are all very fond of being vocal for local, ophthalmologists have also thought of treating the disease locally, and the commonest agent that initially people went for was triamcinolone acetonide, which had a good effect but also has significant local side effects, namely in terms of cataract and raised IOP, which can have cumulative effect. And a bigger problem was this gives you a bolus action, so a sudden rise in the action and then rapid waning of the effect. So you have this effect in peaks and troughs, whereas what you really need is a sustained plateau kind of effect in these cases. So the next thing that was thought of was Ozurdex, which is a sustained release 0.7 milligram dexamethasone implant, which is biodegradable and can be injected, which can be injected with a 22 gauge applicator, and because it has a relatively milder side effect profile, especially when it comes to IOP, because of its water soluble nature. So the claim duration is somewhere between 3 to 6 months. In clinical practice, we don't see it acting beyond 4 months. But then thinking even long term, there are a few entities which require immunosuppression beyond 4 months, and these are typically these entities which where the recurrence is the norm, and even between the two clinically telltale recurrences, you do have ongoing tissue injury on a microscopic level. So the conventional immunosuppressives were thought of. These are typically used in all those cases which are responsive to steroids, but then they are recurrent, they are site-threatening, and steroid side effects are a serious problem. So usually we think of antimetaboloids, commonly used ones are methotrexate, azathioprine, and mycophenolate, and calcineurin inhibitors such as cyclosporin. And rarely, if you want a even rapid control of inflammation, then one can think of cytotoxic drugs like cyclophosphamide. And we are targeting lymphopenia here. So it requires a significant systemic workup prior to starting immunosuppressives. And usually they are started in liaison with a rheumatologist or an internist. And one needs to be aware that all these agents, they cause a significant bone marrow, liver, GI, and kidney toxicity. And at times certain tests might be needed to see if a specific agent is suitable for a given case. For example, one might think of doing a TPMT enzyme levels before starting azathioprine. And not only at the beginning, they also require monitoring while they are being used. So people routinely undertake serial monitoring of hemogram, LFT, RFTs on a regular basis. And the patient also needs to be alerted that he needs to report to the physician or the ophthalmologist if there are any unexpected symptoms or if there are any signs of infection. So thinking of month and year-long therapy, people thought of giving that locally in terms of fluocinolone acetonide implant, which is to be sutured to the sclera in a surgical procedure. But this was fraught with multiple side effects. So this is the implant. This has this pellet of fluocinolone acetonide. This was implanted surgically. But because of the multiple side effects such as cataract and raised IOP, this fell out of favor. And what took its place was a 25 gauge non-biodegradable implant, which is Illuvian, which also works for 36 months. So gives a good cover for almost 3 years. And this is approximately the size of it. So the newest kid in the block is biological response modifiers, which are essentially monoclonal antibodies acting against biological active mediators of immune response, namely such as cytokines. And they are indicated if the patient shows intolerance or inadequate response to conventional immunosuppression or has concomitant systemic disease such as Behçet's or juvenile idiopathic arthritis. And they work beautifully in Behçet's because TNF alpha takes a center stage in the pathogenesis of Behçet's. And any anti-TNF alpha antibody, which are two of them are quite commonly available. One is infliximab, which is chimeric antibody given IV, and adalimumab, which is a humanized antibody tolerated better, which is given in a subcutaneous manner like an insulin pen. Thankfully for both of them, biosimilars are available. And this can be used as a first-line agent. Instead of starting the patient with methylprednisolone and followed by oral steroids plus immunosuppressives, you can directly start off with anti-TNF alpha agent. And as a VR surgeon, I think it would be the treatment of uveitis would be incomplete unless we include vitrectomy as the as a treatment modality, where especially in those cases which are refractory to medical therapy. And this is done to clear the structural entities such as epiretinal membranes, tractional retinal detachments, dense PCO, and even for correction of hypotony. But this can also clear the media and at times this aids in diagnosis for in challenging cases such as lymphoma or even retinal necrosis. Thank you.
Thank you, Dr. Baker. That was a wonderful talk. Any questions anybody has?
Hi, Nikhil. How are you?
Hi, ma'am. Doing so well.
Good. I think you covered the talk wonderfully, Nikhil, pretty much including the latest aspects as well. So, and also you've highlighted that why steroids cannot be good for a long time. So I think more and more as ophthalmologists, we should try to start the patient on other immunomodulators and keep them only for the minimum possible time on steroids. So thanks for bringing that up.
Yeah, thank you.
I'd just like to ask, what would be the indication for starting off straight away with, say, adalimumab, as against oral steroids and then followed by something else?
As I said, where the drug is particularly where the drug is targeting a cytokine, which plays a key role in, let's say, a disease called disease such as Behçet's disease, where you are specifically targeting the disease itself, the disease-causing cytokine itself, instead of causing a broad spectrum lymphopenia.
So in our context, we very rarely go upfront with something like, say, adalimumab. There are very few indications for that. Let's say a pediatric patient where you really want to avoid oral steroids. But otherwise, it's not first-line therapy, and except for Behçet's, as he's pointed out. But otherwise, I think we would have tried some other agent before we go to adalimumab. But
right.
in rheumatology medicine, they do use it as first-line. So it's only a matter of time, I think.
Okay, thank you.
It's been my observation that down south parts of India, we rarely get to see uveitis, the Behçet's uveitis in a very common way. Elsewhere, the rheumatologist, and whenever it comes to us, it's usually through a rheumatologist who would have already started the patient on one of the biologics. It's getting very common with them.
Yeah, I agree with that. So you're muted, Sharam. You're muted.
Yeah, sorry. So let's move on to our next speaker, Dr. Girish Gadre, who's a VR surgeon practicing at Kolhapur and Kudal since 20 years. He did his MS from Bhopal and VR fellowship from SN. Presently, he is also associate professor at Krishna Medical College, Karanchi. He's received a BG Limay Award, YKC Pandit Award, and Best Video Award at different MOS conferences. He's going to speak to us about a very important topic of ocular TB. Sir, you can please start.
Am I audible? Sorry,
yes,
sir, visible?
Yes, you are. Yes, please.
Okay. So I will be starting my topic on ocular tuberculosis. I will be focusing only on the posterior segment, like posterior uveitis. Whenever we get a patient with a choroiditis patch, in that case, we need to look for the different lesions in the form of old choroiditis patches like this, some vasculitis patches like this, and one should focus on the 4 important things: where anatomically the primary site of inflammation lies, how likely infectious etiology is, how site-threatening the inflammation is, and associated systemic diseases. So while focusing on ocular tuberculosis, collaborative ocular tuberculosis study has given us some guidelines and differentiated different types of uveitis patterns into multifocal choroiditis, choroidal tubercles, serpiginous-like choroiditis, retinal vasculitis, subretinal abscess, neuroretinitis, and intermediate uveitis. Whenever we get a case of multifocal choroiditis, I would like to present a few cases. This is a patient who had multiple episodes of multifocal choroiditis in the span of 5 years, presented initially with floaters and 6/6 vision. His mantle and chest X-ray was normal, which was done twice or thrice, and he had already lost his left eye with vision 3/60 and healed multifocal choroiditis patches. He developed retinal detachment in between, developed cataract, undergone retinal detachment surgery, cataract surgery. 2 years he was uneventful in between and developed arthritis, which was gouty arthritis. He had 2 more attacks of uveitis, developed diabetes because of multiple dosage of steroids, systemic as well as topical steroids. Then he presented with a 4th attack with recurrence with multifocal choroiditis patches with some vasculitis area. One can see buccal effect and lot of exudates over that effect. On FFA, the importance of FFA is that one can see the activity in the at the margin of choroiditis patches. One can see when the patch is very near to fovea. One can see the staining in the vasculitis patches. After 3 months of the previous attack, he had a large multiple patches at fovea with a bleed at the margin. So we suspected it is a secondary CNVM due to choroiditis patches. There is a reactivation in left eye with few hemorrhages also. At this point of time, we insisted he was financially poor, so we insisted for quantiferon gold and CT scan. Ultimately, he got it done, and it turned out to be TB gold positive, and HRCT was also showing old pulmonary patches. So he was started on anti-tubercular treatment. And because we suspected it's a CNVM, we have given intravitreal Avastin, which responded very well. After 2 dosages of Avastin and starting of ATT, the lesions completely regressed. And one can see the complete scenario that after 5 years, we could diagnose it as a case of tuberculosis correctly, and the lesions completely regressed. But unfortunately, his vision lost to 3/16 both eyes. Another presentation could be tuberculoma, which manifests as a single or multiple yellowish subretinal lesion with fuzzy border with or without exudative fluid, typically located in the posterior pole. She is a lady of 16 years, history of foreign trip, AP status. Why I would like to specifically tell that many financially good peoples, they won't agree that they have a ocular tuberculosis, and they go for even investigation. So we treated it as a case of toxoplasma, even though there was no retinitis, even though there was no vitritis. All blood tests were normal, even TB gold and MANTU was negative. She was partially responding to steroids, but again, she used to have 2 to 3 recurrences. One can see the active lesion with the temporal margin was active. And she had undergone AC type for PCR, which was positive, and started on anti-tubercular treatment. And ultimately, the lesion completely regressed. Third way by which tuberculosis can present is a serpiginous-like choroiditis, manifests as a multifocal, initially discrete and later confluent lesions, characterized by slightly raised edges showing active edge wave-like progression and central healing, typical like a serpiginous choroiditis. But slightly different part is that they are diffuse plaque-like, non-contagious to optic disc, and they are usually associated with mild vitritis. This is a case where patient presented with left eye vision drop, and the lesion is very near to fovea. Patient undergone investigation, thorough investigation, which he was MANTU positive, so we started on ATT. And because the lesion is very near to fovea, we have started IV methylprednisolone. He was not aware about his right eye lesions, but it possibly turned out to be a presumptive ocular tuberculosis. The patient responded very well. Another presentation could be multifocal choroiditis and serpiginous choroiditis combination. Our teacher, Dr. Biswa sir, used to call it as MPGS choroiditis, which is a combination of serpiginous choroiditis and multifocal choroiditis. This could be a type of ocular tuberculosis presentation. Of course, this has not been described in Coates study. Another way by which ocular tuberculosis can present is a vasculitis, typically as a Eales disease, one of the differentials. Healthy young male patients with typical periphlebitis, capillary non-perfusion areas, neovascularization, recurrent vitreous hemorrhage, and fibrovascular proliferation, typically seen in Eales disease. It is a hypersensitive reaction, as we all know. The presence of perivascular choroidal pigment or small choroiditis patches is highly suggestive of tubercular etiology. Whenever we see a patient of Eales, before calling it as a Eales, if we see a choroiditis patches along the vessel, one must investigate thoroughly for the tuberculosis. Here is one interesting patient who treated for Eales disease elsewhere with steroid and laser, developed recurrent vitreous hemorrhage. MAN2 was negative, TB Gold was positive, started on ATT and intravitreal Razumab because he has a vitreous hemorrhage with oral steroids, and one can see there is a complete regression. I would like to stress on one important point, that there is one area of subretinal lesion, which is a choroidal patch, it's tuberculoma, that was also regressed. One can present tuberculosis as a neuroretinitis or choroidal tubercle. So we investigate patient. The gold standard is demonstration of mycobacteria, but it is not possible in our scenario because of lack of sample. In this setting, PCR is extremely helpful, but that is also invasive. So diagnosis of tubercular uveitis is mostly based on clinical and immunological investigation. These techniques are frequently used to reach a presumptive diagnosis. The baseline immunological testing include PPD, that is MAN2 test, and IGRS, interferon gamma release test. Both tests do not distinguish between active and latent disease. Interferon test is better in those who received BCG and already on steroids, but caution is required in the interpretation. Radiological imaging is extremely important. Usually we do X-ray chest, which is not of much help. So Coates study itself gives us a guideline that HRCT is extremely important, where we can pick up tuberculosis in around 68 to 70% patients. Ocular imaging is important, particularly fluorescein angiography, to look for activity, serpiginous type of cases, CNP areas to do scatter laser, presence of NVs and macular edema. OCT is important to look for anatomical location of lesion, particularly when it encroaches to fovea. Autofluorescence is one of the things where even though it is non-invasive, one can give activity, whether the lesion is active or not. ICG has a limited role. When to start anti-tubercular treatment as per Coates trial in tubercular SLC, one positive immunological evidence is sufficient to start ATT. In tuberculoma, immunological evidence or when patient comes with endemic area with positive radiological finding, one can start ATT. Tubercular multifocal choroiditis is not very specific of tuberculosis, so one immunological test along with a radiological finding is necessary to start ATT. Other studies gives guideline that when patient has a vasculitis with patches of choroiditis along with vessel, one positive immunological evidence is sufficient. Recurrent tuberculosis transiently responding to steroid, patient is coming from endemic area, one can start anti-tubercular treatment with one immunological evidence. Use of INH with rifampicin as an empirical trial dose for a month, and if patient respond, one can also start ATT. The main issue is that physicians are not very they won't agree to start ATT unless patient has a radiological investigation. Normal dose of ATT is 2 months of 4 drugs and 6 months of 2 drugs. If no signs of regression, one can consider case as a multi-drug resistant. Corticosteroids and immunosuppressant has major role but should not be given alone. Paradoxical worsening can be seen in few cases on ATT. Local intravitreal steroids and anti-VEGF has limited role. There are new studies which shows that in tuberculoma there is a very high dose of VEGF. In that case, anti-VEGF agent along with the steroids are indicated. To conclude, Coates study gives us better idea in defining different clinical presentation and its tubercular association. PPD and IGR is an important role, should always be done. HRCT gives us more information than X-ray. AC-type or vitreous type for PCR is informative. ATT needs to be started soon as per Coates guidelines. Steroids has a major role in reducing inflammation along with ATT. ocular tuberculosis can present in any form and should be timely diagnosed and treated. Thank you.
Thank you, Dr. Gadare, for this wonderful talk. We just have time, and Dr. Yogesh is just going to try once again if you can log in and make his presentation. Dr. Yogesh?
I'm just going to start the share screen.
Yeah.
I hope it's visible now.
I think it's getting shared. Yes, please go on.
Yeah. So I'll sum up as quickly as possible, and it will be, I think, very good case for all of us to discuss after all the gamuts of uveitis have been studied as of now. So she was a 58-year-old lady presented with a complaints of decreased vision in both eyes. On presentation, the visual acuity was 660 N18 in the right eye and 624 N10 in the left eye. A significant only past ocular history was she has underwent a cataract surgery in both eyes, and that too was 10 years back. Systemically, she was a hypertensive, on treatment, well controlled. So the ocular finding, the anterior segment in both eyes was almost near normal kind of, and with little bit of an pigment deposits on the surface, anterior surface of the IOL. Vitreous has 2+ cells, hairs, the disc was hyperemic, and there was old perivascular sheathing, and that too was in mid-periphery. Left eye was little mildly affected, vitreous haze was only 1+ kind of, and the rest of the findings were almost similar. She underwent a complete course of an systemic evaluation for a uveitis workup. Everything turned out to be within the range except the ESR was at 50. So patient was started with oral steroid, topical steroids were started, and was asked to come up after 2 weeks time. 2 weeks, the right eye has significantly responded. Visual acuity has improved to 6.9 N6. Left eye improved mildly only to 6.18 N10. Vitreous haze in both eyes has significantly reduced. Left eye did not improve because there was a macular edema kind of. As she has responded very well, I asked her to continue with the medicine and asked her to come up again after 2 weeks time. At 2 weeks, most of the findings remain similar. Visual acuity was same as a previous 6.9 N6 in the right eye and 6.18 in the left eye. Left eye there was a residual macular edema with foveal detachment. As steroids were getting tapered off and she was on 10 milligram of steroids, she was advised to undergo Ozudex in the left eye for the residual macular edema. Ozudex was performed and she was asked to come up after a month's time. At the 1 month, everything was perfectly fine. The left eye vision has restored back to the 6.9 N6, right eye was 6.9 N6. On OCT, though there were very mild few cystoid changes, patient was happy, I was happy. She was put on a Nepafinac eye drop for the right eye residual edema and was asked to come up after 6 weeks time. Instead of 6 weeks, patient presented within 2 weeks only with decrease in the vision in the right eye, and this time the decrease was quite significant, which fall down to the 1 meter vision. Left eye was maintaining a good vision. The cause for the decreased vision in the right eye was a significant increase in the vitreous haze. It was almost 3+, where the retina was barely visible, wherever left was doing quite fine. The only new thing which has come up in the last few days was some hard exudates started appearing at the macula. So this time, considering this is a too short recurrence, I started patient with on azathioprine, considering the rapid recurrence kind of, along with the steroids. After 3 weeks of starting of oral steroid and azathioprine, vision significantly improved in the right eye from 1 meter to 6.18 N10. Vitreous haze has significantly reduced. The kind of an hard exudates which we saw in the left eye has now came up in the right eye also, but vision was pretty good and OCT was absolutely normal. At her next visit, there was a persistent CME in the right eye, and because of which the vision did not improve in the right eye beyond 6.18, which was at last visit, and that's why the patient was given Ozudex in the right eye this time. And after the Ozudex at 1 month's time, again the vision improvement has happened to the normalcy at around 6.9 N6. Steroids were gradually tapered off and azathioprine was continued. The moment steroids were tapered off, within 2 weeks time, she had another recurrence. And this time I referred patient to the rheumatologist just to see if at all I am missing out something.
Rheumatologist again worked up on all the factors which can lead to this thing. Nothing came out to be very positive. Patient was started on tacrolimus kind of an along with the steroid, and the history got repeated. The moment we again stopped the steroid, in a short duration of time, she had a next recurrence. This time, rheumatologist along with azathioprine, tacrolimus has started with methotrexate with steroids. The moment steroid was stopped, the same thing got reoccurred kind of, and the vision has gone back to the decreased vision. That is right eye 636 N18, left eye where 612 N8. Vitreous is appeared, and besides all the usual finding we had at the last visit, there was a patch of an active lesion like a vasculitis patch or plus retinitis patch along the lower arcade. So this is how it looked like in the right eye. Macula had minimum amount of an macular edema kind of, and left eye was absolutely normal. There were few scattered hemorrhages in the mid periphery, and this got me suspicious ki this was not fitting into any particular thing kind of, and what we were suspecting till now. Montage photo showed some amount of an again the vasculitis changes in the right eye in the mid periphery. Left eye was absolutely normal. The peripheral parts were perfectly fine. She underwent FFA, and the FFA showed early disc staining with late disc staining. At the end of an FFA, there were few hyperfluorescence at the vasculitis spots. Rest of the areas were normal, and there was some amount of an diffuse pooling at the macula in both eyes. So what it is, we have scratched everything, and ultimately I referred patient to my alma mater. Dr. JB and Dr. Partho has seen the patient, and they said ki even most of the things were inconclusive, and why not to start the patient on the anti-toxo medications kind of. So we started patient with Ceptran DS along with the oral steroids, and after 3 weeks of the Ceptran DS completion of course, patient were on tapering doses of the steroid. The whole picture has reversed back. Visual acuity has come back to the 6/9 and 6. But I did not have a guts to stop the steroids now. So patient for last 3 months is continuing with 20 milligram of the steroid kind of. And so I don't know what exactly has worked, whether it was anti-toxoplasma medication or continuation of the oral steroid. My differential diagnosis in her case was toxoplasma, sarcoidosis, retinal vasculitis, whether it's a intermediate uveitis or a viral retinitis, not very conclusive. So maybe the expert panel can share something on this kind of thing. Thank you.
Does anybody wants to make a quick comment because we are running short of time?
Hello,
Can I ask something?
Yeah, please.
Yeah, how exactly? I mean, what's the duration for which you are giving those steroids? How rapidly are you tapering those steroids?
Weekly by 10 milligrams, so from 60 to 10, and maybe I mean some times when the complete resolution was not there, even the 10 was continued for 10 days and then 5 milligram for 10 days kind of.
Hello.
Patient really requires 3 immunosuppressive agents in simultaneously, then probably you could consider tapering the steroids a little slowly rather than 10 milligram every week. Second thing is, this looks more like a case of intermediate uveitis than frank vitritis. I mean, it is an intermediate uveitis case. And a publication by Foster's group from UK, I think although this was pediatric patients, intermediate uveitis, vitrectomy works actually pretty well in at least reducing the load of immunosuppressive agents. Instead of 3-drug immunosuppression, you might go away with, it might just give you 2-drug or 1-drug immunosuppression. And simultaneously, it might give you a vitreous biopsy specimen for, running further tests on it.
Yeah, so the last plan was same thing, that when the final recurrence happened, we were thinking about taking a vitreous biopsy. The only problem was like all the immunosuppressants were not able to control the inflammation, but the steroid alone was controlling it kind of. And so whenever steroid was given, the patient used to be absolutely quite kind of. And the moment we started to reduce, I mean to stop the steroid and maintain on immunosuppressant, recurrence used to be there again and again.
All right. Thank you, Yogesh, for that wonderful and interesting case. I once again like to thank the entire team for having this wonderful talks here. And thank you to Swapnesh and Ragini madam for giving us this opportunity. The next speakers are already here. I think we'll hand over the call to them.
Thank you very much for inviting me, and thank you. This was a wonderful session and very good presentations by everyone. Thank you so much.
Yeah, thanks everyone. Stay safe.
Hello, everyone. We now welcome you all to our next session after a enigmatic session on uvea. Coming to the next session, which is age-related macular degeneration. So I would like to invite and welcome Dr. Saurav Sinha, sir, as a chairman, Dr. Nitin Prabhu Desai, sir, Dr. Deepak Bhatt. Are you all here?
Yeah, Shrutika here, Nitin here.
Yeah, very good evening, sir.
Good evening.
So, first of all, let me thank Dr. Ragini madam and Dr. Swapnesh for having given me this opportunity to be a part of this wonderful conference. And let me congratulate the entire organizing team for conducting the conference so flawlessly and bang on time. So we're starting the session just 5 minutes past 5, and it's very impressive how the sessions are conducted absolutely on time. So without delaying much, we will move on forward to our sessions. As we all know, and most of you will agree, that age-related macular degeneration contributes to nowadays more significantly. Nowadays, it has started contributing to major chunk of our medical retina practice. One, probably it's with the age expectancy, which is going high, and number of visits, the regular visits these patients have to pay to a clinic, it has definitely overpassing the diabetic retinopathy cases also. So let us start our first talk by Dr. Saurav Sinha. Dr. Saurav Sinha is a prolific retina surgeon from Netralayam Eye Institute in Bengal, Calcutta, and he is part of many phase 3 clinical trials. I welcome Dr. Saurav Sinha, sir, and we have his presentation being seen here. Hello, Dr. Saurav Sinha, are you ready?
Yeah.
All right.
Right. Good to go. Visible and audible?
Yep.
Yeah. Nitin bhai, namaskar. Okay.
Namaskaram.
So, pachychoroid, is it for real, or what is pachychoroid? I think this talk was a little relevant around 2 years back when we all grappling with this new word. But yes, it is for real. It does exist. And why I say this is a little of few of us. I can see this, all of us. I remember when our PGs were dull FR. So somebody had dull FR likh diya. Then we little bit intelligent. We said RP alteration, a better word to write. And we started also writing granular RP. Nice words we are finding out to explain the same dull FR. Then we also said describe the type of alteration. Pigmentation like this. Then we said no, CSCR. Then by late 2000 something, 5, 3, 4, 5, 6, we started saying polyps. We started saying we can see on the other eye, sometimes imaginary, sometimes actual polyps. Then we said when ICG came along by 2010, 12, 15, we started getting more used to these things. These are hotspot and BVN. So these are words that have come along the last 20 years as I've gone in my practice. These words have come along. Now, what are these words? PPE, PNV, PCV, FCE, PPS. Now, I have my fellows sometimes using these words, futs, and I'm a little, what was that? I did that, passed me by. So we are used to having this OCT and FA. We've sort of mastered these two quite well. But mind you, the PPE, this pachychoroid pigment theory was published way back in 2013. That's really 8, 9 years back. So it's not a new thing that I'm discussing today or something which suddenly dropped into us. Pachy means thick. It's a thick choroid. I think this one definition says it all. It's describing the phenotype characterized attenuation of choriocapillaris. The choriocapillaris is attenuated with overlying dilated choroidal vessels. And and associated progressive RP or dysfunction and evasculation. So these 3-4 things happening: cortical attenuating, cortical is dilated, progressive RP or dysfunction. I think if you know these 4 words, I think you got to talk through. But only you have to have an ICGA to help understand this, where you'll see hyperpermeable and dilated choroidal vessels. And on OCT, you have to do a EDI and see the increased choroidal thickness of the choroidal scleral interface and see how the thickness is, how many microns it is. And once you go into there, you see whether it's focal or diffuse. These are the 4 things: the choroidal thickening, the dilated choroidal vessels for the pachyvessels, and pachychoroid pachyvessels from that, attenuation of the choroidal inner choroid and choroidal hyperpermeability. 300 microns is considered the thickness, and extrafocal thickness of 550 microns. Again, some articles vary from this. So this here is a focal thickness. I'll have more of photographs over here. So this is a focal, just single points over here, whereas this is a diffuse thickening of the layers over here. Now a pachyvessel, this here is a pachyvessel. I sometimes am not able to pick up these things. The more junior people are seeing these. Again, mind you, this is an OCT, this is an ICG. So sometimes one wonders what you have to see different modalities. And again, a vascular hyperpermeability over here is seen on an ICG. Now, if you see again, this is an OCT. These are again OCT-A. One must assume, one must be clear that when you make these diagnoses, you can see choroidal thickness and attenuation here on OCT-A. Now, again, these are different words that we've used over the years: CAC, PPE, PNV, PCV. I'll try and quickly go through these. So I have only one slide here, which I'll try to show all of them. In a CAC over here is what we always said. A pacular epithelopathy is something we see all the time. This is what we would have called long time back as a dull FR. A PNV seen more clearly here on the OCT angiography. Clinically, didn't see too much. We see here on the ICG on the OCTA. Again, a PCV seen better here on the OCTA over here. Focal choroid excavation seen definitely better on the OCT scans. And what is a pacular epithelopathy? Sorry. This here, what you see is what I was referring to as a dull FR. Now we stop using these things. And so you will see this the other anomaly of patients, the CSR. So it's called a form fracture of CSC. Normally don't need to do anything about these, but you must watch these very carefully. Development of CS for development of CNVMs. Routine, what we see regularly, a pacular neovasculopathy. Now here, definitely on a functional angiography here, and on ICG here, and what you see a double layer sign of it typically. So a PNV was something which was not described to us less than 5 years, 8 years back, but we know that these are patients who might do a little bit better depending on what the history is on injections. Now, right. Now, focal choroid excavation, again, these are entities one need to know, but one need not say this is a fluid over here and treat these. This is a non-conforming type, this is a conforming type. I'm not aware of these entities because this does not need a treatment for shear what's on the right over here. PPS, again, a thick choroidal thickening over here, large which you see an angiography over here, direct hyperpermeability, and what you go on to having a PNV. Now, what is the clinical significance of this? PNV is idiopathic, related to CSC, or you can have the RND CNV type. Again, type 1, type 2 types. The terminologies are changing continuously, and these patients will need anti-VEGFs, and sometimes some of them PDT, of course, are the rule right now. We don't know. We hope PDT will come back soon to us. This is something we're more familiar with. Large bleed, quite sometimes been there. When you see this over here, you have RP alteration, polyp thumb like PED. This is PCP for us. Now, there was a time, and there have been publications since then, that patients who in the 30s, 40s seem to have CSC have gone on to have PAD. All have these patients now, and PCV. PCV from PSC old patients, we have seen lots of these patients. This is PNV, something we are looking at right now for the last few years, more carefully with the better quality OCT, and the HRA OCT gives very, very clear pictures of this. Those of us looking at the OCT nowadays are seeing these better nowadays. These are like, I come back to my old slide, all 4 features, very important to understand: a pachychoroid, thickened choroid, focal or diffuse, a dilated choroid vessel, the pachyvessels, the attenuation, inner choroid, and choroidal hypermobility. These 4 features form the pachychoroid phenotype. And I mentioned those earlier. Again, these words, one need not mug them up, if you miss them up. If you miss them once in a while, doesn't matter. As long as you recognize them on your OCT angiography, OCT, ICGA, it's important that some of them do not need any treatment. So the take-home message, what I would like to give is, look for choroidal thickness. in the other eye, one eye has a disease, look for the thickness of the other eye, or if you're having problem with one eye, unexplained, the clinically you're not able to see too much, look for the thickness of these patients. CSC with no typical leak, maybe a slow growing PNV. Again, an osteoangiography in these patients is very, very useful. Sometimes osteoangiography is better than the ICG pictures. The PNV as a differential case of CNV, related to CSR, again, changing hypothesis at all times. And these are all three which will complement each other, the OCT, ICG, and OCT angiography. Thank you very much.
Thank you, Dr. Saurabh Sinha. May I ask a question here? Like, could you tell us some example where, diagnosing of pachychoroid really made a difference in the management process of a particular?
I would feel that today it's these 45-ish, 55-ish patients who are not supposed to have CSR, but have a CSR kind of a picture.
Right.
And they've been waiting for 3-4 months, which is not too bad, but it doesn't come back to 6-6 at all.
Right. Yes, we do see such scenarios.
So normal OCT just gives some fluid over there. These are the patients one should look for in the other eye. One should do an ICG angiography, one should do an OCT angiography, and some of them may do better with anti-VEGF in these patients. I think it's very important. These pachychoroids should be thought of in these patients specific.
Okay, so you would give importance. I mean, you would tilt the balance to treating these patients with anti-VEGF.
Rarely, yes.
Yes. All right, that's interesting. Let's move on to our next talk by Dr. Deepak Bhatt sir. We all are very used to seeing reports of Dr. Deepak Bhatt and how meticulously they are reported. And I think he must be the most popular ophthalmologist among most of the retina specialists and ophthalmologists in Maharashtra. So, sir, are you ready with your talk?
Yeah.
Yes.
Good evening, sir.
Hi. Swapnesh, I can see your tired look.
All Mumbaikars are very lucky to have you all. You should have one branch in Pune also, sir.
Hi, Nitin. Hi, Saurabh. Yeah.
Mumbai needs 3 branches.
Yeah. स्वप्नेश आज जाके सो जाना तू यार. तेरा चेहरा बहुत ही थका हुआ दिखता है.
I've been seeing sirs reports for the last 20 years, more than 20 years now.
Just out of curiosity, sir, do you conduct any short fellowship or short observership courses in ophthalmologic investigation?
Yeah, I am always available on phone. Yeah, there's no fellowship or anything like that. Anything, anywhere, I get OCTs and every day on my WhatsApp and all. So that keeps सबको मिल जाता है. Fellowship is done online for so long. Yeah.
On the go.
So one generation you have taught OCT. Now our generation you are teaching OCTA. So that is your legacy.
Okay. Anyway, let's
start.
Yeah. So he's told me about OCTA in AMD, and this is just going through cases. Okay, not any theory at all. I don't want to go into the theory of OCTA because everybody knows what's going on in the market for a very long period of time. So we have dry AMD and wet AMD. Okay, so dry, what is the role of OCTA? Frankly, not really much in terms of diagnosis, but most important is to rule out a subtle intermediate AMD with which of course is the new terminology which has come, but we still have not found out a clinical significance for that. Well, this is dry AMD. What do we see on OCTA? Well, choriocapillary atrophy and atrophy of the inner and the outer choroidal layers, which of course part of the atrophic process. But the most important role is to rule out a presence of or absence of a CNVM if you have a doubt on OCT. But OCT takes the chunk of the matter, is probably not required. Geographic atrophy, again, as I told you, there could be some areas where some amount of neovascularization is suspected. You do an OCTA, otherwise, frankly, OCTA is of no use. It's a clinical diagnosis and probably an OCT suffices at all. Again, a case of geographical atrophy. Now, this actually slide, I picked it up from Koskus's article, which was written 7-8 years back when OCTA had just come. But it's still the absolute gold standard to differentiate between active and quiescent lesion. And that's probably one of the reasons why we would do an OCTA in the first place for in a case of CNVM. Okay, so we have this case where there is a known CNVM, no CME, and no subretinal fluid. Is this active or not active? If you go by the criteria of Koskus, as I told you, amongst all the criteria, a dead tree appearance, if you remember that, dead tree appearance with no branches and no communications, peripheral anastomosis, is the hallmark to say that this is a quiescent lesion and this does not require any treatment. A case of, again, a patient who's received, this is what I get actually majority of times. 7-8 anti-VEGFs given, patient vision not improving, and suddenly come back, kuch to bhi karo, kuch to bhi karo. Then they say ki chalo OCTA karke dekhte hain, whether there is activity there or not there. This looks like a scar absolutely on an OCT. If you look at the OCTA, it is again a dead tree appearance. There are no peripheral communications at all. So this is a quiescent lesion, even if your anti-VEGF is not going to help. Because you might put it inside and patient might have a lot of expectations from whether should we do it or not. And FFA is not going to be helpful in this particular case. As opposed to that, what is the criteria of an active lesion? Again, this is an active lesion on OCT itself. Do we really require an OCTA? Well, more of confirmation and less of knowing what is going on further around that. So again, as I told, it's an active lesion is going to have peripheral anastomosis. This is the hallmark of an active lesion, and around the CNVM, we will see a sort of a clear area, which is like hypointense an area, and that is suggestive of an edema around the lesion. So this is an active lesion. Okay. Again, a case where, here we would have called it whether query active, query not on OCTA, and this patient, of course, has received more than 10 anti-VEGFs. But his vision still is decreasing, whether these are actually degenerative cystoid spaces or actually it is cystoid macular edema, I would not know. Look at this peripheral anastomosis all going around here. A large CNVM with peripheral anastomosis, I would definitely call this an active, and he would respond, and of course to a certain extent. Coming to another type of an active lesion, this is definitely an active lesion with subretinal fluid. Okay, we saw this peripheral anastomosis again, and this fluid actually is one of the very big hallmark of CNVM, because this fluid is the first thing to go away when we follow up these patients, especially if we do the OCTA within 3 weeks, not after 1 month. Then you see the first fluid going up, and patients' visual acuity is actually directly related to the fluid around the CNVM. Now I want to show you a case of follow-up, a case of active CNVM, which again shows classical anastomosis here and an active lesion fluid. So I had a patient who had was quiescent for a very long period of time, and he developed some amount of fluid, recent increase in fluid. Visual acuity showed very minimal changes, but not much really. And therefore, we went and did an OCTA. Again, look at this OCTA at the choriocapillaries and the inner choroidal layer. This is classic dead tree appearance. It's how you would see in a forest area, classical dead tree appearance, no anastomosis, absolutely like that. So now the question is whether that fluid was really needs to be treated or not needs to be treated. Point of debate, I don't want to go inside, but this is definitely not going to respond to anti-VEGF. Myopic CNVM, actually, I have found that the OCTA is absolutely fantastic in myopic CNVM, especially when you see choriocapillary atrophy on an FFA, and FFA will not be able to diagnose. Active CNVM, I want to show how the follow-up takes place. This is pre and this is post. See the amount of peripheral anastomosis which reduces here after treatment. So it is a very easy way to follow up, these patients here. Again, you see go down deep, you'll see that the activity has come down, the capillaries have come down. And the same patient here. Okay, this is a case of follow-up. I would a pre and post on OCTA. Okay, I'll show you the most important. This was the case of scar, and in the scar, we would like to see that this is really a CNVM or not. Though this all looks like an active CNVM, but this is more often choriocapillary layer. Therefore, I think segmentation is extremely important. So the person needs to sit in front of the OCTA to be sure what is going on. You don't have time for all this actually. Old CNVM, and I'm going to see about follow-up once again. I think yes, PD and one thing. I'll just show you one. RAP lesion. Yeah. So this is the case of RAP, classic cystoid spaces, and we see a track going from the inner retina down to the outside. And you look at the OCTA, this is a section in the superficial plexus, this is a section in the deep plexus, and this is a section of the choriocapillary layers. You would see that the CNVM starts here, goes deep down into the choriocapillary layer. And the most important is to see the video. If we follow the video, this will be going along the track here. This is the CNVM in the superficial plexus. Then we have the going down into the deep plexus, and we see the anastomosis in the choriocapillary layer with a fluid around that. So RAP is something that I have found out to be an extremely diagnostic and can trace us at what extent it is on OCTA. Actually, because of paucity of time, I have not included a PCV, because a PCV in OCTA is a big debate by itself, whether you see polyps or you don't see polyps. Some see, some don't see. So let's not go into that. So finally, OCTA is a tool which can be used non-invasively. Patient is compliant about it, very easily done. And at follow-up, it gives us a fantastic idea whether we should go ahead with the treatment or not. But still a point of debate for all that. Thank you very much.
Thank you very much, sir.
Yeah.
We were pleased to go through all variety of images that you had to show. So I have one question for you.
Yeah.
Like, if you have to name one category of AMD disease where OCTA definitely has an edge above the normal OCT, spectral domain OCT, what would it be?
Myopic CNVM is something in the last 3-4 months is somewhere where clinically also not suspected OCTA has picked up small myopic CNVMs. And you know how difficult it is sometimes when you have myopias of 20-25 diopters and more than that. And is another thing that I came across is this RAP, which is useful. PCV at type 2 CNVM is something which can be done with OCT itself, maybe 99 or 95% of times. Type 1 CNVM, yes. With the newer OCTs, newer OCTs which are coming up, I have these the spectral domain. We are going to be doing more of type 1 CNVM. PCV plus minus. Yeah, Saurabh. Hi.
Yes. Hi. No, I was exactly going to ask that in the I'll put the question that they were around.
Yeah.
Any patient who has come to an OCTA and you are inconclusive about it and you have set up ICG Karao.
So of course for PCV you are asking specifically, right?
Anything, any condition. Like I agree with you that myopic things even I have learned the last 2 years after hearing you all speak.
Yeah. So I have told
it's a fantastic post Karana. I was not doing that earlier, but So any patient, sorry. Go ahead. Go ahead.
PCV is something more than 50% of times I would still say, because I have a branching vascular network, BVN. Yes, I have picked up in more cases than what I thought it was possible. But polyps is like, oh, there, not there. Imagination, too much of imagination and too much of yes no going on there. But I would definitely, but BVN sometimes is seen very well. So if you have a classic picture on OCT of a PCV and you see BVN, I don't know whether we should really ask them for to do ICG in probably, in Bombay there are only very few centers who do that. So that is one thing which is not done so much in Bombay. But yes, that is there. But otherwise, other cases, not really. I would never ask for OCT. Type 2, type 1, and other things. Type 1I is one thing that I'm looking for in the Swepsos technology, which is still in the phase of development. So if we can really pick that, whether type 1 and PCV we can differentiate on OCTA is something which will come in the due course of time, because there's a lot of overlap between the two of them. Yeah, thanks.
All right.
Yeah.
Thank you very much.
Yeah.
For
Yeah.
the
Hi.
knowledge.
Shrutika, I might have to leave just now because there's some family function waiting at home. So
all right, sir.
Yeah.
Thank you.
Thank you. Bye, Saurabh. Bye, Nitin. Bye.
Okay. So moving on to next speaker, Dr. Dipti Kulkarni. Dr. Dipti Kulkarni practices at Mirrors at Dr. Anil Kulkarni Eye Hospital as a VR surgeon for the past 6 years. She has done fellowship at Regina Institute of Karnataka, Bangalore, and she'll be showing us interesting cases of wet AMD. Yes.
Thank you, Dr. Shrutika. I think I'm going to be cheating just a little bit. Dr. Swapnesh asked me to present interesting cases in wet AMD, but while I was perusing through my cases, I realized there are a few perspectives I want, some pearls from the seniors from. So I saw the names, Dr. Saurabh was there, Dr. Nitin Prabhudesai was there, Deepak Bhatt sir was there. I think even Bhavan Kule sir has joined the discussion now. Swapnesh is obviously there. So I want to know your take on these topics. Just a couple of cases. This is the first case, 73-year-old gentleman. He's a diabetic, well-controlled sugars. He had left eye blurring since a couple of years. He said it had been increasing over the last 2 years. And since 2 months, he had some difficulty in reading. And when he had a metamorphopsia, which he noticed while reading a newspaper, that's when he came to us. So this is okay. OCT is fine. All that is okay. But to do an FA or ICG in this case with such kind of an asteroids, I didn't know if we are going to get enough information, to add something to this. So anyway, we went ahead. What we have is a 10, 12-year-old Optoview on which I did this on-fast image. And we went ahead with the treatment. Initially, he took one Accentrix because he was not sure about brolucizumab. So we had to tell him what it is, and then eventually got convinced. We gave him one brolucizumab. He's doing well. Vision is stabilized now for the past almost 8-9 months, 6-9 parts. Reading also is fairly okay. He's happy. But what I wanted to know was, is there any role or are there any markers on this on-fast imaging that could help or that can correlate with an FA or ICG? I'll show you further cases also. In this case, is there any role for vitrectomy, since these are such dense asteroid hyalosis? So he wants me to get rid of them. Whenever he sees the photo, he says, I don't want these yellow spots. Then if at all we do a vitrectomy, how is it going to change the dynamic for the anti-VEGF? So we'll come back to this question after the presentation. This is the second case. He was a 78-year-old gentleman again. He had a very dense cataract, counting fingers 3 meters was his vision. He had some previous episode of allergy to some dye when he underwent some heart surgery. So we didn't do an FFA in him. Again, we could do an on-fast imaging on the OCT. We treated him. He's doing okay. Vision is slightly improved. There's that large scar which keeps recurring on and off. And but my discussion again here is about how can we correlate these lesions? Can they be correlated on something? So I did go through some literature where things are being correlated between an on-fast image and an FA or an OCT angiography. There are a lot of studies about CSR and diabetic macular edemas, but nothing is being mentioned per se for wet AMDs or for that matter, even dry AMDs. There are autofluorescence studies, but nothing about on-fast, which is so readily available. And there are a few studies where they show that even in this previous one, where we can see that this hyperreflective dots correlate with the leaky lesions on the FA. But this, of course, is applicable to DME, not applicable to AMD. So there was nothing much that could help me gauge what is happening in AMD. Again, whatever I came across, these are the hyperreflective areas that they've asked us to watch out for when we are treating an AMD, and watch how they resolve or whether they increase. So most of the times the fluid is lying above these dots, hyperreflective dots, and that's what needs to be watched out for. This is another case again. Okay, so this was a 59-year-old gentleman who came with a recent onset decrease or metamorphosis actually. He's a banker by profession, so he had complaints by looking at the computer. I presume they must have had some previous episodes, but he has not realized this. So in this case, I wanted to do an FA. He was willing, but somehow my the filter on the FA was not working. So this time necessity was the godmother of my discovery here, where again we did an fuss and tried to correlate with what was happening. In this case, the more interesting point that I want to point out is he came back within 3 or 4 days, and within 3 or 4 days of giving an anti-VEGF, he chose Accentrix, but within 3 or 4 days of giving an anti-VEGF, there was total resolution of most of the SRF was gone. He was subjectively very happy, vision had improved, he was able to read and start working. And going on these lines, this is of course a second scenario that I want to discuss about. Going on these lines, there was another gentleman who received, for a straightforward case, he received an injection, and this was just day 1 post-op. Actually, not even 24 hours. He received an injection on 30th August in the evening, and on 31st August, when he came back in the afternoon, the SRF was almost resolved. His vision was better slightly, but he had no subjective improvement. So my questions to the elite panel today here are: what are the earliest changes that we can see on OCT? Is there any correlation between an on-fast, and how do we know when it is going to translate to vision improvement? And what I observed was in both these cases, PVD was fully present. Even we could see the Weissring on ophthalmoscopy also. So is there any role of PVD in the speed of SRF resolution? Sorry for the typo. Is there any role of PVD in the speed of SRF resolution? Thank you. So can I have Saurav sir's opinion or Nitin Prabhudesai sir's opinion on this?
Okay, regarding that asteroid case.
Yes, sir. This one.
Usually as a practice with the asteroid, as it's a standard teaching that FFA works quite well even in the presence of asteroid.
Yes,
so unless this patient had some problem, I think we couldn't do an FA. But FFA always would be a preferred preferred investigation if you have dense asteroid, at least at the baseline. Because nowadays for AMDs we don't keep repeating the FA. We just do it once in the beginning if there is any doubt. If there is no doubt and if OCT quality is good, we really don't need FFA nowadays in most of the cases. But yes, this is one indication where I would definitely consider doing an FFA to confirm the diagnosis and even at times for follow-ups, because clinically it is difficult to judge the lesion whether it's getting better or not.
Yes, sir.
Yeah, and definitely considering only for removing the dots, that's not a very good idea for vitrectomy, because
I agree. Vision was 6/9 part N10.
Yes, sir.
What will you achieve? Like Dilan sir said, no vitrectomy for that.
Yes, sir.
Vitrectomy karoge, anti-VEGF will not stay for a long time.
Yes, sir, exactly. That's how I'm supporting my decision of not doing vitrectomy.
And over the years, over last 30 years, we have seen that with dense asteroid also, patient surprisingly has almost 6/6 and 6 vision, many a times.
And this
conversely, when you advise them vitrectomy, and you think you're doing a great job inducing PVD in these patients is very difficult.
Yes.
You will actually end up not improving the vision too much because they'll have some pathology over there which you could not see possibly. That's what normally happens. So no vitrectomy for me in most cases.
So the on-fast imaging, do you have any thing to share about how to correlate this with the lesions or anything, sir?
Frankly, we don't use on-fast imaging so much, though there is literature. And again, recently it's been mentioned that for PCV also, if you watch those lesions, on-fast would give an indication. But no, there is no single specific point which we really rely on on-fast to. We use it in combination with other things. Like you do a B-scan OCT, you do an OCT A, and you do see that in on-fast, and probably just try to correlate. But no the total dependence on on-fast.
Yes,
that's from my side.
In the absence of OCT, on-fast imaging will not give much information.
Right.
That's
right.
Okay. So, and this about the time of resolution of fluid that I was asking, sir.
Regarding with PVD, yes. See, nowadays because of brolucizumab, now people, because they initially were scared, and so there are reports of brolucizumab acting within hours, as you said, in 24 hours. So these things are reported, but unfortunately for all anti-VEGFs, we rarely do OCTs
Exactly,
so
sir.
frequently. So
Yes,
we
sir.
really
Yes,
don't
sir.
know. We have to do a sort of study to really see, compare
Yes, sir.
between the anti-VEGFs. So I think patient to patient it differs. Yes, PVD, most of the situations, PVD would help in resolution, but
Yes.
I don't know whether it will resolve so fast. Maybe, see, there is a point that giving your injection in the eye also, the people have shown that just giving
That
air in the
PVD
eye
gets
would
induced.
cause
Yes.
PVD. Yeah.
Yes,
So
sir.
we don't know whether the giving the injection, that act itself has induced the PVD.
Yeah, I'm not of the opinion. I don't think PVD is anything in the study results. No.
No, no, sir.
I'm someone who
I'm speaking of PVD in these two patients was already pre-existing, not just with relation to the injection per se, but does a patient having PVD, is he more likely to have a quicker resolution, or there's no relation between PVD
I
and
don't think there's any correlation, because you're not talking about only a tractional component. This discussion would come up. An addition, I'm not convinced about it.
Yes, sir. Thank you, sir.
All right, that was a great discussion. Moving on to our next speaker, Dr. Sachin Kabra. Sir, we all know Dr. Sachin Kabra. He has done his, he's a popular retina surgeon in Pune. He has done his post-graduation and super specialization in retina from Shankar Nethralaya, where he was also awarded the best outgoing fellow. And he has 12 peer-reviewed publications to his name. So I hand over to Dr. Sachin Kabra. He will be presenting about OCT biomarkers.
Yeah.
In
Am I visible, audible?
Yes.
Yeah. Thank you, Shrutika. Thank you, team members, for this opportunity. Nice to see my teacher, Saurav sir. Hi, sir. Let's start. Well, I don't have any financial disclosure to make, and I'll be using the trade name just for the ease of communication. And the communication is going to be clinically oriented. We all know OCT has moved from the time domain to now swept-sort OCT, where we can see the majority of all layers of retina in a very beautiful way. Even the choroid can be imaged quite nicely. Practically what we are getting is a histopath section of the retina in optical format. So OCT has become a very important tool in our day-to-day practice. Now, what do we mean by OCT biomarker? Well, biomarker in medicine is actually a measurable indicator of the severity or presence of some disease. So when you use the word OCT biomarker, just mention some finding on OCT, which will indicate a severity or presence of some disease. Today, we're going to discuss about OCT biomarkers in AMD. Now, let's start with dry RMD first. All of us are aware of this various stages of dry RMD patient comes to us. There are some early drusen, then there are moderate drusens, and ultimately the patient either lands into geographic atrophy when nothing much to offer except low vision aids, or a patient lands into CNVM when obviously injection becomes the drug of choice. Now the clinical scenario is not that easy always. Let's assume a patient comes in these two stages. When patient early AMD or intermediate AMD, can we prognosticate? Can we say that which of this patient will end up in geographic atrophy? Which patient has a more risk? Well, the answer is yes, because the OCT comes for help here also. There's a specific OCT biomarkers for this, which is known as RORA, RPE and outer retinal atrophy, RORA, RORA. Let's see what exactly it is. As the name itself suggests, the RPE is atrophic. The overlying photoreceptors are damaged. So the signal which is coming from vitreous, it gets hyper-transmitted in the choroid. Basically, it indicates that RPE damage and photoreceptor is damaged. If the size is less than 250 microns, we call this incomplete RORA. If it is more than 250 microns, we call it complete RORA. It's a very important biomarker that RPE is getting damaged, photoreceptor getting damaged. And more importantly, if any of this early AMD patient has signs of RORA, they have very high risk of progression to geographic atrophy. So next time patient comes with this early and intermediate stage of AMD or dry AMD, and you do an OCT, you pick up this RORA. When the RPE is damaged, the photoreceptor damage, and the signal hypertransmission happening in the choroid, always be careful that this patient has a very high risk of landing into geographic atrophy. And that was about dry RMD. What about wet RMD? Again, the patient is coming in this stage. Can I predict of which of this patient going to land up with a CNVM at this stage itself? Well, the answer is again yes. OCT comes to help here also. If you do an OCT with dry RMD patient, which is drusenioid PD, but the RP is migrating into the inner retina, you get a hyperreflective foci in the inner retina. That means the RB defense is breached, and very high chance that this patient may end up in wet RMD. Another new term is known as non-exudative macular neovascularization. As the name itself suggests, neovascularization already there, CNM is already there, but it's non-exudative. The fluid is not coming out in the retina. The RP is strongly holding the fort, not allowing this fluid to come into the retina, which leads to irregular RP elevation, which is known as Sayre sign. And if this patient has a 15 times more likely to develop AMD, neovascular AMD. Now let's go to the wet ARMD. Wet ARMD, as the previous speaker was discussing, the same scenario, even I can day-to-day practice. I have 4 very common questions. Am I dealing with wet AMD or PCV? Will my patient vision improve? Is the patient non-responder? Should I change to some other injection? And when I should stop injecting? It's a common question I come in day-to-day practice. Let's try to resolve it by the OCT. Let's start with the first one. Am I dealing with wet AMD or PCV? As Sarosina has already mentioned, the classical findings on OCT on PCVs that either you have sharp PD or thumb-shaped PD with hyperreflective spots on the inner area of the PD, which indicates the polyp sitting here. And the branching vascular pattern spreads along in between, splitting the RP and the Brooks membrane from each other, leading to a double layer sign. The top layer is RP, the ground layer is Brooks membrane. Very hallmark of PCV. And the relative is now the OCT angio also, we can pick up PCV with OCT itself. Why it is important? The line of treatment is different, the prognostic will be different. Coming to the second question, the previous speaker was asking, will vision improve? Very, very important question. Patients spending so much money, so much injection they're taking, will the vision improve? Can I have prosthetic state? Yes. What we look for is known as, we look for a fluid. In a CNVM patient, a wet ARMD patient, the fluid can be intraretinal, it can be subretinal, it can be sub-RP. Now, what is important of all these levels? Let's see. Now, there is strong evidence that the intraretinal fluid, intraretinal cyst, is often associated with poor prognosis, the poor baseline visual acuity and very poor improvement after intravitreal injection. And more importantly, the fluid persists despite doing multiple injection. He has a very high risk of fibrous RP atrophy. So in clinical scenario, if you have intraretinal cyst, it's a negative prognostic biomarker. On the other hand, if you have subretinal fluid, it is associated, the fluid is not in the retina, it is a subretinal space. It is often associated with good visual acuity to start with, and it does improve the injection. And this leads to low rates of atrophy. A lot of studies have come up, there's always this mention that there's a protective role, kind of it protects the overlying photoreceptors from the damaged RP. We're going some neuroprotective factors. So it can be tolerated, but however, this is a very highly controversial topic. Some people go for it. Personally, I go for aggressive for resolution of SRF. But on clinical point of view, SRF is always a positive prognostic biomarker as far as wet AMD is concerned. Sub-RP fluid doesn't have much role as far as the clinical practice is concerned, but if it's associated with intraretinal fluid or subretinal fluid, it indicates this patient is going to require more treatment. So number of injections will be more. But however, on a clinical point of view, it is inconsistent prognostic biomarker. Photoreceptor layer integrity. Obviously, the second white line from the bottom, the photoreceptors are intact, vision is going to remain good. The photoreceptors are damaged, obviously vision is not going to remain good. Nowadays, a lot of stress has been put in the third white line from the bottom, which is on an external limiting membrane. If that is intact, usually patient has a better visual acuity. Shrimp or something known as subretinal hyperreflective material. The material is hyperreflective in the subretinal space. It is made of fluid fibrine or blood or scar. It is associated with very bad vision, irrespective where it is present and how big it is. If it is bigger, it is worse. But decreasing hyperreflectivity and subsequent follow-ups indicates a better prognosis with shrimp. So summarizing, wet ARMD vision is concerned, if you have SRF, you have reasonably good prognosis. If you have intraretinal fluid or a subretinal fluid or a PD with a shrimp, usually have bad prognosis. Next question, is it a non-responder? Shall I change my treatment? Obviously, the internal fluid is not going, vision not improving, we have to think. But is there something specific nowadays? Yes. There's something known as high reflective dots, as the previous speaker also mentioned. Now, I have HRFs or HRTs in primary retinopathy. Now, they are documented in wet ARMD also. They indicate the hyperreflective or the activated RP cells and a lipid microglia. And basically, if you see the HRD and you inject once and disappear on the first visit, it's a very good responder. And they persist after 2 or 3 injections. Usually need to change the injection because this indicates that this RP is still hyperactive and this injection not going to work. Last question, when should I stop injecting? Obviously, when the scar is already there, usually, but there is one specific findings on OC known as outer retinal tubulation. Basic name itself says tubulation, so it's a hyperreflective center, like a tubule, surrounded by uniform hyperreflectivity all around it. And it's outer retina, so it's outer retinal tubulation. It indicates the advanced RP disease, retinal disease, when all the tissues are coming together, supporting each other, trying somehow to survive. Now it is important, this can mimic a fluid and many people keep on injecting on this, but we have to differentiate the intraretinal cyst or the inner retina, while outer retina, as named is outer retina. The borders are uniformly hyperreflective. Here the borders are not uniformly, the shape is a round, here shape is more of ovoid. This is how do we differentiate the intraretinal cyst from outer retinal tubulation. Again, differentiate from exudative cyst is that there are gaps in between. There's no uniformity, where aorta is a uniformly hyperreflective border. To summarize my talk, if AMD patient, early AMD, intermediate AMD, you do an OCT, you pick up an RORA on the OCT, very high chance this patient will end up in geographic atrophy. Is wet RMD or PCB, pick up a specific sign, double layer sign, which will improve. SRF has a good prognosis, intraretinal fluid has a bad prognosis. Is it a non-responder? Wish for the intraretinal fluid persistent? Look for her reflective spot where dissolving or not. When to stop injecting? The scar is already there. And if you're putting outer retinal tubulation without much fluid, better to stop these injections. Summarize, this is what it is. In a wet RMD, subretinal fluid good prognosis, intraretinal fluid bad prognosis, shrimp bad prognosis. Well, no one has become poor from giving. And I thank you for giving the time. Thank you.
Thank you very much, Dr. Sachin Kabra. As usual, it's amazing how you simplify any topic so systematically. We move on to our next speaker, Dr. Shruti Narnavare. She is a retina surgeon at Sarakshi Eye Hospital, Nagpur. She has more than 30 publications in national and international journals. She's also reviewer of European Journal of Ophthalmology, IJO, Pediatric Journal, Therapeutic Advances in Ophthalmology. Yes, we can go ahead with the talk.
Yes, is my screen visible?
Yes. Yes, Dr. Shruti.
Thank you. Good evening, everyone. So thank you, Scientific Committee MOS, for giving me this opportunity. So PCV lesions per se are fragile and tend to bleed easily, and the incidence of breakthrough bleed into the vitreous varies from 4.5 to almost 20%. Here I am presenting bouquet of such cases. So case 1, she is a 70 years female presented with vision decreased to 6/9 since last 7 days. Fundus and OCT showed large serous PED. FFA showed leakage and hyperfluorescence. Patient received 3 doses of injection of aflibercept. 4 weeks after the last loading dose, vision was 6/9 paths with restoration of normal retinal architecture. But 7 weeks later, her vision dropped down to 6/36 with reappearance of taller PED. On repeat FFA, leakage was seen and ICG showed polyp. Patient was proposed and underwent PDT with injection anti-VEGF. At 1 month and 2 months, patient received 2 more doses of aflibercept. After 3 months, injection interval was increased to 8 weeks. Patient received 4th and 5th doses of aflibercept. But 6 weeks later, she presented with floaters since 2 days duration because of mild central vitreous hemorrhage. Patient was further injected with aflibercept. Patient received 2 more doses of injection of aflibercept at monthly interval, and this is 3 months and 5 months later that the patient had healed lesions with dry macula. Coming to case 2, she is a 50 years old female, systemically stable, presented with distortion of vision since 6 days. Fundus at presentation showed a tubular vesicle-like swelling encroaching upon the macula. OCT showed double hump serous PED. FFA revealed blocked choroidal fluorescence. ICG was not contributory, so the patient was advised observation. 3 days later, she presented with sudden decrease in vision to 2/62. Fundus showed massive subretinal hemorrhage over the posterior pole. OCT showed multiple large thumb-shaped PEDs. Patient was given biosimilar ranibizumab on the same day. 8 days later, she presented with total loss of vision, and there was total dispersed vitreous hemorrhage. B-scan showed low reflective opacities with corresponding lesion at the macula. Routine conservative management was advised for vitreous hemorrhage. Patient directly presented to us 6 weeks later. She had meanwhile sought the second opinion at higher center, where also she was advised to continue the same treatment. B-scan and fundus was almost as before, and the second dose of injection anti-VEGF was given. A month later, fundus and B-scan showed increased vitreous hemorrhage, but on B-scan, lesion size was minimally decreased. At this moment, patient was proposed vitrectomy. So patient underwent anterior vitrectomy and core vitrectomy was done. And one can see subretinal bleed, exudates, and the hemorrhagic PD, and therefore anti-VEGF was injected at the end of the surgery. So these are the post-op pictures at day 1, week 1, and week 3. First month after the surgery, second month after the surgery, third and fourth, she received monthly dosing of injections anti-VEGF. And this is 5 months after the surgery, 9 months, 1 year, and 1.5 years later, she is maintaining her vision. And this is the timeline for this patient. Now, 85 years old female, systemically stable, presented with vision of hand movements with total vitreous hemorrhage. B scan revealed vitreous opacities with dome-shaped lesion at the posterior pole. So our diagnosis was CNVM with breakthrough bleed. Patient was proposed vitrectomy with anti-VEGF. In this video, we can see the chicken fat hemorrhage. After removing the chicken fat hemorrhage, we can see the large subretinal black hemorrhage extending almost up to the equator. FAX was done in this case, and anti-VEGF was injected at the end of the surgery. And the post-op positioning was advised in this case. Patient further received 2 more doses of anti-VEGF. At the end, she had vision of 1/60 with the healed lesions. And this vision and the disease-free interval she is maintaining at 5 years also. Now coming to the last case, this gentleman had received 7 anti-VEGFs elsewhere for CNVM, and he presented with sudden decrease in the vision to 4/60. And this is the fundus picture. OCT showed large central scar with fluid with large PED parafoveally. FFA showed activity, and the patient received 3 loading doses of anti-VEGF, and his vision stabilized to 6/36. But 6 months later, he again presented with reduced vision to hand movements because of the vitreous hemorrhage. B scan showed large convex mounds suggestive of hemorrhagic kissing choroidals. Of massive choroidals, he was advised observation. 2 weeks later, we could see that there is bit reduction in the mound's height. Further observation was advised. 5 weeks later, mounds reduced further, and he was proposed vitrectomy for the same thing. So after removing the fresh vitreous hemorrhage in this case, we could see the CNVM lesion with exudates, hemorrhage, and with peripheral mounds. At 1 month, he had vision of 1/60, and he received 2 more doses of anti-VEGFs. And after 3 months, he had healed lesions throughout with the vision of 6/36. So to conclude, the prevalence of PCV is around 22 to 62%, while 63% of cases may have peripheral PCV. The clinical picture in these cases, they frequently present with pigment epithelium detachment with temporal equatorial location. They can be more hemorrhagic and exudatives. Lesions with breakthrough bleed, if we have breakthrough bleeding, mild to moderate vitreous hemorrhage, they can be managed with anti-VEGF alone. But in cases of non-resolving vitreous hemorrhage or severe vitreous hemorrhage, at presentation, vitrectomy with anti-VEGF should be advised. And yes, we need to remember that even after the vitrectomy, we should continue anti-VEGF treatment at monthly interval till all the lesions heal. Thank you.
Thank you very much, Dr. Shilpi. I think the cases were wonderful and managed very, very efficiently. Do we have some comments from the experts?
Shilpi, one question, like it seems that your patients benefit quite well even after vitrectomy with anti-VEGF injections, because there is always a debate whether to give anti-VEGF injection in a vitrectomized eye, and probably steroids are like something like Ozurdex is a little better. But I think your experience shows that even with the vitrectomy, they work quite well.
So Ozurdex in cases of PCV?
No. In general, I'm asking, like, because you have been using them quite frequently. I've seen in both the cases you gave almost 3
Yes.
injections post vitrectomy.
Yes,
So
sir.
they seem to be working well, because there are few studies only which say that it does work equally well, whether it's a vitrectomized eye or a non-vitrectomized eye. But I think your experience shows that they work quite well. So would you recommend giving anti-VEGFs in a vitrectomized also?
Yes,
Vitrectomized
sir.
eye also?
Yes, sir. So we routinely also, in other cases also, if that is a vitrectomized eye and they are presented with us, we inject.
And your experience is that they do
Yes,
well.
experience is good.
Do they take a longer time for resolution, or it's almost the same as in a non-vitrectomized?
Almost the same.
Saurav, what is your experience? You experience the same thing? You give anti-VEGFs in vitrectomized eye?
So I'm sure all of us have a lesser number of these. Definitely, I tend to think more what you are saying. Smaller lesions, lesser amount of heme, possibly they will need the injections don't stay for a long time over there, so they need more injections. But I have one more point of view. One of the first cases that she showed, Dr. Shilpi, it was a fresh heme which she said going up to the equator, and there was submacular large amount of heme. And if you've gone inside that and you can done a vitrectomy, these are good cases for putting in TPA, subretinal TPA, and you should be prepared for that. And just doing a vitrectomy and giving anti-VEGF, fine, I'm okay with that. There's nothing wrong with that. But if you're inside there, be prepared to have a TPA, sometimes drain the subretinal blood, create a retinotomy. I think all of us are getting better at these things, and a lot of our colleagues have shown good results with this. I think it's time to get this. Unlike the last case, we showed some yellow patches here and there. There, I would say, don't do anything subretinal, do vitrectomy, inject and come out. Don't do any heroics over there. But I think in that one case, heroics could have been tried because he was so huge. Yes. No way anti-VEGF will take care of that. And that is a patient with anti-VEGF, like what Nitin is trying to hint a little bit. So much of heme, anti-VEGF may not work well in vitrectomizing those eyes. So I think different situation, different treatments. That's all.
Sir, I think even after vitrectomy, if we just don't want to clear the vitreous hemorrhage or the hemorrhage, we want to treat the lesion. So even after vitrectomy, we need to inject, because
of course, I agree with the whole lot. No doubt about it.
Yes.
There is no discussion of not injecting. The discussion here is how effective is it?
Yes,
No.
Yes.
The take-home message is you have to inject. There is no question on injecting. There is no question of that. Must inject. The only discussion is that how long will it take? How many more will it take? That's all.
All right. Thank you very much for being a part of this entire presentation on age-related macular degeneration. Dr. Swapnish, do you want to say something?
No, thank you very much. And it was a very well conducted session, Dr. Shrutika. Thank you all the expert panels and very nice cases. And it has been a very fruitful day. The Retina Hall was very well attended. And even in this pandemic of webinars, MOS has crossed about 2,000 to 2,300 delegates registering as well as attending in large numbers. So have a great evening. And I'm sure everybody is waiting for the evening match. So signing off, and thank you all, and do join for the next weekend.
Thank you. Bye-bye.
Thank you.
Thank you, everybody.
Bye, everyone.
Thank you. Bye.
Bye-bye.
Thank you, sir.
हॅलो गीतांजली मॅडम.
हॅलो दर्शना.
6:30 ला शार्प सुरू करून टाकायचं ना.
हो हो शार्प 6:30 किती ऑडियन्स असू दे 6:30 विल स्टार्ट. ओके.
तोपर्यंत फोन करू का एकदा परीक्षित सरांना, डॉक्टर शिरीष आणि यांना. म्हणजे थोडस म्हणजे ते जॉईन झाले ना तर सुरू करायला बरं वाटेल आपल्याला.
हो 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 त्यांना 6:25 लाच सांगू जॉईन व्हा.
हो
रागिणी मॅडम. हा त्यांना सगळ्यांना.
मग मी त्यांना असं सांगते की 6:15 पर्यंत तुम्ही जॉईन व्हा म्हणजे आपण 6:30 ला शार्प सुरू करू. मी टाकते आणि एक आमचं एक सरप्राईज 1 मिनिटाचं माझं आणि पंकजचं एक मध्ये आपण समीर दातार सरांचं झालं की करून टाकू है ना. चालेल. ओके सरप्राईज.
हो हो चालेल
चालेल मी सांगेन तेव्हा याला आय एम प्रेझेंटिंग साईला सांगून ठेवते.
हो हो.
He was under national interest exemption, being a doctor.
हे पण बरं पडलं ना मॅडम की म्हणजे आपण लाईन अप करून दिलं ना तर मग खूप सोपं होऊन जातं. आपण 31st असंच करून
हो अगदी. आणि 31st आफ्टरनून पण आणि इव्हनिंग पण दोन्ही आपण व्यवस्थित प्लॅन करू आदल्या दिवशी आणि त्याच्याकडे देऊन टाकू.
आपलं 31st आफ्टरनून तर छानच आहे म्हणजे 4 का 5 लोक फिक्स आहे आपले आणि ते व्यवस्थित बोलणार पण आहे म्हणजे मग 5-10 मिनिटं म्हणजे अर्धा तास असंच होऊन जाईल. 4 खूप झाले आपल्याला. बोरसे मॅडम आहेत आपले सर आहेत सर्व ते सर यांचं वालिंबे सरांचं आणि भगली मॅडम झालं.
हो हो बरोबर.
कारण मग
खरे मॅडमचं आलं तर फक्त व्हिडिओ त्या बोलणार नाहीये.
बरोबर म्हणजे मग अर्धा तास फटाक निघतो कारण एकदम
व्यवस्थित. हाय श्रुतिका.
क्योंकि हमारे पास भी वैसे कैनेडियन वीजा है till 23 तक.
तू म्यूट आहे म्यूट.
हॅलो मॅम.
हा कशी आहे.
हो व्हेरी गुड. आताच माझं एक सेशन संपलं मॉडरेशनचं.
ओके ओके.
सो नाईस टू हिअर युअर व्हॉइस. Very well going. Conference is going on progressing so much punctually. Everything on time.
You also join for this cultural event, Shrutika.
Yes. So it's from 6:30 onwards, na? I just got to know.
Right. Yeah.
6:30 to
6:30 to 8 o'clock, 8:15. We are planning to just wind up.
All right. It's happening all 4 days. Or just today?
No. Today and next Sunday.
Sunday. All right.
Yeah.
All right. Definitely.
Yeah.
Okay, ma'am. Looking forward. See you soon.
Yes.
मोबाईल कसा मम्मी. मोबाईल
दर्शना तू चेंज केलं का काही. आपण ड्रेस कोड नाही ठरवला.
माझ्या पण हे मनात काही आलंच नाही की ड्रेस कोड काही पाहिजे पण मग मी
रविवारी ठरवू मला वाटतं. आता आज राहू दे. मी तर सकाळच्याच ड्रेस मध्ये. माझी IMA ची पण एक कॉन्फरन्स सुरू होती त्यामुळे मी दोन्हीकडे साइड बाय साइड चाललं होतं त्यामुळे
फार छान मॅनेज करून घेता सगळं. एकदम मस्त.
नाही मिळाला साडी नेसायला आता. नाही तू साडी नेसली आहे का आता.
नाही मी ब्लॅक हे घातलंय काय म्हणतं 1 पीस.
ओके ओके.
तर ते मी याच्यासाठी करून घेतलं की ते बॅक आपलं येल्लो हे ना याचं बॅकग्राऊंड ब्ल्यू आहे ना म्हटलं ते बरं वाटेल थोडस.
अच्छा.
त्या हिशोबाने मी थोडस ते हे केलं.
ओके ओके.
कारण आपण जरी ठरवलं तरी ते काय प्रोग्राम्सच मेन आहे म्हणून मग मी.
हो चालेल. ठीक आहे आपण 6:15 ला म्हणजे आता परत येऊ. म्हणजे मी लॉग ऑफ नाही करत आहे लॉग आउट नाही करत आहे. लॉगिनच राहते. आपण 6:15 ला.
येस मी तोपर्यंत कम्युनिकेट करते.
रिंग देतो पैसे.
व्हिडिओ पण चालू करू.
हॅलो नीला मॅडम.
केलं हा वोट.
If you don't want the video, you can stop the video from here and take the other video. But everybody, then you only show me. Lower knee, get to 10. Dhoni get. Right. Whenever you want to present, you put the video on it.
Huh?
Whenever you want to present, you can put the video on it.
Hi Darshana.
आपलं सुरुवातीलाच आहे पोएट्री.
ओके.
हा. आणि मग तुमचं कॉमिक जी आहे ना ती मी तुम्हाला पाठवलंय तसं राहील.
या चालेल. मी ते व्हॉट्सअप वर केलं होतं फॉरवर्ड.
हा मी पूर्ण ते लाईनअप पाठवलंय तुम्हाला. तर हा मनीषा मॅडम ऍक्च्युली वॉज अ सरप्राईज. मनीषा मॅडमचं सॉन्ग आहे ना मनीषा डॉक्टर.
ओके.
दॅट वॉज अ सरप्राईज. पण मग शी इज गोइंग आउट फॉर डिनर. मग मॅडम म्हणे यू प्ले माय सॉन्ग अँड इफ इट इज पॉसिबल यू रिंग मी अप आय विल जॉईन. ठीक आहे. त्यांनी खूप सुंदर सॉन्ग पाठवलंय सवालू.
अच्छा. फेवरेट आहे माझं.
हा म्हणजे खूपच सुंदर एकदम. मी ऐकलं ना ऐकतच राहिले.
माझं फेवरेट आहे. मी पण IMA च्या आमच्या याच्यात तेच गायलं होतं.
हो का.
सुंदर गाणं आहे. हा.
सो शी वॉज लाईक की मी म्हटलं एक शो स्टॉपर शेवटचं एक त्यांचं सॉन्ग आपण प्ले करू म्हणून ठेवलं होतं. नाव पण टाकलं नव्हतं पण मग मॅम थोडं आयसी आहे म्हणजे जॉईन होतील का नाही काय माहिती. बट हॅलो
हाय. गुड
हाय दर्शना.
हाय.
हॅलो नीला मॅडम.
नीला मॅम. डॉक्टर गीता. डॉक्टर वैशाली.
हाय गीतांजली.
We are going live at 6:30 ना.
हो.
अच्छा. माझं तुम्ही प्ले करणार आहात की मी प्ले करणार आहे.
प्ले करणार आहे. सही करणार आहे प्ले.
तुम्ही करणार.
माझं पण तूच प्ले करणार आहेस.
हो हो.
आणि माझं पेंटिंगचं
पण आम्हीच प्ले करू.
ओके.
दर्शना दोन्ही करणार आहे.
दोन्ही.
हा कारण ते होते त्याच्यामध्ये मला वाटतं
2.5. हो. लहान पोएम्स आहेत. दोन्ही प्ले होतील. आणि मॅडम तुमचं पण पेंटिंग रुजुता आणि तुमचं पेंटिंगचा व्हिडिओ पण मग थोड्या वेळात तो पण प्ले होणार आहे.
दर्शन आय हॅव टू रीड माय पोएम्स ना मी ते पाठवते.
हा तुम्ही रीड करा. तुमचा व्हिडिओ फक्त प्ले होईल. तो जो कॉमिक व्हिडिओ आहे
हो चालेल.
तो प्ले होईल.
पोएम छोटेच आहेत म्हणजे लेस दॅन 2 minutes मध्ये होऊन जातील.
हा सगळ्यांचेच पोएम इव्हन नीला मॅडमचे पण लहान होते. मग आम्ही तो लाईव्हच ठेवला. म्हटलं काहीतरी थोडं लाईव्ह पण पाहिजे आणि बाकी तर सगळे आहे रेकॉर्डेड व्हर्जन्स आहेत. मॅम तुम्ही म्यूट आहात की
अनम्यूट करा.
नीला मॅडम ना म्हटलं की तुम्हाला तुमची इच्छा म्हणजे तुम्हाला कविता सादर करायची असेल तुम्ही करा किंवा तुमचा व्हिडिओ प्ले करू कसंही म्हणजे.
व्हिडिओ जर असेल तर प्ले करा.
हा ठीक आहे. दर्शना मग सांगून ठेव तेवढं प्ले
गुड
करायचं.
इव्हनिंग मॅम. रागिनी मॅम. गुड इव्हनिंग.
गुड इव्हनिंग वैशाली. गुड इव्हनिंग दर्शना. गुड इव्हनिंग नीला मॅम. हाय गुड इव्हनिंग गीतांजली मॅम.
Good evening.
All the wonderful glowing ladies on the dais.
Gitanjali is
the most. You are not looking like full day you were attending sessions. You're looking so fresh now.
Yeah, I know. So the ladies, all of you make, I think we together make each other, we rejuvenate each other.
I'm feeling that way. It's a Women's Day today, like all smiling faces, all. Wonderful.
Darshana, I think the other sessions are all closed. It's because people may lose interest. If you want, we can start. Gitanjali ma'am, Neela ma'am, Darshana, Vaishali, Anagha, whatever you all say.
But Karobi is going to come, no? Yes, Karobi.
So people will join in at 6:30, no? Then.
Karobi, okay. So we can wait.
Yeah.
We have given the time of 6:30. So
we have given the time of 6:30, no?
Yeah, right.
Karobi
They might take a break and join back.
Nikhil is also coming.
Yeah, because Karobi ma'am had a session. So
yes.
So I'm here now.
Hi.
Oh, just speak of the devil, huh?
We were talking about all ladies now. We have someone.
I have a lady with me. Daughter, ma'am.
Hi.
Still Krishna has come. Krishna Kanhaiya has come.
With the young lady.
I want to tell one thing. मैंने ये poetry ना आज का लिखा है. I've written it myself. So it's a little funny, nice poem. You all will enjoy it.
Sure.
Okay.
It's called Kahani of a Lockdown Surgeon.
Nikhil, but we will miss that video, na? Your fashion.
I'll prepare it, ma'am. 10th का exam चालू है daughter का, तो थोड़ा time नहीं मिला. I'll do it पक्का.
I think all will be able to relate to your poem about a lockdown.
I know.
Yes, ma'am. Yes, absolutely.
So,
all the sessions were...
can you this thing live वो present करेंगे poem? Your video will go on air, but I thought poetry section आप खुद बोलेंगे तो बहुत अच्छा लगेगा. If it is possible.
I will be speaking. Yeah.
Yeah.
I'll read it out. Yeah.
Neela madam, I was asking.
I can also read it out.
It will look nice, ma'am. वो recorded से अच्छा अगर आप हैं तो फिर if you can. Anagha madam कैसा था पहले से ही we told सही कि you played तो आप सबका मैंने live रखा था यानी.
Okay, that's fine.
Her Anagha ma'am का एक English है and one is Hindi.
English में दोनों हिंदी है ना?
एक ये है ना एक तो हिंदी है ना मैम?
दोनों हिंदी का ही है.
अच्छा दोनों हिंदी है क्या?
नीला मैडम
मैं प्ले करूं क्या मेरी तरफ से?
इंग्लिश
नहीं है, दोनों दिए हैं, दोनों है और वो प्रॉपरली प्ले होंगे. परीक्षित सर भी ज्वाइन होने वाले हैं शॉर्ट वाइल. ज्वाइन हो गए कि फिर अपन शुरू करेंगे. शुभांगी मैडम ज्वाइन, सुनीता मैडम ऑल्सो.
Is this the same link as the audience link or is it different?
No. Audience link is YouTube link.
YouTube link, yeah.
YouTube link, okay.
Hello, good evening all. Good evening.
Yeah, good evening. Darshana, my both poems are in English. चालेल ना?
हाँ?
एक हिंदी आहे. Like once वाटलं तर मग हिंदी बोलेल, पण मग हे दोन तर मी म्हणते. If time permits, then only.
नाही दोनच वैशाली आता दोनच.
आणि 2 मिनिटाच्या आतच होणार आहे.
हो.
30 seconds like.
Yeah.
गीतांजली खूप छान दिसते.
अरे मी आता दर्शनाला म्हंटल की मी व्हाईटच ड्रेस घातला, बॅकग्राऊंड पण व्हाईट आहे. तिने चेंज केला. आम्ही दुपारी सेम ड्रेस मध्ये होतो म्हणजे
माझ्या बॅकग्राऊंडला ते येतच नाही माहिती. आय ट्राय सो हार्ड. ते कर्टन मुळे ना इट जस्ट वुडंट एक्सेप्ट द बॅकग्राऊंड. बॅकग्राऊंड
मध्ये मला पण लक्षात नाही आलं होतं, पण ते मग आय थिंक बॅकग्राऊंड शुड बी ऑफ आणि मग तो व्हर्च्युअल बॅकग्राऊंड घ्यावा लागतो असं काहीतरी सेटिंग आहे. ती सेटिंग केली की ही प्रॉपरली मग हे येऊन जातं बॅकग्राऊंड. इट इज
टेलिंग यू नीड अ प्लेन वॉल स्पेशली
हा.
ग्रीन कलर काहीतरी असं
आयडॉल्सच्या वेळेला झालं होतं ना, बापरे मला शेवटपर्यंत जमलं नव्हतं. मग मी ते विदाऊट एनी व्हर्च्युअल बॅकग्राऊंड केलं. मग नंतर शिकली मी. म्हटलं बापरे हे तर शिकावं लागेल.
ऍक्च्युली वैशाली जे आता नवीन लॅपटॉप आहेत ना, म्हणजे नवीन म्हणजे माझा तरी 1 year ओल्ड आहे, त्याच्यात काही लागत नाही, कसली भिंत ग्रीन
हो.
कलर काही लागत नाही, डायरेक्ट होतो.
Okay, maybe next time I'll try with that.
Yeah, with the new.
I am so used to this, my old laptop ना,
हा.
तर ते शिफ्ट व्हायलाच इतकं इनर्शिया येतोय.
की तुम्ही सेटिंग्स बघा त्याचे, कारण आमचं पण खूप नवीन नाहीये, बट आफ्टर दॅट वी लर्न इट. असं झालं ते.
Yeah, maybe next time नवीन लॅपटॉप ट्राय करा.
ईश्वरचंद्र. स्वप्नेश भी होगा तो स्वप्नेश
कब चालू करना?
अभी थोड़ी देर में बस
अपना नीचे लाके रख
5 minutes 5 minutes
जब तक नीचे लाके रखोगे पहला वीडियो है प्ले करनी कितनी का
ड्रेस इवनिंग के स्टूम
मेरा कुछ काम नहीं है ना
इथे
सही. आर वी रेडी?
अनिल इकडे ये.
Yeah, we are ready to go, madam.
The lineup is same na that we discussed.
Yes, it's all fixed.
Okay. There is one surprise 1-minute video which I will be playing. I will let you know that time. After Dr. Datar's song, na, I will play that small video of 1 minute. It's a surprise thing.
Okay.
Who is sharing the screen, Dr. Darshana? Who has shared the screen?
I think Sai is sharing. No, it is Patwardhan madam's screen.
Madam, will you please stop sharing the screen?
I think चुकून झालं असेल. I realized it, but good. Gitanjali.
दुपारचं मस्त झालं पण सेशन. The songs were really good.
Good, yeah.
मजा आली. तुम्ही बिझी होते का वैशाली मॅडम?
मी नंतर ऍक्च्युली इट वॉज ऑल कन्फ्युजन. म्हणजे मला असं वाटलं की दिस प्रोग्राम हॅज बीन प्रीपोन्ड. सो आय वॉजंट रेडी. म्हणजे म्हणून आय कॉल्ड यू, आय कॉल्ड गीतांजली. मला कळत नव्हतं की काय म्हणजे हाऊ टू वेदर टू जॉईन इट. मग बट आय जॉईन लेट. जेव्हा वेन आय केम टू नो ना की सेशन इज गोइंग ऑन, तर लास्ट 2-3 songs आय कुड लिसन टू.
कल्चरल कमिटी ग्रुप वर मी टाकते रेग्युलरली. जस्ट फॉलो करा ते. म्हणजे मी ऑर्डर्स टाकते त्याच्यात की मी वेलकम डॉक्टर सिरेश. आता थांबायचं पूर्ण प्रोग्रामला.
हो येस येस येस.
आज परीक्षित सरांना मी लावलाय फोन. मॅडम आणि सर दोघेही जॉईन होत आहे.
मी व्हिडिओ ऑफ ठेवतोय. हॅलो.
हा
व्हिडिओ ऑफ ठेवतोय कारण पंकज मला वाटलं चांगले कपडे घालून या.
ऑन ठेवा कंटिन्युअसली. आपल्याला इंटरॅक्टिव्ह ठेवायचंय सगळं सेशन.
सकाळपासून त्याच कपड्यात आहे. तो मला चांगले कपडे घालून या.
हो बापरे. चालेल चालेल.
I think last 2 minutes.
Yes. रागिनी मैम सर आएंगे? लाने सर?
मैडम के साथ तो वो ऑफ करना मैं वीडियो निकाल के रख देता हूँ नीचे. कब दिखाने वाले हो?
Ragini madam.
Please unmute yourself.
Yes. Sai, will you announce it? It is going live or it's live only?
We are actually live only, madam. We haven't stopped the stream at all.
Okay. So should we start? Ragini ma'am? Ragini ma'am is not there. We should start, I think. Gitanjali ma'am? Yeah, Ragini ma'am.
Ragini madam is there.
Yeah.
We were
Good
waiting.
Sorry.
No problem. Should we start?
Yeah, please. Oh, you are the boss.
A very good evening and a warm welcome to this virtual feast of iTalent show, which are we just starting now. And it's my pleasure to have so nice presentations lined up for today's program. Let us start, as we start all good things by the name of taking name of God. We have a beautiful dance by Ridhima Bhagli on Ganesh Stotra. So Mr. Sai, can you play this dance for us? Ganesh Vandana by Ridhima Bhagli.
मूषिकवाहन मोदकहस्ता चामरकर्ण विलम्बितसूत्रा वामनरूप महेश्वरपुत्रा विघ्न विनायक पाद नमस्ते विघ्न विनायक पाद नमस्ते मूषिकवाहन मोदकहस्ता चामरकर्ण विलम्बितसूत्रा वामनरूप महेश्वरपुत्रा विघ्न विनायक पाद नमस्ते विघ्न विनायक पाद नमस्ते
Excellent.
Over to you, Gitanjali ma'am.
Thank you, Dr. Darshana. At the outset, I would like to thank President Dr. Parikshit Gopte, Dr. Ragini Madam, Dr. Shirish, Dr. Pankaj, the whole managing committee, and also Chairman of Cultural Committee, Dr. Darshana Shah. They accepted my request to keep a poetry session in this program. This is just the beginning. हम शुभारंभ बोल सकते हैं. For the first time, we are doing poetry presentation in a cultural program of MOS. There is tremendous poetic talent in MOS members. So this is the first program, and we hope that we have many more in future, and many more poets should write to me, and we'll have Kavya Sandhya, Mushairas, poetry sessions as the days come. So let's start our first poetry by Dr. Anagha Herur. Her video, please.
आओ आज ये प्रण लें हम सब, ज्ञान की ज्योत जलाएंगे, कंधे से कंधा मिलाकर देश की शान बढ़ाएंगे। श्रद्धा का बल भरे रगों में धर्म के पथ पर चलना है, गुरुजनों के शुभाशीष से खुद को सदा संभलना है। बाजुओं में ताकत भर दें, दिल में इतना साहस भर दें, जिन बुलंदियों को छूना है लक्ष्य वही हमारा कर दें। गिरकर फिर से उठ जाएंगे, तूफानों से लड़ जाएंगे, चट्टानें ऊंची हो जितनी नित नित ऊपर चढ़ जाएंगे। हर सामना करेंगे डटकर, लड़ना तान के सीना सीखें, निर्भयता हो मंत्र हमारा, सिर उठाकर जीना सीखें। कर्म ही अपनी भाषा हो अब, मेहनत बन जाए ईमान, हर जिस कार्य से जुड़ जाएं, हम लगा दें दिल और जान। दूर बड़ी मंजिल है तो क्या, नजर नहीं साहिल भी तो क्या, मन में जब विश्वास भरा हो, राहें कितनी मुश्किल तो क्या। हार से हार न मानेंगे, साहस ही रीत हमारी है, बस हौसला टूटे ना अब, इसी में जीत हमारी है। यही विनंती प्रभु से अब है, कुछ ऐसा वरदान दे, सच्चाई के पथ पर हम भी खुद अपना बलिदान दें।
बहुत ही सुंदर शब्द थे।
वेरी नाइस।
या एक्सीलेंट। और स्पेशली अभी जो कोविड वॉरियर्स जो लड़ रहे हैं, यू नो एवरी वर्ड कुड रिलेट टू दैट। थैंक यू अनघा। आप और एक कविता पेश करना चाहती है?
हाँ जी, वो प्ले करेंगे ना?
या
इश्क की शिद्दत दिलों में तिश्नगी है आज भी, इश्क की शिद्दत दिलों में तिश्नगी है आज भी, आपकी यादें हमारी जिंदगी है आज भी, आपकी यादें हमारी जिंदगी है आज भी। हम जमाने के उसूलों से कभी वाकिफ न थे, हम जमाने के उसूलों से कभी वाकिफ न थे, हमको उनकी ही मोहब्बत बंदगी है आज भी। छू गई दिल को उन्हीं की हर नजाकत हर अदा, छू गई दिल को उन्हीं की हर नजाकत हर अदा, जा फना हो जाए ऐसी आशिकी है आज भी। आपसे नजरें मिली और आप ही में खो गई, आपसे नजरें मिली और आप ही में खो गई, आपकी आंखें हमारी शायरी है आज भी। इश्क की शिद्दत दिलों में तिश्नगी है आज भी, आपकी यादें हमारी जिंदगी है आज भी।
बहुत सुंदर। एक्सीलेंट।
Thank you.
Karobi.
Yes, I wanted to present two different kinds of poems. One was kavita and one was in the form of a ghazal.
Ghazal,
for the opportunity.
Beautiful.
Right.
I joined a little late, but ghazal गाया क्या तूने?
नहीं, पेश किया।
सुनाया, पेश किया।
नहीं वैसे नहीं चलता है, गाना पड़ता है.
अभी जाते हैं हम नीला मैडम की तरफ.
नहीं गाओ,
नीला जी
गाओ.
आपकी कविता पेश कीजिए प्लीज.
अच्छा, नीला's poem.
या
Can't hear you.
Voice.
You're muted. Neela, you're muted.
अरे हे इकडे आहे का?
हा.
हे कसं बाहेर
सुरू
जायचं
कर.
ह्याच्यातून? अच्छा.
ऐकू येत नाही.
कसं हे आता परत हे बंद करते.
Madam, stop sharing the screen, and while you're sharing again, there is an option called share sound. Check on that.
Share?
While you're sharing, there is a checkbox called share sound. Check on that and then you start sharing.
Share sound.
Yes.
Share.
म्यूट का बटन पे क्रॉस होएगा तो वो क्लिक कर.
No, I'm not on mute. My mute and video is open. It's only if I start sharing screen that it goes on mute. Can you play it from there?
Do it again now, once again. Let's see.
Madam, I'll guide you. Once you click on the share screen, the pop-up opens, right?
Right.
On the pop-up, left-hand side bottom, you will find a small checkbox called share sound. Just check that. Yeah, just check that and then play. Okay. Then select the video.
Can you see the poem now?
Yes, we can see you, hear you.
What matters most? What matters most has no matter. Love makes the world go round. We earn, give, take and provide money and matter out of love. But love is a feeling. Love has no matter at all. Faith moves mountains. Mountains, huge masses of matter. But faith is a feeling. Faith has no matter at all. We walk, run, and drive cars fueled by energy. What drives us to use this energy? Desire. A feeling. Feelings, our desires, have no matter at all. All this energy and matter we use to get money, wealth, all material things, to seek happiness, only a feeling, happiness that has no matter at all.
Excellent.
Very profound.
There's one more poem.
Yes.
How do we go back?
Cancel. Cut.
See, when we were young, we used to play this game called Fire on the Mountain. Based on that, I present. There's a fire on the mountain, run, run, run. The Stone Age man did run, run, run. There's no food on the plain, run, run, run. The Bronze Age man did run, run, run. Man grew crops, cooked food. Yet to hunt his game, to search for water, the New Age man did run, run, run. Now the modern man has food on the plate, water in the taps, but for work and money, he did run, run, run. The man of today has food on the plate, water in the taps, machines to work, and money in the banks. Yet, for greed, he does run, run, run. Now, there's no fire on the mountain, no game to hunt, no work to be done, no money to earn. But the brainless man doesn't stop to think why he is constantly on the run, run, run.
Thank you.
Excellent.
Neela, all that run, run, run came down with the COVID.
Yeah. Okay, very nice, madam.
Very
Now
nice.
we move to Dr. Nikhil. Are you there, Dr. Nikhil?
I'm right here. I'm right here.
Yes,
Hi,
yes.
Nikhil.
Hi.
Snazzy,
Sorry.
man. How are you?
So first of all, thank you, President Sir, and everybody, Dr. Ragini ma'am, for starting the initiative of the cultural committee. Darshana ma'am, Gitanjali ma'am, thank you very, very much. Karobi ma'am. So thank you to everybody. I am presenting a poem written by me myself, Dr. Nikhil Nasta. So it's called Kahani of a Lockdown Surgeon. As the old lady, you can hear me, right?
Yes.
Okay. Kahani of a Lockdown Surgeon. As the old lady walked into my clinic, she filled the forms in less than a minute, then sat down in that comfy chair and looked around, eyes wide to stare. The waiting room was chock-a-block. It will take me quite long, she thought. Then she made a plan inside her head, smiled slyly, and guess what she said? She told my staff that she was feeling weak. Such an evil streak. The lady was given some TLC, whisked off to the next room and full on AC. Then some pampering and fussing later, they asked her, "Ma'am, now are you feeling better?" She said, "I'm all right, but my throat's gone dry. Some water and a coffee, I can try." So lo and behold, she got these things, and next in line was her checking. She came to my room and went to the chair, read some lines on the Snellens. Not good, only fair. Refraction done, improvement nil. So we dilated the eyes with Tropicacil. A longish wait for half an hour. Then she came in again. I could see it from far. The cataract was like a pearl. Yay, I almost danced and twirled. I checked her on the slit lamp next. Diffuse beam, slit beam, all the tests. A 90D to evaluate the fundus. It was quite clear, pun intended. The problem was the lens. A cataract, it was my diagnosis. I explained to her in grave detail. She nodded her head. Earlier also she had heard this tale. Then she opened her bag and removed a file. Not one, not two, 7 files. All my friends, she had seen them earlier. She knew them on first name basis. Oh dear. Then she smiled and said, "Okay, bye. I'll see you next July." Then, arey yaar, post lockdown, I saw a cataract and I was so jumping up and down. But now, she's gone, yeah, and so my hopes too. Aisa chalta raha. I think I'll shift to Kullu. I'll grow some rice, some wheat, some corn. But on a serious note, I'd rather be here on my own because Ophthal is all I know. Ophthal is all I do. Better days will come after lockdown for me and for you. Thank you.
You can grow apples also at Kulu.
Everyone has to go to Kulu.
And you have other things also. So you have all your this contests and all to win, you know. So
ma'am,
Nikhil can go acting, no? Nikhil can go acting.
So I did a movie role recently, but tell me, which was your favorite line in the poem?
My favorite.
7 files. Tropicacil.
The 5. I like the one. I like the Tropicacil, yes.
Very nice.
So that's it.
We
Yeah,
have
thank you
2 to
so
3
much.
files. You have 7 files in one.
Very nice, Dr. Nikhil.
Yeah.
Thank you so much. Thank you so much.
You can imagine his depression, you know, that he wrote this.
But I'm never depressed. I'm always happy only.
Good evening, sir. Welcome.
Okay,
now
thank you
we-
so much. Thank you so much.
Yeah, you're
It was
welcome.
wonderful. Put a smile on everyone's face.
Thanks so much. Thank you.
So now we move to Dr. Vaishali Une.
Okay.
Dr.
I'm there.
Vaishali?
Yeah. Thank you.
Hey, Vaishali.
Hi, ma'am. How are you? Yeah.
Fine.
Thank you, everyone, the organizers and Parikshit sir and Ragini ma'am and Shirish sir. And special thanks to Darshana, hats off to her. Geetanjali and Darshana have been working so hard. So thank you for this opportunity. Without wasting much time, I'll just recite two of my poems. One is again related to COVID. It is Thanks Invaluable Mask. Mask has always been a friend. Being a surgeon, it was a necessity, not a trend. Surge of SARS-CoV, and now population trusts the patch. Less that caustic COVID is eager for life to snatch. Masks have always defended us from illnesses. Emotional wrecks like me owe it to shield our weaknesses. Yes, it filters out airborne contaminants, but for me, it even masks up my continence. How I wish it could even conceal our tears and guard us against our internal fears. Thank you.
Great.
Yeah, and one more is when my daughters left the nest for higher education. So it's very close to my heart, and I know it will resonate with all the mothers. So a short poem, Fly High. The turmoil in me wouldn't let me blink. For all these years, you were under my wing. Time has come for you to soar high. Fly, my dear, in the deep blue sky. I will watch your flight as I do watch your sisters, taking pride in all your small and big ventures. I promise not to be sad and not to be affected by the empty nest. It's not easy, but the real big test. All these years, our lives revolved around you. Now is the phase of letting you know the real you. Thank you. Thank you so much.
Beautiful.
Thank you
Vaishali?
so much. Thank you.
Yeah.
Thank you, dear. Yeah.
Very nice. Very nice. Yeah. I just now Dr. Parikshit Gokte has joined, so I would like to welcome him. And Dr. Gokte, we are really grateful to you for keeping this poetry session this time in MOS Cultural Program. And this is Maharashtra Ophthalmological Society. We are in Maharashtra, but all the poems were either in Hindi or English. So I take this opportunity to present a Marathi song now and a Marathi poem. And Vaishali presented her feelings for daughter. And this is Thodi Si Natkhat Bhari poem hai. Every wife would relate to it. शीर्षक आहे तू मी. तू मी करता करता आली की रे 50. तू मी करता करता आली की रे 50. कशी सरली वर्ष सारी लग्नाची ही 25. गडबड धावपळ अहोरात्र. गडबड धावपळ अहोरात्र बसायलाही वेळ नाही. गडबड धावपळ अहोरात्र बसायलाही वेळ नाही. गप्पा गोष्टी दूरची गोष्ट बघायला तोंड मिळत नाही. चिडचिड माझी होत असते. चिडचिड माझी होत असते. मोबाईल तुझा कानाशी सदा. चिडचिड माझी होत असते. मोबाईल सदा कानाशी तुझा. माझाही नंबर सेव्ह लिस्ट मध्ये कधीतरी लावून बघ एकदा. विसरतोस लग्नाचा आणि माझा. विसरतोस लग्नाचा आणि माझा वाढदिवस दरवर्षीचा. विसरतोस लग्नाचा आणि माझा वाढदिवस दरवर्षीचा. बोलणंच खुंटलो म्हटलं की दिवस करतोय रात्रीचा. आला घरी की लावला टीव्ही. आला घरी की लावला टीव्ही. IPL फिफा काही बाई. आला घरी की लावला टीव्ही. IPL फिफा काही बाई. एकच सिरियल बघते मी. एकच सिरियल बघते फक्त. तरीही रोजचे टोमणे साही. तू तुझ्या विश्वात रोज आणि मी माझ्या जगात असते. तू तुझ्या विश्वात रोज आणि मी माझ्या जगात असते. तुझ्या माझ्या आयुष्याला नेमकी कशाची गरज असते. मुलं झाली मोठी आता. मुलं झाली मोठी आता. फुटले पंख गेली दूर. तुझ्या माझ्यात नाही तिसरा. तरीही का रे रोजची कुरबुर. खूप झालंय पळणं आता. खूप झालंय पळणं आता. विसावून रे थोडस. खूप झालंय पळणं आता. विसावून रे थोडस. विसरून चाललंय जगणं आपलं. जागूया त्याला जरासं. म्हणत नाही हात घे हातात. म्हणत नाही हात घे हातात. सैर चांदण्या रात्रीची. गरज तुला मला आता फक्त निखळ मैत्रीची. तू मी विसरून जरा. तू मी विसरून जरा जमवूया आता आपलं ट्युनिंग. तू मी विसरून जरा जमवूया आता आपलं ट्युनिंग. टीव्ही मोबाईल विसरून सारं. लेट स्टार्ट द नेक्स्ट इनिंग. लेट स्टार्ट द नेक्स्ट इनिंग. थँक्यू.
सुपर. प्रत्येक वाक्यात मला असं वाटत होतं माझं हिने कसं जाणलंय. खूप सुंदर.
व्हेरी नाईस.
थँक्यू. युजली काय असतं की मी मराठीत बोलते आता, की कवी कवयित्री जेव्हा लिहितात तेव्हा आपल्या भावना म्हणजे आतमध्ये जे मनाच्या आत चाललेलं असतं ते कागदावर उलटतं. पण जेव्हा लोक सगळे अप्रिशिएट करतात, then we are really happy, satisfied. It gives a lot of pleasure. आणि तसंच एक प्लेजर मला आपले MOSचेच मेंबर आणि कॉर्निया सर्जन डॉक्टर समीर दातार यांनी दिलं. माझी एक कविता त्यांना आवडली आणि त्याला एक सुंदर म्युझिक देऊन त्यांच्या पत्नी डॉक्टर भक्ती दातार, अप्रतिम आवाज आहे त्यांच्या आवाजात, त्यांनी गाणं बनवलं आणि ते गाणं रिलीज झालं. म्हणजे तो क्षण माझ्यासाठी इतका मोठा होता की एक कलीग, एक मित्र समीर, तो स्वतः उत्तम कवी आहे, स्वतः उत्तम गायक आहे, स्वतः उत्तम अनेक इन्स्ट्रुमेंट्स वाजवतो आणि त्यांनी इतकं सुंदर गाणं बनवलं. तर आय वुड लाईक टू प्रेझेंट दॅट सॉन्ग फॉर डॉक्टर समीर दातार. जोरदार टाळ्या झाल्या पाहिजे.
फॉर यू एज वेल.
डॉक्टर समीर दातार सॉन्ग. Sai, you have to present from your end.
Sai. Full.
रेडी असाल ना.
असा मार्ग असावा.
Very nice. Very nice.
Yeah. I was president of Pune Ophthalmological Society last year. आणि अचानक आमचं कोविडनी लॉकडाऊन झालं, सगळे प्लॅन्स बदलले. सो आय रोट दिस पोएम आणि ती अशी पूर्ण वर्षासाठी असा मार्ग माझा निराळा असावा असं झालं. कारण टोटली ऑल इनोव्हेटिव्ह आयडियाज हॅड टू बी इम्प्लिमेंटेड. So this poem was that, and Samir made a beautiful song. And Bhakti, who was the MOS idol, say a winner, she had sung this song. So I'm grateful to both Samir and Bhakti for making this poem into this beautiful song. Over to you, Darshana.
Like Vandana said, really the soothing voice and the words exceptional, very beautiful.
Really, we had a very nice poetry section in the iTalent Fest. And let us move now to one more language. Now we had Hindi, English, Marathi. Let us listen to something in Bengali. We have a very beautiful song by Rupali Abhyankar for you all.
যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে, একলা চলো, একলা চলো, একলা চলো, একলা চলো রে, তবে তুই একলা চলো, একলা চলো, একলা চলো, একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি কেউ কথা না কয় ওরে ওরে ও ভাগা, কেউ কথা না কয়, যদি সবাই থাকে মুখ ফিরায় সবাই করে ভয়, যদি সবাই থাকে মুখ ফিরায় সবাই করে ভয়, তবে কোরআন খোলে ও তুই মুখ ফুটে তোর মনের কথা একলা বলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। একলা চলো, একলা চলো, একলা চলো, একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি সবাই ফিরে যায় ওরে ওরে ও ভাগা, সবাই ফিরে যায়, যদি গহন পথে যাবার কালে কেউ ফিরে না যায়, যদি গহন পথে যাবার কালে কেউ ফিরে না যায়, তবে পথের কাঁটা তুই রক্ত মাখা চরণ তলে একলা ডলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি আলো না ধরে ওরে ওরে ও ভাগা, আলো না ধরে, যদি ঝড় বদলে আধার রাতে দুয়ার দেয় ঘরে, যদি ঝড় বদলে আধার রাতে দুয়ার দেয় ঘরে, তবে বজ্র নলে আপন বুকের পাথর জ্বালিয়ে নিয়ে একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে। যদি তোর ডাক শুনে কেউ না আসে তবে একলা চলো রে।
Beautiful melody. Very well sung by Dr. Rupali.
Rupali Abhyankar, she practices in Y, and she herself is a very good poet. She is a very good actress, and she has acted in short films as well. And she is a very close friend of mine. मला माहिती नाही ती आज join करण्यात आली.
Awesome song and awesome singing.
Yeah, awesome singing. म्हणजे
This is evergreen song. Everyone knows and everyone loves.
Yeah.
Very beautifully sung.
Now for a surprise from our side, myself and Pankaj. Do enjoy.
Sure. Rupali, how do you know Bengali?
Madam, Rupali has not joined.
Actually, she's not joined. Okay.
No, मी तिला पाठवला message. I don't know. Acha, let's enjoy Darshana and Pankaj.
Acha, Darshana and Pankaj now on the this.
Ooh. Kajal, love you.
दर्शना आवाज नाहीये का?
नहीं,
It's low.
आवाज नहीं आ रहा.
देख रहे हैं सब देख रहे हैं क्यों भैया?
Volume नहीं है का?
नहीं.
It's low.
Okay.
करो.
One second.
वीडियो चल रहा है.
Oh, Darshana, it was difficult to know whether it's you or it's Kajol. So both of you did great job.
I hope you enjoyed this. We have been doing such presentations routinely in our IMA group, so we love doing this. Let us move on to the next presentation. We have very beautiful painting videos by Dr. Neela Patwardhan ma'am and Dr. Rujuta Machwe.
ये बातें हैं पुरानी, कैसी पहेली है ये, कैसी पहेली जिंदगानी. थामा हरों का इसको किसने, हाँ ये तो बहता पानी. कैसी पहेली है ये, कैसी पहेली जिंदगानी. ला ला जिसने पिया वो गम में भी हंसा, पल में हंसाए और पल में रुलाए ये कहानी. कैसी पहेली है ये, कैसी पहेली जिंदगानी. थामा हरों का इसको किसने, हाँ ये तो बेदबानी.
Madam, superb.
Excellent.
Thank you.
Oh my God. तुम्ही लहानपणापासून करता पेंटिंग्स or you have started like a hobby later?
I always loved painting It's my passion, but I never had the time. Till now, like you know, the children have grown up, gone away, and now we have the time to sit back and do something, follow our hobbies. Like
Beautiful, ma'am. Very
Yeah.
nice.
Very nice, very nice.
I am in love with your glass paintings.
Yeah, I have to make one for you.
No,
Yeah. Yes, yes.
Himalayas was also very beautiful. That knife,
That's a knife painting.
painting.
Yeah.
Yeah,
So
it's
what I
beautiful.
did is I compiled different art forms and in different media and showed a
Yes.
jhalak of each. Like
Right, right. Beautiful.
Thank you.
We have one more beautiful video by Rujuta. Let us enjoy that also.
Beautiful.
Beautiful, beautiful. Darshana, you are muted.
You have been painting since long?
No. This is my lockdown diaries.
Okay, great.
After school time,
My
I
God,
did it for the first time during the lockdown.
Everybody has got
Wonderful.
multi-talented
Really
during
is.
COVID.
Exactly.
Amazing,
yes.
amazing.
That is the benefit of COVID, we should say.
Yeah.
I don't think I did anything constructive.
Dancing, ma'am, you were amazing dancer.
Madam, you gave us so much happiness with your smile.
You too, yeah.
Ma'am, you made me do Kathak for the first time. That too only in 2 days. So hats off to you.
But that was beautiful, yeah. You did it
She's
so
the
well,
spirit, the spirit that makes everything happen.
I know.
Spirit which makes the world go round, but it does not have any matter. No, everyone's poems were good. Vaishali, I heard one of your poems, but that was very nice.
Oh, ma'am. Thank you so much.
I was feeling hungry, so I went for a snack.
I'll share with you on the WhatsApp, ma'am.
Do that, please.
Which one you heard? The COVID
I heard the first one. I didn't hear your daughter's one.
Second one is about the daughter's
Daughter.
list.
Yeah, I didn't hear that one.
I'll share it with you. Yeah, ma'am.
And rest of the participants were just excellent. What talent we have here. We don't need anything, All the film stars can be put to shame, All our celebrities
We
are
have very nice comedy skits. So let us start with Ti Fulrani by Tanmay and enjoy this beautiful skit.
नमस्कार. ती फुलराणी या नाटकातील ओरिजिनली भक्ती बर्वे यांनी केलेला तुला शिकवीन चांगलाच धडा हा मोनोलॉग मी सादर करत आहे. काय मास्तर साहेब गधडी काय नालायक हरामजादी थांब तुला शिकवीन चांगलाच धडा तुझ्या पापाचं भरलाय घडा मोठ्या मस्त स्वतःला मास्तर तुझं गटारात घाल जा शास्त्र तुझं मशनात गेलंय ज्ञान तुझ्या तोंडात घालीन शान तुझं क तुझं ख तुझं ग तुझं घ मार पैजेचा घेतोय इडा तुला शिकवीन चांगलाच धडा तुझा पुत्रीन समदा माज तेव्हा येशील गुंडाळून लाज माझी चट्टत येशील बुट मी म्हणल काय आज इकडं कुठं हात पसरून मागशील भीक मी म्हणल जरा शुद्ध बोलायला शिक. मग उडवून हात लावीन धरायला वाटचल बाहेर मुकाट. उग वळवळ करताय किडा, तुला शिकवीन चांगलाच धडा. तुला दाखवते बघ चोरा, तू बघशील माझा तोरा. ओ हो आहा, ओ हो आहा, हाऊ स्वीट लवली ब्युटी चार्मिंग हाय. समद्या धरत्या मंजूचं पाय, कुत्र्या वाणी घोलतील गोंडा न तरण्या पोरांचं दारात लोंढा. हाय मंजू, हाय दिलीप, हाय मंजू, हाय फिलिप. मंजू बेन केम छो, हाऊ डू यू डू, कम कम गो हँगिंग गार्डन. आय बेग युअर पार्डन. कुणी आणतील शिलिकची साडी, कुणी देतील मोत्यांची कुडी, कुणी घालतील फुलांचा सडा, तुला शिकवीन चांगलाच धडा. मग कुठूनचा येईल एक राजकुमार, सफेद घोड्यावर होऊन स्वार. टिक टॉक टिक टॉक टिक टॉक टिक टॉक टिक टॉक टिक टॉक टिक टॉक. नजरेला जेव्हा नजर भिडल, झटक्यात माझ्या पायाच पडल. म्हणाल मंजू देवी झालो मी तुझ्यावर फिदा, क्या खूबसूरती कैसी अदा. माग माग काय हवं ते माग, प्यारी माझ्यावर धरू नको राग. मी मातूर गावठीच बोलल, मनातली गाठ हळूच खोलल. गालावर चढल लाजेची लाली, नजर जाईल अलगद खाली. म्हणल मी हे काय असो, लोकात उगाच होईल हसो. कुठना पातूर सरड्याची धाव, टिटवीनं धरावी का दर्याची हाव. हिऱ्याच्या कंठाला सुतळीचा टोळा, आणि गटाराच्या पाण्याला सोन्याचा गडा. मग राजाच येईल रथात म्हणाल कसं बिकर पण हो माझी सून. दरबारी धरत्याल मुठीत नाक म्हणत्याल, राज्याचा मान तरी राख. तोंडा बांधानी रांगोळा काढा, त्या अशोकाला शिकवीन चांगलाच धडा. मग म्हणजे म्हणाल महाराज ऐका, त्या अशोक मास्टरला बेड्याच ठोका. शिशाचं रस त्याच्या कानात होता आणि लखलख सुरीनं गर्दन छाटा. मास्तरला घोड्याच्या शेपट्याला जोडा, पाटलून काढून चापकाला फोडा. जेव्हा राजाच्या शिपाई धरत्याल, तुला म्हणशील म्हणजे सोडीव मला. कुत्र्या वाणी लोळशील कसा, रडत बसशील ढसा ढसा. तुझा तुझा आ तुझा न, तुझ्या श्या तुझं बसकन अंगावर येणं. भोग आता गप तुझ्या कर्माची फळं, तुझ्या तुरुतुरूची भेला कायम चटाळ. महाराज म्हणत्याल याची गर्दन तोडा. मी म्हणल जाऊ द्या गरीबाला सोडा. तू म्हणशील मंजू देवी आलो मी तुला शरण. मी म्हणल शरण आल्यावर देऊ नाहीये मरण.
Excellent performance.
It was really difficult thing to pull off. You have done it very nicely,
Tanmay. Yeah. आणि पुलंचे शब्द आहेत ते इतके सुंदर, त्याच्यात रिदम आहे, त्याच्यात भाव आहेत आणि ते परफेक्ट त्या स्टाईल मध्ये फुलराणीच्या. इट वॉज एक्सिलेंट.
खूप सुंदर, मस्त मजा आली.
You keep on acting, or this was just for a change?
No, I like acting. Actually, this was I had picked it up in childhood when my aunt was practicing. So it has somehow stuck, and I have performed it at various places. So this was just a hobby.
Great.
Very
Thank you.
Let us move on to our next presentation.
Sorry. Very nice, Tanmay.
Yeah.
Very nice.
Thank you, ma'am.
Acha, Tanmay is a great dancer also. You must see her Lavani, where she moves around.
Next Sunday.
Next Sunday.
Tanmay will have a session on
Tanmay is a superb presentation, huh? Superb.
Thank you so much.
Dr. Shubhangi Nigvekar, we have a melodious song by her. She was one of the finalists of Idol and got a special recognition award also. Presenting you, Dr. Shubhangi Nigvekar.
बहुत खूब. Shubhangi madam, have you joined?
Beautiful.
I don't think so. She always chooses very tough songs, and she has a pure classical base. She has learned from her mother. Her mother is also a great singer, and so she sings always these tough songs perfect.
It's like a professional singer.
Yeah, she's like a professional singer. Now let's move to our next comedy session, and this is by Dr. Tejaswini Vaimde. तेजस्विनी फार सुंदर स्टँडअप कॉमेडीला स्टँडअप राहायला पाहिजे. ती बसून करते, अप्रतिम करते, स्वतः लिहिते, स्वतः सादर करते. तर तिचं एक छानस आपण हा एक पात्री नाटक म्हणूया, एक पात्री प्रयोग म्हणूया किंवा स्टँडअप कॉमेडी म्हणूया. एक सुंदर सादर करते डॉक्टर तेजस्विनी वाळिंबे.
तसं मी कोणाला माझ्या मनातलं कधी सांगत नाही बरं का, पण तुम्हाला म्हणून सांगते. परवानं मला एक विचित्र स्वप्न पडलं. म्हणजे मी अशी जात होते टिळक रोडवरून आणि मागून आवाज आला, हमारी मांगे पुरी करो, हमारी मांगे पुरी करो. मागे वळून बघते तर काय, अशा जाड्या जाड्या माझ्यासारखेच 3XL 4XL साईजचे बायका माणसं चालले होते झेंडे नाचवत. तसं मला पण वाटतं बरं का, की रेल्वेमध्ये आणि बसमध्ये जरा रिझर्वड कम्फर्टेबल सीट्स पाहिजेत आमच्यासाठी. आणि ते विमानातले टॉयलेट्स, त्या अन्यायाविरुद्ध ते आवाज उठवायलाच पाहिजे. मग मी घुसले मोर्चात, हमारी मांगे पुरी करो, हमारी मांगे पुरी करो. फार कठीण काळ आला हो आजकाल. म्हणजे आता मागच्या रविवारचीच गोष्ट. अशी मस्त प्रसन्न सकाळ होती आणि काजू, मटार, केशर, गाजर घातलेलं असं गुलाबचं देखणं रूप आणि मस्त सोबतीला मँगो शिरा. माझ्याच कौशल्यावर खूप खुश झाले मी. आजकाल काय झालंय, ते वेबिनारचं जरा पिकच झालंय जास्त. तर मी काय करत असते, आपल्या किचन ओट्यावर मोबाईल ठेवते, आपली श्रवण भक्ती सुरू, एका दगडात 2 पक्षी. तर एक वेबिनार सुरू होतं डायटिशियनचं, आहार तज्ज्ञाचं भाषण सुरू होतं. आणि बाई म्हणते कशी माहिती का, वेट लॉस करायचं असेल तर 3 Dची आवश्यकता आहे. डेडिकेशन, डिव्होशन, डिटर्मिनेशन. घातलाच बाईने मिठाचा खडा. झाला आता काय तो मँगो शिरा गोड लागणार आहे. तुम्हाला सांगू ना, हे डाएटवाले ना असं काय काय खाऊ घालतात ना बेचव. आता ते नवीन क्विनोआ आलाय, ओट्सची बहीण. तुम्हाला सांगते, कोणाचा कोविडमुळे जर धंदा बसला असेल ना, तर ते क्विनोआ विका, चांगले पैसे मिळतील. पण थोडे दिवस असं. डाएट फूड म्हणजे काय, येतील बहून जातील बहू. त्या कोरोनाच्या औषधासारखं आलं आलं आणि गेलं गेलं. पण माहिती आहे का, हे असे डिटरमाइंड डिवोटेड वगैरे जे लोक असतात ना, असतात बरं का. मागे मी एकदा त्या गोखलेंकडे जेवायला गेले होते. अशा छान छोट्या छोट्या पोळ्या केल्या होत्या. म्हटलं छान करते ग पोळ्या तू प्रिया. अगं म्हणजे काय म्हणे, 6 सेंटीमीटर डायमीटरच्याच पोळ्या असतात माझ्या, परफेक्ट. आणि त्या पोळीला जे कणिक लागते ना, 8 ग्राम काहीतरी, ते कणिक पण मिस्टर गोखले आदल्याच दिवशी म्हणे मोजून ठेवतात. आता सांगा, ऐकावं ते नवलच बाई. तुम्हाला सांगू का, माझं तक्रार करायचा स्वभाव नाही बरं, पण ते व्हॉट्सअप उघडा, जोक बघा किती कसे कसे असतात ते. आता एक परवा जोक आला होता, एक अशी ढब्बू मिरची आरशात बघते आणि तिला दिसते अशी लवंगी मिरची आरशात. आणि खाली काय लिहिलं होतं, ड्रीम ऑफ ऑल वुमेन. आणि या जोकवर स्माइली किती लोकांच्या, 1 2 3 4 5 बाई 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 बाई. पण तुम्हाला सांगू का, मला नाही आवडत तसं. काय दिसते हो, धड ते झिरो फिगर, ना पुढचं ना बागचं, सुकड बोंबील. जाऊ द्या, आजकाल काही लोक सहानुभूती दाखवतात. पण आता माहिती का, ते टीव्हीवर प्लस साईजचा एक डान्स शो पण आला होता. आणि आता एक जाडेबाईची टीव्ही सिरियल पण आली आहे. मला ना पाककलेची पण खूप आवड आहे बरं, पण खूप गिल्टी फिलिंग येतं हो आजकाल. म्हणजे ते माझ्याजवळ आहे संजीव कपूरचे पुस्तकं वगैरे, खाना खजाना, चौपाटी स्पेशल सगळं वगैरे. पण मग तुझी खालच्या ड्रॉवरमध्ये लपवून ठेवलं. आता माझ्या मनात आलं होतं, मागे ते डोळ्याच्या आरोग्यावर मी पुस्तक लिहिलं ना, पाहू आनंदे. म्हणलं लिहावं एक, खाऊ आनंदे. पण वाचणार कोण? सकाळी उठून ते न्यूजपेपर उघडा आणि जाहिराती वाचा. 10,000 रुपये फक्त, 10 किलो वजन कमी करा आणि पोटाचा घेर कमी करा आणि कमरेचा घेर कमी करा, हेच वाचायचं नुसतं. तुम्हाला सांगते, लोक दुसऱ्याच्या भावनांचा विचार नाही करत. आता परवा आम्ही अशा मैत्रिणी जमलो होतो, सगळ्या साईजच्या होत्या, S पासून XL पर्यंत. एक मीडियम साईजची काय म्हणते माहिती आहे, कळलं का गं तुला, त्या शिंदे काकू गेल्या ना परवा हार्ट अटॅकनी, चांगल्या शिडशिडीत होत्या. दुसरी 3XL काय म्हणते, अगं ते देशपांडे काका पण गेले ना, ते तर होते पाप्याचं पितर. तिसरी काय म्हणते, म्हणजे काय जाड लोकांनाच येतो का हार्ट अटॅक, ते नॉनव्हेज आणि दारू जाऊन बसतं ना धमन्यात, असं म्हटलं. आणि चौथीच्या घशात अडकला पनीरचा तुकडा. आता हिचा नवरा ढोसत असेल ना रोजची दारू, म्हणून अडकला पनीरचा तुकडा. मग सगळ्यांच्या नजरा गेल्या माझ्याकडे. म्हणजे डॉक्टरची कॉमेंट पाहिजे होती ना त्यांना. मी म्हटलं हां, ओबेसिटी इम्पॉर्टंट रिस्क फॅक्टर आहेच तसा. तर माझं बोलणं मला पूर्ण करूच दिलं नाही. तर एक मैत्रीण काय म्हणते, तेजस्विनी तुला मी खरं सांगू का, दैव असतं बघ एकेकाचं, डेस्टिनी, दुसरं काय. आता डेस्टिनी आम्ही पण मानतो बरं का, म्हणजे कसं आहे आम्ही डॉक्टर पण अनुभवतोच की, म्हणजे वी ट्रीट ही क्युअर्स. तसंच मग आता नशिबातच असेल तर काय, खा मग खाऊन घ्या, काय दे बरं लाडू दे बरं, ते म्हणजे काय खाऊन घ्या चला. पण आता डाएटचं पण मला खूप नॉलेज आहे बरं का, पण मी कोणाला फुकटचे सल्ले म्हणून देत नाही. आणि लोक उगीच म्हणायचे लोकांसंगे ब्रह्मज्ञान स्वतः मात्र कोरडी पाषाण, पण लोक सल्ले देतात. म्हणजे कसं, एकदा मी डिनरला गेली होती, असं माझ्या प्लेटमधलं आईस्क्रीम पाहून एक जण म्हणतो कसा, तेजस्विनी लेट इट गो वेस्ट, अदरवाईज इट विल गो इन टू युअर वेस्ट. म्हटलं अजिबात नाही, अन्न टाकायची आमची काही संस्कृती नाही. अन्न हे पूर्ण ब्रह्म, मी खाणार म्हणजे खाणार. आता खूप जण विचारतात मला, ते डॉक्टरचे दिसले होते मागच्या रविवारी तळजाईवर, सिंहगडावर पण आले होते, तुम्ही नाही येत का. म्हटलं मी नाही येत बा. म्हणजे आता सांगा रविवारची काय मला कामधामं नाहीत का या गडावरून त्या गडावर उंडारायला. तुम्हाला सांगते ही ट्रेकिंगची फॅशनच आली आहे आजकाल. आणि ते वोकॅथॉन मॅरेथॉन काय म्हणतात ते व्हॉट्सअप उघडलं सकाळी की ते वाचायचं, हा 4 किलोमीटर धावला, तो 6 किलोमीटर चालला, मी तर आपली पाठवून देते, 1 अंगठा 2 फुलं, 1 अंगठा 2 फुलं. आता परवा ना एक पेशंट आली होती माझी आणि काय म्हणते, मॅडम तुमच्या क्लिनिक जवळनं मी फिटनेस सेंटर सुरू केलं आहे. म्हटलं अरे वा अभिनंदन अभिनंदन. आणि मॅडम तुमच्या स्टाफसाठी ना मी डिस्काउंट कुपन ठेवले आहेत तुमच्या रिसेप्शनवर. आता तिला लक्षात आलं की या क्लिनिकमध्ये रिसेप्शनिस्ट पासून डॉक्टरला सगळ्यांनाच गरज आहे फिटनेसची म्हणून. म्हटलं थँक्यू हां असं तर म्हटलं, पण रागच आला मला मनात. असा जळफळाट झाला म्हणून सांगू, तशीच आली तणतणत घरी. दार उघडलं घराचं तर मुलगा विचारतो, आई आज काय करणार आहे खायला. म्हटलं खा माझं डोकं, तू करणार नशील ना तर मी स्पॅगेटी करतो. म्हटलं कर स्पॅगेटी कर आणि त्यावर ओत भरपूर चीज. विद्यार्थी ना तू, विद्यार्थ्यांनी कसं राहायला पाहिजे, काकचेष्टा बकोध्यानम श्वान निद्रा तथैव च, अल्पहारी गृहत्यागी विद्यार्थी पंचलक्षणम. लेक्चर दिलं झोडून त्याला. आणि मग आपलं मनात म्हटलं बरं झालं आपली तर विद्यार्थी दशा संपली बाबा, चला त्या.
मस्त एकदम सुपर. 1 अंगठा 2 फुलं, बेस्ट.
सुपर मस्त.
And the pace was so steady and the humor was unlimited. And Tejaswini madam is so talented throughout the competitions which we took throughout the year. Anything you name it, she did it wonderfully. Be it photography, be it decoration, be it poetry, painting, everything you name it, and she has done it so nicely. But how many prizes we are going to give? So,
very good.
So it was the case.
It's a subtle humor, but we literally feel like laughing loud.
Yeah.
म्हणून ना खाऊन पिऊन मस्त राहायचं.
I'm really proud. Tejaswini is my batchmate, and she was like that only in our college days also.
Okay. Very subtle humor, but
really made a sit down comedy of a stand up comedy.
Yeah, sit down comedy. Where is she, by the way? नहीं है क्या थे?
But she is not like there.
Joined. Yeah.
Okay, fine.
Now let us move on to a musical feast. We have Dr. Sandesh Doshi with his harmonica presentation. Please enjoy. Wow.
Wow. It's amazing.
Superb. Wonderful. Yeah.
Morning 2 we had Zabardast performance and evening 2.
And bonus whistling.
Yes.
No, you know what? See, the thing is that he sang the Sayonara, Sayonara, na? So I was just remembering the heroine who was enacting it, and I felt Vaishali would fit the scene, you know. If he had let
Yes.
her wear a kimono and she would have done this, no, she would have looked like the heroine herself.
Yeah, wow, ma'am.
So next time, वो dance करना है तुमको.
Surely, you have given me ideas.
Yes. And tell Sandesh only to bajao, you know, so and somebody else can sing.
Sandesh sir, how do you find time for harmonica, for mandolin, for singing, for marathon, for cycling?
Oh,
And
there's a lot of time.
VR surgery. And VR surgery.
Oh, there's a lot of time. I think for your hobbies, you don't have to find time. You somehow manage to find.
Yeah.
And I think you have got that inborn talent, so you don't need that much of practice as well. To
No,
make
no,
that
no,
look
no.
it's- Yeah.
No, you need practice.
No, but I think Sandesh, no, God has given him a 36-hour day.
See, like
8 hours
you-
for VR surgery, rest is for hobbies.
see, one is born with musical ear, and I'm lucky to be born with a musical ear. So it's very easy to adapt between various forms of music.
No, it shows the way you whistled extempore. It was too good, you know.
Now I take the opportunity to welcome my dear friend Dr. Vandana Kabra for her song. Vandana is a great singer and an enthusiast badminton player. And in Aurangabad, we have her all ladies get together every month. So she is the Jan of every party. So welcome, Vandana, for your song.
Thank you, dear.
वो चांद खिला वो तारे हंसे ये रात अजब मतवारी है वो चांद खिला वो तारे हंसे ये रात अजब मतवारी है समझने वाले समझ गए हैं ना समझे वो अनाड़ी है वो चांद खिला वो तारे हंसे ये रात अजब मतवारी है समझने वाले समझ गए हैं ना समझे वो अनाड़ी है वो चांद खिला वो तारे हंसे ये रात अजब मतवारी है चांदी सी चमकती रहे वो देखो ना समझे वो अनाड़ी है, वो चांद खिला वो तारे हंसे, ये रात अजब मतवारी है.
Beautiful.
Very nice.
Very
वंदना,
nice.
हम
Such
ये
a
समझ
melodious
चुके,
voice. Yeah, very melodious
Thank you.
voice.
हम
Yeah.
ये
Thank
समझ
you so
चुके
much.
कि आप बहुत ही बेहतरीन सिंगर हो, बेहतरीन दोस्त तो हो.
यस यस यस, आई ऑलवेज फील है ना, हम लोग जो भी हमारा किटी होता है औरंगाबाद का, मेरा और वैशाली का हमेशा एक फोटो तो साथ में रहता ही है.
अरे हमें भी बुलाओ ना.
आइए, मोस्ट वेलकम.
ऑलवेज वेलकम.
Every month we meet and it's full of fun. Such a
यस
stress
यस
buster.
यस,
it
बहुत
is.
अच्छा है, मतलब वी हैव वेरी गुड ग्रुप, बहुत बढ़िया है.
Yes. Even I see it on Facebook. We enjoy the photo.
Yeah.
आपकी
Thank you
आवाज
so
जो
much
है,
for
it was,
giving.
perfectly suiting नूतन. ऐसे लग रहा था कि ओरिजिनली चल रहा है. बहुत
Thank you
बढ़िया
so
लग रहा है.
much. Thank you
Even
so
I
much.
would say it was one level above the idol performance. Somehow I found this very, very, very melodious.
Thank you. Thank you so much.
Next, again, we have a very, very good entry, or I may say different entry from Dr. Prashant Yosthali, whose musical biodata I will like to read because it is very interesting. He started playing harmonica at the tender age of 47 years and learned from his guru, his friend Dilip Gaitonde, and is being playing various instruments, pianica also, melodica. And I would like to hear and then talk what are these instruments, and really it was very interesting reading his biodata. So let us hear him first.
Excellent.
Thank you very much.
Yeah. Can you just explain to us how you are doing if you have the instrument right now?
Actually, the thing is that I primarily play the harmonium, and mostly I play the Indian classical one. That is why, as you must have realized, that I have taken liberties of developing this song on my own, getting shades of various other rags also in between. This is not the original one. The original song is sung by the legends Bharat Ratna Pandit Bhimsen Joshi and Lata Mangeshkar, and the music director is Srinivas Khaleji. So it's a very tough song, but then since it is a classically based song and little bit I learned classical, so I tried to develop the song on my own. So there are from the original rendition, this is a little different. Now the thing is that this is an instrument called as the pianica or the melodica. It is also called as a melodica. So you can say that he Petichi Chimurdi Bahin, or the younger sister of harmonium, because the harmonium is pretty big, and the keyboard, see, this is the harmonium, and that one, the harmonium is based on the air pumping is by the bellows, whereas here it is totally based on a pipe that goes into the melodica instrument, and the thing is the wind blown is directly from what you are going to blow. So your tidal volume has to be really good. So this is the pipe that goes into the instrument. I bought it, now to tell you the good part of the thing, I bought it as a post-COVID physiotherapy. I was down with COVID in the first wave. So rather than doing those respiratory exercises, I said, why not, since I am already playing the harmonium, why not try the pianica or the melodica? And this is a very, very good post-COVID respiratory exercise. So it adds to your tidal volume, and that is how it has been played. But the drawback is that the moment you stop blowing air, the instrument stops playing. Because there are no bellows. Your wind and your lungs and your tidal volume is what the air blown by you is what keeps the instrument going. So the moment, it is very important where to take a pause. Because once you're out of breath, you're going to inhale. At that time, the instrument is going to stop. That is the beauty of the instrument.
Prashant, I must say that since you've explained this to us, it's like sort of phenomenal how you have been playing this for nearly now 5 or 7 minutes without any pause, and
Yeah.
it was really good. And you asked me whether I should play a Bollywood number or anything, and I told you anything would do. I'm glad we decided on this number because it was really very good. And
Thank you,
difficult,
thank
as you say, because you all would understand the nuances, but it was really nice.
Yeah, right. Thank you.
It was amazing.
Yes.
Beyond words, actually.
Thank you. Thank you
Melodious
very much.
physiotherapy.
All credit to my guru, Dr. Dilip Gaitonde, who himself is a senior ophthalmologist. He's 3 years senior to me, and I have learned in the cultural secretary room during my MBBS days, and then there was a big gap of 25 years. After that, I started going to him again at the age of 47. That is when the formal training started.
He also is going to be playing, I think next Sunday or whatever.
I don't know. I have no clue.
Yes, yes.
I'll talk to him.
No, he has consented to it.
Okay, great.
Yeah.
That
No,
will be a
very
much
nice.
better performance.
These people, I must tell you all an incident. These people, they really make magic out of their music. See, when we were having our BOA meeting, and I was supposed to dance on a Launi, and at that point of time, I couldn't get the karaoke track for the Launi at all, and I wanted to convert that Launi into a ophthalmic based parody kind of thing, and for that I needed the music. So the thing is that since there was no track available, we asked a lot of people, they couldn't get it. It was then that Namrata sang the song. Prashant and Dilip and Harish, they created the music. I created the lyrics of that, new lyrics for the ophthalmic thing, and I danced with 2 other girls on that, So it was like kind of a potpourri, but it worked out well.
It was a big hit.
It was a big hit,
Real talent.
No, it was good fun. More than talent, it was good fun. Because we didn't know whether it would happen, but it happened. Means till 2 days before the event, I was not sure whether the song was coming through or not. But it did, and it came through very well. So all
Wow.
thanks to these people only.
In spite of the hurdles, you won, and what we have played.
They were good. I mean, Namrata also did her best, and they created. And the day
Anyway,
they were
thanks a lot
supposed.
for all the MOS members, Ragini madam, Karopi madam, Darshana madam,
I'm always
everybody
there
has
for
put in a
you.
lot of effort.
We are enjoying actually
Yes.
we are enjoying the talent.
Really.
Amazing talent.
True talent, true to its name, the program.
Okay, now we go to
I think
Dr.
Maharashtra has a
Vaishali.
lot of talent, and the thing is that, see, when I was doing the BOA talent thing, I knew the people from Mumbai who are talented, though a few people are still getting added to the list. But the names from Maharashtra, I mean from Pune and rest of Maharashtra, was given to me by Jignesh, and I'm really happy because really talented people are there. Means like Geetanjali, Tanmay, Vaishali, all of you all, Vaijayanti, very very nice. Good singers and performers.
Yeah.
So now I welcome Dr. Vaishali. She is a cultural committee member, a lady with a very pleasant personality, beautiful smile, and a very sweet voice.
It's a
So she is
calling
going.
that kettle black.
So she is going to present something, humor in ophthalmology. So we are very eager to, watch that.
म्हणतात ना, डोळे हे फिल्मी गडे, डोळे हे जुलमी गडे. मी आज सांगते की डोळे हे कसे मजेशीरही गडे. आज आपण आमच्या घाटीच्या ओपडीत फेरफटका मारून येऊ. त्यातले मजेदार किस्से मी तुम्हाला सांगणार आहे. चलायचं ना घाटीच्या ओपडीत? ह्या मजेशीर किस्स्यांमुळेच घाटीतली जी प्रचंड गर्दी असते, रश असते, त्यामुळे थोडंसे असे आल्हाददायक छान सुखकर क्षण येऊन जातात. सगळ्यांना माहितीच आहे किंवा जे आपल्या घाटीचे विद्यार्थी नसतील त्यांना मी असं सांगते की आपली पहिली जी खोली असते ना ती विजन टेस्ट करण्यासाठी असते. मग दुसरी असते कन्सल्टेशनची आणि लगेच त्यामागे आहे डार्क रूम. तिसरी खोली सिनियर ऑफ्थॅल्मॉलॉजिस्टची आणि शेवटची ही रिफ्रॅक्शन आणि आमचे ज्युनियर रेसिडेंट जे टेबल वर्क करतात त्याच्यासाठी असते. पण या असे 1, 2, 3 नंबरच्या खोलींमुळे आमचे पेशंट जे बऱ्यापैकी वृद्धच अधिक असतात त्यांच्यामध्ये खूप कन्फ्युजन असतं. मग आम्ही पहिल्या खोलीत गेलो, नाही तिसऱ्या खोलीत गेलो, पहिलीला तिसरी, तिसरीला पहिली, असं सतत गोंधळ चालू असतो. एकदा एका आजीला मी सांगितलं की आजी औषध टाकून ते अंधारी खोलीत जाऊन तपासणी करा. त्यावरती आजी म्हटली हो खूप अंधार येतो डोळ्यावर. मी परत तिला सांगितलं आजी जाऊन औषध टाक आणि ती अंधार खोली आहे ना तिथे जाऊन तपास. ते तिचं आपलं तेच, माझ्या डोळ्यासमोर खरंच अंधारच येतो, खूपच अंधार येतो. तिचं वारंवार ते सांगण्यामुळे माझ्याच डोळ्यासमोर अंधार आला हे सांगायला नको. दुसऱ्या वेळेस असेच एक आजोबांना मी सांगितलं की आजोबा तिसऱ्या खोलीत जाऊन डोळे धुवून या. ॲक्च्युली डोळे धुणे म्हणजे आम्ही ज्याला सॅक सिरिंजिंग म्हणतो त्याला आम्ही पेशंटच्या रुग्णांच्या भाषेमध्ये डोळे धुणं असं सोपं एक बोलतो. म्हणून त्यांना सांगितलं की जाऊन तिथे सॅक सिरिंजिंग अर्थातच डोळे धुवून या. बराच वेळ झाला ते आजोबा काही परत आलेच नाही. मग नंतर खूप वेळानंतर मी पाहिलं तर ते अर्धे भिजलेल्या अवस्थेत आले. मग खुलासा असा झाला की डोळे धुवायला बेसिनमध्ये पाणी नव्हते म्हणून ते बाहेर जाऊन डोळे धुवून आले. हे ऐकून माझ्या डोळ्यातच गंगा जमुना वाहू लागले होते. आणखीन एक किस्सा म्हणजे आता आपण ऑपरेशन थिएटरमध्ये आमच्या फारच गमती जमती होत असतात. आमचे आत्ता सांगितलं की बरेचसे वृद्ध पेशंट असतात आणि त्यांना बऱ्याचदा दिसण्यासोबत कानांनी कमी ऐकू पण येत असतं. म्हणून 2 टेबलवर 2 पेशंट जेव्हा झोपलेले असतात तर आम्ही सांगतो एकाला इन्स्ट्रक्शन आणि तो पाळतो दुसराच रुग्ण. एका आजोबाला सांगितलं आजोबा थोडं मान उचला की ज्याचं ऑपरेशन ऑलरेडी सुरू असतं तोच मान उचलून उठून बसायला तयार असतो. अजून एक हलका फुलका गोष्टी म्हणजे प्रीमेच्युअर बाळांची डोळ्यांची तपासणी. त्याला आम्ही म्हणतो ROP स्क्रीनिंग, अर्थातच रेटिनोपॅथी ऑफ प्री मॅच्युरिटी. तर दर बुधवारी आमच्याकडे लहान मुलांचं हाय रिस्क बेबी स्क्रीनिंग पण असतं आणि त्याच दिवशी मग आम्ही ROP स्क्रीनिंग अर्थात रेटिनोपॅथी ऑफ प्रीमॅच्युरिटीचं पण स्क्रीनिंग करत असतो. तर अशी खूप गर्दी, प्रचंड लहान बाळं आणि त्यांच्या आया आणि आज्या अर्थातच आलेले असतात. तर खूप गर्दी असते. एकदा असंच मी माझ्या रेसिडेंटला म्हटलं, चल आता घे सगळे ROP बेबी स्क्रीनिंगला. तितक्यात एक तरुण आजी जोरात ओरडली, अहो मॅडम, आम्ही काही गुन्हा केला नाहीये, बाळ कमजोर आहे, तो काय आमचा दोष नाही, आम्हाला असं ROP वगैरे म्हणू नका बरं. हे ऐकून आम्ही सगळेच डॉक्टर ROPच्या पिंजऱ्यात उभे राहिलो. आमच्या कॅटरॅक्टचे पेशंटला तर बरेचदा त्यांचे सुना आणि मुलं आम्हाला सांगत असतात, मॅडम यांना जरा सांगा ना चूप बसायला, फार बडबड करत असतात हो. आणखीन एक किस्सा म्हणजे आमच्या OPDतला सांगते. एक वॉर्डमध्ये आमचे कॅटरॅक्टचे पेशंटचा राऊंड चालू होता. ही झाली गोष्ट आमच्या रेसिडेन्सीच्या वेळेस. आम्ही मॅडमसोबत राऊंड घेत असतो. अजून एक गंमत म्हणजे आम्ही ऑफ्थॅल्मॉलॉजिस्ट बऱ्याचदा म्हणजे अक्षरशः 90% लोक विजन टेस्ट करताना 2, मग 5 आणि 1 हा हीच क्रमवारी चालू असते. तर कॅटरॅक्ट पेशंटचं आम्ही राऊंड घेत असताना मॅडमने विचारलं, बाबा दिसतात का बोटं, किती बोटं आहेत? तर ते आजोबा म्हटले, बोटं काय म्हणतात, मला तर तुम्ही अगदी हेमामालिनीसारखे वाटताय. हे ऐकून पूर्ण वॉर्डमध्ये अगदी खळखळाट झाला. ते म्हणजे याचाच अर्थ ते आजोबांना छान दिसलं, पण शिवाय आमच्या रेसिडेन्सीची खूप छान हे झालं की मॅडमनी आम्हाला सगळ्यांना लगेच शेट्टीच्या कॅन्टीनमध्ये ट्रीट दिली. मग आवडलं ना आपल्या ऑफ्थॅल्मोपडी आणि वॉर्डमधली चक्कर? मला अपेक्षा आहे की माझ्यासारखं तुम्हाला सुद्धा आनंद झाला असेल. थँक्यू सो मच. धन्यवाद.
मस्त. खूप छान.
Very nice. Thank you.
Humor in ophthalmology.
All in a day's work.
व्हेरी व्हेरी नाईस.
करुवी मॅमला कळलं का?
हा कळलं ना. कशाला
आरोपी जास्त आवडले असतील
आरोपी जास्त
तुम्हाला.
आवडलं.
आरोपी जास्त आवड. मलाही
Very
मगाशी
nice.
तो प्रश्न होता की करोबी मॅडमना मराठी कविता वगैरे समजतात का?
नाही, मराठी समजतो, कविता कशाला समजणार नाही.
Very nice, Vaishu.
Thank you.
Very nice.
Thank you.
Next talent also coming from Aurangabad. We have Dr. Sunita Gopanpallikar ma'am presenting a beautiful song. She was also one of the finalists of MOS Idols. Please enjoy her song.
Yes, a pride of Aurangabad along with Vandana.
बाहों में चलिया, बाहों में चलिया, ओ हमसे सनम क्या पैदा, ओ हमसे सनम क्या पैदा, आज तो नहीं मिलन ये संग है उम्र भर का, बाहों में चलिया, ओ हमसे सनम क्या पर्दा, ओ हमसे सनम क्या पर्दा. चले जाना है नजर चुरा के यूं, देखा मीठी साजन तुमने मेरी कलाई क्यों, चले जाना है नजर चुरा के यूं, देखा मीठी साजन तुमने मेरी कलाई क्यों, किसी को अपना बना के छोड़ दे, ऐसा कोई नहीं करता, बाहों में चले हमसे सनम क्या करना, हमसे सनम क्या करना।
Wonderful singing.
Wonderful. Yeah.
Yes. The pause and this very melodious.
Madam, you start your video, please. Sunita madam.
Yes. Thank you, everyone. The video is hanged, I suppose.
Okay. She has received many awards and prizes also because of her singing.
Okay.
Yeah. Thank you so much.
It was a lot of feelings also. Yeah, she's here.
Yeah.
Okay. Excellent singing, ma'am.
Thank you.
Now we are coming to the end of this program. Before that, again, a small surprise for everyone. Let me present my screen. We hope you enjoy this. Thank you.
What a pleasant surprise, Darshana.
Wonderful, Darshana. One can't believe it is the same Darshana who enacted Kajol, and now you're totally in a puppet thing. Very nice.
Yeah. आणि ती स्वतः बरोबर नवऱ्यालाही मस्त नाचवते.
Thank you. Pankaj loves to do dandiya also. So we learn all forms of dandiya every year. New type.
Wonderful.
Yeah, have a great time.
नहीं वो नचाती नहीं है, वो उसके पीछे पीछे आता है, बोली ना जहाँ मैं जाती हूँ तुम वही चले आते हो.
True, very true. Excellent performance.
Thank you so much.
Very nice.
As we come to the end of the program.
मस्ती करने का, मस्त रहने का.
Yes.
Enjoy. Yeah.
खाने का, पीने का, मस्ती करने का.
Yes, ma'am.
Yes.
So as we come to the end of this program, we have a grand finale song for all of you. Dr. Manisha Doctor was our judge for MOS Idols, and she readily consented to play, give a song, sing a song for all of us. So let me present the song first, and Madam will be joining soon.
So nice of her.
Yeah.
आज मौसमों से रूठ गई, फूलों की शोखियाँ जो
you so much.
Wonderful.
Too good.
What a
Too good,
lovely
superb.
voice and song,
Very
ma'am.
melodious.
Beautiful. It was.
It's my
Thank you
favorite song, man.
so much.
Favorite.
Thank you so much for inviting me. It's so nice of you. Thank you. And what awesome talent all of you have. I'm in awe.
And I was hoping I could do
Always
Bihu
so
dance.
nice to see you. Thank you so much. So well, and you look like a big fairy, I must say. Thanks a lot.
Exactly.
Y'all are just amazing. I always tell Kumar, इतना talent है ophthalmologist में. I'm absolutely mind blowing. इतना काम के साथ आप लोग इतना अच्छा गाते हो और so multi talented, just superb. Thank you.
Yes.
It was our pleasure, ma'am. Thank you so
The song was so melodious, very nice.
And ma'am looked also so elegant, so
I know.
cute, and
She also looks like a chini gudiya.
Yeah. And that continuous smile, while singing, that smile was so cute, like it touched heart. It was so cute.
Thank you so much.
It was an evening. It was an evening well spent, especially when India-Pakistan match is going on and India is not doing well. This was a great time that everyone had. Those people who joined over here, they are happy. Those who are watching TV, they are happy.
I put that message in all the groups that don't be stressed out over the fall of wickets. Join the cultural program.
Yeah.
And we had so nice feast of talent.
Yeah.
I'm really thankful to each and every participant. It was worth it that we arranged this program and everyone participated so happily and energetically and nicely.
Thank you.
And thanks to President Dr. Gopte and Ragini ma'am and Shirish sir, Pankaj, and the whole MC, everyone, to have this in the afternoon, again in the evening, and again we are going to have gala time on 31st. So it's very nice of you. Beyond ophthalmology, we have to enjoy and we have to keep smiling, like me and Karovi madam.
Yes. Thanks to Darshana also, she has a major role in all this, getting us all together.
She herself is very talented and interested, so she likes doing these things.
Ruby ma'am, I'm really thankful to you. I got this opportunity to know you so well, and you are so cooperative and helpful every time I call up or ask anything. I'm thankful to
Gitanjali. Guidance what you gave us, like it was really good.
Thank you. You're always welcome.
Thank you everyone. It was a wonderful program. Actually, I was organizing cultural secretary when we had a conference here.
2018, yeah.
It was awesome.
Right.
So I know kitne pains रहते हैं इसमें करने में, and you are arranging it. It's online, so it's
just
really.
When Karube ma'am was talking about the Lavani nose, I wanted to tell her about our 2018 experience. How we had a the ramp walk and this dancing and singing. It was superb. Like we enjoyed it a lot.
What I want to say is that we are enjoying it on this virtual platform, but once it gets physical, there'll be much more enjoyment. Because when you
waiting for it
in front of a crowd who cheers, whistles, there's nothing like it,
Yeah, that's true, madam. But I would say this virtual platform has brought all of us together.
Very true.
Yeah, we started knowing, like myself and Darshana, we hardly knew each other. But with this platform, like we have become so close friends. She can call me any time of the day. I can call her any time of the night. So no problem for us.
I'm always relaxed. Yeah, Gitanjali ma'am is there, Vaishali ma'am is there. Like I can pull off any program. And now you are there, ma'am.
No, really. No, the thing is that it actually started as a separate venture in different districts, and then now finally it has come all together. So it's much nicer, because the thing is that you recognize the talent from all other districts, and really good people are performing and all that. That's the reason why I said that keep it limited to people who perform well, word of mouth, because that is very important. Otherwise, when you do auditions, what happens is that somebody who really doesn't perform well, that person may feel offended and all, and why do you want to take that kind of thing? So do it. And if you know somebody singing well whom you didn't know, you can include him, there's no problem.
Great.
It's always better.
Yes.
So looking forward to 31st now.
Yes. Lot of dance and dhamal we are planning.
Dance, songs, dhamal.
One person couldn't sing in the morning today.
No. We asked for some extra time, and
everyone finished.
Yeah, everyone finished.
No, I was feeling a little guilty because I asked Sandesh to whistle, so I thought I took away that time.
No, the moderator was so good enough, said we are enjoying, please carry on. So we finished.
Including
the retina people are very accommodating. They didn't mind the extra time that the cultural
No, I just said including Ragini because he's the main
so we are in your retina hall now, so retina people are very accommodating.
Yeah, I know.
Hi Manisha ma'am, lovely to hear you. Thank you so much for gracing this.
Thank you, Ragini ma'am. Thank you all of you for including me in part of your programs.
It's our honor, madam, that you are here. It's our
last
honor.
time when we did the program with you and Harshul, from that time you have become a part of our family, just like Kumar Bhai is.
That's so nice of you. I really enjoyed. That's what I was before you came on. I was saying there's so much talent.
I was there. I was very much here, but I was sitting quietly at the end of the day. Not my cup of tea. This cultural thing.
No, you have also been very much. You had another conference, right?
Manisha, there's a good glow behind you.
Yes,
there's a lovely
Kumar's photograph.
Okay.
This is a photograph that Kumar has clicked, so that's my backdrop.
Okay.
Yeah, Kumar.
Another talent. Your ophthalmologists are really multi-talented.
Nice photos are phenomenal.
We'll say thanks to everyone present here. Really, it was my pleasure throughout, and my committee and participants, everyone. Once again, very, very, very thank you for being.
And thank you, Dr. Darshana.
Thank you, everybody.
Thank you, everybody.
Thank you, everybody. Thank you.
Bye-bye.
I think that this was a very fitting end of a wonderful, wonderful day and a lovely, 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 enthusiastic team. Dr. Sandesh Bhai, you rock. Anaga, Gitanjali, Sarobhima, Darshana, putting it all together. And I think it's Vaishali, everybody.
Thank you so much.
Thank you so much.
Hats off to you, Dr. Ragini. Dr. Ragini, hats off to you that after this whole day of hard work, you are still here and appreciating everyone.
Everybody is working very hard. Everybody is working very hard. I am just a part of the team. Sumit is now, we were sitting and writing 30th. That's why I was quiet for some time. Now on to 30th and 31st. Actually, can I say something? Saturday, we might have to have some morning sessions. So we have a 1 to 2 break, session even on Saturday now, actually, which was not there initially.
Okay.
So now 3 more sessions, Saturday and Sunday, both 1 to 2, 1:30 to 2, and Sunday evening, your grand finale.
Okay.
No, we can arrange an afternoon session on Saturday, as we have many entries coming up. So again, a song session can be kept on Saturday afternoon.
A melody can be kept.
Melodies,
we will have 6 melodies then.
Yes.
Sure.
Ragini?
Yes, ma?
Go and sleep. No 30th now. 30th is tomorrow.
Big hug to you, ma, and big hug to everybody. Manisha ma'am is looking so pretty with that halo around her.
Exactly.
We are all so different, but we all love each other. And I think beauty is not just physical beauty. I'm looking at all of you, and I don't know why, but because we connect with each other, we all are glowing today.
Well said, well said.
Thank you so much, everyone. It was lovely.
Thank you.
Thank you,
Thank you
so
so
much.
much.
Bye.
Come back, huh?
Thank you.
Bye.
Bye bye. Thank
Bye bye,
you.
everyone.
Bye, everyone.
Sandesh
Bye,
bhai, you
Sandesh.
are a genius.
Oh, thank you. My entries were taken last by Darshana. Thanks to Darshana.
No, now Darshana is not going to put them last at all. They are first.
Hey, Ragini, what
Ji,
you
ma.
said? What you said? Genius or genius?
Robi Mano, as the night gets young, Robi Ma's jokes become.
More khatarnak.
But then Sandesh bhai, of course, is used to. Hi, ma'am. How are you? Lovely, lovely, ma'am. It was great to hear you.
Very nice, yeah. She sang so well.
पण मजा आली एकंदरीत.
It was great.
हो मज्जा आली, खूप मजा आली.
Dr. Sandesh, it was lovely. Awesome.
Hey, Sandesh, if
आणि-
you sit like that, you'll get a backache, man.
नो 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 मी मस्तपैकी झोपलेलो आहे.
झोपलेलं आहे, but that is not a good position, yeah.
नाही, नाही. आणि करुबी तू इथं असल्यामुळे मला असं नेहमी टेन्शन असतं कुठल्या दिवशी तू मला फोन करून सांगशील की उद्या प्रोग्राम मध्ये तुला पाठ घ्यायचा आहे.
आता 2-3 रेडी करून ठेव.
But Sandesh bhai, just see him, he has a backdrop of his clinic.
Yeah. And he's reclining.
This is like a comedy act.
I know.
He had
really, he's really
Right,
too good at
everybody.
everything, yeah. I mean, he's like a one-stop shop, अगर कुछ नहीं है संदेश गाना गा, मैंडोलिन कर, विसिल मार, कुछ भी कर.
नहीं अभी तो ऐसा कुछ नहीं है कि कुछ नहीं है because you know what, I dragged my dad today in the afternoon. I said, come see how my conference is. He said, what is all this singing? So I said, Dad, these are all ophthalmologists, and he couldn't believe it, he was so happy.
Next he'll also tell you मैं भी एक गाना गाता हूँ.
No way. All of us are very besura.
Hey, but now, no. But next time, next Thursday, that 31st, Ragini, you have to do something.
Me?
Your choice.
Ma'am, all
Your choice.
the people will run away.
No, they'll all aggregate. Don't worry.
No, they will all run away and they'll say, Bapre,
won't.
Darshana, you please leave this post of cultural.
No, ma'am. Every person in the committee is performing.
फरमान जारी हो गया. You have to do something. Sing, play, dance, whatever. Read a poetry.
You remember Sir singing last time?
Yeah, but thanks so sweetly.
Today he has conveniently run away to Pune for a meeting.
Okay. That's why we'll catch him next Sunday.
31st.
But I'm serious, Ragini, please prepare something.
Okay, oh God, I'm tense now.
Otherwise, what I'll do, I'll come to JJ and we'll...
I'll put my face and in the background, Sandesh bhai will be singing.
अरे तू मेल वॉइस किधर लेती है यार?
The harmonica.
फीमेल को लेना. Or you know what? I'll come to JJ and they like with
It's so
many
tense.
questions, we'll have what we call as a tap fight, no? एक नल के पास जाके बांडी बेंडी फेंकने का, झगड़ा करने का. That will be a good thing.
I was not a part of that BOA act also,
You were.
I wasn't.
Hey, you were. You came to buy my bibbers.
I wasn't.
You came to buy my bibbers.
I can't do anything. I am too miserable for that.
Ragini, you and sir came to buy my bibbers.
Yeah.
Bibber, shika kai. Remember?
Yeah, that was in BOA, but not the online program.
Yeah.
Madam, you said bibbers. I was not getting what she's saying, bibbers. Those are
Bibber.
That was the live BOA program.
Yeah, live BOA program.
Even I was wondering what is
bibbers. Then she said bibber, then okay.
Then you understood.
Anybody is fasting for Karwa Chauth? Is the fast over?
Not me.
Not me.
Not me.
I'll ask if my husband is fasting.
Maybe.
Okay. Chalo, bye everybody.
Bye.
Yes,
Bye.
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 Seriously,
Good
go and
night,
sleep, yeah.
everyone. Good night.
I'll sleep.
Good night.
Sumit and Swapnesh, let me sleep.
Screenshot
I'll
लेने
sleep.
को बोलो दर्शना. Ask for a screenshot.
Yeah. I know.
Yeah.
Hey, somebody sing a lullaby for Ragini.
Who is getting?
Sir had sung last time, है ना?
I know.
La 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 lori.
Lori.
दूध में बतासा.
Darshana, have you requested Mr. Sai to take the screenshot, please?
Yeah.
Thank you, Sai Dada. Thank you so much for the whole day. Flawless.
Yes, yes.
Flawless.
It was flawless, really. Thank you so much.
Thanks for
Sai,
calling.
And thank you, Sai Dada. Thank you.
Did you have?
Good night.
I've taken a screenshot, man.
Okay, thank you so much.
Thank you so much.
Thank you so much.
Bye, everyone.
We should have Sai Dada also. We should have had in the screenshot.
I know Sai Dada, where Sai Dada is gone.
He's hiding from all the women.
Hey, Sai Dada, you unmute. You put your video on, yeah. There Sai Dada is there.
Now
Where
you
is
have
he?
to take a
Now one
screenshot.
screenshot.
Now the screenshot. This is important.
Now finally we can put a face to the name.
Correct.
No.
Done.
He's a genius. Thank you. He's so relieved when day 2 is over. Now the next weekend.
Ready for
No.
next week.
Till the
You know
next
why he's
conference.
relieved?
Sai Dada, after a few conferences with us, no, you're going to lose your head.
Already started losing.
No, I will buy a wig and keep for you.
I still enjoy anyway.
No, we'll buy a wig for you in advance.
साई दादा will say कि कहाँ से ऐसी बहन मिली. My God, रात हो दिन हो साई दादा सुबह SMS मिल गया मेल नहीं गया.
Now he's waiting. He's
Thank
waiting.
you.
to
It was
go.
wonderful,
Run away.
wonderful. Great.
Bye.
Thank you, Sai Dada. Thank you, everybody.
Bye, everybody.
Bye.
Bye.
Bye. Good
The
night.
sunrise has become little vertical.
Yeah, I'm now sitting. That you threaten me.
Yeah. This posture is good. Okay, bye everyone. See you all.
Bye.
Bye.
Bye bye.